technology program
Yeah.
rather
Wow.
than for one on medications.
Hmm.
So it was quite fascinating.
Yeah. Huh.
Now, when we go on, I go to share, right? To share the screen so I can show my slides.
Yes, you can just now, you can try a dry run. I mean,
Okay. So I hit share screen,
yes.
right? Okay. And now, so I want to go to my desktop, or should I put up something? Yeah, this is the part I'm a little confused with. Oh, I see. So whatever I
So you
want
are
to put
doing the
up
share
there.
screen. You are doing share screen.
Okay, hold on. Okay. Now I just put up the slides, but it doesn't come up as a choice on my share screen link.
No, is it your slides are on your desktop?
Yes.
So I mean, just share the screen, and then there is
Okay.
a button of coming that says share your screen. And once you will
All
share,
right.
yes, now it
Here
has,
it is.
and now
We got
make
it.
it on a full screen.
Okay, so I want to put this
Yes.
down there, and now go there.
Yes.
Yep.
It's
Okay.
perfectly fine.
Okay, so when we get to that point, so if I leave this now and just make it in the small, in the
Yeah.
corner there, I just have
Now-
to pop that up.
No, but
Or
you
actually,
have
I
to-
can leave it. I can leave it up, right?
No, you can't leave it because now the Bob is going to share the screen. So you have
Okay, so I have to unshare. So I have to just put it in the bottom corner until.
and then you have to unshare your screen.
You have
Stop
to
sharing.
stop
Oh,
sharing.
okay.
There,
Yeah.
there is a stop sharing. You have to.
Oh, so I have to do stop sharing.
Yeah.
I see up on the top.
Yeah.
There we go.
Oh, yes.
There you go.
Perfect.
Yep.
Okay. I'm glad
We
you're going
remember
first,
you
Bob.
multiple times when India Libre had come.
I'll tell you, Roger, I've done this so many times now.
Okay.
I tell everybody, you know, in the last 6 months, I've been to Taiwan 3 times, once, Korea, India. Now this is, I think, the 3rd time.
India, I invited. Second time you are talking for me only.
Yeah. And so I've been all over the world and it's been painless. No frequent
No, I
flyer
know.
miles.
I've done it with Qatar and
Yeah.
a number and the UK. I've
Yeah.
done it, but you know, when you have so many nice people around to tell you what to do, you just don't remember exactly
Right.
what the steps are. But
Yeah.
I'm sure I'll be able to get it up when
That's
it's ready.
It'll be fine. So I'm ready whenever you guys say the word.
Yes, so now I think we should start. So it's already 8:55 and we have Padmana. So
Good morning, sir.
yes, good morning everyone and good evening from for those who are joining from USA. We have both our faculties who are from USA. So now I invite Dr. Padmanabh to invite our both the chairperson and then we can start the session. Over to Dr. Padmanabh.
Yes, sir. Good morning, sir. I welcome both the speakers and chairperson for the today's first opening morning session of DICARE Con 2020. And for today's morning session, we have chairperson Dr. Rakesh Parikh from Jaipur and Dr. Alok Modi from the Mumbai. I welcome both the chairperson for this chairing the session, and I request both of them first introduce our international speaker and then start the session. Dr. Rakesh Parikh, please.
Sure, Dr. Padmanabhan. Thank you for inviting me here. And I welcome both the speakers for the first session of day 2 of the conference. And I'll be introducing Dr. Robert, who is the first speaker in the session today. So Dr. Robert is the CMO of MEDTRONIC Diabetes. And he is also the professor of medicine at Uniform Services University of Sciences. He was the valedictorian of Boston University of School of Medicine. And he has established the Endocrine Society's Clinical Practice Guidelines Committee and served as its chair for 6 years. He was also the Endocrine Society president from 2009 to 2010. He has been active in Diabetes Technology Society, which gave him its Leadership Award in 2011, and he has over 310 scholarly papers to his credit. So now I hand over the mic to Dr. Robert to start his presentation.
Well, thank you very much, Dr. Parikh, and thank you very much, Dr. Sabu, for asking me to participate in this very exciting conference. And I just learned that there are over 30,000 people who are registered, so it's very impressive. I'm going to share my screen now, and we'll get started in a second. Okay. So what I'm going to talk about today is the progression that we have made at Medtronic towards an artificial pancreas system. As you know, Medtronic has played a leadership role in diabetes technology for over 30, 40 years. And I'm going to highlight some of the advances and some of the data that go along with those advances along the way. And you may ask, well, why do we need this type of advancement? And I think most are very familiar with this slide. I think it's the most popular slide that has been shown in the last year and a half since it was published. And this is a graph of the results of a survey from the T1D Exchange, which is a registry in the United States of 21,000 children and adults with type 1 diabetes from 81 of what is considered to be arguably the best endocrinology and diabetes centers in the US. And what you can see here is a graph of the A1C over the age continuum. And in the orange is the data that this same T1D exchange collected in 2010 to 2012, and then in the blue from 2016 to 2018. And I take at least 3 lessons from what this says. First, it says that we have a big problem in our young teenagers, children, teenagers, and young adults, where their A1Cs are spiking up to 8.5 to 9.5. We have a situation where the population, again, arguably in the best diabetes centers, even in adults as they get older, don't reach the goal of 7%. On average in these centers. And what is most dismaying is that it actually looks a bit worse in the 2016 to 2018 time period than it did 6 years earlier, suggesting that at least up to that time, the technology, which has a high penetrance in these diabetes centers, really hasn't made much of a difference. And again, this was at the the latest slide. The latest survey was just as the 670G was coming out, so it doesn't include the data and the accomplishments of the first hybrid closed loop system, which I'll talk about shortly. But this is why we need technology. And I believe that until we have a cure, it's going to be the advances in technology that are really going to make a difference. Now, this slide, which I'll show you several times, gives you an overview of where the technology has come from and where it has gone. And you can see on the left-hand side of the slide some of the historical now advances from the first sensor-augmented pump almost 15 years ago to a first threshold suspend pump where insulin was suspended at a threshold. And then the one I want to just show very briefly is the data from the first predictive suspend, which is the MiniMed 640G. So this algorithm takes the intelligence of prediction to the next level. So in threshold suspend, when you hit a threshold, insulin infusion stops. There's still insulin on board, so the glucose can still go lower, and it can be suspended for up to 2 hours. And this is like having an airbag where if you hit the car in front of you, the airbag deploys. Your car may be wrecked, but you can walk away safely. Threshold suspend operates quite differently, where it predicts based on the rate of change when you will hit the threshold and stops insulin, even if the glucose is still in the normal range. and then restarts it at the time that it starts to increase. And this is similar to the safety brakes that we now have, which can sense that you're going too close and start to the car in front of you. So you never hit that car and the airbag never deploys. So that's the threshold suspend and the predictive suspend. How does this predictive suspend actually work? Some of you may be familiar with the SMILE study, which I think, in my opinion, is one of the most spectacular studies in diabetes ever conducted, as you'll see from the results. This was a randomized controlled trial of the MiniMed 640G, so this had the predictive suspend, and they took people who had increased risk of hypoglycemia because they were hypoglycemic unaware or had severe hypoglycemic episodes in the previous 6 months. It was randomized between that thresholds, between the predictive suspend and just the pump alone without CGM. It was over 6 months in 5 countries, 16 sites, and you can see the design of the study on the lower right. And what did they find? Well, they found that there was a 73% reduction in the number of hypoglycemic events, less than 55 or 3 millimoles during the study period in those who had the predictive suspend. The events were significantly shorter, and the time spent in hypoglycemia was 79% less. And more impressive was that the HbA1c levels didn't go up significantly because the suspend feature was thought perhaps might, if you interrupt insulin delivery, it might go up, but it actually didn't. And the rate of severe hypoglycemia, as defined by an actual event, needing assistance, seizure, or coma, was 84% lower than it was in the control. So I, again, would think that I have not seen, maybe since the DCCT, as an impressive randomized controlled trial as this one, showing the power of this automation of predictive suspend. So that brings us to the first hybrid closed loop system, the MiniMed 670G. And the feature that MiniMed 670G has is auto basal. So every 5 minutes, the basal rate can change. And what this is shown on this slide is that now the variability in glucose, and this is the sensor glucose over 24 hours in a patient, showing it's pretty flat. And that variability is now seen in basal insulin. So you see periods where the basal insulin goes up, it goes down, it's suspended. And now that we have transferred variability in the actual glucose to variability in insulin delivery, which now operates on a feedback system. Now, this single patient illustrates this, I think, best. Here's 4 nights in a single patient during a week. And what you can see is that the sensor glucose is flat throughout the day and night, as seen here. Well, this is through the night from midnight to 6 a.m. But you see that each day or each evening through the 6 a.m., the basal insulin delivery is different. So no 2 nights are alike. And there's no way without this automated basal insulin every 5 minutes that you could have predicted when you would have needed to suspend, when you needed a higher basal rate. And most people have 1 or 2 overnight basal rates who are not on automated systems. And I like to say that in the United States, where we have snow, we say that there are no 2 snowflakes that are alike. Well, in diabetes, I think this demonstrates that no 2 nights are alike in their need, in one's need for insulin delivery. And so by having an automated system that adapts to the needs, you get these flat glucose curves. Now, the results of the pivotal trial that was run in the United States was designed as a safety study. So it was a run-in period of 2 weeks, followed by a 3-month at-home study period. And this is the cumulative percent A1Cs for all the study subjects, and the curve is shifted to the left, so that at baseline, only 38% of those met the goal of 7% And by the end of the study period, 62% had reached that goal. This is in adults and adolescents. And in pediatrics, it went from 36 to 51%. And here are the mean data. Mean went from 7.4 A1C to 6.9 in adults. And on the right, it went from 7.9 to 7.5. And most importantly, in over 22,000 adult and pediatric patient days of exposure, there was 0 severe hypoglycemia and 0 diabetic ketoacidosis. Now, here's the modal day display in orange. This is the run-in phase. And what you see during the study phase is a number of interesting things. You see that in adults, most of the improvement is in hypoglycemia. In adolescents, most of the improvement is in hyperglycemia during the day. And in children, most of the improvement is in hyperglycemia overnight. And that, we think, is because parents of young children let their children's glucoses run high during the night because they're afraid of severe hypos during the night. And they let their children have higher glucoses than are ideal. But with this automation, you can bring this glucose down to the target of 120 by the morning and do it so it's safely. And I think this speaks to the individualization across the age continuum of how these automated systems are actually working. So they work to what the need is for glucose control, and in each of these 3 age groups, they're quite different. Now, if you recall, the DCCT study was very successful, but it was successful at a price. So this is the hemoglobin A1C on the x-axis and the rate of severe hypoglycemia on the y-axis, and severe hypoglycemia here is defined as needing assistance, seizure, or coma. So here's the A1C goal, and in DCCT, it almost reached that goal. This was 1983 when the study actually started, and the severe hypoglycemia rate was 62 per 100 patient years. And in subsequent trials that I've put here with CGM, the STAR-3 trial, the JDR CGM trial, STAR-3 trial, they all brought down the severe hypo rate and approaching again the A1C in the case of JDRF of 7%. But the 670G trial actually got the A1C to just below 7%, and there was 0 severe hypoglycemia. So I think this, in a picture, tells the story of how technology has brought us to improve glycemic control based on A1C, but also improve glycemic control in terms of severe hypoglycemia. Now, on this slide are the results of the pivotal trials of the 670G across the age continuum. So the time in range, this is the stack bar array that was adopted by most professional societies now, and as a result of the International Consensus Conference, which took place in Paris a couple of years ago. And you can see that in adults, it was a time in range of 70 to 180 of 74%, with a very low time below range of 70 of 2.3%. In adolescents, it was 67%. In children, 7 to 13, it was 65%. And the youngest children, almost 64%. And this was the result of pivotal trials. But the question is, do pivotal trials really reflect what might be going on in the real world? And here's real life data in 119,000 patients in the United States, in whom we see that their time in range, and most of these are adults and adolescents, and a few children because it was just approved at the time of this data collection, but 71% time in range, which is pretty close to the average of what the adults and adolescents were. So I think this data gives us comfort in understanding that, at least in the case of this technology, these pivotal trials do reflect what happens in the real world. And in fact, with respect to hypoglycemia, there's actually a lower hypoglycemia rate than there was in the pivotal trials. Now, the only other commercially available system in the United States that uses a hybrid closed loop is the Tandem Control IQ. And you can see the % time in range in the control group in their randomized trial. and in closed loop, and their results were that their closed loop system increased time in range to 71%, as shown here on the right, and the A1C just above 7% for the group. And you can see also here in the modal day that the time in range improved during the night, as one would expect, and it does in all these systems, because during the night people aren't eating, and therefore the systems can actually do their best at controlling basal insulin and glucose levels. Now, the next step in this iteration from the standpoint of Medtronic is the advanced hybrid closed loop. So this has now been CE marked in Europe and has been commercialized. And it really makes, there's several differences which I'll discuss in a second. But this is the next step in getting to a personalized closed loop, which I'll describe at the end. So what's the difference between this advanced hybrid closed loop, which is called the 780G, compared to 670G? It has a lower algorithm set point of 100 instead of 120. And this is the lowest set point that's available in any commercial system. Importantly, it has auto correction of hyperglycemia, and it auto corrects down to 120 milligrams percent and does so every 5 minutes. And I'll show you an example of that in a second. And then there's increased stability of auto mode so that people stay in automation for a longer period of time, which of course allows the system to take advantage of the algorithm. Now, every day, patients struggle with their diabetes. And I'll go into a little bit more of this, but I think this little note that a child wrote down about how she was coping with what she was going to eat at school for lunch and how many grams of carbohydrates. And we know that 76% of people feel carbohydrate counting is burdensome, that typically patients with type 1 diabetes miss at least 2 meal boluses a week. And that we know will cause an increase in their A1C. And we know that 2/3 of persons with diabetes underestimate their carbohydrates. So when we're designing a system, we not only want to make it their glycemic control better, but we want to make it easier and unburden them. And that's one of the things that the advanced hybrid closed loop or 780G system does. And here's an illustration of how it does it. So if you don't have diabetes and you eat a meal, your blood sugar goes up over the first hour or so, and then it comes back down. It never goes above the normal range. If you have diabetes and you don't take your insulin, of course, it goes up and it stays up. And depending on, even if you do take your insulin, it's not going to be ideal if you underestimate the carbohydrates or if you take the insulin late. With the hybrid closed loop 670G, what you get is an automated increase in basal rate of every 5 minutes, and that mitigates the increase in glucose compared to what you see on the left. But with advanced hybrid closed loop, you get auto bolus. So on top of the auto basal, every 5 minutes you get extra insulin. So again, it mitigates the rise and brings it down more quickly. And this is much more physiologic than what was previously we had in 670, and really achieved some very important results that I'll show you shortly. There have been 3 studies of this system, a US pivotal study that Anders Carlson at University of Minnesota was the PI, a study in New Zealand from Martin de Bach at Otago University, and a study called the FLAIR trial, which was an NIH-sponsored study led by Rich Bergenstahl. And each one of these were differently designed, different age ranges, and I'm only going to have enough time to talk about the US pivotal study, but each of them were presented at the American Diabetes Association in June, and publications will be coming out with them on each of these in the next month or so. So in the US pivotal study, the overall improvement in glycemic control was to get a time in range to 74.5%, a decrease in A1C of 0.5%, and you can see the improvements in time above, time in, and time below range here. But interestingly, because of the ability to tune the algorithm by adjusting the active insulin time and adjusting the target, in those who had the most aggressive, which we are recommending these settings be used, 2-hour active insulin time and 100 milligram per deciliter target, almost 79% of people in this pivotal trial got to a time in range of 70 to 180, and at not sacrificing the time below range, as you can see here. And the same is true in terms of adjusting the active insulin time, even if you set it at a higher set point, 120. But this is the target that we're aiming for at 80% or greater. It almost reaches that, and it does so at settings that are 2 hours and 100 milligrams per deciliter. Now, if you look at this on a population basis, again, we see that the A1C was achieved at baseline in 29% of the subjects, went up to 47. If you look at the GMI, and you look at the GMI reaching 7%, and that's the glucose management indicator, in 52% of the subjects at baseline. At overall, it improved to 72%. And if you optimize the settings, it's up to 84%. And then the time and range goals, which we set at 70%, go from 45% of the population up to 79% of the population. So if you're looking at this not only on an individual, but on a population basis, you're basically getting the vast majority of patients to the A1C or the GMI specifically, and the time and range goals that have been set by the various professional societies. Now, finally, I want to talk a little bit about personalized closed loop. Personalized closed loop is just what it sounds like. The algorithm will be updated as needed. So there's the data is being collected in the cloud. It's being compared to optimized settings. And as those settings can be optimized safely, they're going to be sent back down to the pump so that in the end, no two people will have the same algorithm. There's also automated meal handling, which is meal prediction. And this device has received breakthrough device designation from the US FDA. One of the ways the meal prediction is going to be verified is with the use of a motion algorithm attached to us, incorporated into a smartwatch. So each of us has gestures that denote when we're beginning to eat and how quickly and how much we're eating. And this will be incorporated into the algorithm. So meal bolus insulin can be started and stopped appropriately. So this is a high-level view of, again, a little bit of a historical comparison of where we've come from and where we're going. And I think this is really very humbling because it's happened so quickly. So if you look at studies in which MDI and finger stick blood glucose monitoring has been used, time and 45% at best. If you add CGM, it gets up to 51. If you combine pumps and CGM without any of the closed loop features, you get up to 55%. If you have the closed loop predictive suspend, you get up to 63%. In the 670G and in the US now 770G system, you're up to 72%. The tandem control IQ is 71%. Advanced hybrid closed loop is between 75 and 79% with optimized settings. And the personalized closed loop, we believe, will be able to deliver reliably 80+% time and range. And don't forget, this has all come over a period of less than 5 or 6 years. So what about the burden of diabetes? We can get better results, but in fact, we want to also get a better patient experience. And if you just take a high-level look at this, this is what people with diabetes have to take care of every day. Literally, they're living with decisions and making decisions about everything that they do, everything they eat, and this just is overwhelming to say the least. So if with 670G, some of these chores and tasks have been taken account, and their burden has somewhat been relieved. If you look at 780G, which is the advanced hybrid closed loop, you see in the check boxes now in red that many more have been taken into account. And then finally, with personalized closed loop, with meal prediction and meal simplification and smartphone control, you can see that many of these things, if not almost all of them, are going to be taken into account, greatly relieving the burden of diabetes at the same time getting improved glycemic control. And finally, one of the things that Medtronic has done is developed an extended wear infusion set. So using innovative technology, which addresses insulin degradation and preservative loss, we've developed an infusion set that now lasts up to 7 days in over 80% of people. And this goes from what is now about a 2 to 3 day wear. Not only does this reduce burden, but also saves vials of insulin because you don't have to change the infusions set every 2 to 3 days, and it also reduces the amount of plastic waste that's being thrown away. So with that, I want to thank you very much for your attention, and again, thank the organizers for inviting me to.
Thank you, Dr. Robert. It was a wonderful presentation.
I'll stand by and take questions after Dr. Mas.
I think we'll take the questions at the end of the session. We just got one question for you, but I think we'll take it after the second talk is over. So now I request Dr. Alok Modi to take from the session.
Yeah, it's an honor. A warm welcome to both the speakers for today, and a very warm good morning to Dr. Bansi and the organizers from Mumbai. It's an honor to introduce our next speaker for today. Professor Roger Marks is the director of AGP Clinical Academy, Portsmouth, England, and Minneapolis, Minnesota, which I have visited in the past. He was also the professor and executive director of the Diabetes Research and Training Center at the Albert Einstein College of Medicine till 1988. And subsequently, he joined as the clinical professor and head at University of Minnesota, which is the collaborating center of WHO in diabetes translation, which is a joint program of the International Diabetes Center and the Mayo Clinic, which is a twin city next to Minneapolis. In 2017, he had the unique honor of being presented the Harold Rifkin Award by the ADA for doing distinguished international service in the cause of diabetes. The AD recognized Dr. Mas for his work as a developer in the first SMBG reflective meter with an onboard memory, for developing the AGP for CGM and authoring the internationally acclaimed Stage Diabetes Management Program for professional education. Even in 2020 April, the NHS adopted the AGP Clinical Academy's CGM and Clinical Practice online training program to prepare the diabetologists and physicians for their own virtual management of diabetes. You will be pleased to know that Dr. Mas has authored 5 books, many chapters, and to his credit, he has more than 100 peer-reviewed articles. It's an honor for the Word International faculty that he is presented, and he continues to be a faculty at numerous academic centers throughout US, Europe, Middle East, Africa, Asia, and Latin America. And today we are honored to have him amidst us today. And sir, the mic is over to you, and we are eager to listen to you. So over to you, Dr. Roger. And
thank you very much.
Alok, I should say Professor Maje is a wonderful person as well. I have the honor of learning from him. And I should say he's a very, very, very great mentor and very down-to-earth person. I think with all his accomplishment, you know, that people cannot match that thing. And he has a very, very fine balance. So very good morning.
Absolutely.
Well, thank you,
I
Mithun.
totally agree with you, Mithun.
Mithun was my fellow, so he's making all of that up. Thank you very much. It's wonderful to see some faces, some familiar faces, and not having traveled 20 hours to see everybody. Dr. Das, how are you?
Yes, I'm fine, Roger. I'm fine. Remember my days with you, both in the Park Nicolette and when we traveled everywhere about the stage diabetes. Thank you very much, Roger. Thank you.
Thank you. It is a great pleasure and a great honor to join you. And I will share my screen now. I hope this works. Okay, where are we?
Yeah,
I hit share screen. Oh, wait, up here. It says you are share. Oh, wait, I should probably put the Let me figure this out now.
If you open up your PowerPoint, yeah,
Yes, I'm going to do that. Yeah.
and then share screen after
Oh,
that.
here we go. Here we go. There we are. Thank you. And for a person who specializes in technology, I apologize. The technology seems to advance before I can. So my presentation is going to be on continuous glucose monitoring. And in a way, it follows the presentation on insulin infusion pumps as part of this whole idea that technology has finally caught up in diabetes and is moving ahead very rapidly. A lot of that is due, obviously, to the times and the idea of virtual diabetes management, which once was unheard of, is now considered almost a necessity. So we're going to look at individuals with type 1 and type 2 diabetes. Our work extends all the way from the simplest forms of diabetes all the way up to individuals on insulin infusion pumps. So again, it does follow somewhat the previous speaker. I want to begin with the whole notion of what is this all about? Why are we doing this? And to do that, I want to explain the ambulatory glucose profile in some detail, as it's been in a development literally over a 30-year period, beginning with self-monitored blood glucose and then being moved over to continuous glucose monitoring. It is a way of taking a look at diabetes from a broader perspective, or what we would call a diurnal glucose profile. So rather than look at individual times or individual days, it takes into account the idea that there is glucose variability and exposure and stability and hypoglycemic risk, all of which must be addressed in order to manage diabetes better. I will identify 4 new measures or dimensions for each of these variables, which have become increasingly important as we try to understand how to improve glycemic control using this technology. And finally, I will present 2 cases, one in type 1 and one in type 2, in which all of the things we'll be talking about have been effectively applied. Why are we doing this? What is the underlying purpose? I've always believed in medicine over the last 30 to 40 years that I've taught it, that one should always begin with explaining why you're doing what you're doing, so that once we understand this, we can answer the question, did I meet the goal? So why should I care about continuous glucose monitoring, ambulatory glucose profile, or in fact, an insulin infusion pump? Well, we want to understand what diabetes is, the metabolic problems or the characteristics. We also want to be able to select and adjust the appropriate medications, whether it is a closed loop pump or it is a simple oral agent. We've got to understand which one to select and what the science that is behind that is, and then how to use science to make the adjustments. We also want to understand the behavioral effects. When you think about continuous glucose monitoring or any technology, it is dependent upon the individual patient's use of that technology. There is no technology as of yet that can be completely implanted with a glucose sensor and a pump that might one day significantly benefit diabetes control. But for now, it still requires that we have to understand human behavior. We also want to be able to understand whether the therapies that we're trying really work. We saw the outcome data on insulin infusion pumps, and that said, yes, they're working. And the hybrid version is working better than previous versions, which are working better than MDI. So we're always interested in understanding the clinical outcome. But we also need to start at a scientific base. And it's fascinating to me over the last 40 years, beginning with self-monitored blood glucose and now all the way up through continuous glucose monitoring, one still has to argue for the need of verified, unbiased, and accurate and reliable glucose data to make a clinical decision. And I'll start with that in a moment. And as we begin to think much more about precision medicine, which is based upon the principles of evidence-based medicine, we really have to seriously argue the benefits of having data that are verified, unbiased, and accurate. So dependence upon patient self-reported data in logbooks has to now be seriously thought of as the very far past, that the future lies with continuous glucose monitoring and other methods of accurately and reliably obtaining important data. And most important, as we understand more and more about diabetes, we also understand it's not so much how much glucose exposure you have, it also may be the variability in glucose and the stability of glucose that may contribute significantly to clinical outcomes. So, having said all of that, the why comes down to this: continuous glucose monitoring with AGP analytics are needed to make effective clinical decisions within the rubric of what we now call precision-based medicine. This is the old way we looked at glucose. 3 points in a single day, which our mind then makes the connection. In 2008, with the advent of commercial continuous glucose monitoring, it was possible to connect those points with scientific data. And as we can see, the 3 points misrepresented terribly the average glucose for this patient, what the profile actually looked like. If we look at any one day, and we heard this from the previous speaker, we know that no 2 days are alike. So here are 2 weeks of continuous glucose data. And if I take the second week and superimpose it upon the first, we can see no 2 days are alike. So how can we expect an individual with diabetes to manage their diabetes given a single oral agent without understanding that the variability and the instability are characteristics of their diabetes, and that changes in behavior, in diet, in activity, when and how much of the oral agent or the insulin is given, all of those have to be factored in for management. When continuous glucose monitoring was first introduced, and it was noted that there were differences each day, many of the different companies decided to represent the data on a single graph over multiple days, in this case 14 days, with each individual day represented here. And we got to choose what we saw. Did we see the high glucoses or the low glucose? And that characterized the overall glycemic control. Well, as you can see here, overnight it seems to be within a target range, the dotted lines, but during the daytime, some days it's above, some days it's in the hypoglycemic range. In 2008, I introduced what is called the ambulatory glucose profile, a different way of looking at this, which was actually developed 20 years earlier when I developed meters with a memory. At that time, my residents and fellows could not understand that there was an underlying pattern. They could not see it. So I produced what was known as a modal day. We had a scattergram of all the glucose values, and you had to figure out what the pattern was. I then, both physiologically and mathematically, forced a pattern on it that made sense, that represented the extreme values, the center values, and gave us a better picture of the overall glycemic control of this individual. So made up of 5 curves, a median, as you can see here, the interquartile range, which represents 50% of the values, 25% above and below the median, representing 2 more curves, and then the interdecile range, representing the 10th to 90th percentile, so we can explain the outliers. Now we have a better way of looking at glucose for this individual over a period of time, because we know no 2 days appear to be alike. And to develop therapy, we've got to figure out a way of improving this overall control, not just a single day, but for multiple days over an extended period of time. And to do that, we have to address various aspects of glycemic control to understand this better. So before we get to that, I want to talk about one interesting factor that occurred in 2008 when I first introduced the idea of AGP. One of the companies, Abbott, picked up the idea right away and put it into its software. But the other companies, the other major manufacturers, said, no, we want to represent glucose differently. Unlike in cardiology, where all EKG machines were alike, most of the different companies represented glucose in different ways. And they had been doing this over the years, whether it was reflectance meters or now this new introduced idea, CGM. Well, by 2012, my group and the International Diabetes Center managed to convince the major companies that there was a better way to represent glucose overall, which was the AGP. So here is the CareLink AGP. It's the same as Abbott's AGP. It's the same as Dexcom's AGP. Essentially, you have here an average instead of a median, but that's pretty much the same. The interquartile range representing the 25th to 50th to 75th percentile. So you basically have a way of looking at the diurnal glucose pattern. So now that we have a common language, what can we do with it? Can we improve glycemic control? Well, in order to do that, we have to address several different components. As was mentioned by the previous speaker, time in range has become a very popular element. Before that, estimated HbA1c, average glucose, all of these were essentially single numbers representing in an attempt to represent an overall picture. What does it mean if someone is 75% time in range? And I'll show you that in the cases I'll present. Here you can see the range being 4 to 10 millimoles, that virtually all the values except in the evening are outside of range. So how could you represent that as time in range? Well, 20% of the values are in range, but never between the hours of about 6 a.m. and about 4 p.m. You don't find any values in range. So we've got to get down to the specificity, which is the concept of precision medicine. And in the specificity, we've got to be able to say what the glucose exposure is, whether there is excess exposure, and when that takes place. We've got to do that in the same way with glucose variability. And here I'm showing you a profile on the left and the individual days on the right. And as you can see, if you look at overnight, and now we look at the individual days, you can see it's fairly narrow. And actually, one day is very similar to the next. But when you go to the early morning hours, you'll see something different. Before we get to that, I want to introduce 4 terms that should be part of our lexicon in describing any of the variables that describe diabetes, such as hyperglycemia, hypoglycemia, variability. That is the magnitude of the events, the frequency, their duration, and their distribution. Once we understand that, we can target or make much more precise our therapies. That's why the pump works. It is actually targeting, determining the magnitude of an event, and then responding to that event by infusing an appropriate amount of insulin. So when we look at the mid part or the mid-morning period, now we can see a much wider variability going from hypoglycemia to significant hyperglycemia. So we have to understand that in order to understand how to improve that therapy. So when you look at hyperglycemia in this one chart at that one period, you can see that the magnitude is considerable. The frequency is 3 times. The duration is 2 hours. and it lasts for, and it's distributed between 8 and 1000 hours, or 8 a.m. to 10 a.m. in the morning. So now I want to take you to the real world and to the application of these principles in clinical practice. I have been very fortunate to work with my friends and colleagues in Portsmouth, England, at the Diabetes Center there, where I started the AGP Clinical Academy. The purpose of the academy essentially is to prepare physicians to be able to use these new technologies, whether it is CGM or pump therapy, in a way that will optimize glycemic control. So in this first case of type 1 diabetes, and I used MDI because that's much more common. However, we have a large number of pump patients that we've used the same approach. We can see in the overall glucose profile, so here's this 25-year-old female, 10 years duration of type 1 diabetes, fairly normal BMI. Her MDI regimen is 50 units per day, 25 of basal in the morning, and then pre-meal boluses, as you can see, 10, 5, 10, a fairly straightforward model or approach to taking care of diabetes. What you can see here, however, are there some significant problems that have to be addressed. There's hyperglycemia in the early hours of the day, throughout the morning hours, and I'll show you this with the point here. And there is some hypoglycemia very early in the morning, and again at other points in the day. And we have to understand this in terms of their magnitude, frequency, duration, and distribution. And we can see those events here, and I've put a table below to show you that I've just simply listed them there. It's a simple way of doing that. Again, understanding hypoglycemia's magnitude, meaning how far it goes down. In this case, it's very, very few, less than a millimole, below 4 millimoles. So it's not very, very bad, but its frequency is 3 times a day. And we have the variability. So the wider areas of glucose in the middle of in the early morning hours, and then in the middle of the evening hours. So what would you do to improve glycemic control here? And what is your goal? Clearly, to put more of the values within the target range, time in range being a major goal. But we want to do that in very specific areas. We want to do that here, and we want to do that in the evening hours. So the decision was made to split the basal insulin and do some minor adjustments to the bolus insulin. And the question is, again, listening to the way we approach diabetes, we have to look at the outcomes. So when you take a look at this now, 6 months later, we've seen some improvement. And one of the beauties of an ambulatory glucose profile is you can actually see the results. They're not numeric, although they can be converted to numbers, but they're really visual. And what you see here is that there is still hypoglycemia to deal with in the morning. There is still variability in the mid-morning hours, but the hypoglycemia in the middle of the day has gone, and the variability at the end of the day has gone. So we've managed to target 4 areas and dealt with 2 of them very well. Now here is over 12 months. And my experience with the Portsmouth group is that we have been now following patients since 2012. So we've had almost 8 years, or 6 to 8 years of following patients very effectively, all on continuous glucose monitoring. So what have we accomplished? Number 3 AGP is the last one we took, which would have been in, I think, November. So the exposure to glucose remained unchanged, around 6.5%, 6.4%. Improvement in variability, reduced hypoglycemia, and reduced hyperglycemia. End result was a significant improvement in the time and range, but I can tell you exactly where that improvement was. So we improved it in the morning and we improved it in the evening, and we managed to achieve our clinical goal. Obviously, when you think about diabetes and you think about 95% of the people with diabetes, we're dealing with type 2 diabetes. The same technology can have a vital effect on individuals with type 2 diabetes. This is the glucose profile of a 65-year-old gentleman with 20 years duration of type 2 diabetes, significantly obese, on a regimen of 3 different agents, oral agents, metformin, sitagliptin, and glycoside, and an HbA1c of 10.5%. Looking at the overall AGP, you can clearly see virtually nothing is within the target range. Very few values, and the target being set at 6 to 9 millimoles, there's only a few values within the target range. So what do you do about something like this? How do you respond to the exposure, the variability, the hypoglycemia, of which there is none, and the significant hyperglycemia? The decision on the part of the physicians here was to drop the SU and the DPP-4 and start on a GLP-1. The basic rationale behind this was that these therapies, they had reached their maximum, they were not benefiting the patient, and waiting any longer did not seem to make any sense whatsoever. And we still wanted to give the individual a good quality of life. Question is, were they effective? So here is the AGP at baseline, and here is the AGP after 1 month on the combination of keeping the metformin and the GLP-1. And you can see now where the results improved. You can see that there was significant improvement overall. There was a drop in the glucose exposure by nearly 2 percentage points. But in addition, we have a narrower, much flatter profile than we had previously. And I'm going to superimpose it on top so you can see how much benefit we've achieved. Now, we still have not reached ultimate good control. And so the physicians decided to add insulin with the idea of overall lowering the profile and stabilizing it. And so we added AM basal insulin at a very, very low dose of 0.1 unit per kilogram. So this is the metformin GLP-1 before the addition of insulin. This is with the addition of insulin. So you can see the profiles improved significantly from previously. And this is over the last 2 years, we've been following the patient, and they're now up to 0.6 units per kilogram. And this is a very recent profile. So the baseline up at the top, a 65-year-old male, 20 years on classic oral agents with essentially very, very poor glycemic control. What is medicine all about? What is our purpose? To do this. Get him to 66 years old with now 21 years duration, but with a profile that should protect him from significant complications. That's the underlying purpose to all of this. Our discussions of technology, whether it be a pump or CGM or the combination of the two, is to achieve this level of glycemic control, not shown just in numbers, but in actually looking at the overall diurnal profile. So we got reduced exposure, reduced variability, time and range improved by 95%. No hypoglycemia, and slight weight reduction. I want to end on a simple note. If you clearly state why you're doing what you're doing in medicine, that is, if you have a purpose and it's understood what that purpose is, if the decision is consistent with the facts and figures, that is the scientific evidence, not simply I feel good, but scientific evidence that's verifiable, like CGM data, then the facts and figures will reinforce the decision. The second AGP will be better than the first. But if the decision flies against the facts, then we have to be ready to make changes in the therapies so that we can follow the science. Thank you very much. Been a pleasure.
Thank you very much. That was really an eye-opener. It actually, the second case is, I would call it as a prototype case, because we do see such many type 2 diabetics with a high, with a very disturbed profile who have been maxed on their oral therapies. And that was really an eye-opener. Dr. Rakesh, would you like to initiate the question answer session?
Yeah, I think we can go ahead with the question answer. We have a few minutes for a few questions. So the first question is for Dr. Robert. The question is with regards to the cost of the pump, like specifically about the disposables. So for Indian patients, the disposables are very costly and that you need for the lifelong. So the question, or probably the suggestion is that can we expect the cost of disposables to go down in near future?
Well, I think the answer is, like every technology, as it matures and as the field expands, the prices usually do go down. There are many ways to help it go down, and I think all the device manufacturers are working on simplifying the manufacturing, simplifying the materials, and I expect that over time there will be a decrease in cost, not only because of competition, which always causes prices to go down, but I think because of the innovation that is really rampant across our industry. So I think there's, I'm very optimistic about the future. But cost, and you know, without going on to a diatribe about cost, I think cost and benefit have to be looked at together. And you know, and the benefit in achieving these kinds of glycemic improvements, whether it's with automated insulin delivery or with very smart use of CGM, that benefit on an individual level for the patient and for the healthcare system has been shown over and over again to be very cost effective. So we have to think about this in more general terms, not only for what it costs the individual patient in the short run, but what it costs the patient in the long run and the healthcare system in the long run as well.
Right.
Yeah, that's right. Dr. Roger, there is a very relevant question here. In fact, even it's my question. Dr. Daya and Dr. Hazra would like to know. So, is there a possibility that there are times when there is a lot of hypoglycemia and hyperglycemic episodes recorded by the Libre Pro, which may not match clinically in the real sense, in vitro hyperglycemia and hypoglycemia? Do they actually concur with each other accurately through and through all the spectrum of hypo and hyper, or is the periods where the CGM may be misguiding us?
As we're learning more and more about CGM, my experience and my perspective is it is the most reliable data for hyper and hypoglycemia that you can get. Okay. However, it has its limitations. There are drug interferences, as you know, with certain drugs may interfere. And there are times where it simply doesn't make sense, logical sense. And we have to use an alternate way of measuring it. But for the majority of the individuals, for the majority of the time, and as you know, the hybrid closed loop systems are dependent upon CGM. And they've been approved. And so my gut reaction is there was a time when CGM was first introduced that naturally there were all kinds of problems, especially because of calibration issues. We've resolved the calibration issues, and those will even get better over time. And things will be made much simpler. Now you can get the data coming to you on your phone, so that's going to make things a lot easier. And as I say, as we learn more and more, it's going to be better and better. All technology improves. The key is to understand, why do we need this technology in the first place? So I have a simple answer. How else are we going to make the clinical decision? It comes down to simply asking a question: what are you going to rely on if you don't have CGM.
Absolutely. Is it true? I have been told in some meetings that when the LibrePro CGM records a sugar level below 40, it's to be ignored. It's not accurate if it shows a... And most of the LibrePros that I have done in my patients, they show in the majority the hypoglycemias they have been recorded as 230 minutes, 160 minutes, which is actually mind-boggling.
Mm-hmm.
Is that really reliable?
I've not heard that, and you know, I don't work with any of the manufacturers, so some of this is proprietary information that they may have. I would suggest that if it's device specific, that one get back in touch with the manufacturer and get as much information as you can. They do have much more data on real life experience than I have. I can tell you this, from the 6 or 7 years working with my friends in Portsmouth and my colleagues at the International Diabetes Center and at Mayo Clinic and friends at the University of Virginia, CGM has now become the basis for their research. That's their research tool, which I'm glad of, because now you have accurate and reliable data. So yes, there will be some errors, but clearly they're not significant enough. Now for one individual, yes, they always are. But as a larger population-based use, I would say not a problem. It's nothing to be worried about or necessary to address that way.
I think Dr. Meena wants to add something. Dr. Meena, you can unmute yourself. You're muted. But you're still mute. You need to unmute yourself.
Yes. Yeah. My question to you, sir, is that does temperature make a difference? Because post-lockdown, I had some Libre sensors which were totally erratic. So in a country like India, do you think that the sensors should be stored in a particular temperature, 2 to 8 degrees or whatever? Or can they be kept outside?
And again, I've worked with groups in India. I've worked with groups in Hong Kong and Singapore, China. I've not heard that temperature, ambient temperature, is a major factor. For some individuals who sweat, sometimes there's difficulty in, but I think that they've improved the adhesive. But I've not heard that. I mean, it's remarkable when you think the technology is 10 years, 12 years old. We're going to find some problems with it. But again, it's so much more superior to any other means of collecting data. I don't know what our choices are. I mean, I don't know what I would, if you asked me and said, tell me an alternative, I'd say there's no alternative. If you want to understand the glycemic patterns of an individual, if you're thinking of putting an individual on a pump, my recommendation is before you do anything else, put them on CGM for 2 or 4 weeks. Make sure you understand their underlying pattern, and then use that technology. If you're moving to an expensive therapy from an inexpensive therapy, the cost-benefit analysis is to benefit that patient, you've got to have a better outcome. And if the more expensive, like a GLP-1, much more expensive than the inexpensive sulfonylureas, then you should be able to justify it by improving their overall profile. Same thing with a pump, same thing from MDI to a pump. That's the whole notion of all of this technology, to give us better ammunition with which we can fight a major war, which is getting worse. As you heard from Dr. Bob, the whole idea of individuals in the United States, type 1 diabetes, treated at the best institutions, not improving. That's terrible. There should have been improvement by now. And we have the best technologies in the world. So we're still lacking in our understanding enough about diabetes to put in behavior and to put in the factors of diet and to understand this variability and how unpredictable diabetes can be.
Professor Maze, if I would say, like Steve Jobs with his Apple has changed the way we look at computers. You have changed with AGP the way we look at diabetes. So thank you for that. And then any words to inspire the generation next to come up with innovation?
Yes, I mean, that is the key. Whether it'll be, implantables, whether pumps will be useful for type 2 diabetes, I think they would. And I think we have to think about the day that we start considering that as a major therapy. The gentleman in the case number 2 benefited tremendously by simply the addition of insulin, which was unheard of 20 years ago.
Absolutely.
Oral agent insulin, you had to fight everybody to be willing to consider putting individuals on insulin who were being treated with oral agents. We now know that that's effective and it's safe.
Thank you, Dr. Roger. I think we are done now because the panelists for the next session are already there, and
thank you.
We already crossed our time. So, Dr. Alok, do you agree if we can close the session now? And
yes, sure, absolutely. And as a closing note, I'd like to offer thanks, and it was a treat. It was a wonderful presentation. Sunday morning started on a fantastic note, and you've spoken milestones in half an hour. So I'd like to thank the organizers, Dr. Bansi, my colleague panelists here, our rapporteur, and both the speakers for an outstanding talk delivery. Thank you very much.
Thank you.
Thank you.
Thank you to all the speakers, both the speaker and the chairperson, for the sharing the first session. And I welcome Dr. Bharat Sabu for our next session. He is going to introduce our chairperson, Dr. Bharat Sabu.
Before Bharat starts, I just wanted to have, the slides from the company, and there is one question which was asked by Dr. Ashok Das, do we have a AGP Academy? It is, we have AGP Academy in our country, and Dr. Mithun Bhartiya from Guwahati, he heads, and I'm the part of that AGP Academy also. And thanks Dr. Roger and Dr. Bob for making it possible on Saturday night from USA. It's late evening. Thank you once again.
Thank you, Roger. Thank you.
And thank you. It's a pleasure, and I look forward one day to see everybody in person.
Yeah. Thank you.
So do we.
Take care and happy holidays. Happy holidays.
So over to now Bharat for to introduce the next chairperson.
A very good morning to all of you. First of all, I would like to thank Bansi sir and the team DiaCare for giving me this opportunity here. And the next session which we are dealing today is nothing new in diabetes. It is about the newer concepts. And today we have with us two eminent chairpersons, Dr. Meena Chhabra ma'am from New Delhi, and my dear friend, Dr. Ashutosh Chaturvedi from Jaipur for the next session. So over to you, ma'am.
Good morning, everybody. And it's a cold, wintry day, and I have the proud privilege of introducing the first speaker, Dr. Juliana Chan. Professor Juliana Chan is a clinician scientist graduated from the Liverpool University, UK, with accreditations in endocrinology and clinical pharmacology after receiving a period of training in psychiatry. This is the most interesting part of her CV, which I love, that she also knows how to deal with the psychology of the patient. Over the years, she has organized many conferences, seminars, and workshops. She is currently a member of the steering committee in the Hong Kong government for control and prevention of non-communicable diseases, and a Hong Kong government-funded theme-based research involving diabetes, and she takes personalized care of patients. So over to Dr. Juliana Chan for her first talk. A very warm welcome, Dr. Juliana. And the stage is all yours.
Thank you, Dr. Meena, for inviting me and for the introduction. So let me just share my slides. Can you see my slide?
No, not.
Okay, let me just try again. Okay, here we are. Share screen. Okay, share. So can you see my slide now?
Yes, we can.
Okay, thank you. So firstly, I would like to thank the organizing committee, particularly Dr. Sabu for inviting me to give this talk. So I thought I would take this opportunity to really share with you the Lancet Commission report on diabetes entitled Using Data to Transform People's Life and also Diabetes Care, which was really just published online in November and is now actually full printed form in the January issue of the Lancet. Okay, let me just see. So we launched this report on the World Diabetes Day, the 14th of November, and you can download the entire report together with the editorial, the commentaries, and also a video as well as this whole slide set actually from the Lancet website. So this really represents a 4-year project by 44 global experts and researchers in epidemiology, public health, clinical care, and health economics from 5 continents to propose action plans in order to reduce the burden of diabetes and NCD. In this particular, over these 4 years, we have done really extensive data mining, to actually curate, to review the literature and also to synthesize new evidence, and most importantly, really propose actions, and also in order to at both a macro environment level as well as a micro environment level in order to improve care. So here you could see that actually, despite the availability of insulin, for nearly 100 years, and we're going to celebrate the centenary insulin next year, there is still considerable variation in type 1 diabetes related mortality, as high as, for example, 40 per 1,000 person years in areas like Ghana and also Middle Europe and Central Asia. As well as to 0, for example, in high-income carriers like India. It is this epidemiology, this variation that indicate there is tremendous opportunities for improvement. Even in high income, however, we've already heard from Dr. Mazzi that even in type 1 diabetes, despite all the technologies, we still have a lot of improvement to make. This is really the Pittsburgh Diabetes Register established in USA, and you could see that over time, these are the years of diagnosis of these individuals, and that's really over time there is really the mortality rate or the diabetes related complications have not really changed over these periods of time. So people diagnosed in 1950 as compared to people diagnosed in 1975, although there's a seemingly reduced incidence of complications. Actually, statistically, they were not different. They were very similar. Of course, within this, there's actually considerable variations with a lot of social disparity, particularly in people who are coming from the minor ethnic group, as well as people from, the low-income groups, which obviously give the highest incidence of complications. However, we use modeling to show that actually we can make a difference if we can actually improve care. So if we use, we now know even in high income countries, the standard mortality rates of people with type 1 diabetes is 2.5 compared to those without diabetes. And even these, many of these people in the high income countries are receiving comprehensive care. So in upper middle income countries, and for those people who are receiving intermediate care, the SMR is 4.9. However, this increased further to about 13 to 33 standard mortality rates compared to those without diabetes. And note that these are all very young people, depending where they live, whether it's lower middle income countries and most of these people are really just receiving intermediate care or even very minimal care. So in 2017, 1.61 million people with type 1 diabetes aged less than 25 years were diagnosed before the age of 20. And during this period of time, 14,000 young individuals with type 1 diabetes died. We estimated that 84% of these deaths, could have been prevented if all nations implemented guideline-based intermediate care, for which we mean basal bolus human insulin regimen, tools for self-monitoring blood glucose, education for self-management, and regular A1C monitoring and complication screening. And if we implement comprehensive care, which include CGM, for example, you could see that actually the rate of mortality can be tremendously reduced. We also, over the last 30 years, we've really done a lot of research, and there is now evidence-based strategy in type 1 diabetes, including, the reduction of A1C, the blood pressure, the LDL cholesterol. They can each individually or collectively reduce the risk of cardiovascular disease or cause death by 10 to 20% in people with type 2 diabetes. In particular, the use of statins and renin-angiotensin systems inhibitors can also prevent this cardiovascular renal event, by 20 to 40% in people with or without diabetes or high risk for having diabetes. SGLT2 inhibitors, the GLP-1 receptor agonists, they are game changers, and we know that they can independently reduce severe and renal events and death. Most importantly, to make this happen, we need to use data-driven, team-based integrated care through care reorganizations, and that has now been shown to reduce cardiovascular events by 20 to 60%. And in terms of prevention, if we can sustain weight reduction in obese subjects with type 2 diabetes who have diabetes for less than 6 years, by 15 kilograms more, we can actually induce remission of type 2 diabetes for up to 2 years. Structured lifestyle modification, structured lifestyle intervention and use of metformin can also each prevent or delay type 2 diabetes in individuals with impaired glucose tolerance. But the challenge is, how do we make this happen? We've heard that actually, despite all these technologies, we now have nearly 9 drugs, oral drugs and injectables. These are really large surveys. So we curated data for 1.9 million people with type 2 diabetes in cohorts with at least 5,000 individuals. And you could see that particularly in type 1 diabetes and young people with type 2 diabetes, really less than 50% of these people are at the goal of 7%, which is still 1% higher than a normal A1C. However, and this obviously contributes to the increasing incidence of complications and death related to diabetes. Once again, it is the variations that actually give us the hope that something can be done. Here you could see that in many high income areas, there is actually declining, the mortality rate of diabetes is actually declining in some of these countries where, for example, there are universal health coverage, there is better healthcare system, and that people are actually more informed. And so how do we actually translate this kind of benefit to the greater number of people in the low and middle countries, which actually account for 80% of the people with complications. 80% of people people with diabetes are actually living in low and middle income countries. Again, we performed extensive meta-analysis, and again, really simple things like reducing A1C by 0.9%, reducing 10 millimeters mercury of blood pressure, and the benefit is more obvious in those with high blood pressure, and also than those with lower blood pressure, and also the reduction of 1 millimoles of LDL cholesterol. We could really reduce, both all-cause death, cardiovascular death, ischemic heart disease, and stroke, anywhere between 10 to 30%. And again, using modeling, we estimated that in these 10 top lower middle income countries, including India, which account for 50% of the diabetes burden in the world, that actually in 2017, you could see that we can expect 3 million of deaths due to diabetes, and 1/3 of this is actually due to cardiovascular disease, either due to stroke or myocardial infarction. However, by ensuring that these people are having access to statins, to reduce the cholesterol, and also blood pressure drugs to reduce systolic blood pressure, we can actually reduce nearly 1 million deaths just by ensuring that these drugs are given to these individuals. However, in this report, we also pointed out that there is actually considerable variations in terms of the prices of these life-saving drugs, even though many of these drugs are now generic. And of course, the high price of a lot of the insulin has always been in the headline, even in high-income countries. And so this is really where the government has to do something to improve the macro environment to ensure that these life-saving drugs are actually affordable and accessible to all people with diabetes. At the same time, we also, while we have now sort of data suggesting diabetes are highly treatable, there are now also emerging challenges. And that is particularly the rising incidence of young onset diabetes, which will result in premature death and comorbidities after 20 or 30 years of uncontrolled or unmanaged diabetes. And this is really, again, showing that because of the lower risk of death among people, among young people without diabetes, the standard mortality rate of people with diabetes is particularly stark in people who are in the younger age group. And more importantly, these young people are actually at risk of multiple morbidities, and particularly, this is really a study really showing the accrual of hospitalizations during a lifetime in people with young onset diabetes, and that as time goes on, during the 30 years, these people would have spent more than 100 days of in the hospital, and with with mental illness being a very important cause of hospitalization during the early course of disease, and then later on replaced by cardiovascular and renal diseases. And here, infections is also a very important cause of hospitalization in these young people. The important thing is, again, we've heard repeatedly from previous lectures that we are dealing with behavior. And in order to change behavior, education and also motivations are important. And to do that, relying on doctors alone is difficult. And here, this is a meta-analysis showing that by really shifting tasks, in other words, using other non-physician staff to relate to engage the individuals with diabetes, and also to maintain the provider and patient communications, focusing on promoting self-management is associated with reduction in A1C, blood pressure, and LDL cholesterol, and these are substantial reduction in risk factors. By these quality improvement program on top of whatever is happening to these individuals. So in this Lancet report, we highlight the importance of using preferably diabetes centers, diabetes teams, and also to implement plans and establish registers in order to integrate care delivery, in order to also educate not just the patients, but also the professionals. And most importantly, is to collect data systematically to drive actions. And this is really showing that specialist diabetes centers really serve multiple purposes. Here, we have diabetes mini teams and multidisciplinary diabetes centers work collectively to provide different services, particularly structured assessment, diabetes register for risk stratification and care triage. Importantly, to use that data to provide feedback and to empower and to encore individuals. And in order to provide continuing care, to promote self-management and to provide ongoing social support and lifestyle changes. And if we can link these registers to population and hospitalization statistics, we'll be able to understand more about the causes and consequences of diabetes and to evaluate the impact of these programs. In this report, we also highlight, a data set, to establish diabetes register, which need to be collected at baseline and maybe every 2 years. And this will ensure quality assurance and also to, deliver these multiple purposes. And imagine a person diagnosed with diabetes at the age of 40, all we need is really 20 assessment throughout his life journey, which could really make a huge difference to this outcome. So again, using modeling, we were able to demonstrate that, for example, here, using the data in China, and assuming that 50% of people are diagnosed, and that among people who are diagnosed, 70% are treated for 3 years in order to reduce the various sorts of A1C, LDL cholesterol, and also blood pressure. And by actually reducing all these risk factors on top of the integrated care, again, we can actually reduce nearly 1 million cardiovascular events. And this is really showing that, if we start because we know most of these complications are 3 to 9 times more expensive than those without complications, the sort of money that we can save, talking about in terms of billions. And indeed, there are examples just really using Hong Kong, which is a small city, but a very reasonably good system, and where we can collect data very systematically. We're able to show that this territory-wide risk assessment and management program have really contributed towards the reduction, 50 to 70% risk reduction in terms of death rates, in all age groups, particularly overall. But the evidence is actually less in young people, which is another unmet need. But by and large, you could see that actually there is significant reduction in terms of all-cause death, in terms of diabetes complications, and in terms of acute complications such as tuberculosis. Of course, diabetes is not just a personal problem, it is also a societal problem. So in this report, we really give a very macro view so that there is something for everybody, and highlighting that really we are actually facing demographic and also ecosystem changes. And there are a lot of changes in terms of lifestyle, which contribute to the development of these risk factors, which culminate to cause these multiple comorbidities and ultimately premature death. And every level, we will need a integrated and cohesive strategies in order to deliver context-relevant policies, to promote community health literacy and patient empowerment, strengthen the primary care, which is well linked to the secondary and tertiary care, in order to reduce all these the morbidities and mortalities. And so what we are proposing are absolutely in line with what are being proposed by the United Nations in terms of the SDG, the Sustainable Developmental Goals, the WHO, in terms of the professional guidelines, in terms of the framework for control of NCD, and also the professional guidelines in terms of how to deliver care on an individual basis. So at the individual level, integrate care with teams, community level, lifestyle changes, use of metformin, health policies such as sugar tests and reducing trans fats, of course, universal health coverage, and a societal level, really protecting the environment, reducing social disparity, and improving health literacy, general education. But more importantly, diabetes is a lifelong disease. And here, we're really talking about, the transgenerational nature of diabetes, and that we really have to improve both the maternal and also childhood health in order to reduce childhood obesity, improve maternal health, in order to stop the cycle of the vicious cycle of diabetes begetting diabetes. And now we highlighted a very important concept, and that is in clinical care. Very often we do observational studies, through the epidemiology, we understand the risk factors, the effect size, and then we actually do intervention, and very often we do pilot studies, feasibility studies, then we do definitive randomized trials, and then we synthesize the evidence using meta-analysis, and this will then actually drive the policy and from the basis of professional guidelines. However, in the more macro environment, particularly when we talk about population policy, and we will actually need a different approach, and that is we need the political will, actually based on available evidence, to actually implement the policies. But most importantly is to continually gather data in order to evaluate the impact of these policies in a naturalistic environment. And by so doing, we start actually gathering the synthesis, gathering the evidence, and then to actually inform decisions. So these are really two approaches how we actually deliver evidence-based practice and also practice-based evaluation. So again, in this comprehensive report, we use modeling, again, based on available evidence, to really estimate, for example, in a population, assuming how many people have diabetes, how many people are at risk of developing diabetes, and how many people are at risk of actually developing pre-diabetes, because pre-diabetes and diabetes can all convert to cardiovascular diseases. And if we can actually implement in societal population and community-based strategies by promoting public health, early detection and intervention, by strengthening both the primary healthcare system, then we can estimate that after 10 years, we can actually prevent 22,000 diabetes events and also 17,000 cardiovascular events. And for 1.3 billion people in China, after 20 years, we could have saved 44 million cases of diabetes and 67 million of cases of cardiovascular diseases. So, so I think it is important again to note that at least from, I understand the audience are mainly clinicians, that there is really consensus both at the IDF as well as, for example, KDIGO, and particularly in this Lancet report, that because of the silent and continuous progressive nature of diabetes, there is really a need to register these individuals systematically, to assess the risk, to stratify the risk, and to review these risk factors in order to control them, and relay these risk factors back to the patients and the care providers to reinforce compliance, and also for early intervention and to recall to avoid default. Really, our goals are simple: to promote self-management, to treat to multiple targets, and with ongoing medical and psychosocial support. And these databases can not only influence decision at a personalized level, a bit like the CGM, the doctor's level, other healthcare professional, but also at the system level. Most importantly, it's the payers, so that they understand the value of preventive care in order to save life and money. So with that, I would like to finish and really encourage you to see this video. These are, again, as I said, you can download the link from the Lancet website. And there is a Lancet webinar where we have a 1 hour discussion where we have the commissioners summarizing some of the key messages. We have Dr. Richard Horton, the editor of Lancet, that invite us to do this analysis, his view about this problem. We have stories actually from patients, and including patients from India, really telling their perspective, and this message really come through, and that is education. Only if they know, they would have changed, they would have improved their care, and they would have been more compliant with the treatment in order not to get the unnecessary heart attack, etc. And also people from, clinicians from developing world saying how much they need help from the government and also from the payers to make that happen. And so I hope, my brief discussion presentation will motivate, and also hopefully some of you to join this global movement in order to use data to translate, to use data to close the gaps. And I think one of the important things is really we have to close the professional knowledge gaps, particularly like these kind of meetings. And I think the one thing out of this COVID-19 is now these educational forum can reach out to so many people. But of course, importantly, we should make that knowledge available and into actions and to help patients. Thank you.
Thank you for that wonderful talk, Dr. Juliana. Can we ask questions now, Dr. Bansi?
Yes,
or we proceed?
yes, Meena, I think it's better to ask the question now because all three talks are different. So, I mean, you can continue the discussion and then we can ask the Jibin too.
Dr. Juliana, so this is awesome because you can motivate governments to change their strategies if you provide data to them. And you could also tell them that if we do a CGMS, we prevent complications. So a CGMS may be costly, but the cost of complications is even more. So congratulations, and super proud of you for doing what you're doing. But could you tell us, how do you take it at the primary level? Do you address schools, the principal, the teachers, or do you address communities and community centers, or is it via television media? How do you motivate the community?
So this is really a report directed to many planners and decision makers, and I'm really pleased that the WHO has also taken notice of this particular report. And in fact, on the Diabetes Day, there was a 1 hour WHO webinar just precedes the Lancet webinar. And now we have a new director for the NCD, and Dr. Ante, and she's a gynecologist, but she's very committed to really implement, the evidence to practice, because really it is long overdue. I think the COVID-19 has told us, it is really the people with diabetes, they are really at the front, right? And we must, do something about that. So I think they are now lobbying a lot of the government and also industry and funding agencies to improve the macro environment, particularly the access to drugs that are really important, but not just the medications, but also the monitoring tools, right? The laboratory tests, and also, the care team, which are the total package. But at the same time, they also look for champions to actually implement some of these integrated, data-driven integrated care model, again, in order to, build capacity and also to inform the decision makers. So actually next year, there is actually so they are doing this in collaboration with University of Toronto because of the centenary of insulin next year. And so there will be a seminar actually in April. And meanwhile, I think, I think it would be really good to have some champions to actually implement some of these actions. So I think, I think this is really everybody's business. In our conclusion, we say in many ways, each one of us might probably have contributed to this ecosystem, the globalizations, the good side and the not so good side, the environment, the technology, the food technology, the environment that actually promote the obesity, and then also, despite the changes in the system, we have not really changed our healthcare system. We are still stopping at we're still really fragmented primary care, as well as, the high the intensive acute care. But what we really need is an integrated care model that link people all the way from primary care to actually acute care. And I think, we have actually give a work plan, right, for people to implement it. So, I think it's now up to us to take whatever actions that we think we're in a position to do it. But I think evaluation and reporting it and sharing of best practices will be really very important to motivate more people to join the movement. And that is the objective of the Lancet Commission.
Thank you. Thank you so much. More power to you, Dr. Juliana. More power to you, and may you be able to motivate governments and agencies. Thank you so much. And so I think we proceed to the next talk, and I request my co-chairperson to introduce the next speaker.
Thank you so much, ma'am. I take this opportunity to thank you, respected Dr. Bansi Sabu sir and the organizing committee of DICARECON. Thanks, Dr. Bharat Sabu sir, for a warm welcome. Very good morning to all of you from land of Rajasthan, India. And I have this pleasure to introduce a very multifaceted personality, Dr. Jibin Chi, who has been versatile in many fields. He has obtained his medical degree from Medical University of China. Then he went in the field of preventative dentistry in the middle of 90s. After that, he obtained a master's degree in international business administration and a master's degree in business informatics from Rotterdam School of Management in the Netherlands. To his professional career, he has worked in preventative medicine, biopharmaceutical, tissue engineering, medical device and biotech companies across the globe. In the past 3 decades, he has been specialized in transitional medicine to bring innovation and scientific advancement into the medical community. And owing to his diverse experience and knowledge, he has engaged in various academic activities and a speaker in diverse scientific conferences at the international level. He has been attending the Japanese AIDS Summit Conference, Swedish Harmony Expo, and Second Eastern European Chinese Medicine Annual Meeting. To our pleasure, he was also international faculty at the recently concluded 45th annual meeting of RSSDI and was invited speaker at the 7th Diabetes Asia Study Group meeting. He was also a lecturer and therapist at the Holiday at Sea Medical Wellness Cruise in USA, which is one of the most top 100 wellness holidays voted by National Geographic magazine. And he's versatile in his, he's a Chinese, but he's Dutch national now, and he's currently residing in Sweden. He speaks English, Dutch, Chinese, and Japanese. So I welcome Dr. Jibin Chi. Welcome.
Thank you very much for the introduction, and it's a great pleasure to be at this conference again. And now I try to share the slides and see. Can you see the slides?
Yeah, kindly make it full screen, sir.
Yeah, sure. Okay.
Yeah, okay.
All right. Today I would like to introduce a new disruptive theory to looking at what have went wrong over the last century with diabetes. See, by next year, it's exactly 1 century with the discovery of insulin. So the discovery of insulin is supposed to be the biggest breakthrough in medical history. And we have 4 Nobel Prize winners associated with insulin and insulin test. And if you look at insulin, is absolutely the best studied medicine, the best manufactured medicine, and today is also the biggest product in the whole world. So by 2025, it will be close to $60 billion worldwide annually. But how come with the best possible medicine, the best innovation in the world, we make diabetes a rare disease to be a pandemic crisis? Today, with all the success, we have not only each 6 seconds, 1 person died, but we also every 5 seconds, 1 person developing the diabetes. So I think we have to ask a fundamental question. So what is diabetes? This is the IDF definition. Diabetes is a chronic disease with pancreas and no longer be able to make insulin. So now let's look at what happened over the last centuries. There's only one focus that we're looking at to restore insulin release. However, if you look at the so-called counterpart of insulin, glucagon, it's not about more or less, it's completely opposite. So when you have intake of a meal, your sugar level already high, but glucagon put out 75% endogenous sugar. So how come glucagon is not possibly the elephant in the room in the fight on diabetes? So glucagon, since its discovery, is being ill-fated because the insulin discovery, and also it's extremely challenging to accurately measure glucagon, and the mismeasurement is up to 10 to 30 fold. So just recently, there's a study looking at the 10 commercial glucagons, and none of them can really satisfy the clinical scientific need. So that has been a major challenge that we couldn't really understand what's going on with glucagon. So now today, with the understanding of glucagon with the new technology, what do we really found out? Glucagon, we've been fundamentally wrong. It is not a counterpart of insulin. It's not actually sugar. The fundamental role of glucagon is regulating energy, amino acid metabolism. And the definition of glucagon also should be changed. So how that impact on diabetes? Let's look at this simple study, everybody familiar. Using healthy subject, you do an OGTT, compare with mixed diet. So what happened? This is traditionally what we understand. In healthy subject, you see no difference with doing OGTT or mixed diet. Now, with the new development, looking at accurate measuring glucagon, this is the outcome. In healthy subject, when you have mixed diet, present of sugar and protein, insulin and glucagon release at same time. So glucagon goes up at the same time in healthy subject. This is exactly what we see in diabetes patient. Insulin glucagon release parallel. So this phenomenon not only presented in healthy study, but also in animal study, in obese patients, in bariatric surgery, before and after, all show the same consistent result. As soon as has mixed diet, insulin glucagon released at the same time. So just take a moment to understand what's going on here. See, if you drive a car, you have brake and acceleration. You can use brake and acceleration at any time. Doesn't matter how fast or how slow you drive the car. But one thing you never do is put acceleration with the brake at same time. And this is exactly what's happening when you have a parallel release of insulin glucagon. So research is to say what everybody else has seen, yet to think what nobody else has solved. So this is the theory I want to bring forward today to show to the world why we've been so fundamentally wrong. Let's look at insulin resistance. Study shows even normal glucose tolerance people have already lost 60% of beta cell function. Now, the normal relationship between insulin and glucagon is maintained by this. The pulsatile reverse release of insulin and glucagon, and at the same time, particularly phase 1 burst release of insulin to control glucagon. And this is facilitated by two mechanisms. One is GIP regulation, the incretin, and the other is actually high concentration of insulin in the islet, which is 100-fold more than the serum, and also the same in the liver. Now, once we have a parallel glucagon and insulin release, what happens? All this mechanism is not going to work. So there's only one way to make it work, is GIP release, which stimulates insulin and glucagon release at the same time. And this parallel release also caused conflict in the pancreas and liver. And in this conflict, liver must be a winner because the liver is second largest organ and has extreme regenerative capacity, but pancreas doesn't. And why beta cell function has to be disabled, and also why insulin resistance. It has come to the fundamental role of glucagon. Glucagon is not a managing sugar. It's extremely important for our physiological conditions, and particularly with energy expenditure, stress response, and energy expenditure proteins, and even with autophagy. So today, that's why today's study shows that even for diabetes patients, glucagon should not be suppressed. It's critically important because important regulating energy expenditure. However, the very interesting thing is the energy expenditure role of glucagon will be suppressed when you have a high concentration of insulin. So today, if you think about this, what are we being fundamentally wrong with increased insulin, particularly long-lasting insulin? You suppress the energy expenditure role. So now, does it really make any sense? Let's look at a very interesting study by Dr. Chu, president of IDF. His group conducted 10 years follow-up looking at onset of diabetes, say, fasting total GIP level significantly associated with diabetes development and independent of any other factors. And well, GLP-1 were not. And what is even more interesting novel finding is that the elevation of fasting GIP level even before diabetes and even in healthy subjects. This is exactly what we're talking about, a parallel release of insulin glucagon driven by GIP function, elevated GIP function. So now let's look at the diabetes again. So what is going on with insulin resistance? So we understand liver and muscle insulin resistance established much earlier before onset of diabetes. In the muscle insulin resistance, in both animal and human, you do not develop it into diabetes. However, in liver insulin resistance, you do develop into diabetes, and also not only diabetes, also liver diseases, atherosclerosis, all associated with liver insulin resistance. And now, the insulin resistance is accelerated with the fasting glucose elevation. And today, just by measuring the fasting glucagon level, you already can differentiate between healthy diabetes, obesity, and prediabetes. So now, what is happening? Diabetes is not even pancreatic disease. It's liver originated. And you look at glucagon dysregulation happen not only in diabetes, but also in liver disease, like NAFLD and NASH. And NAFLD today is 25% of general population. So today, if you look at glucagon dysregulation, not only with diabetes, not only with liver disease, but also with thyroid dysfunction, which is discussed a lot in diabetes, they parallel with each other. So liver, as original site of diabetes, was originally already brought up in the 18th centuries by the greatest man of all science. In the 18th centuries, Dr. Bernard already talked about a sugar-like substance from the liver that is related to our nutrition and food and responsible for diabetes. Because of his theory, an ENT doctor reversed that obese patient who hospitalized more than 20 times. So now, let's look at diabetes development model. This we've been having following for the last century. We look at sugar goes up because of insulin. Now with this, we say diabetes should have a different model. The development diabetes is a crossroad between the sugar and protein, insulin and glucagon. So with this, the onset of diabetes is starting with parallel insulin glucagon release and relate to dysfunction of GIP and glucagon, and later liver, and then come to pancreas and beta cell dysfunction. In the end, beta cell turn into alpha cell, which has also been proven by scientific study. So if you would put this model to then really explain what's going on, with this model, you can fit nicely with all the debate we're talking about the difference between Western and Asian diabetes, and also including the new sub-Asian groups talked by Dr. Mohan. And in the end, this is fundamental metabolic disorder, including cardiovascular disease, liver disease, even cancer. So the true cause of diabetes, of all the metabolic disease, is actually hypoxia, oxidative stress, and build up advanced glycation and product, which is also glycated protein, which is fundamental to diabetes and all the chronic diseases. So now I want to take a moment to see what's the true implication of glucose dysregulation. It's not a hyperglycemia, it's hypoglycemia. In both Taiwan type 2 diabetes, developed more than 10 years, the presence of hypoglycemia because of glucose dysregulation. So normally we regulate hypoglycemia with adrenaline and glucose. But when you have a diabetes developed to up to 10 years, both adrenaline and glucose dysregulated. They're not responding to hypoglycemia. And this is exactly the moment, according to worldwide, all the guidelines, we intensify treatment with insulin as a second line. So insulin take more sugar away, so more patients actually develop into hypoglycemia. Patients die from hypoglycemia because of wrong guideline. Can I prove that? This is the study, large-scale survey on severe hypoglycemia in Japan. Around 75% hypoglycemia, severe hypoglycemia in over 10 years patients. And if you look at treatment, over 90% using insulin sulfonylurea. And you look at all the study we put together with duration of diabetes, the long duration of diabetes with second line insulin, you're using insulin, you increase deaths and hypoglycemia. And if you look at a major study, this is the UKPD has succeeded because of short-term new diagnosed patient. And the others, ACORD, for example, because of late diabetes, dysregulation, hypoglycemia because of insulin, and how much is happening. 19 of the 41 patients misclassified, actually it's hypoglycemia classified as cardiovascular death. And the same with the publication talk about second line anti-diabetic. Everything talk about cardiovascular death, but nobody talk about hypoglycemia caused by insulin. So this phenomenon actually was long addressed at the same year as use of insulin by Jocelyn. Talk about dangerous hypoglycemia. 28 again. So today there's no doubt the guideline must be changed. And insulin doesn't mean that it doesn't have an effect. And insulin should be first line and also short term. So now this is, take a moment looking back, the war on cholesterol. We've been fighting since 1984. It fundamentally changed our diet. The mixed diet, so-called healthy diet, bring the one thing that within 16, 17 hours is only loaded with sugar and the fat is not used. By doing that, you only need sugar. You don't need oxygen because only oxygen is needed for fat cannibalism. So life is only in one equation, that in the celery, we turn sugar and oxygen into carbon dioxide and water. And when lack of oxygen, today there's a tremendous scientific research looking at oxygen. So what happens? This is the Warburg effect. When you don't use oxygen, one molecule of sugar, instead of produce 36 ATPs, you produce only 2 ATPs. So what it means, you need 18 folds more sugar to maintain normal cellular breathing. So this is the so-called Warburg effect. So life lost meaning, we become a survival machine. So if you look at diabetes with insulin, with nutrition, all the components still mean one thing, NTOR, which relate to cancer onset. So that's why today, if you look at back, insulin, diabetes, glucagon, and cancer, they all intervened together. Yet we fail to recognize the fundamental mechanism of metabolic system. So if you look at diabetes in the new century, what is diabetes? I would envision this what we should be looking at. We should look at glucagon, look at gut and liver inflammation, and also we should look at fasting diet with a renewed approach and looking at different breathing therapy, extremely important, and not count calorie, but count element, because protein get down to the bottom line is only nitrogen. Nitrogen is toxic and is only detoxed in the liver. So in the healthy diet, you should count how many elements going out, how many elements going out. So if you want to lose fat, 10 kilo fat, you need breathing 29 kilos oxygen and 80% of fat going out through carbon dioxide through breathing. So at the same time, we should look at first-line treatment, and electroceutical is something we have to look into, and as well as sleep medicine. So I believe real voyage of discovery is to have new eyes, not just looking at new landscape. We've been spent a whole century looking for landscape, new treatment. But I think we should really change fundamentally why we ended here today with best knowledge we have in the whole world, diabetes making a pandemic crisis. So I hope this gives us a new way to look at what's going on, and hope will bring a new future on diabetes. Thank you very much.
Thank you so much, Dr. Givenchy. Indeed, the real voyage lies in having new eyes. Very, very correctly said. So I now request Dr. Meena Chhabra ma'am to kindly give expert comments.
Do we have any questions in the chat box? So Dr. Jubin, would you like to talk about some newer peptides which could directly act on the GLP-1 as well as the glucagon receptors? Is there something like that in the pipeline for management of type 2 diabetes?
You asked me?
Yeah.
Yeah.
Question addressed to me.
Yeah, Dr. Cheet, my question to you is, first thing is an awesome talk, an alternate view. We've always had a glucocentric and an insulocentric view, and now you are trying to change to a insulin glucagon centric view. Thank you so much. So my question is, in the future, will we have some peptides which would be directed to both glucagon receptors and GLP-1 receptors for the management of type 2 diabetes?
Well, today is already in development. There are lots, pharmaceutical research looking at new drugs, putting glucagon with, GLP-1, etc. all together. However, my fundamental standpoint, this is not correct. Our approach on diabetes is not correct, because we shouldn't aggressively address sugar level, because the sugar level raise up is responding to lack of energy expenditure. By increasing insulin, as I suggested, when present of insulin, glucagon is suppressed on the energy expenditure role. This is the most important mistake we make. So that's why today there's a lot of research going on, but I don't believe it's correct. It's just going the same direction. We try to push insulin up. I think that's not correct. We should take looking at energy expenditure, that glucagon to release its function, release energy. That's the important thing for us.
Thank you so much. Thank you. So I think our audience will be wiser, and there is a food for thought. Talk about glucagon, also think about glucagon and read about it. And our approach to type 2 diabetes management may be different in the next few years. Thank you to Dr. Givenchy for that awesome talk, stimulating talk, which will motivate all of us to go back and read more and more about glucagon and its role in the pathogenesis of type 2 diabetes. Thank you so much.
Can I just make one comment? It's the company's impression that it's only for type 2, but it's not true. It's also type 1. There's no difference between type 1 and type 2 from fundamental mechanism. Today, new study also shows, again, type 1 diabetes is not just autoimmune. It relates to pancreas, oxidative stress, inflammation. So that's why both exactly the same mechanism, but we really should look at liver.
Thank you so much. Thank you. But what about SGLT2 inhibitors then? Because they cause glucosuria, the body perceives as a loss of energy, and there is hyperglucagonemia. But SGLT2 inhibitors are showing awesome results, reducing cardiovascular mortality, even progression of chronic kidney disease. So how do you explain the SGLT2 effect, although they cause hyperglucagonemia?
You see, I can only illustrate this way. If you build a house on the sandy beach, you can try whatever to repair the house, but the fundamental is wrong. So that's why we've been going on this for a century. We can try whatever we can. We can also completely replace the whole organ, including heart, but the fundamental, the root is wrong. I think that's where we ignore it. We cannot afford already today, with all the research, with all the scientific study, with all the drug we release, $60 billion a year, we're still not addressing diabetes. That's the problem. You can reverse diabetes without a drug. And in India, particularly, it's possible.
Thank you so much. Thank you. And on this optimistic note, we proceed to the next talk by none other than Dr. Anil Bhansali. A very warm welcome, sir. Dr. Bhansali obviously needs no introduction, but it's my proud privilege to introduce him. He is Professor and Head Department of Endocrinology at PGI Chandigarh. He has got the Outstanding Investigator Award in 2019 by WIDF. He has got the Professor B.S. Raheja Memorial Oration 2019. He was bestowed with the prestigious B.C. Roy Award in 2018. He has been the President of the Endocrine Society of India in 2012, received the Professor M.N. Sen ICMR Award in 2009, and the Professor M. Vishwanathan Award, RSSDI 2009, Dr. P.N. Shah Memorial Oration Award in 2007. Over and above, he's an excellent human being, a teacher, a mentor to most of us listening to him. Over to Professor Anil Bhansali for his talk. Dr. Bhansali, are you sharing your slides? Organizers, is Dr. Bhansali sharing his screen and his slides? Yeah.
Now, able to see?
No, sir, you're not. We can't see your screen, sir.
Okay.
There's a button right, you can see, share screen, green.
Yes,
Share.
I'm doing, yes.
First, we have to stop your screen sharing, madam.
No, the organizers have to do it. I'm not sharing. The organizers have to stop sharing.
Actually, ma'am, I think Sare shared the wrong screen.
Yeah.
So you have
Now
to take
it is
the
okay?
PPT in the background. You have to take the PPT in the background and then share the screen.
Sir knows that. His slides are open in the PowerPoint presentation. Dr. Bhansali, are your slides in the PowerPoint already open in the PowerPoint? I think someone, Hardik, can someone please?
Hello.
Yeah.
Good morning.
Hardik, can you help sir share the screen and just tell him?
इनका होगा यार, मैं आपके आऊंगा
Yeah,
दोपहर में
Neela.
2 बजे के आसपास.
Bansali sir, there is a green colored saying share screen. Press that. Hello. Yes, we can see your slides.
Sir, click on slideshow mode.
So can somebody help you, Dr.
Yes.
We can see your screen now.
Yeah.
It's not
So now
moving.
the slides.
Screen.
You know, you learn it now. What did I do it earlier? Yeah, I don't remember. You're not able to, but this is getting a problem. Next time, if you don't know, then you don't give it. You have to go here.
Yes.
100 times I've told you, go here.
See.
I'm not.
No share. Now it is okay?
Yeah, we can see the screen, sir. Can you move this?
Is able to see the slides?
Yes, sir. Just make it full
Yes,
screen,
yes.
please.
Now it is okay?
So just
Yes,
make it
yes.
full screen. Just make it full screen.
Slideshow is okay.
Yes, yes.
Make it slideshow.
Slideshow. Fine now?
Can you please move the slides for him? Are they moving?
Yeah.
They are not. Yeah, they are moving now.
Yeah. So.
Okay now?
Yes, Dr. Bansali, sir. Please proceed with
Yes.
your talk.
Yeah.
So we patiently wait for an excellent deliberation.
Yeah.
Start, sir.
Thank you, chairpersons. Thank you, Dr. Banshi, for inviting me for this great conference. And I'll be talking about the DBCD, that is a dysglycemia-based chronic diseases, which is a very integrated, holistic, and a newer concept, which is encompassing from evolution of diabetes to its complications. And important point here is that, yes, the important point here is that this not only includes the complications related to macrovascular, but as well as microvascular. So we can see the key mechanistic drivers for dysglycemia-based chronic diseases includes genetics, environmental factors, and epigenetics. And they are very complexly interacting and eventually leading to evolution of a disease. So you can see that the stage 1 is only an insulin-resistant state. Stage 2 is a pre-diabetes, stage 3 is diabetes, and stage 4 is type 2 diabetes with complications. And the key cell organelle which is involved in this is basically a mitochondria, which has got a defect in carbohydrate as well as in free fatty acid metabolism.
Your slides are not moving.
Possibly because you are able to hear?
Yeah, but little louder, sir, and your slides,
Okay.
don't move them yet.
Yeah, possibly because of the free fatty acid metabolism is impaired, which eventually leads to more availability of the free fatty acids.
Technology people, Dr. Bansali's slides are not moving when he is already on a 5th slide.
Bansali sir, your slides are not moving.
Now moving, sir? Yes.
No, sir. Can you just double click on the screen, sir? Just double click on the screen. Just anywhere on the screen, double click.
Now?
And now move the slide, sir, with the arrow.
Yeah.
No, sir, they're not moving.
Kindly share it again. It will be moving again.
Or we can hear stir extempore.
No, it is going on now.
No, sir. The
No,
first
sir.
slide, stratification and strategies for CVD risk reduction. They're not moving.
He can speak extempore, but we won't understand all that.
Yeah. This will be difficult. Yes.
You please
Yes.
reshare it. It will work.
Yes, I'm sharing.
No issues, sir.
Application window. Yes. Share. Now.
Yes.
Yes. And now, sir, click on this slideshow button.
Yes.
Now click next.
Now moving, sir.
No, sir. Bottom left slideshow button. I think slideshow is not working. You can take one slide by one slide. You can click on individual slides if you can. And
Yes, sir. Click on the second slide now and we can.
Yes. Now it is okay.
No, sir.
No.
You go into the left side and click slide by slide on the left, where we see all your slides on the left.
Can we proceed to the next talk and give sir some time to?
No, man, I will do that. I'll just do that. Yes,
I will
sir.
do again.
We know you will do it. On the left, there is a ribbon of slides, sir. You just click on the slides,
You
individual
just
slides.
go to the slide show. It's on the bar. You see, you read from home to the right, home format thing, and then you see there's a slideshow. You click slideshow.
Yes.
Yeah. Share screen. Yes. Application window.
Just click on slideshow now, sir.
Slideshow, sir.
In the top, sir, there is home, then format, themes, tables, charts, smart art, transition, animation, and then slideshow.
But sir, I'm not, because slides are already okay.
Hello.
No, I think it's your cursor still not moving.
Yes.
Your cursor is still on the first slice where you do the formatting. So you should double click, get out of it, do a double click, get out of that, and then go to slideshow. Because you're now at the formatting.
Yes.
Now it is okay?
No, it is not okay, sir. You have to do on the
slideshow now.
slideshow. You have to come out of it. मीना, मैं सुन रहा हूँ, मैं आ गया लेकिन
Not coming?
No,
सर,
sir, not coming.
आप एक्चुअली डॉक्टर अनिल बंसाली, आपने गलत जगह कर्सर लगा रखा है. आप इसमें से बाहर निकल के साइड में स्लाइड शो दिख रहा है, वहां पर स्लाइड शो पर टिप करिए.
Where's your cursor?
डॉक्टर अनिल बंसाली.
Yeah, cursor is this.
How is the cursor?
Yeah.
आप प्रेस
Go to slide.
आप स्लाइड शो करिए. ये यहाँ नीचे लेफ्ट के अंदर आपको दिख रहा होगा, जहाँ 4 टिपके बने हुए हैं. उसके बाद में आपको वहां पर क्लिक करना है.
4 टिप, एक जस्ट
बॉटम लेफ्ट में सर 4 टिपके हैं, उसके बगल वाला आइकन
आपके लेफ्ट के अंदर दिख रहा है. डॉक्टर अनिल बंसाली, आप देखो, वहां पर आप अपना माउस ले जाके वहां क्लिक करिए. आप या वेर को वीडियो कॉल करिए ना फोन के ऊपर. मैं आपको फोन पर बता देता हूँ.
slide
You send me the slide so I can run from my side.
Yes. चलो वहां पे नहीं चलो.
Is anybody is there with you?
Yes.
Yes,
So
we can now see your 6th slide and your cursor also. Just click on the slide show, sir.
कर्सर को आप नीचे लेके जाइए.
ये लेफ्ट बॉटम लेफ्ट,
हाँ,
ये सर इसके पास वाला ये.
हाँ,
यस,
अब
वेरी
इसको
गुड.
क्लिक कर दीजिए.
ओके नाउ?
ना आपने क्लिक नहीं किया वहां पर. आपने अभी भी जो 4 टिपके बने हुए हैं, उसके बाद में जो पावर पॉइंट स्लाइड शो आता है, वहां पर क्लिक करिए नीचे. और इसके आगे सर आप कहाँ जा रहे हैं? वहीं यहाँ
वाला
क्लिक करिए. क्लिक करिए. इट इज नॉट गेटिंग.
तो सर टेक स्लाइड बाय स्लाइड, वन स्लाइड
सर ये आपका उसमें ड्राइव में से है, आप वो राइट साइड में ऊपर जो प्ले बटन दिख रहा है ना सर,
प्ले बटन,
हाँ
प्ले बटन
वहां से, हाँ
फ्रॉम स्टार्ट, सबसे पहला वाला सर, लेफ्ट में सबसे पहला फ्रॉम स्टार्ट।
सर का वो दबी नहीं रहा है मेरे ख्याल से। हार्दिक उनको ऐसा करो, प्रेजेंटर व्यू के बिना ही करा दो, फर्स्ट स्लाइड से ही कर दे।
ठीक है, ठीक।
सर यू कैन स्टार्ट, देयर इज नो प्रॉब्लम, नाउ यू कंटिन्यू।
Now it is moving, sir?
Yes, you have to, yes, it is seen. You
Yes,
can
we can see, sir, this way.
Fine.
So from first slide, you can start.
Yeah, it's moving.
Moving now?
Yes,
sir.
It is moving.
Very much.
Start with the first slide.
Yes.
Please go ahead, sir.
Okay, my sincere apology for the this technical hassle. So I will be talking about the DBCD, that is a dysglycemia-based chronic diseases. It is a new concept which is comprehensive and integrated approach encompassing from the evolution of disease to the complications. And here we can see that this not only includes the macrovascular complications, but this also focuses on microvascular complications. Very interestingly, this has also been involving the cell organelle, which is of great importance in for diabetes, and that is mitochondria. And the altered metabolism for the free fatty acids and glucose that eventually leads to more availability of the free fatty acids into circulation and ectopic accumulation, and eventually leading to adiposity and insulin resistance. So the whole system now focus of this DBCD is on mitochondria. That's one. It's a very holistic approach from evolution of a disease to complications, and that's why the strategies are now planned to target the different stages, so you can prevent the diabetes even from the population-based approaches or population-targeted approaches. So this includes the stage 1 is insulin resistance, where the adiposity is the main characteristic feature, followed by the pre-diabetes, that is stage 2. Then the biochemical abnormality more worsens, then you have got a diabetes, and eventually the long-standing diabetes along with multiple comorbidities, you develop so many diabetic complications, both microvascular and macrovascular. The approach in DBCD is now also focusing on mitochondrial epigenetics. As I mentioned, the mitochondria is integrating cell organelle for two basic metabolism, fat and carbohydrates, and this 17 beta oxidative machinery becomes impaired or becomes defective, whether it is because of mitochondrial loss or whatever the mechanism may be, that eventually leads to more free fatty acids in the circulation and eventual adiposity. So the primary culminating event is adiposity, and that is possibly because of the altered mitochondrial function. And this shows that even in thin fat Indians, where you have a more visceral obesity, more abdominal fat, the fat cell size is even smaller. The larger adipocytes, we have a more larger adipocytes than the smaller adipocytes, which are more insulin sensitive, and they may be possibly more dense into the visceral compartment. That's why the thin fat Indians, and eventually leading to the adipokines, which are both pro-inflammatory and decrease in adiponectin, and eventually leading to insulin resistance and type 2 diabetes, and so many consequences of this insulin resistance as a dyslipidemia, endothelial function, hypertension, oxidative stress, and atherosclerosis. So the culminating event for the first stage 1, that is a stage of insulin resistance, possibly your visceral obesity is playing a role, and possibly at that point of time, the altered mitochondrial function may be responsible for this adipogenesis. If you look for the metabolic drivers for this dysglycemia-based chronic diseases, there are 6 parameters have been incorporated, but I think the most important is obesity. If you take normal weight as 1, then the obesity is around 900 folds relatively higher for causing this. And for a stage 2 pre-diabetes, the risk further increases. So you can see that the most important metabolic driver among all, physical activity, obesity, smoking, hypertension, and lipid abnormalities, the obesity is playing an important role in evoluting the disease. It's a global problem. It is not only a problem in India. We had earlier published our data of mortality in patients with diabetes, which was mainly attributed to infection. But that was a 15 years earlier data, and now the data are again changing. So we also now encounter majority of patients with diabetes, they are dying of CVD or they are dying of CKD. This is the data from our own country. The 27 years data shows the increase in prevalence of cardiovascular disease, stroke, as well as ISD that is rising. Another thing which has come into play that why from evolution of a disease from insulin resistance to pre-diabetes and diabetes, and what happens to the cardiovascular disease in initial stages before the development of diabetes. This has been called a ticking clock hypothesis, means the clock starts ticking even prior to the emergence of hyperglycemia. And this clock starts ticking because most of the comorbidities like dyslipidemia, like obesity is already there, hypertension, or hyperinsulinemia and hyperproinsulinemia all contributes to cardiovascular disease. So meaning by that, the pre-diabetes, which is a window period, maybe encompassing from 7 to 9 years, that window period basically leads to accumulation of so many comorbidity and eventually leading to complications. So what I mean to say that the clock starts ticking even from stage 1 when the insulin resistance starts emerging by accumulating more visceral fat. The glycemic control and cardiovascular risk. The glycemia, in fact, the hyperglycemia, like if you see the data from DCCT, the microvascular complications, they are significantly reduced with euglycemia. Similarly, in the UKPDS, you also find that there is a reduction in cardiovascular events. However, in a 7-year follow-up, it could not achieve a statistical significance. But if you see the data in the follow-up of the 15 years, the cardiovascular disease also reduced and mortality reduced. But if you start intervening late, then in fact the cardiovascular disease and mortality are not influenced. So what we mean to say that the glycemia plays a role, but if you start intervening early and intensive, if you start intervening late, then the glycemia related cardiovascular benefits in fact does not emerge if you start intervening late. But the non-glycemic factors are very important for cardiovascular risk, and even not only for a macro, but for micro as well. And this is the data and 1 millimole of LDL and 0.9% of hemoglobin A1C. The maximum benefit you reap with reduction in blood pressure. However, all contribute, so you have a 12%, 8%, and around 3% reduction in cardiovascular events with blood pressure reduction, cholesterol reduction, and hemoglobin A1C reduction. And even if you reduce a 10 millimeter blood pressure, you see the forest plot very clearly shows that all events, including microvascular events, all are in favor of reducing the blood pressure to a higher range. Even we have so much of facilities now, we have so many targets now, and still our patients with diabetes are still not reaching CV goals. And this is the data which shows that 81% of the patients could not achieve all 3 goals. So only 20% could achieve all 3 goals. If you cannot achieve all 3 goals, the cardiovascular risk reduction may not be complete. Similarly, the weight loss, which has always been a focus, because once you have accumulated weight and once you have accumulated adipose tissue mass, the weight loss improves cardiovascular risk factors, but that is only in a short term. Here you can see that this data shows that the weight loss was associated with decrease in cardiovascular events with this. So even when you have all 3 goals, that could be achieved in 24% of individuals. But in a long run, even you focus on weight loss, the reduction in cardiovascular risk factors is almost same. So meaning by that, the weight loss also loses its efficacy in a long run for reduction in cardiovascular risk factors. The possible mechanism means the other comorbidities possibly takes over, And the adipocyte, one theory which has come is an adipocyte starvation. So even you continue maintaining and sustain your weight loss, the cardiovascular benefit in fact diminishes with time. Statins, which are the prima now the pivotal treatment for the dyslipidemia and remarkably reduce the cardiovascular events in patients with diabetes. So many data from a primary prevention and secondary prevention. And you can also do that whenever you use a low statin and lipid lowering therapy, and you have a remarkable reduction, but there is still residual risk, and this residual risk has been added to the remnant cholesterol, which is not rather than LDL cholesterol, which may be contributing for additional risk to the cardiovascular disease. There are many ways. So what we can have learned that if you target multiple risk factors, data from UKPDS, GCCT, and so many trials, including blood pressure, lipids, and all, still you have a residual risk. The cardiovascular risk reduction can be stratified by the AHA ACC classification, and you can have an app, and you can find out the risk of a given individual. JBS3 is a joint British society that you can also do that. And this is a study from Kerala, which found very, very appropriate for our Indian subjects. The Framingham score is another score, and ACC they usually overestimate. So that's why they have suggested that you should possibly use a JBS3 score to estimate the 10-year risk and lifetime risk for cardiovascular disease. Here uses a known SDL cholesterol, total cholesterol, and SDL cholesterol from non-fasting samples, and the risk stratification according to the therapy and this. So you can calculate the ASCVD risk, and possibly this data is only confirmed from Kerala, where this score has been used and found to be useful. Now the strategies for further cardiovascular risk reduction. So now we all know that the SGLT2 inhibitors have changed the whole scenario. They have unequivocally shown the hospitalization for heart failure was remarkably reduced, and there was also an improvement in a 3-point MACE. However, there was some heterogeneity in these three molecules which are in a forefront. In addition, there was a renal benefits are very, very consistent with all three molecules which we have. But I think that one of the major targets which I talked about the mitochondria, where the really SGLT2 they do have an effect or not. I think the effect is possibly not there. Now, if you can see that the SGLT2 increases free fatty acids and ketones and decreases glucose by glucosuria, and once they are in a mitochondria, these free fatty acids, the only drug which has been found to be having some beneficial effect on mitochondrial fatty acid metabolism is PPR-GAU. Otherwise, no other drugs have been shown. So the glucolipotoxicity is reduced by SGLT2, but the metabolism which is altered in the mitochondria, in fact, is not influenced by any class of drug, whatever we have, including DPP4, GLP-1, and SGLT2. If you go further, the extra glycemic effects, we are all aware about that. They do reduce preload, they do reduce afterload. Even the adipose tissue mass is also reduced, and there is improved glycemic control. And in fact, there is a hypouricemia, uric acid is also reduced, and there is a more sodium excretion, and there is a improvement in systemic vascular resistance. So these are the probable mechanisms for that. Mainly intrarenal effects, sodium excretion, and intravascular effects, and eventually leading to renal protection because of a restoration of the tubuloglobulin feedback, improvement in heart failure, and cardiovascular protection. And this is to show that those patients who had an established CVD, they do better than those who have the CVD risk factors. That was some heterogeneity. So now we can look for that. So now the focus is on mitochondrial targeting for glucolipotoxicity. Does it matter? So let us see that whenever there is a mitochondrial dysfunction, in whether this is because of uncontrolled hyperglycemia or whether it is because of an increase in ROS, reactive oxygen species, this interferes with the oxidation of the fatty acyl coenzyme A, which leads to accumulation of the diacyl glycerol and ceramides. This leads to more ROS and eventually interferes with insulin signaling pathway. I think the question is that how important is this mechanism, because the two principal substrates which are to be metabolized, free fatty acids and glucose, are all taken care by the mitochondria. You require a glucose metabolism and ATP synthesis for insulin secretion, as well as you also require a free fatty acid metabolism in a fasting state. So there is always a metabolic switch and there is a metabolic stability. So a time comes when you have a free fatty acid metabolism and a time comes when the glucose is metabolized. So mitochondria plays a very, very pivotal role in energy generation. So what happens that when there is a mitochondrial overload or mitochondrial dysfunction, there is a decrease in mitochondrial pyruvate uptake and lipid oxidation. There is a decreased substrate for ATP generation, and eventually this leads to accumulation of glucose and lipids into the circulation, glucolipotoxicity, which impairs the insulin signaling pathway, MAP kinase, and microvascular complications. So I think why the focus is shifting from mitochondria, because the fuel metabolism, the predominant cell organism is mitochondria, and this is based on this. So unmet need for an ideal drug which can target the metabolic flexibility or metabolic inflexibility. In fact, metabolic flexibility means the mitochondria are adapted to metabolize the need what they have. But because of the disease process, they are not able to work effectively. That's why the term coined, which is a metabolic inflexibility. So out of all the available drugs so far, except the PPR gamma, which I talked about, that the metabolic inflexibility and including the respiratory transporter chain 2, 3, and 5. So they are related to endothelial dysfunction and leads to more insulin resistance and other cardiovascular risk factors, including hypertension, dyslipidemia, and vasculitis. So to summarize, the DBCD is a comprehensive and integrated approach to target metabolic disorders, encompassing insulin resistance to T2DM and cardiovascular disease. And I will mention it is not only CVD, but it is also microvascular, because particularly diabetic kidney disease is also an important risk factor for cardiovascular disease. The multiple risk factor intervention at an early stage of disease delays or halts the progression of CVD, but remain elusive in addressing residual risk, because their residual risk is possibly because of mediated by the like remnant LDL, which I talked about that, and we also talked about the mitochondrial dysfunction, which can also contribute to worsening or residual risk to cardiovascular disease. The mitochondrial dysfunction is a hallmark in T2DM and attributes to beta cell dysfunction and insulin resistance. The therapies which can target the mitochondrial health may be rewarding in preventing the complications related to risk factors, particularly hypertension, dyslipidemia, or related to hyperglycemia, because both will be helping us in improving the mitochondrial function and eventually the improved bioenergetics of the system. Thank you for your patience hearing. I hope the subject was slightly new, so that's why some audience may not pace with me, but I think I was able to make it clear that the now focus is shifting from onset of disease or type 2 the established disease, from established disease to a evolution of a disease to eventually to complications, and seeing a holistic approach to disease. Thank you.
Thank you so much, sir. So it was an awesome talk. So my question is that in spite of addressing multiple risk factors, does genetics also play a role? We see so many patients with uncontrolled diabetes not doing so badly, while people with not so bad HbA1cs and lipids end up getting cardiovascular disease. So what is the role of genetics in...
Yes, certainly this cannot be denied, because the role of genetics is very important. That's why I think this model also takes care of the role of genetic factors. We have talked not only genetic, environmental, as well as the epigenetic factors also, which have been taken into consideration. And you are very right that some diabetics we see in clinical practice, despite of a very poor glycemic control, they do not develop complications. This we see, so genetic factors are definitely playing a role. And I think again the focus may be on a mitochondria, because the mitochondrial health may not be so much impaired in that. So that's why they are able to keep a balance between glucose and free fatty acid metabolism. So that may be the one predisposition. And other genetic factors possibly might, because they do have a poor control of glucose. So insulin signaling mechanism may not be so much of impaired, But I think the more maybe, or they might be having a preserved beta cell function, preserved beta cell mass. So may not be, the decline in a beta cell mass may not be so faster in them as compared to this. And thirdly, their vasculature may be different. Vasculature may be different in the sense that the vascular may be resistant to all these oxidative damage and ROS damage. So possibly all three factors, or maybe more than that, may be playing a role that why some are predisposed and why some are prone for developing a disease.
Are there questions in the chat box? My co-chairperson, Dr. Ashutosh.
Sir, should we, can I ask one question? Sir, should we focus more on the non-pharmacological treatment, which will address all the factors rather than individual drug?
Yes, very right. That, as I mentioned, that very importantly, the non-pharmacological factors or a healthy lifestyle or a vigorous moderate intensity physical activity is very important, because which targets most of the cardiovascular.
Dr. Bhansali, my question is that as most of us are vegetarians,
pharmacotherapy, which may be including including your antihypertensive statins and all this. But I think one thing which I showed you in one slide that was also very important is that even with the continued lifestyle modification and focus on weight, the cardiovascular risk reduction was almost similar in those who were on intensive versus those who were in control. Only the cardiovascular risk benefit was seen for a short term. That is, for short term means here the short term was at least for 5 years. But if it was prolonged for 9 years, then the beneficial effect on a cardiovascular risk factor reduction was also lost. That was a very surprising, because possibly this is a adipocyte adaptation. So that may possibly lead to the lesser reduction or at most a plateau of the cardiovascular risk factors. But I think the major beneficial effect was seen in early years when you focus on weight. So what I will suggest that lifestyle modification along with pharmacotherapy, including statins, ACE or ARBs, SGLT2 inhibitors, I think they take care of multiple risk factors, but still the residual risk remains. For that, we may require some other tasks. Yes, any more?
To sum up, Dr. Bhansali, your message to the audience is that we should move from a glucocentric approach to a vasculo-glucocentric approach, where we not only control the blood sugars, but we also control the blood pressures, we control the lipids. So my question is, sir, how important are triglycerides? Do we?
Yes. Yes. So one of the metabolic drivers, which I mentioned in one of my slides, was the triglycerides. And the triglycerides also contributes to adiposity, and this also contributes to insulin resistance. But the beneficial effect of reducing triglycerides on the cardiovascular events have only been shown, some studies shown in women, but not in men, one. And secondly, this is only with, and the effects are not consistent. So I think the focus has always been on LDL cholesterol. Even the data study showing an effect on HDL cholesterol or raising HDL cholesterol was not so beneficial, because the LDL was too low in those studies. So I think we do know that there are harmful or detrimental effects of triglycerides, but reducing triglycerides really reduces the cardiovascular risk is still questionable or debatable. So I think yes, certainly if they are more than 500 milligram per deciliter, you must very effectively treat, because you don't have not only risk for a CVD, but you have a risk for pancreatitis also. So I think take care of that part, but the consistency of data on reducing cardiovascular risks by normalizing triglycerides are still questionable.
Right. Thank you so much, sir. Any more questions? If not, let me thank our esteemed speakers. Thank you so much, Dr. Bhansali, for that awesome lecture and the message to the audience to focus on multiple risk factors to decrease cardiovascular disease. Thank you. And I think we close this session with a very big thank you to all three speakers.
Thank you.
Thank you for joining us.
Thank you so much, ma'am.
Thank you, ma'am. Thank you, Ashutosh. Now, I would like to hand over the session to my friend, Dr. Viral Raj, for the next Insulin Symposium second. Dr. Viral, over to you. Dr. Viral, you are mute. Unmute yourself.
Thank you, Bharat Sabu sir. Welcome to all delegates for this wonderful conference of DiaCareCon 2020. I would like to invite second symposium, Insulin Symposium 2. I would like to invite Dr. Navneet Shah sir, who is a very senior physician from Ahmedabad, and Dr. Anil Kulshetra sir from Ahmedabad to start this Insulin Symposium 2. Please, sir, continue.
Thank you. Thank you, Viral. And in the beginning, let me thank Bansi and his organizing team for inviting us to be a part of DiaCareCon 2020. So my heartfelt gratitude to Bansi and all his colleagues for this. Now, there is some change in the program. This is the Insulin Symposium 2, and the first speaker is Dr. Ishwar. So let us be happy about that Ishwar is with us. And Dr. T.K. M. Ishwar at present is a consultant at Ideas Diabetes Center, Rajkot. He has a lot of international and national publications to his credit. He is a speaker at various national meets like Epicon, RSSDI, DFSI, and Diabetes India. He is also a regional faculty in Saurashtra region for PHFI certificate course in diabetes, CCBD, and then PHFI gestational diabetes course, and Bioconabite diabetes certification program. He is a speaker for many national level conference. And today he is enlightening us regarding the insulin treatment motivation, the tricks of the trade. So may I invite Dr. Ishwar for delivering your lecture to the gatherings. Thank you.
Thank you, Navneet Bhai, and pleasure. Navneet Bhai was my teacher when I was in second MBBS, and I'm happy to see Mahadev Bhai is also there. Wonderful to see our teachers being there. Many, many thanks to Bansi and the entire team of DiaCon. Actually, some international speaker was to take this topic, but because of some ill health, Bansi assigned this task to me 2 days back, and it was a topic of great interest to me. So I hope I'll do justice. I'll very quickly put up the slides. I hope I'll do justice to the topic. Is my screen visible?
No.
It's not visible. Huh? There is some problem. So, yeah. I think I'll tell Neelam to share the slides. Is it visible now?
Yes, now it is visible.
Yeah, perfect. So basically, the topic for today is a very important topic as far as people who are practicing diabetes are concerned, because we will need to put many of our type 2 patients on insulin sooner or later in the course of their disease. And we know that it's very, very difficult to motivate them and to make them take the insulin without feeling that it's a punishment or a burden for them. So I'll try to collect some data from this and try to see how we can motivate our patients to make them take insulin as early as we want them to. Next slide, please. So we know that almost 100 years have passed since insulin was first used to treat a diabetic patient. In fact, next year we'll be celebrating 100 years of insulin. But though 100 years have passed, insulin itself remains a very touchy subject with patients and many of the doctors as well. And there are so many fears and there are so many misconceptions about the use of insulin. Next. So the problem is that neither the doctors nor the patients want to initiate change. We talked about the treatment inertia. We are not ready to go forward. We don't want to change. And when we do want to change, our patients don't want to change. So this is the biggest problem, especially when we are giving out an injectable therapy. And insulin being a daily injectable therapy is all the more reason where we need to really put our heads together to convince our patients that we need to change the way we are treating you. Next. So we all know this is a very old and very familiar slide, that because of treatment inertia, the standard thing is that we do what the patient wants. They ask us for more tablets, more time. So when we increase from monotherapy to dual therapy, then triple therapy, and by the time the insulin is initiated, the HbA1c is quite high, it's 9 or 9.7. On the other hand, if we have a more aggressive approach, and earlier in the disease, when two drugs in almost 50 to 75% of doses fail, if we start insulin, then we can bring down the HbA1c for 7 to 8 years. And we all know the legacy effect, that if we bring down the HbA1c initially, then we'll have a very good legacy later on. Next slide, please. But every time the patients think that something magical is going to happen, they will say, give me 1 month, I will do this, I will improve my diet, I will start doing exercise. I've eaten a lot of sweets last month, there was some function in my house, I will change. But something magical doesn't happen. And it's very important for the patients also to be convinced that nothing magical is going to happen, that their drugs have failed, their beta cells are not producing insulin, and the only answer is to give insulin from outside. Next. So there are so many barriers to insulin initiation. There are patient-related barriers, of course, but there are doctor-related barriers as well. And this is a very big problem as far as doctor-related barriers are there. So we'll discuss these barriers and how to overcome them in the further slides. But just to go through the barriers quickly, patient-related barriers are fear of, they feel it's a failure, that I have failed in my treatment. I have not done the right thing. They have betrayed their family by, having themselves to take insulin. So they feel it's a personal failure. They are worried about complications because they feel that if they take insulin, their eyes will go or their kidneys will go. They are worried about weight gain. Of course, they are worried about needle phobias. Only when you show them that the needle is so small and so thin, they realize that they need not worry. They still think that it's like a routine injection, which is given intramuscularly. There are so many taboos regarding insulin use, and we have faced lots of problems just before marriage. If somebody is on insulin, so difficult it is to convince the other side that this is not a big issue. There are other regional issues, different parts of the country. Definitely hypoglycemia, everybody is worried that if insulin is started, sugars will go down. How to give the insulin, whether it's pen, whether it's vial, how to do that. Of course, non-compliance, that patients we write, they promise to take, but they don't do it. A change of lifestyle, because if you are using human insulin, you have to take it 20 minutes before the meal, and all these things are there. And then, of course, the most important in our country is economics, that the good insulins, the safer insulins, the insulins which produce less hypoglycemia are very costly. We can't afford to give it to the poor patients. And those who are not very much affording, they have to use the conventional human insulins with all their drawbacks. Doctors also have problems that, there is a clinical inertia in spite of attending so many conferences and, hearing so much about the keeping the HbA1c low. We don't want to initiate early. There is lack of knowledge, lack of technical expertise. We don't have access to the trials which suggest that we should start insulin early. We don't have staff to, educate and motivate the patients or motivate ourselves. And of course, in developing nations, how to make the insulin reach the periphery, how to maintain the cold chain. All these are also very important issues. Next. So if you see the barriers which are perceived by the physicians, this is also very important, because whenever we go to attend a conference, and this is a very important topic, and this they think is that, the barriers which patients will have a problem. So they may say that patients can't afford the price of insulin, but actually if you compare the human insulins, the price is almost equal to or even less than some of the drugs which are available. Inability to afford a blood glucose monitoring device, because obviously when you're giving insulin, you would like to monitor their fasting, or post-parental, if there is an hypo, you would like to monitor them. So the cost of the strips, the cost of the glucometer, fear of the pain of the injection, fear of hypoglycemia. They feel that patients will not have the knowledge or efficacy in administering the insulin themselves, how much the family will support them. Always the question is, now once I start, it will become a habit. So they think that taking insulin is a habit which they will have to continue for the lifetime. How to maintain the compliance, that morning, evening, or 3 times a day, or dose, whatever we are giving, how to continue it in a proper way. How to do regular monitoring in the house, or with your job, or with whatever profile of work. Students also have difficulty in monitoring. How to store the insulin, though we tell them that one you can keep at room temperature, how to store the other insulins. Many people in the villages, they may not have a fridge, or even the electricity may not be coming for 24 hours a day. As far as the healthcare system is there are not enough educators. Especially we know now that because of this problem of COVID and hyperglycemia, mucor has become such a big problem that we are not really taking care of the diabetes, either in the hospital or out hospital. We are only focusing on that COVID and how the patient will come out, and we forget that so many other ancillary things are important. Then lack of insulin to low income patients, that I think is now overcome, because government hospitals are providing very good support, and even good quality of analog insulins are also available in civil hospitals. And of course, biggest problem is heavy workload, that we don't have like America or Europe, that we see 10 or 15 patients a day. that there is a target driven thing that I want to see 100 or 200 patients a day. And when you're seeing so many patients, you can hardly give any time to the people to, discuss insulin and how to take it. We also have negative attitude towards initiation of insulin, that many times I know that when some GP or somebody wants to refer a patient and we tell that this person needs insulin, they themselves are very much, unhappy that you're starting insulin. Why don't you try some medical therapy or some more oral drugs? That's because they're also not trained, they're not motivated, they're not confident. And, they also talk with the patient that, no, you take the drugs and something will happen and your reports will become better. Of course, definitely the most important thing is that patients don't give enough time to educate and train. And I think patients can't, the physicians can't do it. You need to have the proper staff. So you need to have good educators, good dietitians, and all the people should be, working with you so that enough time can be given to the patients and all their questions and fears and everything can be answered. Next, please. So this is a very, so many different barriers are there, and they always think that it is the last stage of diabetes. So patients, many times when they come, they ask you that how severe is the diabetes? Now, this is a very difficult answer, but there is no severity, there is only duration of diabetes. And as the duration progresses, if the sugars remain high with oral therapy, we need to start the insulin. But they always associate it with a very advanced diabetes, and that now the patient is not going to give very long. They say that insulin is an addiction like tobacco or alcohol. Once I start insulin, no other treatment will work. If I can't inject, I will be dependent on others. I'm very surprised that it's so easy both to inject with a syringe and with a pen. Even then, somebody comes from the hospital or some nurse comes and injects the insulin morning and evening. So this is a very, very difficult thing which we have to work on to solve. They feel that injections will be very painful. They always say that I'm absolutely all right. My reports may be high, but I don't have any symptom. Why are you giving me insulin? And then they say that it's very costly. So these are all the reasons which patients will give to us that we don't want to use the insulin. Next. So this is just in a graphic way, they have put the commonest reasons. Almost always is the dislike of fear of needles. I'm sure that's there for everybody. And even for a COVID vaccine, people are saying no, so insulin is a different thing altogether. Dependence on insulin, anxiety, the worry that the disease has progressed, concern about the cost because basal insulin analogs are a little bit expensive, whether I can manage myself or not, I'm a failure, how will I check my sugar, will my weight increase, will my sugars go down, will my daily life be routine or will I need to change? Suppose I make a mistake, suppose I take more insulin, suppose I take insulin by mistake twice, will my skin be affected, will I get any scar? Is my insulin working? So many times patients after 2 to 3 days, they come and say that, sir, you have started insulin, it's not working. Then we have to explain that by titration is to be done, then it will work. Next slide. So we'll talk about some of the strategies. We have talked about the fears, what patients are having and how we can overcome these strategies by talking with them. If we can talk with them, well and good, but we are very busy in our practice, definitely we can tell our educator or our, whoever staff are there to talk with them. Next. And all these issues are there, like sense of loss of control. You tell them that once you take insulin, your diabetes will be controlled again. Initially, when patient comes, you have to counsel them that this is 50% of the beta cells are gone. That's why you have developed type 2 diabetes. And over a period of time, this 50% will go down, whatever medicine we use, to 30, 20, 10. And sooner or later, when enough insulin is not being produced and the sulfonylurea and other tablets which depend on insulin production to work, they will not work. You need to take insulin. So if at every visit, though they are on oral therapy, if you tell them that they will need insulin later on, then they won't have this belief that my disease has worsened. Then there is a feeling of personal failure. So you have to tell them again that it's inevitable, whatever you do. If you don't take care, you will need insulin early. But if you take care, you will need insulin later on. But it's not, that you will not need it at all. And it's not a threat that you start eating properly, don't eat sweets, don't miss your medicine. Otherwise, next time I'll give you insulin. So that's the wrong method. You should not give a threat. You should always show them the size of the injection. And mostly our staff, they take, a dummy injection in front of the patient, which makes them less fearful. We also make them inject themselves with a distilled water or something so that the fear goes away. And once they see that the needle is very small, it's very thin, that fear always goes away. So we need to introduce the thing in the hospital itself rather than they go home and they have this fear that how much pain I will have. Then, once you monitor, the big advantage of telling the patient to monitor the sugars is that we can not only guide them about increasing or decreasing the therapy, they themselves will understand that the glycemic control is improving. Then we need to do something to reduce weight gain, which of course we know because insulin is anabolic, and we need to prevent hypoglycemia and maybe give some other drug which will produce weight loss. Of course, fear of hypoglycemia is there, so always start low and go slow. Titrate regularly. I'm not saying that don't increase the dose, but be careful about titrating so that hypoglycemia can be avoided. And we all know that insulin pens are there. Long-acting insulins can be given once in a day. Educators are available to talk about all these things. And we always make it a point that counseling should always be done with the whole family at least once when the patient comes for the first time or when you initiate insulin. The relatives who are in the house who are taking care of them, all of them should come and participate in the counseling session so that they can properly understand why they are giving insulin to the patient. Next, please. So these are all the queries which the doctor has. So is it a lifelong drug? Will I have a restricted lifestyle? Whether it's cost effective, that if my diabetes, if I'm spending more money on insulin, will I get the desired results? Is there no other way out? That is always the question that, sir, please give me anything, any costly tablet, but you tell me whatever I will do, but find some way out, which is not there. It's one of the best options. And they're worried about traveling. If I go to a party, if I go to a function, if I go out, how will I take my insulin? Social stigma, they're worried about, injecting insulin in front of family or friends. Pregnancy, very much worried about the insulin, then about the technique, about the prick, and whether it will cause complication or death, whether my eyes will go, my kidney will go, I will die. So all these things are there, and the challenges are also there. Denial is there, anger is there, rejection is there. Of course, physician inertia is there. Alternative medicine is a very big problem in our country, that we are using Ayurvedic or some other type of medicine. Fads of diet, somebody will tell them that you don't eat for 12 hours and you have only 2 meals in a day. They'll do that. Lots to follow up. Everything is good, so they're not coming back and not doing SMBG on a regular basis. So if you have a good interaction, whether it's personal or group, generally we have I've found that personal interaction is good, because in a group, those who speak will speak and those who are shy, they will never speak. So those who are shy and they have some questions, they will not be able to talk with the educator. So we always do, individual family or individual patient interaction. Unless it's a group meeting or something like that, I avoid, giving advice in a group, because everybody's advice is different and everybody's family and social circumstances are different. So personal interaction in the clinic is the best way, but you can have once in a month, you can call all your patients. And, especially in type 1, Bansi is a part of it. And, we call all the children together and, we educate them and then we interact with them. And, so many things can go forward along with that. Of course, media is very much useful. We can have articles in the media about management and insulin and all, remove all the misconceptions. And you can always share success stories. We always say that Wasim Akram was, was taking insulin and he used to play cricket. So if you give a couple of success stories, then patients are very happy to continue the insulin. Next. So this William Polonsky, there are 3 slides from IJCP. And of course, in India also, Dr. Kalra has done a lot of work on, initiation of insulin. So you need to understand that before the patient needs insulin, there are certain questions, and you need to understand that there are certain questions which need to be asked at the time of initiation. Very important topics about hypoglycemia, especially things like driving and other things. And, I've got few bus drivers who are, on insulin therapy. So, they can't change their job because that's the only way they can support their family. So how they should prevent accidents from occurring by, not having hypoglycemia, this is also very important. Then logbook, continuous titration, self-care behavior, always follow up regularly, and, review the logbook. Many times people come with the readings, but you just cursorily glance through them. They won't write the readings because they feel the doctor is not giving any interest to that. So both in short term and long term, you should answer all the questions, answer all the issues that the patient is having. Look at the logbook, look at every time, tell your staff to see whether the technique is right. Only yesterday I had a patient who was using a U100 cartridge and using a U40 vial. So this is very common in our country. So we need to see that all these mismatches don't happen. And of course, in special populations like renal, CVD, depression, mental illness, elderly people who are staying alone, people with Parkinsonism, rheumatoid arthritis who can't operate this needle or you can't fill the pen or all those things, those who can't see well, Those who are having high risk of hypoglycemia, who had recurrent hypoglycemia, we want to avoid. In all these people, we need to definitely see how we continue and how we start and how we maintain the insulin. Next. And again, these are all the questions. As I told you, I'm not sure about taking insulin. The patients will say, my aunt took insulin and she lost her leg, or she had a heart attack. So everything that happens after the insulin starts is associated with insulin. That, whatever happens to in the house, anything which is there, that is because, sir, you started insulin for me. So we need to clarify all these doubts. Insulin is a danger drug. My disease is very bad, so I need insulin. I failed with diet and exercise and pills. Now I don't know if anything will work for me. I may lose my job. I'm afraid of needles. How long will I have to be on this? It's a lot of work for a long-term result. You are talking about 20 years from now. But why do I need to take insulin? Then you have to explain that, just like children studying, that if they study, the results only come after 20, 30 years of study. So then those who are having busy, they may have some problem with the brake. Though I didn't take insulin, sir, yesterday evening I didn't take it, but I felt fine. So really, if I miss insulin, is it okay? Then what are the doses? How have you decided that 20 and 10 or 15 units at bedtime? How have you decided it? And why do I need the insulin? Suppose there is some problem and I don't remember. Can I call somebody? What to do if I've got hypoglycemia? And all these things are there. So it's very important that when you are initiating insulin in a large number of patients, you need to have a 24/7 call support. So in our clinic, every patient is given a number. Those who are on insulin, compulsorily those who are on basal bolus or multiple dose of insulin have to measure their glucose and report to the educator at least twice in a week. Type 1 people have to report at least thrice in a week, and GDM people on insulin have to report almost every day unless the control is very good. And if there is any problem, they can call that number and tell what is the problem. If it's a simple dose adjustment problem, our staff handles it. If it's a major problem like having severe diarrhea, fever, or something in which they need admission, then immediately the staff get in touch with us and we get back to the patient about what is to be done. So the fear goes away. They feel that somebody is there with me. Somebody can take care of me. If I have got hypo, if I have got any other issue, the doctor is there to help me out. The biggest problem which we have seen when we didn't have such a sort of backup was that patient would develop some fever or diarrhea or vomiting and have hypo, go to some local doctor, maybe they are staying somewhere. I'm in Rajkot, Porbandar or Junagadh, which is few 100 kilometers away. The doctor will admit them, correct the hypoglycemia, change all the medicines. So if you are in touch with the patient and you manage it on phone and guide them how to go, what to do, then you can see that the continuum of the treatment is maintained. So a helpline for the patients is not only good for the patient, but it is also good for you. It sees that the patient remains with you. The confidence of the patient increases, that my doctor is always available. It's not your number which you need to give, but you need to have a well-trained educator who will take care of all the questions. And since I have got 4 or 5 educators, the phone rotates to them every week. So nobody gets, multiple calls throughout the month and they get tired. So you need to have this phone rotating among the people so that, everybody has got some role to play and nobody gets tired of, because we get multiple phones and, mostly they're genuine. Out of 100 phones which I may get in 2 or 3 days, I don't think more than 2 or 3 phones are such that we tell them that, Baba, why are you phoning for this? They usually phone with genuine problem. And we have to understand that after studying MBBS and MD and, doing a lot of diabetology, now we understand about insulin and hypo and hyper. That poor patient doesn't know anything about diabetes. So we have to be there to help them and guide them whenever they have any issue. Next. So there are certain goals, we are worried about the patient's fears, concerns. We need to listen to them actively. Look at the patient. Some of them are very happy. Oh, sir, start. Yesterday I had a patient who said that he was an executive in a big company. Okay, you start my insulin. And certain people, they will look at the lady, will look at her husband, they will look at her son. Please, you tell the doctor not to start insulin. So from the patient's look, from their behavior, we can understand what is this patient thinking about when you said that we need to start insulin. So we need to understand how the patient feels, because if the patient is ready to take, there is no need to, spend your time saying why insulin is important. It's more important to problem solve, how to prevent hypo, how to prevent hyper and all these things. So first look at the patient, how they feel about it, then why insulin is needed. If they need to understand, you need to explain and educate. You can use so many analogies. Then you solve the problems of the patient about the fears and about the cost and about the hypo and hyper. Then you develop a plan. Always remember that patient is at the center and we are always at the periphery. And so you should have a shared decision making about what is the best insulin you can give them, about how it will help them, how their routine daily work will not be disturbed. And what is the self-expectation? You have to remember, it's not a marathon. It's not a sprint. It's not that you are running 42 kilometers or 100 meters. It's a lifelong thing. So we need to be a partner with them, because throughout their life, they will be on insulin, and we need to see that their goals are met. Next. So Dr. Kalra and Dr. Of course, many of his colleagues of Bansi is also there in many of the publications, and lots of publications in India from Dr. Kalra and so many other colleagues which he has joined with, which gives a lot of this thing to us, that in our country there are specific, because country specific things are there. We have lots of education problems, social problems. So this is an AIO approach that asks, explain, E is explain, I is have positive and pleasant thoughts. Then O is observe the changes regularly, and U is try to upgrade the patient's health and behavior. And if you read these articles, Dr. Kalra has written, these recommendations are huge number of recommendations. And if you really read, you understand that all these things are actually happening in our patients, but we have never thought about all these things. And you just say that you start insulin and say that my patient is not ready to take it. Next. So there is a water approach, which is just published again by Dr. Kalra. WATER, welcome with warmth, ask, assess complaints, tell the truth why you are giving insulin. Don't tell that, let us see for a month, make the patient feel that after 1 month we are going to go back to oral. Explain with empathy and reassure in return. And then, one paper with Dr. Bansi and Dr. Kalra and their group talked about Da Vinci principles and insulin experience, about curiosity, experience, sensation, blurring of margins, art, science, balance, body health, and connections. And if you read the article, you will understand that actually, it's more of a human psychology which we are dealing with. Because finally, it's like a COVID vaccine. It's a therapy. But, there are so many implications of the therapy, because human beings are social animals and they live in a society. So how the best we can, translate this psychosocial thing into actual experience. Next, please. And so there is something known as insulin distress. And it's an emotional response of the patient to the suggested use of insulin. And mostly the patients are distressed. They are very much scared. They are very much apprehensive. And that is the biggest barrier to insulin therapy. So we need to address this. And a group of endocrinologists have come together. I will tell you the next slide, in India, to develop a toolkit that would help, whether it's a GP or an MD or a super specialist, to implement the motivation strategies so that there is a positive behavioral change. It overcomes the insulin distress and we can achieve our treatment goals. Next. And this is the paper. It's a practitioner's toolkit for insulin motivation in adults with type 1 and type 2 diabetes. An expert panel. Again, Dr. Sanjay Kalra, Sarita Bajaj, they were the main authors, and there were a lot of other people who are involved in the writing of this paper. And if you read it, you will understand that there are so many things which people think about, which are happening in our clinic every day, but we don't address it. And that's why sometimes our patients don't take the insulin. Next. So you have to understand that in the center of the circle is the therapeutic inertia. Patients are worried about the side effects. They're worried about the regime, burdensome regime, basal bolus is 4 injections. They're worried about the needle, about injection. They're worried about people saying that I lost my aunt because of diabetic kidney disease. Insulin was started. Somebody will say insulin was started. I had a heart attack. Then there is poor communication. So these are the barriers. And then the solutions are in the outermost circle. Your better therapies, so the hypo is less. You've got analog basal, so the hypo is less. You can, in India, premix is very useful to reduce the burden of the regime. There are devices, there are thin needles, there are pens. So the fear of the injection is reduced. Of course, we need support from our staff so that the negativity can be removed. And communication is very important. As I told you, that patients and doctors need to be on the same line as far as communication is concerned. And if you impart all these things, programs, mobile apps, good devices, support, and then, backup and improved therapies, then I think most of the barriers to insulin therapy will go away. Next,
sir, please little bit faster. We have a time limit.
Last two slides.
Okay, sir. Thank you.
Who wants to change? We always say who wants to change. Everybody says who wants change? Everybody wants change. When we say who wants to change, then nobody wants it. And when you say who wants to lead the change, everybody will go away. So when we attend the conference, we all say that yes, we need to start insulin. Then if we ask somebody that who wants to start insulin, then people will not be very happy. And then when you say that who wants to advise other people to start insulin, then definitely everybody will run away when we talk about this. So we need to change this mentality, and actually we need to see that insulin initiation occurs much earlier. Next. So this actually is the true thing, that if there is a good counseling, non-adherence is brought down to 26% to 90% adherent. So those who are not adherent, if you give good counseling, there is a very good response and people do listen to what you say. Next. So there is the last slide, and I have tried to, try to compress whatever I wanted. It's a very vast topic. I would request those who are interested in initiating to read, and that will help them out in a better way. Thank you.
Thank you, Ishwar, for elaboration of the topic. And now I think that my co-chairman is not there. So I would invite the next speaker, Dr. Naboza Lalik. Pardon me if my pronunciations are not correct. And he is the director and head of the Department of Metabolic Disorder. Also intensive treatment and cell therapy in diabetes, Clinic for Endocrinology and Diabetes Metabolic Disease at the Belgrade, Serbia. He is a professor of internal medicine at the Faculty of Medicine, University of Belgrade. He is the Dean of Faculty of Medicine in University of Belgrade. He is a member of Serbian Academy of Sciences and Art. He is the chair of National Expert Committee for Diabetes of Serbia, and he is the president of Serbian Diabetes Society, and he is the chair-elect of IDF Europe. And he is going to tell us about the ironing out glycemic variability with appropriate insulin choice. Dr. Lalik, please.
Distinguished Chairman, I would like to thank first of all the organizers and especially Banshi Sabu for the invitation to be with you today and to give a talk. Now I will try to share my slides. Can you see them now?
Yes, yes, doctor.
Okay, thank you. So my task of today is to try to put on the table the possibilities, the options, how to iron out the glycemic variability with the appropriate insulin choices. This topic has been very up to date in the recent years when many insulin formulations have been discovered. And when, on the other hand, we discover the glycemic variability is an important option for the to tackle for the optimal treatment of diabetes. That is why I will compose my talk with the first short introduction, and then I will be talking about glucose variability as itself, especially with reference to hypoglycemia and chronic diabetes complications. And then I'll try to in a systematic way say about what types of insulin treatment are promising in reducing glycemic variability with some final conclusions. So let's start with the beginning, the introduction. That is the basis and the dogma that we took with us for many decades, if you wish, that we should evaluate the control of diabetes through three main parameters, and that is fasting plasma glucose, postprandial, and HbA1c. And we thought that it would be enough, and in routine practice, it is more or less what we do. However, the data were accumulating that it is, first of all, not only HbA1c enough to assess glycemic control, and sometimes can be misleading, but also the changes of blood glucose, and as well as the variability of blood glucose, and not only the fasting and postprandial values. That with some technical upgrading that went in meanwhile, especially with the CGM continuous glucose measurement, we became aware that we should go back to glycemia, to its variability. Of course, not to forget HbA1c, but to put the control of diabetes in a more complex basis. That is, it is important, and there are a lot of evidences that it is important, because if you look, and this is of course a classical approach, to two patients that have almost the same HbA1c or similar, like these two in this subject 1 and subject 2. At the slide, you can see that the glycemic variability in subject 1 is really huge, with a lot of deep hypoglycemias, while with patient 2, subject 2, we don't have these phenomenon. So in this context, and if we look only at HbA1c, this very important fact for the control of diabetes in these two subjects would be neglected. So that it finally appeared important and accepted by almost everybody, that apart from the three parameters that we used for many years or decades, we should include glucose variability as the fourth cornerstone of the evaluation of blood glucose or diabetes control. And how to approach glucose variability. And you can see that you have a list of different markers, and of course you cannot get enough measurements in any environment, in any practice, to evaluate these metrics. And but usually how all this story ended up is that by these days, a coefficient of variation is something that is used as a measure of glucose variability, and measuring, in fact, the amplitude of glucose variability. But however, and that this approach has been prevailing until now when we speak about the glycemic variability. But in an effort to go deeper into the control, especially in type 1 diabetes, and especially in patients using new technologies in diabetes, such as insulin pump, a group of American diabetes associations have decided to go further on in defining the recommendations, what can be important for the control of diabetes in these patients, and to launch new parameters for evaluation of diabetes control, which can come from CGM, from continuous glucose monitoring. And they said in their recommendations that glycemic variability, in other words, stability of coefficient of variation, should not be higher than 36%. So we have now a goal to reach, and this is what is important, that glycemic variability evaluation now became quantitative, and it is there is an attempt, there is an effort that every patient in a practice, especially type 1 patient, falls into this category. And that is about introduction on glucose variability as an important parameter, which became very important in the last couple of years in the evaluation of patients for first of all, of type 1, but also of type 2 diabetes on insulin as well. Why is, from pathophysiological aspect, glucose variability so important? Because it is very tightly related to hypoglycemia and late diabetes complications. And you can see here the famous slide that is connecting the intensive treatment in DCCT study in the intensive group of patients, which shows that with the decline of HbA1c, you have with the changes of HbA1c, you can have the changes, the positive changes of retinopathy. But the other side of the whole story is shown on this slide, and that is that in intensive group, in fact, you have the increase of severe hypoglycemia, which is shown on the left side of the slide, and that in fact it goes as well with decreased retinopathy as together with good glucose control. By that time, it was not so important in the eyes of the investigators, who were happy to find some way to prevent diabetes complications. But however, by the course of time, it became visible that in fact you decrease the complications on the but the cost is high regarding severe hypoglycemic episodes. And that is, of course, that poses the question how to avoid it. On the other hand, some later studies have shown that glucose variability predict hypoglycemic events even in patients with type 2 diabetes, because if you look, those ones who have a great standard deviation of their blood glucose, and you can see that hypoglycemic events are the most numerous, especially in this group. So that the glucose variability can have a sort of physiological meaning in a way that can be the background on which hypoglycemia can develop also in type 2 diabetes. And the third aspect, which was underlined also from 10 years ago on, is the effect of glucose variability on vasculature and oxidative stress. Ceriello and his group made some studies evaluating the relationship between the changes of blood glucose. You can see these three groups: one with stable hyperglycemia, one with stable, let's say, almost normal glycemia, and one with the great oscillation. And you can see that the flow mediated dilation of in these patients is the worst, is very much affected in type 2 diabetes, especially in the group having the blood glucose from 5, oscillating from 5 to 15 millimoles per liter, so that FMD is here very severely affected. Something very similar happened in the situation which is not very frequently elaborated, and that is what happens after hypoglycemia. Because the changes, if after hypoglycemia we have hyperglycemia, which is rather frequently the case, and the cause of glycemic variability, we have the same picture of affected FMD, which then, but not FMD, the increased production of IL-6 and of some prostaglandins that are responsible for the atherosclerotic changes. So glucose variability might be the basis also on some unfavorable changes in the vascular wall and leading to atherosclerosis. Finally, the changes of blood glucose with different with the simultaneous hyperglycemia and afterwards hypoglycemia can induce increased production of free radicals in mitochondria that can cause many changes, that can trigger many pathophysiological intracellular mechanisms, some of them leading to the classical ones leading to microvascular complications like polyol pathway or increased PKC production, but also there are others who are very much related to macrovascular complications, such as increased expression of NF-kappa beta and increased presence of age. And this is the way how, in fact, glucose variability together with oxidative stress can be another channel amplifying the risk for both macrovascular and microvascular complications. In this context, glucose variability is not just a burden for obtaining the good glucose control. It has the meaning, an important meaning as an initial change for the for life-threatening hypoglycemia and atherosclerotic changes. And that is why there were a lot of attempts to try to decrease glucose variability with the use of insulin treatment. First of all, this curve of increased severe hypoglycemia at the same time retinopathy was decreased from DCCT attracted the attention for many years, and that was why one of the reasons to try to find some insulin formulations that would at the same time lower blood glucose and prevent late complications, but without such a high risk for severe hypoglycemia. And the discovery and the introduction into practice of the first generation of insulin analogs was in fact the first step in that direction. And because you can see that in comparison to NPH insulin with insulin analog, you can just decrease this relationship and obtain the same effect without severe hypos. And here, of course, the same process has been continued. And in this slide that is used many times, you can see that two most frequently used insulin analogs of the first generation are really decreasing the glucose variability, and that is and insulin variability, and that is clearly shown at these columns, but also at these graphs, making an adequate environment for the improving of the situation regarding the glucose variability of insulin therapy. That is not only when the whole aspect of the kinetics during the day is concerned, but also the overall, when you see what is the reproducibility of the overall blood glucose lowering effect, you can see that with these two insulin analogs of the first generation, you can obtain much better results than with NPH insulin, and that meaning glucose exposure tends to be more consistent in comparison to NPH insulin. So in this context, the same stands for a maximum blood glucose lowering effect, which is then also more suitable for good blood glucose control in comparison to that one with NPH insulin. So you can use them with a lower risk of inducing increased glucose variability. Finally, second generation of insulin analogs brought in also more potentials in regarding the daily glucose variability, and you can see that with some of them, really the daily glucose variation and can be for very low in when they are compared to the first generation of insulin analogs. It can be 4 times lower, and regarding the daily variability, analyzed with a very sophisticated approach with the use of insulin clamp. Somehow simultaneously to that, there is a lot has been done with the work of insulin pumps, which merged some 10 years ago with the with the glucose sensors, and created some 5 years ago world's first hybrid closed loop systems, in which were for widespread use, of course, in the countries that they can afford it, and in patients that are in the system that can afford it. But this sensor and the respected algorithm can really enable the control in which glucose variability is very much decreased. The number of companies that is really working on that is increasing day by day, and there is a lot of chance that at least for type 1s we will have a good tool for decreasing glucose variability. That is how daily download, as they call it, or the daily profile of glucose can look like in a patient. And you can see that the majority of values of blood glucose values are within the normal range, but it is to be noted that this is not a miracle by itself, and that here you can have some peaks of glucose here and there during the day or during the night or early morning hours, which should be all the time adapted, and for which, unfortunately, the algorithm is not something that can annulate this changes. But however, the situation is much better than with any other approach regarding glycemic variability. So finally, if you would let me conclude after all this, is that evaluation of glucose control in diabetes comprise not only testing of postprandial and preprandial glucose and HbA1c, but also of testing of glycemic variability, which is an important variable. That glucose variability is found to be an independent predictor of hypoglycemic, especially severe episodes, and increased glycemic variability diminishes flow-mediated dilation and increases oxidative stress, which might be the basis of cardiovascular damage. That's why it is something we should not forget in any patient. On the other hand, insulin therapy has always been associated at the very beginning with human insulins with increased level of glycemic variability. However, that became in the focus of the next attempts to improve the insulin therapy, and even the first generation of insulin analogs brought in decreased glycemic variability, thus enabling safer use of this type of treatment in the prevention of chronic complications without frequent hypoglycemias. Even more second generation of insulin analogs, especially basal ones, exerted even better removal of both hyper and hypoglycemic episodes, although still not perfect, but however with an important advancement. And the use of sensor-augmented insulin pumps with appropriate individualized algorithm can decrease glycemic variability to really marginal levels of importance for the control of diabetes. But of course, the limited use of this device, of this technology, still does not make it a sort of universal tool for the patients for the patients in any of our offices. Thank you very much.
Thank you, Dr. Professor Dalek. Now we will be going to the third lecture of the Insulin Symposium 2, and Dr. Florian Totti from Albania is going to deliver the lecture on new insulin therapy in diabetes, which is faster, longer, and safer. So may I have the biodata of Dr. Yeah. He is a lecturer at the Faculty of Medicine, Tirana Medical University, and he is the head of the teaching unit Service of Endocrinology and Metabolic Disease and University Hospital Center, that is named as Mother Teresa. He is the president of Albanian Diabetes Association. He graduated from the Faculty of Medicine, Tirana, Albania in 1992, and from thereafter, he was a resident and diploma of internal medicine till 97. And afterwards, he was a resident and diploma in endocrine and diabetes. And he speaks and writes fluently in English, French, Italian. Received the title of Doctor in Medical Sciences in 2005 with the thesis, Prevalence of Diabetes and its Chronic Complication and Metabolic Control and Diabetes Treatment in Tirana district. He is a associate professor in 2010 and professor of medicine thereafter in Tirana Medical College in 2015. He is participant on several national and international programs of diabetes, such as ALBI-DIAB, Screening Diabetes Retinopathy 15 years after St. Vincent Image Project, and he is also invited for delivering a lecture at ESD postgraduate course and national representative of IWGDF. He is the initiator and the moderator of different training programs for PWD, GP, nurses, and pharmacists in Albania. He is the first author of a writing group of national guidelines on type 2 diabetes in Albania in 2008 and 2012. And during this period, from 1997 to 2015, has published as the first author or co-author more than 13 articles in peer-reviewed journals, and he has presented more than 50 oral presentations in national and international conferences and Congress on Diabetes. So the floor is to Dr. Florian Totti, who is going to speak about the new insulin therapy, safer, longer, and faster. Dr. Totti, please. Dr. Totti, you are mute, so you have to unmute your mic.
Hello.
That's it.
Thank you. Hello, everybody, and thank you for inviting me to this marvelous Congress. That it is normal now. It is virtual. It's very interesting this session, especially, and I wanted to add some data about the new insulins. Can you see the slides?
Yes, yes.
Okay. So we are all familiar with how insulin is secreted in people without diabetes and what is the problem, especially with type 2 diabetes. More clearly shown in this graphic when we can see that especially for the oral glucose, people with diabetes tend to have a later answer. That's why the postprandial glucose is much higher to people with diabetes, and impaired fasting glucose is the first problem of prediabetes. This is the people that are known in the world for discovering and using insulin for treating diabetes since 1921. Very soon we will have 100 years of insulin use for people with diabetes. And this is Marjorie, a less known dog, who he was the first dog with diabetes made by pancreatectomy. And Leonard Thompson, the first person treated with insulin. Since then, more than 100 million people have been treated with insulin, and we are all very familiar with the miracle of insulin, with changes in small children already dying of diabetes, and they are living today thanks to insulin. But after the discovering of insulin, we were known with chronic complication of diabetes. Some of them are more familiar to us, some of them are less familiar, especially gastropathy and peripheral vascular disease. But we have to remind that when the people with diabetes are diagnosed, they have lost about 50% of their beta cell function, and their insulin resistance is more than 40% present in them. And diabetes is very costly due to its complication. If we reduce the glycated hemoglobin, we can reduce by 60 to 70% the complication of diabetes. If we reduce by 1% the glycated hemoglobin, we can reduce by 37% the microvascular complication, diabetic nephropathy and retinopathy. We can reduce by 43% the risk for amputation. We can reduce by 21% the death related to diabetes, 14% the heart attacks, and 12% stroke. And some of the messages that are very clear from the large studies made with type 1 and type 2 diabetes was that be aggressive with glucose control in type 1 and type 2 diabetes at diabetes onset or shortly after to prevent long-term complications, to have a glycated hemoglobin of less than 7%, and primarily in young middle-aged subjects free of vascular complication. But what we are facing today, we are facing a failure due to clinical inertia to our patient. In these slides, you can see that when the insulin therapy is initiated, the average patient has accumulated 5 years of glycated hemoglobin of more than 8% and 10 years of glycated hemoglobin of more than 7%. And it's true that specialist care endocrinologists are adding insulin faster, but even in this case, they are neglecting to increase the dose or to make a combination of 2 or more medicaments in people with diabetes. And when the general practitioners were asked when they would start insulin if they were diabetics, they were start their insulin for their own at 8.2% of glycated hemoglobin, but actually they recommend the insulin to their patients when the glycated hemoglobin is about 9.6. So the insulin therapy is initiated much later with a heavy risk for having diabetes chronic complication. And we know that higher is glycated hemoglobin, more important is the role of fasting glycemia. And when the glycated hemoglobin is about 8.5 to 9.2, the role of postprandial and fasting glycemia is almost the same. And the earlier basal insulin initiation can give a bigger low of glycated hemoglobin. If we can see, if we start the the insulin when the patient are with a glycated hemoglobin of less than 8%, it's true that they don't lower too much the glycated hemoglobin, but 75% of them will attain the goal of glycated hemoglobin of less than 7%. While when the glycated hemoglobin, the insulin is initiated when the glycated hemoglobin is 9.5, it's true that they can have a bigger decrease in glycated hemoglobin, but only 33% of them will achieve the goal of glycated hemoglobin of less than 7%. This is how the insulin is produced by our pancreas with bolus when we have the meals, and the basal insulin during the night or during the fasting period. That's why we have the rapid-acting insulins and the basal insulin. The first rapid-acting analogs are Lispro, where there are changes in amino acid lysine and proline, and Aspart, and the less known is glulisine. But how do they their pharmacodynamics is different? We can see that the insulin aspart is faster, for example, than human insulin, but faster insulin aspart is even faster than insulin aspart in itself. That's why they are used as pre-meals. We can see in this graphic what is the difference between insulin aspart and regular insulin, and we can see that insulin aspart, as all analogs, are with a higher and faster pharmacodynamics compared to regular insulin. And Lispro and Aspart have almost the same profile as we can see in these slides, where almost all the values are similar to each other. While the faster insulin aspart, even more faster than aspart in itself, and we can see that they initiate, that it starts earlier the effect, and after 30 minutes has already the double of the effect to lower the glycemic level compared to insulin aspart. From 15 to 30 minutes, the action of the faster insulin aspart is much higher than the insulin aspart in itself. And this is true for the subcutaneous injection and for the insulin pump use. So we can use the faster insulin aspart even in the pump. In the study onset one, the estimated glycated hemoglobin change from baseline was more significant with faster insulin aspart compared to aspart in itself, or even to the aspart before the meal. As for the safety findings, the number of adverse effects was similar between insulin aspart and faster aspart post meal or in the meal time for at 26 weeks and 42 weeks. Insulin 200 Lispro is a new insulin Lispro, more concentrated and with a similar action of insulin compared to Lispro, but much faster than rapid insulin. It has the same dose as 100 units insulin Lispro, but half of the volume. we need to monitor the potassium level. Would have fluid retention, especially when it is used in concomitant with TZDs. And the most common adverse events are hypoglycemia, allergic reactions, injection site reaction, lipodystrophy, and pruritus, which are almost similar with all other insulin. So for the basal bolus treatment, we have the bolus, which are analogs, fast-acting analogs or faster-acting analogs, and the basal insulin. The basal analog insulin, the more known are glargine 100, detemir, which are the first basal analogs, and after that we have some biosimilars, as it is abasaglar, which is a similar of insulin glargine of Lantus, and we can see that they have almost the same pharmacodynamics between them. So no changes in studies made with abasaglar compared to insulin glargine. And we can use them as basal analogs to especially to cover during the night or during the fasting period. Insulin degludec, it's a new basal insulin. It's produced in hexamers, and after that they are linked together to create a long multi-hexamer assemble, and after that they are deposited in subcutaneous depot, and the zinc diffuses slowly, causing individual hexamer to disassemble, releasing monomers. That's why the pharmacodynamic of insulin degludec is much flatter and much longer than the other insulin analogs, even in studies where you can inject it during different hours in different days, always having insulin in circulation even after 24 hours, but without any risk of hypoglycemic. This is the day-to-day variability between degludec compared to insulin glargine 100 units and insulin glargine 300 units. You have seen it in the previous presentation from Professor Lalic. And we have now combination of insulin degludec together with insulin aspart, so we can have 1 or twice daily injection instead of 4 injections per day. Another basal insulin is insulin lispro-pegylation. With the pegylated chains, we can longer the effect of insulin and having a much flatter pharmacodynamics. The most fearsome problem for insulin treatment is hypoglycemia, and which has a considerable burden to patient and society. In studies made in UK, Sweden, and Germany, we can see that the cost, direct cost related to hypoglycemia, is from 39 to more than 40 million euro per year for treating and preventing hypoglycemia for people with diabetes. That's why one of the most important tool to compare the new basal analogs to the old one, or especially to the NPH, is the risk for hypoglycemia, because they are all very efficacious to lower the glycated hemoglobin. So they had a better metabolic control. They have less weight gain with new basal analogs. But what is more important is that they have less risk for nocturnal hypoglycemia. For example, comparing insulin glargine 300 units compared to insulin glargine 100 units. And the same, it's true when we compare degludec, for example, with glargine 100 units. Another study was the CONCLUDE, a trial comparing the efficacy and the safety of insulin degludec and insulin glargine 300 units in people with type 2 diabetes inadequately controlled with basal insulin and oral antidiabetic therapy. And they have compared diabetic patients treated with insulin glargine 300 compared to insulin degludec 200 unit. And the post-hoc analysis showed lower glycated hemoglobin and fasting plasma glucose for the group treated with insulin degludec and less weight gain for people treated with glargine 300. Lower dose were used for degludec 200 unit compared to glargine 300 unit, and there were no differences in hypoglycemia during the titration period and no difference in the overall safety profile. But the severe hypoglycemic events in the group of degludec was much lower. And now we have a new basal insulin, once weekly insulin icodec, the new insulin from Novo Nordisk, and we had some studies. The last one was published just in November 2020. When they concluded that estimated mean change from baseline and the glycated hemoglobin level was 1.33 for the group treated with insulin icodec once weekly compared to the glargine group, and the rates of hypoglycemia with severity of level 2 and 3 were lower in the group treated with insulin icodec compared to glargine 100. Another issue with the new basal insulin is a so-called risk for some kinds of cancer due to the high level of IGF-1 receptor affinity, especially for insulin glargine. But in the study origin, we didn't see any increase in cancer incidence with basal insulin compared to the human insulin. Just 2 words about the insulin Exubera, inhaled insulin, which can be used as a bolus insulin. This is the comparison of the pharmacodynamics of inhaled insulin compared to the regular insulin, and we can see that the inhaled insulin has a much faster action compared to the regular insulin. There are some limitations to use it. It is used only in adults and in type 1 diabetes, but together with basal insulin, not for diabetic ketoacidosis, and we need to assess the lung function prior and during treatment. So, as conclusion, we need to remember that we need to titrate insulin to keep glycated hemoglobin of less than 7%, titrate basal insulin to fasting blood glucose between 100 and 110, 5.5 to 6.5 millimoles, titrate prandial insulin to 2 hours post-meal of less than 160 or less than 9 millimoles, and in summary, insulin therapy replaces complete lack of insulin in type 1 diabetes, supplements progressive deficiency in type 2 diabetes. Basal insulin added to oral agent can be used to start therapy. Full repriasis requires a basal bolus regimen, and hypoglycemia and weight gain are the main medical risks. But the new insulin analogs and injection devices facilitate use. In type 2 diabetes, use insulin according to the rule of 5 M's. More in more patients, more early at diagnosis or shortly after, more physiologically, prefer basal insulin first and prandial later as needed, more aggressively treat to target, and what is more important, more safely minimize the risk of hypoglycemia. And we need to remember that the insulin is a natural hormone created by nature, not by drug companies. But it is what exactly is missing in people with diabetes. If we can make a diagram of where we are, we began in 121 with insulin and syringes. Now we are here and we are very close to the closed loop, as Professor Lalich mentioned in his presentation. And the future can have microneedle patch, which can give like a small robotic insulin in the needed dose at the needed moments for people with diabetes. But still, we need the education to know how to treat and how to improve the glycemic control to avoid lipodystrophia, for example, in people with diabetes, and to have some jokes even about diabetes. And with that, I wanted to conclude my presentation and to thank you for inviting me to this wonderful Congress. Thank you very much.
Thank you, Dr. Toti. Now that comes to the conclusion of the third lecture delivered by all the speakers. And do we have any questions in chat box? If we do not have any questions in chat box, I would still request if anybody is interested in asking the stalwarts in the field to ask regarding their queries.
Navneet bhai, we can have some questions answered. To unmute yourself.
Yeah, I done that. Any
There is
questions?
no questions.
Bansi will ask question.
So this was a fantastic session. It started with Dr. T.K. Mishwar, and then Florian had talked about and then Nebo was there about the newer insulin, then ironing the glycemic variability. So there's always in India, there is a use of premixed insulin, which is one of the very highest use. And I could not understand after the continuous glucose monitoring, which had become very popular in our country also. I mean, still people use so much so premixed insulin, even to the type 1 diabetic patients. Even I don't understand the use of now premix in type 2 diabetic patients. I don't find there is any place where type 2 also a premix can be started. But in type 1 diabetic also, we see a lot of patients with insulin, which is started with premixed insulin. So I just want to ask all three of you that your personal experience with using a premixed insulin versus just a convenient to put the patients on it twice daily, not checking out for any glycemic variability, no monitoring, neither patient goes in hypo nor he may go in good control, and just you are satisfying ourselves only. So I just want to ask all three of you about your experience of using premixed insulin in your country and your colleagues. TKM, you can start with, then we can have
India, of course, as you rightly said, it's no reason why, but it's the favorite insulin. Premix analogs are also as favorite as premix human insulins. And I entirely agree with you that because the concentration is fixed, you have either 50-50 or 30-70 or 25-75. Once you start that, there is no way you can change the ratio of the short acting to long acting. So absolutely, you are absolutely right that in advanced diabetes, it is very difficult to titrate. Maybe initially in the first 4 or 5 years when we start premix, we get good results. But as time progresses, I don't think that it is possible to titrate or have a good control with premix, especially if you do a CGMS. You realize that there are areas where you have hypos and hypers, which a fixed 30-70 or 50-50 cannot cover. You need to have a different basal which works 24 hours a day and different bolus which covers the 3 meals. So I agree with you, but I don't know how long this premix is going to continue in India. And
continuously, it's a complete propagated,
yes.
the premix insulin marketing is done. And I can tell you, even if you can show me a single patient whose A1C is less than 7.5 and you have a time in range more than 70%, you will have a lot of hypoglycemia.
True.
I have more than 50 patients data of AZP, which I have kept recorded, and to show that, that is not a single patient where you can show on a premix insulin patient is well controlled. It is just a satisfaction from the clinician that you have started a patient on insulin therapy. And for a patient who is having feeling that there is a convenience to use it, people do use. I just want your opinion, Neboja, I mean, in your country, how you use, and then Florian also.
I mean, similar to India, there was, in fact, a widespread use of premixes in Serbia. I don't know, it may be a sort of a pragmatic phase of our approach to insulin treatment, in a way that we discovered postprandial glucose, and that it is important, and it was a sort of comfortable way to improve, let's say, postprandial glucose. But it was much easier for a patient, much more comfortable to do that with the premixes than with the combination of a basal plus boluses before the meal that represents the worst part of the day. But however, after premixes, a lot of other things have been discovered. So I think that slowly, because a lot of market has been covered with the premixes, and by the way, premixes were causing hypoglycemia in different types of the day. For example, you can experience them even in the morning, so before noontime. So this was the danger, but I think that gradually, with everything that has been discovered, with the GLP-1s, with the as very important postprandial agent, that premixes are slowly getting out of the scene. I mean, in addition, there are combinations of second generation analogs and that are taking their place. So in that context, I think that they will be replaced one day by new insulin formulations.
Vinay, want to say something? You're raising your hand.
Dr. Florian also, and then we will take some of the Indian experts, Meena and Mithun also.
Can I have one question, please?
It was like the use of premix insulin to, initiating and intensifying with the premix in the era of continuous glucose monitoring, where you have, and plus you have a better insulin, second generation, longer acting basal insulin versus premix insulin versus basal bolus therapy also. In type 2 diabetes, and type 1 definitely not to be used, but there are patients who are using still, or there are clinicians who are using in type 1 also.
Bansi, what about initiating premix insulin instead of basal insulin once daily in patients with type 2 diabetes, where you get an advantage of controlling your post-dinner as well as the fasting hyperglycemia, which you don't get.
I just tell you, I mean, I may be wrong, but I can tell you after, because before 4 years, I mean, I may agree with you that you may start the patient on premix, but then I started using the continuous glucose monitoring. I'm just telling you, Vinay, then once we started using CGM and EZP in our patients, I have yet to find a patient who is controlled on a premix insulin. If his A1C is less than 7.5, I can bet you that if patient is not going in multiple time hypoglycemia and he is achieving 7.5, I may change my statement completely, but otherwise I can send you 100 AZP reports who are on premix insulin.
You did not get my question,
Bansi, what he is asking? Yes, Dr. Vinay.
What I'm trying to say, Dr. Bansi, is Instead of initiating with a basal insulin once daily in the night, why not to initiate with a pre-mix insulin in the night?
I mean, you are talking of Rhizodeg is still okay.
No, I'm talking about even mixed start. I'm not talking about
because that the no mix part that once in a daily will not take care of 24 hours.
No,
so I am starting some of the patients on this new co-formulation because which contains a longer acting, and the biggest meal of the day can be covered with the 30% of the short acting insulin, Vinay.
Now, what the issue is the premix versus basal plus therapy. Now, when we look at the basal plus therapy, it is the basal insulin and the combination of a short-acting analog. So difference is there. If you use only single premix insulin, it will not cover the ideal basal insulin.
Exactly.
So that is the problem.
What I'm trying to say is the another shot should be a fast-acting insulin, not a premix insulin. The premix insulin in the night and rapid-acting insulin in the morning instead of another.
But then you use the co-formulation, na? Why you use the, I mean,
I'm saying,
don't make it something which is not scientific. Putting the patient on a premix night time and putting a short acting in morning time. Put co-formulation before dinner and put the short acting analog before breakfast or before lunch. I mean, try to give the therapy which looks more scientific.
Absolutely. Bansi,
I mean, yes, Meena, please.
Bansi, my question is that normally we read that 50% basal and 50% bolus. But in my practice, the boluses, the dose of bolus in most of type 2s when I'm giving basal bolus is much more, with about 20 to 30 units of
because we are carbohydrate eaters. Our diet contains a lot of carbs. Even for type 1 also, it does not go with 50-50. It has to be go 40.
So how will it go with 30?
My request to the all panelists now, I would like to take the Mithun comment also because he is thinking something, I don't know. But the point is the expert should use at least the best therapy because many more in India are going to follow you. So I mean, if you are not going by the what is guideline based, what is scientific approach, please make your, I mean, our prescription should be more scientific.
No, that's what I'm saying.
People will not follow you.
That when 50-50 doesn't work, most of our patients, carb eating country, need more boluses. How can 30-70 work? And
it cannot be. There is no possibility.
That is the question. So we definitely.
Mithun, you want to make any comment? Otherwise, we can
so
close
one small thing which I've tried and it works is that using Rhizotec and maybe using Voglibos or Carbos or something like that.
Fine. That is okay.
Yeah,
that's fine.
That is
perfectly fine.
Injections.
That's okay.
But I agree. Premix Mera, I'm out of 100 prescriptions if I do in a month. Not even maybe one prescription.
No, but Mithun, now even that you one patient which you do now, my request is you do the ambulatory profile.
Somebody who is not ready to
all
change
the
that
consultant who are sitting here, if they have a premix insulin, if they have a patient on premix insulin, and they have a A1C of less than 7.5, do AZP, and we can sponsor that study from RSSDI. So blindly you do, send the bill to me, I will pay for it from RSSDI, and I will get the data also. I can give you openly this statement. Openly, I am telling you. So once again, thank you. Now, I just request Dr. Navneet Bhai to wrap up this session so we can start with our oration.
Right. Thank you, Bansi. Once again, in a concluding remark, I must thank Dr. Ishwar for last-minute replacement because of the hassles from the international speaker who was sick, and he made a very beautiful presentation. We are extremely thankful to Dr. Naboza Lilik for his talk regarding the glycemic variability, and Dr. Toti regarding his newer, safer, longer duration insulin. So thank you all. It was a very nice and interactive session, and everybody contributed to this session. So we need to have a grand applause for all three speakers and Dr. Bansi Sabu for arranging this virtual Diabicon 2020. And now we are all looking forward to hear Dr. Parthakar, the Gold Memorial Lecture. So over to you, Bansi, and the rapporteur.
Thank you very much.
Yeah.
Thank you very much, sir, and the panelists for the wonderful session. I would like to hand over session to my friend, Dr. Rutul Goklani, for the Diacare Gold Medalist audition. Thank you.
Thank
Over
you,
to you.
Viral. Thanks, Navneet Bhai. Thanks.
Thank you.
All the speakers, Florian and Nebo and Tikam. So before we start the oration, I think we all can wish Partha happy birthday. So
Happy
Wishing you
birthday.
very happy
birthday is
birthday,
there.
Partha.
Happy birthday, Partha.
And today morning also, Dr. Meze also was remembering you. So now over to Dr. Rutul for this session.
Okay. Thank you very much, sir, for giving us such a wonderful opportunity. And we have now DIACARE Gold Medal Oration. We already had a wonderful session on continuous glucose monitoring today morning by Dr. Roger Maze. And now we have none other than Dr. Partha, who is actually pitching CGM so hard in UK and NHA. So I'll invite our today's chairperson, Dr. Premal Thakur, who is from Ahmedabad, and Dr. Sanjay Reddy from Bengaluru. Thank you very much.
Good afternoon, everybody. Thank you, Dr. Bansi Sabu, for having this wonderful virtual DIACARE conference. And happy birthday, Dr. Partha Kar. And I would ask my co-chairperson to kindly introduce the oration and its significance, and then I would introduce Dr. Partha Kar. Sir? Hello?
Hello, can you see me?
Yes,
yes.
And can you hear me?
Yes,
yes, sir.
Fine. Good afternoon, everybody. First and foremost, of course, I must wish Dr. Partha a very happy birthday and a very long, happy and useful and contributing life to the field of diabetes. And then if I'll be failing in my duty, if I do not thank my colleague and good friend Bansi Sabu for doing me the honor of chairing this DIACARE Gold Medal oration. It would not be out of place to say a few words about DIACARE Diabetes Conferences. The first was held in 2010, largely local, mainly with the family physicians in focus. As is well known, family physicians still provide care for a large majority of patients in our country. In 2014, the conferences became pan-Indian with speakers and delegates from all over India. The value and the popularity of these meetings can be judged by the fact that the last meeting in 2019 attracted 1,600 delegates. This year, in 2020, DIACARE Con has truly gone global, being entirely held on a digital platform, and has attracted almost 20,000 national and international delegates from all over the world. 40 international luminaries in the field of diabetes have done the DIACARE Con an honor by joining as faculty. This, in brief, is the history of the DIACARE Con. Once again, and once more, before I end, I would like to thank Bansi Sabu and his very hard-working entire team for holding this meeting smoothly, and you would all agree successfully, and in the process setting a benchmark. And one should also appreciate the fact that gold medal oration has been introduced with this conference. I would now request my co-chair, Dr. Sanjay Reddy, to introduce the distinguished speaker, Dr. Partha Kar, and then to invite him to deliver his gold medal oration on paradigm shift in the diabetes management with the advent of real-time CGM. May I please request Dr. Sanjay Reddy to introduce the speaker?
Good afternoon once again. Happy birthday once again, Dr. Partha. And it's been an honor for me to introduce you. I've been listening and probably interacting with you a couple of times. Dr. Partha Kar is a consultant in diabetes and endocrinology at Portsmouth Hospital, NHS Trust since 2008. He's been a clinical director of diabetes from 2009 to 15. His main passion is to helping redesign diabetes care in an attempt to integrate chronic disease management across primary and secondary care. He's instrumental and he's the co-creator of TED Talks that's talking about diabetes, and type 1 diabetes, rise of machines in the type 1 diabetes comic origins, is also very instrumental and been very active with Diabetes India and RSSDI, and also come out with something called Language Matters, which is very, very instrumental in trying to help patients with type 1 diabetes and practitioners like us to interact better with type 1 diabetes patients, and is passion for integrating technology with diabetes management, especially CGM, is well known and has been instrumental in largely advocating the use of CGM in all NHS patients, especially with pregnant women with type 1 diabetes across the NHS platform in the UK. He's a brilliant speaker, administrator, and also somebody who's passionate about what he's going to talk. And this talk on today would be paradigm shift in diabetes management with advent of real-time CGM. Over to you, Dr. Parthakar.
Thank you. Thank you. Good morning, everybody. Hope you can hear me. Lovely introduction. And it's very early in the morning here, so excuse me. I've just had my coffee, so I'm awake and I'm ready to give my lecture. But I would just like to say also, as ever, a big thank you to Banshi for the invite. Everybody knows about his famous organizational skills and all the events he throws. But this year has shown up another different skill of his, how to organize virtual conferences smoothly too. So it's been, fantastic. And to close the year with this honor, much appreciated. So without further ado, I will do the technology bit of sharing my screen so we can, hold on. Let's see. Right. Okay. So hopefully you can all see that and we will start. So we're going to talk time in range. We're going to talk about CGM, and we're going to talk about how this may be supporting the concept of looking at newer drugs, safer drugs. And it's not just in type 1, but across the spectrum, because I think it's a matter of time. It's a progression. And I always say that whenever we talk about new things, let's always look back in time and think about step changes in diabetes management as we go along. Step changes have been newer insulins coming through. Step changes have been, who have been in the business long enough will know about the step change of when we move from dipping of urine to pricking of fingers. And now we're moving towards, how can we check our blood glucose without any invasive techniques? And that is not surprising, because I have always said that if you want to look at how medical technology is evolving, you always need to keep an eye on Apple. So if you look at what Apple have done, Apple have moved from, just normal phones and stuff. And now the phones can also look at the option of giving you ECGs. They're looking at the options of giving you oxygen saturations. So it's a matter of time. Once you have glucose monitoring integrated into an Apple Watch or an Apple phone, I think that's it. That becomes very much mainstream. And I think during these present times of COVID, having oxygen saturation is obviously a big thing, etc. So that's where we are at the present moment. Taking it forward, I'm sure Roger Meze must have touched upon this in the morning, but I'm going to just to rehash that HbA1c, I think, continues to be an incredibly valuable metric, especially in many, many countries, that we need to be aware that when we talk about continuous glucose monitoring, we're very much at the start of a journey. We are nowhere near a situation whereby majority of the population can get it, and due to many reasons, mostly due to financial reasons, also due to the fact that not all clinicians are trained in it, which again is something that will happen with over course of time. We learn about new drugs, we have learned about SGLT2 inhibitors, we have learned about GLP-1 analogs, we've learned about newer insulins, and we'll learn about this technology as well. It's part of our job, and that's what we do. But HbA1c continues to be a valuable metric. And the most important thing is that that's the only metric that has been strongly associated with complications, according to all evidence-based medicine. I was here in the last talk, and Banshi was talking about science and evidence-based medicine. So if we still follow that, then HbA1c continues to be a very valuable metric. And that's important to bear in mind. It's also affected by conditions that affect the lifespan of blood glucose, red blood cell. And it's a surrogate marker, doesn't capture hypoglycemia, provides no information about short-term glucose variability. And I think there are racial differences, genetic. So there's lots of gaps in HbA1c, which again is very, so if I give you an analogy, I can give you the example of creatinine. Creatinine moved across to EGFR because creatinine wasn't giving you the full picture. The creatinine of For example, Arnold Schwarzenegger and the creatinine of Mother Teresa could be the same, with very different views of where things are. And you could probably look at HbA1c the same. It's got lots of variations around it, still the gold standard, but lots of variations around it. And I think that not capturing hypoglycemia is a major issue. So you can look at HbA1c on face value and say somebody's got an HbA1c of 5.8%, which on face value looks like absolutely brilliant and amazing control. But it's probably also negating out the hypoglycemia that person is having, and thereby we're missing out on that bit. And if we're just doing a look at the HbA1c, no further reviews, then that would have missed out some of the issues that we could have tackled with better drugs, better medications, etc. So here's some example to make the point. I mean, as you can see, these are the 4 people with very similar HbA1cs, and their glucose profiling, as you can see, very different through the day, very different spikes through the day. And I think taking a step back, that's what a continuous glucose monitoring does do for you. It gives you an overview of what's happening through the day. So rather than us sort of saying, well, you know, you need to just change your diet, or you need to probably give yourself one more tablet. What you can look at, for example, if you pick any one particular patient, let's say you pick the last one here, the HbA1c 8%, you can look at the spike in the evening and you're starting to think, well, is it the dinner time? Should we look at the diet around dinner time, or should we give them some fast-acting insulin? So in a sense, it gives you a better understanding of which areas to focus on and target, which I think is a very welcome as we try and get on top of HbA1c control. And as you can see, this is one of the issues with the HbA1c we talk about, especially with the racial differences. As you are in a tighter range, you can see the difference in HbA1c between the 2 groups, which can fundamentally also change your diabetes management. And I think that's quite important, that thereby we don't use it as a clear-cut singular marker for everybody, irrespective of the racial difference. So those are some of the drawbacks within HbA1c. So one of the concepts that has come through, Tadej Batalino, who some of you may have heard speak, and his colleagues have done a really good paper in Diabetes Care 2019. The reference is there. And they have come up with a proposal as to what we should have as our targets. Now, I think, as you can see, they're very ambitious targets. They're very different based on whether you've got type 1, not only type 1, type 2, it's about the older patients and higher risk. So you're trying to, for want of a better phrase, take your foot off the gas pedal, off the accelerator a little bit when you're in the frail category or the older or the higher risk category, irrespective if you're type 1 diabetes or type 2 diabetes. And you're trying to have more levels. So you're trying to avoid the hypos, in short, in that particular age group. So you can see the differences there about the pregnancy, the older, higher risk, and the type 1, type 2. Those of you who would like to have a look at that paper, it's worthwhile having a look and having that, just a simple chart, having it stuck up. I do have in my clinic room. It gives me a very good visualization of what we're aiming to do. And I think what it does do is have this sort of conversation with the person sitting in front. And I think this is why continuous glucose monitors, or in any shape or form, whether you're talking about Libre, whether you're talking about Dexcom, whether you're talking about Medtronic's Guardian Connect, what it does do is it changes the dialogue that you're having with your patient. So time in range is a concept where you're trying to get the patient's blood sugars between, if I go back one slide, and then you can see your target range is 70 to 180. So if you're saying to a person that, if you go back to this slide, if you're saying, well, if you get your blood glucose between that 70 and 180, around 60% of the time, your HbA1c is 7.5%, which is a very different place to be in, rather than saying, well, to get to 7.5%, you must do harder, you must try harder. What you're trying to say to the patient is that what we're not asking you to do is stay 100% in range, because frankly, that is pretty impossible to do. A lot of people without diabetes will struggle to do it. And I think, as you can see, 70% of the time in range brings you to an extremely good level. So I always say to my patients, have that discussion when, for example, they come with an HbA1c 9%. You're saying, well, why don't we do it one step at a time? Let's get it from 40% to 50%, because you can see that drop. And I think that sounds more achievable to the person, rather than the usual clinic review where you say 9%, let's try another drug and let's try and bring it down. And you don't know what you're targeting and you don't know what message you're giving. So the language matters thing comes into play a little bit, where we're not sort of just saying to the person, not showing our frustration. As I always say, people live lives you don't know the pressures they're under, but give people something achievable to do. It's a bit like, we all would like to have achievable targets in life. I don't know about you guys there, probably, but here, post-Christmas, we all put on weight. I certainly have, after having all my food and drinks, etc. So achievable target for me is to try and lose a bit of that weight. It's not easy at certain ages to turn around and say, well, as of next year, I'm going to turn something into like, I don't know, something like Brad Pitt or Salman Khan. It's not possible with all our work. So achievable targets in life is always good from that point of view. As you can see, 6.7, 70%, which flip it around. You're saying to the person, 30% is fine. Don't get agitated when you see that some ranges. Don't get disappointed. Don't get disheartened, but you're on the right track. Even if some readings are outside that range of 70 to 180, don't worry. 70% will get you an amazing HbA1c. So I'm going to talk a little bit about insulins because I think it's important, because what happens, understandably, a lot of conversations in the whole continuous glucose monitoring space goes very much limited into, oh, is it only about type 1? I'm going to give you a few examples where it's not the case, and why I think over the course of time, this will become across the board pretty much a change of paradigm of care. So as you all very well know, you can see the progression of insulin. I always use this slide to talk about a very similar concept that we have with iPhones. So those of you who have heard me say about it, I've said this many a time before. What is the difference between iPhone 4, and iPhone 11? The answer is nothing, especially if you want to think about what is its primary purpose, which is to answer a call. They both do the same things, no change. But why do we have a more upgraded iPhone? Well, first of all, because the older iPhones have been taken out of the market, so there's no option. And second of all, we very rarely use our phones nowadays just to answer a call. We do it for many other things, like we would like to have the internet very simply at the hand on our palms. We'd like to be on social media. We would like to, use an app for X, Y, and Z. We would like to play games. And I think if you think of insulin that similar way, that's what's happened with insulin. It all drops your blood glucose. What it does do as time has progressed, they're a bit more smoother. They give you more flexibility. They give you change of timing. They can give you less hypo. So it gives you more functionalities. And that's the way to look at the progression of insulin. And why do I talk about that? Because if you look at all the studies of insulin or the newer insulins, you can see the reproduced hypo. That's the main focus. And you've heard this from Novo Nordisk, from Sanofi, all of the guys who brought up their newer insulins. The focus has been very, very clear. Our newer insulins gives you much more smoother coverage, and it gives you less hypoglycemia. So you've seen this slide deck and had talks about it many, many times, and possibly done talks yourselves as well. If you look at these particular trials, and that's sort of in relevance to some of the earlier talks that was going on, you can see these sort of trials, and I'm not going to labor too much the point, but as you can see, these particular trials looking at this combination of newer insulins focusing on one thing again: confirmed hypos, nocturnal hypos. What are they talking about here? And this is where I go back and wrap it around the whole concept of CGM. How do you know a person is having hypos unless you know what the sort of time in ranges are? You don't, unless you're asking that person to get symptomatic, or they're waking up at different times a day, checking their blood sugars 8 to 10 times a day. It's pretty impossible to find it. And the reason we say that is because the impact of hypos on a system. So it becomes like a very, very circular discussion. How do we pick up hypos if you're not checking it? And how do I ask somebody to check it if you're not giving them a good degree of quality of life, which continuous glucose monitors do bring to a certain extent? Again, had study showing rates of hypoglycemia. Kamlesh Kunti, who you have heard from, fantastic speaker and professor from UK. Lots of studies showing that people reporting hypoglycemia not as high as much higher than what you would expect as things stand. Severe hypos, Southeast Asia being actually higher than severe hypos. And this is where I make a point, which I've done previous talks on about, is that as we grow older, our response to hypoglycemia, or in the sense of how our body reacts to hypoglycemia, is also very different. So it's not very easy to pick up hypoglycemia just by standard questions of, are you shaking and have you had a full-blown hypoglycemia? It doesn't quite present like that all the time. And here's the point I make: hypoglycemia twofold higher for older patients, because hypoglycemia in the elderly can present in a very, very different way than we find in our younger patients. And I think that's why it's underreported as well. Hypoglycemia hospitalization costs, as I'm sure you're very well aware, continues to build over the years. And the economics of it is a very good paper here, assessing the economic impact of insulin-related hypoglycemia, an excellent paper, which looks at what happens when you have the hypoglycemia on an economic basis, so to speak. So I'm sure you've seen all this, and in fact, this one has just recently been upgraded a little bit by the ADA. The ADA EASD guideline keeps on talking about the changes, a very much modern guideline, which is adaptable to all the changes. And you can see the focus, a lot of it here, which again, continuous glucose monitors would be quite useful to attain, especially when you're looking at the hypoglycemia side. And I always reference this paper as well, which came from India many years ago, which talks about hypoglycemia and type 2 diabetes. The point of these hypoglycemia slides are to say, this is where continuous glucose monitors have a very strong foothold, and they will gain one as we progress. If we are looking at simply of tackling hypoglycemia, how do you know they have hypoglycemia when we are not always sure of the presenting symptoms? This is where CGM can come into play, and I suspect will as we grow older, as we grow more attuned to the system of using hypoglycemia. So from a patient's perspective, there's this really good study done from King's College, which talks about what is, from the patient's perspective, the most important things for their diabetes. And most people are fearful of amputations. They're fearful of going blind, and quality of life is a very important thing. While for clinicians, on the other hand, a very important thing is glucose control, death, etc. So death actually comes number 6 or 7 on the list for somebody with diabetes, according to that paper. They're more worried about the quality of life. Amputation and blindness directly related to quality of life. And I always ask everybody, if with affordability understandably being a big question, that if you had diabetes yourself, would you like to prick your fingers, or would you like to have a non-invasive method of doing so? Answer is always the same. If the evidence base suggests that the device you're using is quality controlled and safe enough, then of course you'd like to use a non-invasive way of checking your glucose levels. Now, if you then take a step back and think of the use of glucose monitoring, continuous glucose monitoring, beyond the field of just type 1 diabetes, where I think it's absolutely priceless with a very different physiology, regular monitoring needed, and type 2 diabetes in people where you want to prevent hypos, take a step back and think of what use it could have, even on a short-term basis, for people who you're trying to look at preventing type 2 diabetes or to put type 2 diabetes into remission. There is a good paper out which talks about the role of what we call physical review of your own glucose levels in relation to food. So does it act as a motivator for people when they look at their glucose level? They can scan themselves, or the glucose reading comes up when you're taking certain types of food or you're doing certain activities. You have a better understanding, apart from the input from dietetic colleagues, as to what impact glucose levels can have on your body, what impact certain food does, etc. Do you then consider having one less laddu than when you go to somebody's house, etc.? So one of the things is about changing the discussion. We're talking about time in range with patients is a fundamental thing of where we go, bearing in mind fully the issues around accessibility, which is not going to be present for many, many groups of people. But for the people who can afford it, and I've heard Banshi say this many a time, there is a significant amount of people who can afford X, Y, and Z. And for the people who can, it's certainly something to go into looking at. As time progresses and hopefully prices drop and companies have bigger market shares, they look at prices, then though they will become far more accessible. You're talking about tackling highs and lows together. You're talking of using of appropriate drugs and assessing their efficacy by visualization. And most importantly, we are having a conversation of acceptability, in the sense that diabetes is with you. What can you do? What can we visualize for you that we as a clinician or a specialist can help you target, rather than blindly saying you need to do more exercise, you need to just eat more healthily. What are the obstacles? I mentioned clearly about availability and affordability being a big question. And just to put this in context, even in countries like the UK, whereby everything is funded from the national health and it's tax funded, not everybody with type 1 diabetes, let alone, has got access to every single device. And that's because it's not cheap. It takes time to show its benefits, as we are hopefully showing. But I always mention the point about industry responsibility, and I keep challenging industry personnel as well, that if they want their device to be widely available in markets which may not have the economic strength, then they also need to target the market accordingly, not just keep it for the people who can afford it. Because the more you use it, the more the efficacy grows, the more the confidence of people grows, and the more you move towards using it. So I'm going to finish there, but I think what I wanted to say is that I think as a concept, we're very much, I would say, we're in the foothills. So please don't take this talk as saying that this is it. From tomorrow, everybody should be on CGM. A lot of people you see won't be able to afford it. But I think it's about saying we are here at the start of the journey. And I suspect in the next 4 or 5 years' time, you will see this becoming very much more mainstream as you find other devices. And I said at the very beginning of the talk, biggest game changer, if Apple switches its technology and gives you glucose monitoring at the end of its phone or its Apple Watch, you'll see how that takes off as well. So I'll leave it there. I'll thank you again all for the invite and happy to take any questions if there are any. Thank you.
Thank you, Dr. Partha. That was very nice.
Thank you.
Thank you very much. And thanks for getting up so early on a Sunday morning to be with all of us. It's a challenge, I understand. Dr. Bansi, as is oration, it's customary we don't have questions, but I see a couple of hands up. I would leave the dais to Bansi to decide if he wants some questions to.
We may have some comments, because this is
Bansi, I have a question.
So yes, Meena and Dr. Premal Bhai and somebody, Dr. N.K. Singh also joins. I mean, if anybody wants to make some comment, but if they want some discussion also, Mithun is also there, and we can always have some comments from Partha also.
Yeah.
So Dr. Partha, my question is that diabetes and travel. So when you're traveling eastward or westward and you're going to live there, has that been simplified because of the CGMS? So patients who are traveling can see CGMS help them in deciding when to inject the basal again or the boluses.
Yeah.
Is there any such paper on diabetes?
No, there isn't a paper as of yet, but I always reference, there is a fantastic website that was built by Professor David Kerr called Diabetes Travel, right? So what we had to do, as all of you know, when your patient comes to you and says, well, not that many people are traveling right now, but, I want to go to, let's say, Brazil for a holiday. And you're sitting there thinking, is it to the east? Is it to the west? Does the clock go back or front? And what do you do? Now, that website was really useful because you could actually say to the patient, why don't you put what insulin you're on? And it will tell you when to change it, because that was quite clever. But the problem is that, as you know, that it's easier said than done when you're a long haul journey and you're traveling out. I think CGM does give it. I think especially what many of my patients do or used to do before traveling got banned is that they would set alarms. And that's quite a clever way to do it. So you would say that, what are you worried about? You're worried about your blood sugar starting to go up, right? And you're missing the timing of it. So what patients would do is set an alarm at a certain level. And if you had the alarm coming up in the middle of your flight, you might have missed your dose and you need to get up and do your dose. So absolutely, without question, for many people, and I know some of my colleagues who have diabetes themselves, they've used their functionality to great effect on long travels. Absolutely.
Thank you so much.
Dr. Partha, I have a very practical question now. I understand idealistically, or everybody in an ideal world, I would want everybody to be on CGM, and that's a dream. Now, if I want to choose patients, now this is a question from everybody else. I know pregnancy and CGM or type 1 diabetes, everybody should have it. Now, if you have limited resources, and what is the type of patient you would prefer to choose CGM?
Yeah, so I always talk about what I call in medicine. I think we need to look at what I call ROI, which is return of investment, right? So I think there are two groups of people who I think you will benefit a lot. One is, I think, the population where you're getting worried about them actually getting admitted to hospital a fair bit. In spite of everything you've tried your newer insulins, and they're still coming and saying, my dad's falling down, and he got in. So I reckon with them, it could be, even if for a short term, right? You don't have to keep it on them. I think that's quite useful. The other group of people, I think, is your young adults, both type 1 and type 2. So type 2 young adults, the return of it is huge if you can tighten, because what happens, you're in your late 20s, early 30s, and you're thinking, I can't possibly have diabetes. And you just, and those groups of people you have to tackle. Now, if you can tackle them at that stage quite quickly, right, by bringing their time in range down and convincing them, your return of them having a heart attack when they're late 40s or 50s is huge. So I think if you really and you want to pinpoint two groups, young adults and your elderly who are at risk of and having multiple hypos, probably would be your two groups, I would say.
I think my thoughts gel there. Thank you very much on that. But I think
Any more comments?
So one more, like Sanjay was asking, which are the patients or which are the group of patients who should be on continuous glucose monitoring. But I'm asking slightly, interested, which are the patients who should be on a professional CGM versus the continuous glucose monitoring? I mean, instead of that, because we have now availability of both professional as well as real-time CGM. So, I mean, we identify that class of patients who can be put only on continuous glucose monitoring, and some of them are on professional, that's fine.
So I think the continuous glucose monitors, like, let's say, I presume you mean things like Dexcom and stuff.
In between Libre and Libre Pro.
Yeah, so I think the continuous glucose monitors need a lot of adjusting to for the person concerned, because there is a big thing that's coming through right now called data fatigue, right? So let's not ignore that factor in the sense that you've got continuous data being thrown at you. So you need to have a particular mindset, also be ready for that. So if I ask, the way we have looked at it in the UK, just to give you an idea, we think Libra, for example, is a more mass device, right? Because it lasts for 2 weeks, in, out, gone, don't like it, easier to do. The Dexcom needs a bit of training. The Dexcom is more continuous. It's always there. It's got alarms on it. And lots of people with diabetes, type 1 or type 2, will tell you the alarms really causes them problems to the extent that some people just switch it off. So I think it's important to have that balance. And I think when you are picking a patient, the mass device nature of it needs to be borne into mind, which isn't very different to when you're using, let's say, metformin is a mass drug. There's no question about it. It is. Is SGLT2 inhibitor yet? Not quite. Will it become one? Maybe. But you still are thinking about the patients you want to pick and choose as you go along. So I think we're in that phase. But as I said, if Apple changes it, it becomes a mass device automatically, because just simply because of the reach. And I'd be very surprised if it doesn't happen already.
Thank you, Dr. Partha. I think we ate into some of the time for lunch. If there are no further questions, and with permission of everybody here, I see Dr. Das very eagerly saying that's my lunchtime too. And thank you very much. It was a pleasure. And I thank my co-chair, Dr. Prem Thakur, and also once again thank Dr. Bansi and the team for getting us all together.
Final comments from Dr. Premal Thakur, and then we will have a citation to Dr. Partha.
Okay, right.
I think Dr. Ashok Das wants to make some comments.
Yeah, I just wanted to say, Partho, it was a fantastic lecture. And yesterday, Bansi wanted to speak about the legacy effect. You rightly said that in the young people between say 20 and 39 and 40 to 64, if we do not use this device, or looking the other way around, that if we allow the blood sugar to be high, they will be having more heart attacks, kidney attacks, and as you rightly said, and that's the best opportunity. So this group, as you rightly said, I'm very passionate that my younger colleagues must use in this group more and more. That was my talk. Thank you.
Thank you. Thank you.
Over to Parimal.
Thank you, Dr. Partha. Thank you very much. That was a very enlightening lecture. And most important 2 points that you made. First is time in range. And secondly, we are at the foothills area. In a country like India, not all patients can afford it. But we hope in due course, it will be possible. Thank you very much. Thank you.
Thank you.
Once again, thank you, Dr. Partha. Thank you, Dr.
Thank
Sanjay.
you.
Thank you, Dr. Premal Bhai and Dr. Rutul. Now, can I request Neelam for a citation, which we are offering digitally to Dr. Partha, and gold medal also digitally we are transferring, but we will definitely get gold medal also when Partha will be meeting.
Sure, next year, sure, absolutely sure. Vaccines coming out.
Vaccinated, Dr.
So you
Partha.
vaccinated?
You got the vaccine?
You got the vaccine?
I have had the first vaccine of Pfizer. The good news this morning is that the Oxford vaccine has just had their second data published with 95% efficacy, which I know India has been waiting for. So hopefully it should be rolled out not very shortly afterwards. And my parents can get it, and then I can go and visit them, which is what I've been waiting for a long time for now.
Thank you so much.
But now we are London flights, we are screening more. We are worried about your plan,
You should. Our hospitals are completely full. You should, absolutely.
So that's the problem. But in
Okay,
India,
but
probably, hopefully, we will get the vaccine, the first dose, maybe in month of January, or we may have announcement on 26th of January. I don't know.
I
Dr.
think so.
Das can comment on it when the vaccine is going to come to India.
Are there more sick patients in the hospitals now as compared to the previous?
Yes. Yeah. We are back to where we were. It's quite busy. So we have, so tomorrow I've got shifts and stuff. So we are all back on the wards. It's quite busy right now. I mean, it's heavy. It's heavy.
But here we have less now, comparatively. I think across the
country. I mean, you know, Banshi, I grew up in Calcutta. I mean, after, you know, as I've always said, if you can drink water from the streets of Calcutta, you can survive anything. So, you know, it's fine.
Yeah.
Good one.
Oh, very nice.
Thank you. Thank you once again.
Thank you, everybody. Much appreciated. Have a good. Okay. Bye-bye.
So now we have only 15 minutes for the very quick lunch, but we have the next session speaker already. Dr. Naresh had come, and we can have some discussion. I think when Mithun is there, the discussion can be there for next 15 minutes. There is nothing to worry. We have Dr. Nasser also. So at least
no rush, Banshi. We can join in 15.
Discussion for next 15 minutes to start because it's 1:46.
Okay.
Rightly, we have to start by 2 o'clock.
Okay.
And 1:30 to 2 o'clock was a lunchtime. So that was 15 minutes was delayed. So Naresh, please wait for.
No problem.
You have your morning coffee?
I've just got it now. I'll see you in 15. No problem. I just want to make sure I'm logged in and everything's okay. So that's
you are in the right. I mean, Dr. Ashish Thakur also. He is also, I think he logged in also. Dr. Ashish Thakur is also there. And then the Chantal will log maybe later on. So for next 15 minutes. Ashish is also there. I can see him very well. Dr. Thakur, how are you?
Good morning, everyone.
Hi, Ashish.
Hi. We're 15, 20 minutes late or?
No.
We're in time. We're in time.
Absolutely right time. It is 1:45, 1:46.
Sure.
Actually, we were having the lunch break between 1:30 to 2 o'clock. And 1 to 1:30, we were having the oration. So
that's a really great idea. A long program like this, it gives you that little bit of room to maneuver.
Yes.
And
that's the reason we had kept a 30 minutes break. So, you know, even if it gets late, by afternoon time, everything is compensated.
So am I going after Dr. Kanumali?
Yes. No, you are the first one, I think.
Yeah, you're first, Ashish.
Yes, Ashish is the first one. The second is Naresh Kanumali.
Sure. So,
you know Ashish, Dr. Ashok Das? I'm sure you must be knowing him.
I'm your father's colleague, Ashish.
For a long time.
Professor BBT is my senior colleague and very close to me, Ashish. I was about to just tell you that yesterday, if you see the postings on the Diacon, people have appreciated Bansi's absolute time keeping. And there is one of my friends, Jyotidev has posted that above everything else, the punctuality, the way virtual cannot be late, as you rightly said, Ashish, and it was great.
Virtual cannot be late. I fully agree, sir. Everybody is at the right time, you know.
So it was absolutely good timekeeping. Today also good timekeeping. So we'll start in 15 minutes. Good.
And from one session to other session, we are keeping enough time for the discussion, and then from one talk to other talk, there is a difference of 5 minutes.
Naresh, I'll tell a story in the meantime. No, I was in Japan for a meeting. So my wife was with me, you know. So after I reached there, my talk was about 2 o'clock. And between 1:45 and 1:40 and 2, there was a speaker who didn't come. So I requested Ashish, one of my colleague, Dr. Took. Now he's become Sar Took. He is the principal of a college in London now, medical college. So I told that, can I give my talk? I knew him very well. Give my talk little earlier. My agenda was to go to Kyoto with my wife. So he said, no, you cannot give the talk because somebody might come to listen to you exactly at 2 o'clock. So you wait till 2 o'clock. So that's
here though in India we can't have, because at 2 o'clock this is a digital platform and people will be logged in at 2 o'clock. We had just sent a message to all the registered delegates that at 2 o'clock there is a diabetes and heart failure symposium.
We cannot start before 2 because people might log in at 2 to listen to Ashish. session.
A fantastic organization, the Bansi. I mean, it seems like it's going like clockwork here. Well done.
Yesterday, I was talking about Bansi in another program. It was NUCD workup. I am in charge of that program also, but one of my relative, Kanun Go in Qatar. So I just described Bansi that forget about the organization, forget about the social work, forget about the type 1 work, forget about his contribution to diabetes in country, RSSDI presidency. But you know, of late, Bansi's scientific contribution also has been great. You see his talks on the TIR, he talks on the recent advances, he talks on the GLP-1. You know, I think really multifarious. God gave him more strength and more energy to carry it forward.
Absolutely.
Ekeda sir, there's something else that has changed. You see, India when I was in UK, we have Greenwich Mean Time. India had an Indian Standard Time, which was generally half an hour, 1 hour from the actual time. I think online has changed that, and perhaps physical form में भी रह जाएगा थोड़ा बहुत.
नहीं हो जाएगा. जैसे मैंने Andrew used to come to India for many times for diabetic footwork, Mithun. So I'll tell we'll start the meeting 12:30, and as Indian I sometimes say 12:30 sharp. Even today, also 12:30 sharp.
In England, we have for those people from Wales, we have something called Carmarthen time, which is anytime. So you can turn up anytime, speak anytime, whatever you want.
Naresh, tell me again, what is it? What time? What is the Wales time? What is it called?
Carmarthen. Carmarthen is a place in Wales. Carmarthen.
Carmarthen time.
Carmarthen time.
Like Greenwich.
Or anytime. You turn up whenever you want. You speak whenever you want.
I'll tell you a small story. When I had returned from England, I was there 14 years. When I'd come here, when I got invited for a marriage, it stayed 7 p.m. onwards. Yeah. You used to get up and get there at 7:30. Nobody would have been there. Not even the bride or the bridegroom's side. So we slowly learned. That means 1.5 hours के बाद आना, पहले नहीं आना.
That is the time bride goes to the shop for getting painted and getting the attire done. They go at 7:30. They come back at 8:30, and you have to wait in the hall till they arrive for meeting them.
Exactly, sir.
We'll just be back in 2 minutes.
Sorry? Yeah.
Be back in 2 minutes. Yeah.
We'll do some work in that AGP field. Roger and me were together in IBC. So, and we went together to China and to Hong Kong for their step diabetes, SDM, no? SDM is given up now, not given up, is now become old. So, but he's a fantastic guy. And you must bring the sister Ellie, you know.
Yeah, Ellie, very good lady.
Yes,
Ellie was very good.
Now she has left. She has joined, I think, Eli Lilly or something. I don't know where she has joined, but she's not working in the Bergenstill or Roger now.
I think there was IDC, I think Majid left, and then I think Bergenstill is still there.
He's there. Where is Ellie now? Ellie is where now?
Sorry?
Ellie is where now?
Ellie had moved on. She has sent me an email where she has moved on. I can find out and send it to you.
Yeah, then I'll
but she has moved on from the IDC. That part I know. No, it was very useful. It was Roger really mentored me, and I learned a lot of. I used to do a lot of AGPs because of him.
And you know, the respect they give you is great, and the noon salad on that road on the right hand side. I talked to Kamlesh yesterday. I inquired about Dad and Dr. Kamlesh Tiwari. Ashish, I'm talking to you. Ashish, are you listening? So he said that Shah is fine. So yesterday I talked to Kamlesh ji, our API president now, about Shah, about Dad. So he said that that everything is fine. Shah is doing very well. I have not talked to Dad for last 1 month, person to person. He's busy, and I didn't talk to him.
Thank you for your kind.
Thank you. And Dad and Mom came down here. You know that, to Pondicherry. I was so happy. And
absolutely. I mean, I've been there. I mean, the last time I was there.
You have a Pondicherry connection. Your brother's wife is from my place, Pondicherry, Punna.
Well, Pondicherry was my brother.
Peck. They were from the Pondicherry Engineering College, no? Peck.
That's right. and I'd been there on a good few occasions, and I remember the CSI conference in Chennai.
Exactly.
In the year 2000, when it was a really big meeting, and then we all again went to Pondicherry because I really loved the place.
Come back again. I
used to go and buy the from that Auroville shop in the town. I used to buy incense sticks.
It is still.
That's all I could afford from the shop. I used to as a resident, I used to enter the shop and just buy 1 or 2 or 3 packs of incense sticks.
There's another shop has come called Oroform. So this Oro will going to buy something to Oroform. For the first time, they got a shock of their life by seeing the price at the Oroform.
and I used to kind of show off in my room and not use it for up to 2 years.
Good place.
Because Delhi, I mean, at that time, traveling was, flying was not a common thing. So the Tamil Nadu Express used to take about 36 hours to Chennai, and then a bus straight from Chennai bus station
to Pondicherry.
Pondicherry used to take about 2.5 hours roughly.
Exactly.
And but it was a nice, very nice journey actually. So, but when we went in, I think 10 years later, it was all very nice. And I even went from Chennai to Bangalore by road, via Sri Perumbudur.
Via Sri Perumbudur. Correct. 40 miles from Chennai.
And visited the memorial and
Rajiv Gandhi Memorial.
Yeah, that is again about 20 years ago. I think 25 years ago. So
I think that is here. That is in the, sir, can you make your video on? Sir, Bade Bhai, that is here, Ashish. Sir, will you make your video on?
Yes.
Sir, namaste. You see, I was just talking about you and
I heard you.
Sir, where is madam? Madam should be sitting with you. Shiva Parvati should be together, sir. Lakshmi Narayan should be together. Madam is not here?
Oh, madam is there.
No, not visible, sir. I cannot see madam.
She is not here, naturally.
Good. Thank you, sir. So very happy to meet you. My sincere regards.
I'm glad to see you. I was listening to you.
Thank you, sir. Thank you. Good. Sir, it's a very bright video. You should have made it on. Fantastic. Good. I think that's video you see, Ashish, brighter than yours. No, it's brighter, quite brighter. No. What we do, Ashish, we put a lamp just behind the laptop, and the that light comes on your face, because India has become the e-medicine capital, Ashish.
Yes, absolutely.
So what we do, Bade Bhai, we put one round light here, cold light source, so that light comes to the speaker. So the speaker is lighted. Otherwise, no.
Hello, Bansi.
Yes, sir, I can listen to you. I am sorry.
Bade Bhai is missing you.
I was just busy and to start with some other hall. That was the reason. So once again, sir, welcome. Thank you.
God bless you. God bless you.
You called me, so I thought you should be here, and that's.
No, I called you to appreciate you.
No, sir.
The program was going on well.
All your blessings.
Absolutely.
I always remember, and I'm sure you also must be having the sweet remembrance of our 2011 API. And sir was the ICP chairman, and I was working, and that CME program was done by Dr. Thakur Saab.
Yes.
And we were there at Muzaffarpur also.
Yes. Muzaffarpur, I went. I stayed in the house, sir, fixed for me. Fantastic place.
Yes, sir.
And that sir put me in somebody's beautiful bungalow.
That doctor is no more now. Dr. C.M. Jha.
Yes, C.M. Jha. See, he passed away.
So, do we have Maulik, Pradeep Joshi, and Anand Shankar?
Anand is here. Anand is here. I saw him just now.
Yes.
Anand
is there. If Maulik and Pradeep Joshi is also must be there.
Pradeep is here.
Pradeep Joshi is here, sir.
Pradeep Joshi is here. Bansi bhai, once you call anyone, they will be there. I can see his name.
Pradeep is here.
Pradeep, good morning.
Good morning, sir. Good morning, Bansi.
It's now good afternoon time because it's a, sir, we are in Bhavnagar. The speakers are from UK. So for them, it is good morning. Anand is from Patna.
जब पहले
Pradeep is from...
good morning होता है. पहला meeting is good morning.
Good morning, Ashish sir. Good morning, Naresh sir.
So I think now we can start, Anand. I don't see Maulik, I could not see. So you can start the meeting.
Sure, sir.
And
So,
to introduce with our first speaker, with Dr. Ashish Thakur. And we have a great pleasure that today we have not only Ashish is with us, but we have Dr. B.B. Thakur, Ashish's
Exactly,
father,
sir.
and very eminent personality from India, an eminent physician, who is a past president of our API, Indian College of Physicians, and a very respected teacher for me. So I welcome Dr. Thakur Sahab for gracing the occasion. And now I request Dr. Anand and Dr. Pradeep Joshi to chair this very important session on diabetes and heart failure. And you please introduce Dr. Ashish. Over to Dr. Anand.
Good afternoon to all in India and good morning to all in UK. Respected Vish Pitama for me, Dr. Thakur sir, Dr. A.K. Das sir, and respected all. Thank you, Dr. Bansi sir, for giving me this opportunity to introduce Dr. Ashish sir. Sir, Ashish sir is a son of soil of Bihar, and we are very proud of him. He always encouraged a new talent in his all forums, and he's consulted cardiology in the this Mid Yorkshire NHS Trust, and he's an honorary senior lecturer in the University of Leeds in medical school. So I request Dr. Ashish sir for his oration. Over to Dr. Ashish sir.
So I request Dr. Lejek to start his oration, his paper, and that we will discuss this paper later on. So over to Dr. Lejek.
Good afternoon.
Thank you very much. I must thank all the organizers, Dr. Sabu and everyone who've kindly invited me for the DiaCareCon December 2020 virtual, which I'm sure is running fantastically. I hope you can see me, see my slides, and hear me well. Am I heard well?
Sound is little less, I think. Ashish, little louder. I don't know whether my system, little louder maybe.
Can you all hear me well?
Yeah, it is better now. Much better.
Okay.
Yes, sir. We can hear you, and your slides is visible, sir.
All right. Thank you very much. So I think this is a very interesting topic, and the more you think about it, the more you start to worry about diabetes in general, as to why it kills people. And this, perhaps as a wider term, affects the mortality of diabetes quite significantly, and continues to be perhaps the #1 cause of death in patients of diabetes, if not just morbidity. So I'll be talking about some perspectives. I'm not going to be kind of lecturing about medications in particular, but giving you, are you not able to hear me? Raise hand if you can't hear me.
Now it is
okay.
very clear. Ashish is very clear.
Right, okay, great. So, I think in terms of my disclosures in the last 12 months or so, well, you know, it's been a pandemic, and we've just had some admin support from a few industry partners for our educational events, and nothing more to declare here. Now, this one, perhaps you will all be aware of, that diabetes actually, and now we're talking of type 2 diabetes, because heart failure in particular has been studied for the large majority in people with type 2 than type 1 diabetes. However, we know that over a period of time, type 1 diabetics have a similar outcome than compared with type 2 diabetes patients. But most of the research which has been conducted so far has included type 2 diabetes rather than type 1. But we can, and all the results have been extrapolated to them, to that cohort, to extract the information and apply all the channels. But we know that, this is a complex syndrome. There is a glucose excess, there is resistance to insulin, and that leads to a lot of things, as you can see in red and green, eventually leading to something called, either through the muscle route, causing a weakness of the muscle, or through the arterial or circulatory route, causing ischemia, etc., eventually affecting the muscle, making it much weak, and causing what we call as a diabetic cardiomyopathy, either on its own or in combination with different things, eventually called heart failure with reduced ejection fraction. But this is just a beginning of the story. If you look at this just gives you a slightly different perspective in terms of how you want to see this. It's again a different way of seeing this than just one particular way. And again, going from left to right, you've got so many things ranging from atherosclerotic cardiovascular disease to a range of metabolic, cellular, structural dysfunction, neurohumoral activation, all culminating into ischemia or hypertension-related change or a muscle-related change, eventually leading to heart failure. To be precise, if we really had to break it down further, we continue to learn as we speak that heart failure has a much greater impact on cardiovascular mortality in diabetes than myocardial infarction and stroke. And we continue to learn this, and these are some of the trials which are focusing on the newer novel anti-diabetic drugs. And this is one of them. Maladaptation. Now, that is a real thing which happens within the cardiac myocyte in diabetes, eventually leading to a diabetic cardiomyopathy. I wouldn't really want you to spend too much time on this complex cartoon, but just look at the things in blue here, that these are a series of things which happen eventually in a heart muscle, in the heart artery, within the interstitium of the heart, so on and so forth, within the electrics of the heart. And the key things are heightened sympathetic response, apoptosis, fibrosis, inflammation, heightened oxidative stress, all culminating to cardiac dysfunction. And that's what perhaps is now recognized as a clear entity called diabetic cardiomyopathy. Now that just summarizes what I've just said on the left side in the text form. In three key features, they can either have hypertrophy, they can have dilatation of the chamber, as you can see in the lower cartoon, or eventually leading to weakness or dysfunctional pump due to a range of conditions. And the treatment is linked to treating one or more of these conditions. Now, linking that to what we do for these patients as doctors, cardiologists, diabetologists, and team members, that we try and shift the balance much more towards this side, depending on the functional class of the patient, ranging from 1 to 4. We don't want them to have continued insults. We don't want to have them minimal or under treatment. We don't want to have progression of disease as much as possible. And we can try and using whatever we can in terms of what we have available in whichever part of the world we practice and work, we can try and put them towards this side rather than trying to keep them in this side. But we know diabetes doesn't have recovery. There's no recovery. Remission is something which has never been tested as an endpoint in any trial. We talked about it on the World Diabetes Day last month, in October. And of course, we continue to learn more and more and more, actually, about these things. On November, I think it was just before Diwali, we talked about remission as an endpoint. So we've now moved on to something really interesting, which I'd like you to know. And if you may be already aware of that, we've been talking about heart failure. Well, that's just a reduced ejection fraction, which is less than 40% as per established criteria. The large majority of diabetes patients will also have symptoms due to preserved ejection fraction, which is just complaint of breathlessness, the reduced effort tolerance. And then in the middle, this is still being studied as we speak as heart failure with relatively mild or heart failure with mid-range ejection fraction. That is, again, it's just semantics and it's just maths. But remember, this is something which is still being studied in terms of impact on medications and long-term treatment, long-term therapy, and what happens to the structure and function of the heart. So for the discussion purposes going forwards, I'll be dealing with the reduced primarily and a little bit on the preserved side of things to give you a flavor of where we are as of today. So this is an echocardiogram, as you all must be aware of how it looks on a 4-chamber view. This shows you a dilated left ventricle. That's the left atrium, right ventricle. You can see the contractility on the right side is much better. And on the left side, this chamber seems to be a bit wider, dilated. And here onwards, it seems to be a bit thinned out. And even though these segments seem to be contracting, they're not contracting as well as this. And this area seems to be contracting much less. And this is what typically you would see in a patient with ischemic heart. An inevitable sequence, consequence of this. If we really had to turn around, now that's something which on the right side, compare this to this, you see that this is a much, much dilated or wider chamber where it's contracting quite weaker or just moving around a little bit. And that's with pooling of blood around in. And this is what a dilated cardiomyopathy rather than a regional wall motion abnormality type thing looks like. And many people laid down the line are diagnosed to have this condition rather than this, with rather normal coronary arteries, but just muscle dysfunction. And these two would fall under reduced ejection fraction because of the weakness of the heart muscle or the LVSD, whereas this, if you see, shows you a reasonably contractile left ventricle with a little bit of thickening around. And these are the patients who would complain of breathlessness all the time, most of the time, with every single activity or minimal activity, despite no matter what you do for them. And that's probably what we would know as heart failure with preserved ejection fraction. So that just gives you a flavor of how you image, and you can pick up what sort of phenotype they might fall in. Okay, so it's a unique syndrome, right? So there's no doubt about it. We can keep on discussing this, but moving on, it's a perfect storm in the body for lots of things, primarily premature atherosclerotic disease leading to sudden cardiac death. We know that 70% of mortalities in heart failure due to diabetes are not due to pump failure. They are due to arrhythmias and sudden cardiac deaths, for example, whereas the other bits are, and they are mainly triggered by acute coronary events, whereas the rest could be pump related. So this just gives you a comprehensive list of what all you can expect unique syndrome. What are the key challenges from an Indian perspective, which I've learned having worked across both continents on a regular basis? That, of course, I mean, we're no different here versus there, but there are certain specific things perhaps which we should be aware of. Age-wise, there's no difference. I mean, except for the fact that Western world might have or does have a much higher elderly or very elderly population. We have massive discrepancy in our homeland in terms of levels and types of care, and that is reflected in the range of mortality from the different causes I've just mentioned, and add to that atrial fibrillation. That's so common. We have an undefined burden in lots of areas. We don't have a national heart failure register, and guidance derived medical treatment. We're not sure about it. Well, I'll tell you a little bit going forward, but I don't think we're using medications as we should. We're not kind of revascularizing appropriately, anywhere perhaps, and patients are not aware of the diagnosis they carry, the prognosis they have, the medications they are on, why, etc., etc. And of course, multiple opinions are sought that lead to delays in prognosis, and of course, prognostic or non-prognostic treatment. So there are some unique challenges, and the always breathless patient is always the biggest challenge we all face all around the world, with multiple comorbidities, you name it. And we're now continuing to recognize that anemia, renal impairment, lung, vascular disease, other organ disease, so common, especially if you have an elderly or very elderly person you're going to deal with, and add to that AF, weight problem, small coronaries, so on and so forth, and previous revascularization. It all can get just difficult after difficult to try and sort these patients out, and mental health again is within the center of it. It's a large case burden, we know that. So we have to adopt a heart team approach often to try and slow the trend and try and improve the prognosis and adapt the resources locally, use novel drugs where we can. Not everybody is going to have an LVAD. However, LVAD has changed the whole course of these patients. There are much less transplants being carried out than LVADs being implanted. Palliative care is much better on the board. And we are able to undertake lots of procedures for these people now to try and give them a better prognosis in terms of something which can come out after difficult discussions and meetings in teams. So that's just a cartoon. I'm sorry to use this horse analogy, but this is just gives you that the large majority of heart failure you and I would see may not be systolic dysfunction, but just be diastolic impairment. But we can perhaps prevent that transforming into systolic dysfunction. Yeah, we know this is a circle and a vicious cycle, muscle, altered coagulation, kidney disease, vasculopathy, so on and so forth. Now, we're not really good at symptoms assessment. We can assess the glycemic control quite well. We can perhaps point out the comorbidities and look at what else is going on in terms of the patient, and that will make us worry about what we need to really do for them in terms of every single medication we want to give them. We may want to do tests. We may want to give point out some red flags. Assessment of silent myocardial ischemia is not yet perhaps an established standard of care. And we know that females, especially diabetics, continue to experience microvascular vasospastic angina. And we should have a backup plan for refractory symptoms as to what are we going to do for these people. And ultimately, the one-stop heart failure clinics are the only perhaps option for them. Right, so a little bit of nitty gritty. About 22% maximum, I would say, overall prevalence. However, it can vary up to 50%. Hospitalized, about 40%, 4 times the general population, and much higher in elderly, as you can see on the right graph. Now, bear in mind that up to 30 to 40% of LVADs currently, the assist devices have diabetes. About 20% of transplants have diabetes, with worse outcomes compared to the non-diabetic ones. So that's just some snapshots. The spectrum of coronary disease, it just gives you a flavor. If you look at these moving pictures, you see why it is so difficult to offer every single treatment. So this is an artery of a 38-year-old man with diabetes. Doesn't look any different from an 82-year-old lady with small calcific coronary arteries with tight stenosis, which could be diffuse, and that's from a 76-year-old man with multivessel disease. And that's what you expect to find when you take these people onto the cath lab table to find out what's going on in the coronaries. And unless you sort that out, you're not going to make them any better in terms of prognosis or symptom if they have systolic dysfunction. Recurrent CAD is another big problem, that no matter what you do, their endothelial response is so aggressive that, so this is a chap with a couple of stents in his LAD artery, and he's coming back and back and back with symptoms, and his neointimal response continues to worry him, and that's, of course, is causing him more problems on the go. So it just gives you a flavor of the kind of stuff you need to look at and think out of the box while treating somebody with heart failure. However, bear in mind, don't be surprised if you see absolutely plumb normal coronary arteries in people with a heart failure, and only to give you a sigh of relief that you only need to treat them from a muscle point of view. So we have consensus from ESC guidance that for diabetic coronary disease, PCI works in most of the people. However, CABG is preferred when there's complex disease or multivessel disease or proximal LAD with left main stem. I wouldn't go into detail of that. How many patients of diabetes have been included in clinical trials of medical treatment? Well, not many. It's interesting that only until the recent last about 10, 15 years, studies have shown to have increased number of diabetes, and the recently conducted emperor-reduced trial of empagliflozin had about 50% recruitment. That was considered to be a landmark, compared to the initial 1990s trial of SOLVE trial, which only had about 27% or so. So that shows that how underrepresented were diabetic patients in those heart failure studies. So that's the sort of algorithm. You first try and find out, is the heart muscle weak or is it preserved? If it's weak, you find out whether there's coronary disease. If it's yes, well, then you try and deal with it. If no, then you get on with the 3 key medical options, which is the angiotensin inhibition, either using ACE/ARB or ARNIs, and beta blocker as best as possible, and MRAs, and then think about SGLT2 inhibitors as it's being talked about, and then consider other things. Do not ignore the anatomy unless it's normal. That's the message. For preserved ejection fraction, there is no defined treatment. It is supportive treatment and management of comorbidities. That is the underlying message. So, learning from all these trials over all these years, what we've kind of learned that we could treat either symptoms, we could treat prognosis, we could treat for prevention, we could treat for reduced hospitalization, and try and improve survival. And we know that whatever you do is going to work for everyone, not just diabetics, for heart failure, except for a few medications, which are slightly different. routinely, IV iron is now used because a lot of it was being ignored in the past. And we have specialist units which run iron infusion for these patients, and that suddenly improves the symptoms. I'd be very interested to tell you that this data was really mind-blowing. The CHAMP heart failure registry, that no more than 1% of the people in the study were on optimal doses of any conventional medication, which included beta blocker, ARNIs, ACE/ARB, and MRA, etc. Only about up to 30% were on beta blockers, optimal doses, or ARNIs or ACE/ARB, and about 70% or so were not on MRAs. So you can imagine how far we need to go even before we think of anything else, because these three medications are prognostic. They reduce mortality, we know. They increase lifespan, we know. So we must try and do everything we can before we move on to other things. In our population where we work, no matter where we are, India, UK, US, here, there, I think this is what is the gold standard. We must stick to the basics of the medications we know which make difference. A simple medication like ramipril in optimal dose can cause a huge difference, along with a beta blocker and a potassium sparing diuretic if tolerated. So that's what happens, when we try and use these medications. This is a very complicated slide, but this is a recent one which shows you that complex interplay of different medications trying to address different needs and trying to treat at cellular and micro level in terms of trying to address, along with glucose modifying medications. Glycemic control and heart failure, well, basically the underlying message that lack of intensive glycemic control and heart failure, admission and death, well, it's got to be individualized depending on functional status, life expectancy, hypoglycemia, etc., etc. It doesn't really reduce all-cause mortality or cardiovascular mortality. It may reduce non-fatal myocardial infarction if you're really going for intense control. So that has been shown. And that's quite well represented in this American Heart Association slide, ranging from 6.5 to 8.5%, and just showing you how you need to flex between these factors shown in blue and individualizing the care rather than just thinking like in a straight line. Preserved ejection fraction. Now, goalpost is moving. We're now trying to subset these patients that actually, are they obese? Are they just diabetic? Do they also have risk factors? Are they just breathless? Do they have pulmonary hypertension? Do they have COPD? Do they have sleep apnea? So on and so forth. And then addressing everything differently, accordingly, and trying to see if it works. And that's called phenotyping of these HFpEF patients, and then trying to address their lung arteries, musculoskeletal weakness, AF if they have, causing them problems, chronotropic incompetence, so on and so forth. This is a wonderful way of trying to address those issues. Until recently, we've been saying, oh, there's no cure for it. Yes, there is, but you really have to go down and sit down with the patient and address every single comorbidity separately in trying to see if the echocardiogram doesn't show any LV dysfunction, systolic dysfunction wise, I'm saying. And that's what it summarizes here, that we just focus on treatment of comorbidities, mainly diabetes, hypertension, CAD, obesity, and anything else you might come across needing help from your other colleagues, which may involve pulmonologists, nephrologists, mental health specialists, so on and so forth. I wouldn't show you this because this is a diabetology meeting. There'll be talked about the glycemic control medications and what they do for heart failure, etc. But I'll just move on to the ESC recommendation that yes, they're all class 1 in terms of ACE beta blocker and MRAs, which I've just said. Wherever possible, Entresto does really work, but we need to have a little bit of caution about using it with other drugs, with potassium and blood pressure being two important considerations. I'm more than happy to answer a few things from our experience at the end of the talk. And of course, further treatment as indicated. Ivabradine, yes, you can and you must use where you think that beta blocker cannot be used. It's a class 2A indication, so yes, there is good amount of evidence to show, and it's the medication which can give you a much better heart rate reduction compared to a calcium channel blocker if you combine it with a beta blocker. If you're struggling to control the heart rate below 70 or so, do not combine direct renin inhibitor. That's not recommended with other things. Yes, and that's just a repetition of things what I've said. And you must revascularize. Now, lowering the risk, of course, SGLT2 inhibitors or this unique medication, we're still learning how it works. Whether it works by reducing glucose, whether it works by reducing the things in the cardiac myocyte, so on and so forth. And we'll learn a little bit more on the go in the session today. But yes, this is something now shown to have made a real difference, and now class 1 indication to lower the risk of heart failure hospitalization in patients with diabetes. In fact, it's now recommended even for people without diabetes in heart failure due to the benefits. And that's perhaps shows you in summary as to how they protect both from a heart failure and kidney point of view, and also trying to bring the hospitalization down. The more the risk factors, the more the benefits, so on and so forth. And yes, there are issues. We all have found issues in using them, and there is a patient selection to be kept in mind. But they are very useful, and where they work well. Time will tell. I think by next year we would know a little bit more in terms of the other group of medications, the GLP-1 agonists, which have really made a difference to the atherosclerotic risk, which for diabetics is another key indicator, prognostically, and how we can combine them together, and maybe we'll have more trials coming along the line to say that yes, this is now perhaps a complete change or shift, a paradigm shift in diabetic management. So that's a summary of evidence, in terms of novel drugs, both with risk, without risk, so on and so forth. They all reduce rehospitalization, and EMPA reduces mortality as well. And they all stabilize CKD and reduce heart failure hospitalization. So just to sum up, I think we need to treat this as a team. We need to have our, from a UK point of view, we have diabetes nurses, we have community setups, we have hospital setups, and they're linked together, and it works well. There are regular annual checks, so on and so forth, and one-stop clinics. Secondary care, there's a lot of people involved, and you can see that, and if you take it another step forward from a cardiology point of view, then this is what we call as an extended heart team approach for these patients, where often we have to make complex decisions with a lot of people involved at one stage. And this slide is about 10 years old when the whole concept started to emerge, and we were mandated to use them, and we have weekly meetings now every Wednesday. I'll end with this. Now, I spotted this day before yesterday. This has come out. Feel free to browse through. It's a wonderful document, again, emphasizing on different aspects. And thank you very much for your time. I'll stop sharing now.
Thank you, Dr. Shakur, for a very lucid presentation. And yes, you're right that this is bringing everyone together. The diabetologists, cardiologists, all are having good thoughts on the CCF. Our next talk will be by Dr. Naresh Kanumili. He will be speaking on SGLT2 inhibitors, now more used in treatment of the heart failure rather than the prevention. Dr. Naresh is practicing as a physician and diabetologist in Manchester. And I remember his one quote that medication should be always after the education. So he's a very good educator. Over to you, Naresh, sir, for your talk. Thank you.
Thank you very much. I'll try and share my screen. So thank you, Ashish, for a fabulous presentation. Always good to hear a cardiologist speak before me, in the sense that, as you said, in the UK, there's a lot more cardiologists taking on board about diabetes now, and that is fantastic. And as you said, we also are arguing the toss whether SGLT2s are cardiology drugs or diabetes drugs, but it's good to know that we're all fighting for the same reason anyway. So I want to just take a perspective from primary care, and I'm lucky enough to sit in secondary care as well. So I can see what's happening on both sides of the coin in a sense. And so I just thought we'll just do a little bit of, I'm not going to go straight into the trials, etc., because I do feel that we would have touched into a lot of it during this conference. So these are my disclosures. So we talked about, again, we must have heard about this a lot of times now. Diabetes is a growing global epidemic. 1 in 11 people have diabetes, and it's going to increase year upon year. And none of us, especially in diabetes world, or now even in the cardiology world, are not going to be out of business. 80% of diabetes burden is the lower middle income countries, and 30 to 80% have undiagnosed diabetes. But we also know about how to treat diabetes. We know that once we start treating diabetes, we want to try and prevent micro and macrovascular complications. And again, this is teaching you to suck eggs with regards to these. And one of the things we were focusing today on was the thing around the 33% increased risk of hospitalization for heart failure. And diabetes is just more than hypoglycemia. I think, like Ashish was saying previously, when the diabetes world, a lot of the diabetes specialist nurses, etc., were focused on hypoglycemia as the main aspect of management of diabetes. But now we know there are huge other implications around it. It needs to be a little bit more holistic. And I think a lot of the holistic care generally tends to happen in primary care, dare I say, and in secondary care sometimes, although I am sitting in secondary care at the moment, I also feel a lot of us are still glycemic focused until the recent cardiovascular outcome trials. Again, this data is available for everybody to see that the importance of glycemia. So one thing we should not forget, yes, glycemia is important because it does reduce all these complications. But patients with type 2 diabetes remain at increased CV risk. And again, we can see in the UK with regards to improvements in the use of statins, ACE inhibitors, etc., we have reduced the morbidity associated with diabetes, but death from diabetes associated with cardiovascular risk still continues to remain at a high level. And again, Ashish touched upon this about optimization of therapies. I mean, it does not happen just in cardiology, but also in diabetes as well. About this is work done by Kamlesh, etc., as well, which shows actually we take such a long time for adding additional therapy. In heart failure, they get discharged into primary care. We ask them to optimize up-titrate therapies, and that generally does not tend to happen, which is a sad thing because that actually promoting or increases the mortality associated with heart failure. And time to additional agent, again, this is, again, like I said, it is work done by Kamlesh. It just shows mean A1C intensification was 8.7%. And by the time we get to using insulin, it generally tends to be about 6 to 6 years, which seems like a phenomenally long time for a person with diabetes, with all the added problems associated with diabetes and the microvascular and macrovascular complications. We're talking about heart failures per se. Heart failure is one of the first complications that cardiac complications, type 2 diabetes. It's very frequent. Again, 68% in one study had evidence of LV dysfunction 5 years after their type 2 diabetes diagnosis. It shows that these people are the ones who have not had a previous ischemic event, still presenting with some evidence of LV dysfunction. and it's almost forgotten. Again, if you look, 28% of patients with type 2 diabetes population had undiagnosed heart failure. And then it's fatal. Again, Ashish touched on this, concomitant diabetes doubles the risk of heart failure in people with risk of death in people with chronic heart failure. Besides risk factors for development of heart failure, type 2 diabetes also increases the risk of hospitalization for heart failure. We do know that repeated hospitalizations for heart failure, again, increases your mortality associated with heart failure. So just reiterating the point, that heart failure hospitalization associated with very poor prognosis. Then again, we've touched upon this before. There's a heart failure and diabetes interaction, a two-way pathophysiological link. I won't go into this because Ashish has touched on this about the different mechanisms that are reported to be involved in development of heart failure associated with diabetes. And heart failure has wide clinical implications, including the potential for kidney damage. I think one thing we're trying to understand nowadays is, okay, there is a link between the heart, the kidney, and then how is it that one thing leads to the other and worsens one another? And that's why I think not just heart failure combined clinics, we're now having what are these, we nationally call CARE-ME clinics. Currently we're developing, the guidance has already come out on how to run a holistic approach to patients with diabetes by running what are called CARE-ME clinics. So heart failure increases the risk of kidney function decline and adverse kidney outcomes. So on the left, you can see heart failure is associated with more rapid decline in eGFR. On the blue bar is the one person with heart failure showing at least 22% rapid decline in eGFR compared with those without heart failure. And heart failure is also associated with significantly higher risk of incident chronic kidney disease and mortality. So we can see there is a link between heart failure and kidney disease. So it's not just enough talking about heart failure, we need to link that with the kidney and the metabolic consequences of diabetes. Declining in eGFR and worsening albuminuria increase the risk of developing heart failure. This is also considered individual risk factors for developing heart failure and increasing mortality and morbidity. And what we also need not forget is not only is heart failure increasing in prevalence, diabetes is increasing in prevalence, but diabetes and CKD is also increasing in prevalence. Like we said before, there are 422 million adults living with diabetes. 30 to 40% of these patients will develop CKD. And the number of deaths associated with CKD, as you can see on the right, is rising exponentially. And it is the leading cause of end-stage kidney disease, and prevalence is increasing. So preventing diabetic kidney disease or reducing diabetic kidney disease progression could reduce CV events in type 2 diabetes. So what I'm trying to do here is just saying it's not just about heart failure, but it's not just about the kidney, but it's a whole system approach that we need to be having, which is what, again, Ashish talked about. Like he said, they had this multimodal clinic with the patient at the center, and that data was published about 10 years ago, and we still haven't properly established these clinics. And right now we want to bring in the nephrologist into the whole team as well. He did have a nephrologist on the slide as well, but I think now the nephrologist is going to be more acutely involved, especially with the therapies that we are talking about nowadays. So if you look at it, compared with diabetic patients with no kidney disease, people with diabetes and stage 3 kidney disease have 3 times the risk of congestive heart failure, 85% higher risk of myocardial infarction, and 65% higher risk of stroke. Therefore, focusing on detection of DKD and preventing or slowing its progression could substantially reduce rates of cardiovascular and non-CV events. So unsurprisingly, cardiorenal disease associated with mortality risk in type 2 diabetes. So heart failure, CKD, you can see the hazard ratios are high, and similarly with regards to all-cause death as well. Despite this, there's a high prevalence of both undiagnosed heart failure and CKD in type 2 diabetes. I think one of the things we are trying to promote here in primary care is for GPs and nurses to have a high index of suspicion with the person that presents to you with symptoms such as shortness of breath, fatigue, leg edema, but no previous history of ischemic heart disease. We're trying to build into the templates of the nurses asking these particular questions. And we're trying to develop that and saying what particular question will direct us to send a person with previously no history for a BNP or an echo. So things like orthopnea, are they using more pillows than normal, but they have not had any diagnosis of ischemic heart disease or heart failure. So you can look at this, I showed this before, it's 28% of patients who are undiagnosed. And with regards to CKD, not a lot of persons with diabetes know about CKD. And then once you talk to them and say, oh, I've got chronic kidney disease, they suddenly start getting very worried about it. So if you think about it, 96% didn't know they had CKD stage 1 to 2. 82% did not know about that stage 3 kidney disease. So cardiorenal risk develops along a risk continuum, highlighting the importance of early prevention. Again, prevention is the key here now. Now that we got a lot of data talking to us about, okay, when do we introduce certain therapies? Can we introduce it earlier on in the disease cycle to enable better management and reduce cardiovascular outcomes? So you talk about multiple risk factors, which we have to deal with no matter what. And then we talk about disease progression, risk of complication outcomes. Lifestyle modification is something that has to exist throughout the disease cycle. And then you look at medication targeting specific conditions, complications, and outcomes. So this is where prevention works, and there's a therapeutic window. The reason for this is we do know that some of the trials, the cardiovascular outcome trials that have been discussed at this conference and also to be discussed later, some of them focused on people with established cardiovascular disease, and some of them focused more on patients with multiple risk factors. Those are the people that we generally tend to see in primary care. And the people to the right are generally tend to be people who Ashish probably sees. You know, you probably have established cardiovascular disease. So the question is, how can we add life to years and not just years to life? Again, we talked about this multidisciplinary approach. Important to have lifestyle advice and support. You optimize blood pressure, lipids, and CKD. And in the UK, we have what I call the 3 treatment targets. That's the HbA1c, blood pressure, and lipids. And those are mandatory, and I think they are the keystone of management. But now have these additional therapies that are available that help us look beyond those 3 as well. One thing we advise in the UK, and like Ashish touched upon it, in India, there's a lack of registers. Here we have registers and we have phenomenal data within primary care. And we're trying to encourage people to actually audit the people with diabetes and look at people who are possibly high risk groups and probably bring them in for medication optimization and change of medication if necessary. DPP-4s are commonly used and very widely used and very cheap, and they're probably the 2nd most prescribed drug, or probably 3rd most prescribed drug after metformin and sulfonylureas. But they do not reduce CV events. They can be what you call they are safe, but do not reduce CV events. Again, Ashish touched on the fact on one of his slides about saxagliptin not being a good drug to use in people with symptoms suggestive of heart failure. Whereas SGLT2s and GLP-1RAs, they affect on major adverse cardiovascular events across all the trials. You can see the benefit. Obviously, Alexa did not show that much, but every other trial, Leader, Sustain, Excel, Pioneer, the EMPERE-REG, Canvas program, DECLARE-TIMI, all of them showed cardiovascular benefits. GLP-1RAs demonstrated neutral effects on the risk of hospitalization for heart failure in patients with established cardiovascular disease. But SGLT2 inhibitors can prevent hospitalization for heart failure in patients with ASCVD at baseline. All these trials that we looked at, EMPERE-REG, Canvas, DECLARE-TIMI, all showed that. Obviously, the patient populations were different in each of these, especially if you look at Canvas and DECLARE, they had people with multiple risk factors, a higher proportion compared to EMPERE-REG, etc. So when people ask you, okay, which SGLT2 you use, I think it's difficult to just say, use this one, use that one. But I think I would focus on what the trials showed, what the patient population was. And a lot of people would argue whether this is a class effect, but I'll leave that for a discussion for another day. So again, available evidence suggests benefits are modified by kidney function. Whatever the eGFR, there seems to be some benefit because we do know below 60 of eGFR 60, the higher the glycemic effect or hypoglycemic effects of SGLT2 inhibitors is much reduced. So it's purely for that they had an EGFR of 60. It was not for any safety reasons, it's more for efficacy. But we do know that below 60, the effects for heart failure and kidney disease were present. So that's why the licenses are changing currently. Again, I'm not going to go through this, but SGLT2 inhibition may improve hemodynamic parameters. Patients with type 2 diabetes potentially leading to cardiorenal protection. Various mechanisms have been put forward for how SGLT2 inhibitors might be protective. And they talked about diuretic effect, the effect on the arterial walls, effect on the heart itself. So there are various things, and it's still being investigated. We're not completely sure. So how has it affected the guidelines? I mean, there have been huge changes in the diabetes guidelines across the world. Sadly, NICE is still coming up to speed with that, and they're currently undergoing change. But at the moment, if anybody was managing a person with diabetes, would tend to use either the ADA or EASD guidelines. And this actually, what is happening, this actually takes into account what is happening within the cardiovascular outcome trials. So what do we do? I mean, most guidelines tend to be very cumbersome and huge. So what we did in Manchester was trying to develop what's called the Manchester Cardiometabolic Pathway. Excuse me. And we tried to distill the guidelines into one page and try to make it easy for people managing diabetes in primary care to be able to decide what the next best therapy is. And all this was evidence-based. And the pathways generally tend to be dynamic. So because as the evidence is changing, we need to be changing the pathway as well. Guidelines, especially in the UK, will take much longer to change. So we go through various bits of how to manage with regards to monotherapy, dual therapy, presence or absence of ASCVD, etc. Again, triple therapy. And then intensive therapy about insulin. So it takes you through various stages of management. So I've just put up a case here, just purely from the fact that I'm not going to go through an elaborate discussion about it, but this is kind of a typical person we might see in our clinics who presents with raised HbA1c and lipids are satisfactory, but he has a diagnosis with heart failure 6 months ago. And the question was always, what next after metformin? And this is where our guidelines come into focus and say, well, actually, if you have somebody with this sort of risk factor and heart failure CKD predominates, think about using therapies such as the SGLT2s, which have cardiovascular outcome benefit. Again, if you meet the same person, John, but this time with a CKD progression, we try and advise about diabetes, kidney disease management, which generally talk about A, B, C, D, which is ACE inhibitors, blood pressure targeting, cardiovascular risk reduction, and diabetes management. Again, the guidelines suggest that if CKD predominates, you focus on the type of therapy that would invariably tends to be an SGLT2. And especially with the data that's come out now with regard to canagliflozin, and then we're awaiting data from DAPA, CKD, etc. So this has been a game changer for us with regards to using canagliflozin, and it gives you proper guidance on when to initiate canagliflozin. And it's taken away the barrier of EGFR of 60. So what do we do with intercurrent illness? This is another thing that we're promoting heavily, especially during the COVID period, trying to, especially people who are on SGLT2s, trying to show them the importance of remembering sick day rules. And we use this acronym, which is called SADMAN, which is SGLT2, ACE inhibitors, diuretics, metformin, ARB, and NSAIDs. These are the therapies that you need to look at if you are unwell. There are numerous resources that have been available for people to try and manage diabetes in primary care. And we've got this available at GP Notebook and gives you a step-by-step guidance about which SGLT2 to use, when to stop, a red, amber, green guide for usage of SGLT2s. And so it makes it easier. The reason for all this is to try and promote earlier initiation of therapies, which we know now have huge benefits for persons with diabetes. And also We're talking about people with heart failure and no diabetes nowadays. Again, GLP receptor 1 guidance. So when I die, I want my grave to have free Wi-Fi so people can visit it more often. So in summary, type 2 diabetes is complicated by multiple interconnected cardiorenal metabolic conditions, and type 2 diabetes, CKD, and heart failure, especially intertwined, is associated with an increased risk of heart failure and end-stage kidney disease, both of which result in poor prognosis and increased risk of mortality. There's a bidirectional risk relationship between heart failure and CKD, with onset of one associated with increase of onset or progression of the other. And cardiorenal risk develops across a continuum, highlighting the need for early intervention to prevent disease onset and progression. I will stop there and take any questions there any. Thank you very much.
Thank you, Dr. Naresh. We will, yeah, Bansi, please go on.
No, questions can be at the end, so you can invite Dr. Shantal now. She's there.
Okay. So thank you, Dr. Naresh. Over to our next speaker. She's Dr. Chantal Matthew. She's a professor of medicine and a hand of endocrinology at the Belgium. And her topic is impact of CVOTs on contemporary guidelines for heart failure and CKD. Over to you, ma'am.
Hello, dear friends. Greetings from Belgium. And I have to tell you, I hope my internet will hold, because we are having a big storm here in Belgium. So, yeah. Can you see my screen?
Yep, we can.
Yes.
Excellent. So it's really a pleasure to be with you. And thank you again, Banshi, for inviting me. And you know that I prefer to be face-to-face in India and not on a Zoom conference. But with the vaccines happening, we will see each other again. I am sure of that. Here are my disclosures. And actually, when I was preparing this talk, I was thinking of how to start this talk. And again, I use my pet slide to really illustrate the complexity of treating people with type 2 diabetes. It is one of the most complex diseases, with, as the previous speakers introduced, all kinds of complications and organ systems coming together. But when we're talking about glucose control, there is one phenomenon that is quite central in type 2 diabetes, and that is the failure of the beta cell. Indeed, in order to have the hyperglycemia that is an integral part of type 2 diabetes, you need a failing beta cell. If you have a very strong beta cell, you can be as resistant against insulin as you wish. Your beta cell will overcome this. And so this failure of the beta cell is what creates all of the problems for the clinicians worried about glycemic control in type 2 diabetes, because this failure of the beta cell is a progressive phenomenon. And I brought here a very old slide from the UK PDS, where they calculated beta cell function. And so at the time of diagnosis of hyperglycemia, you have a decrease in functional beta cell behavior of about 50%, and this is a progressive phenomenon. And so when we go back to the very glucose-based guidelines that we had in the previous years, it is that phenomenon of progressive failure of the beta cell that is at the center of our guidelines. Indeed, this is the old guideline by David Nathan in 2006, with a refreshing in 2008. And dear friends, our lives were very simple then. Because yes, we knew that blood pressure control was important. Yes, we knew that lipid control was important. But for glucose control, we only had lifestyle, metformin, sulfonylurea, and insulin. And so it was quite easy. Everybody needed lifestyle and metformin. And then you had the choice: start basal insulin, start sulfonylurea. Very, very easy. The big change came with Silvio Enzuke's ADA-ESD consensus. They called it an algorithm then in 2012, where they really brought in a new vision where they said that multifactorial approach was important, that as you can see here in blue, lifestyle was the basis for all treatment in all people with type 2 diabetes, and where they illustrated by the pink background that metformin should also be in everybody's therapy when you're talking about treatment of people with type 2 diabetes. And then they brought in very interesting approaches, namely that we had to reflect on therapies thinking about side effects, weight gain, hypoglycemia. We also needed to think about efficacy in glucose lowering, and then a concept that they introduced, cost. Cost being a very important part of the consideration which treatment to use. But still, you see this progressive failing of the beta cell forced us clinicians to have a progressive buildup of therapies in people with type 2 diabetes, lifestyle, metformin, and then one therapy, adding a second therapy, etc. Now, in 2015, they had a small update because in the meantime, there was another class of glucose lowering agents that came in our hands as clinicians, namely the SGLT2 inhibitors, and they added the SGLT2 inhibitors there. But look at the place of the GLP-1 receptor agonist, quite low in the treatment. Now, when you think about this failing beta cell, when you think about this progressive addition of therapies, what the algorithm in 2012 and 2015 said was that every 3 months we needed to reevaluate glucose control, putting forward individualized hemoglobin A1C targets for every patient. The mean target being 7% for most people, but if you have elderly people, you could allow, for instance, a higher hemoglobin A1C target. If you had young people or people with a long life expectancy, you would have stricter hemoglobin A1C targets. But so every 3 months evaluation, meaning that you would go very, very rapidly up in your treatment additions. Now, as shown by the previous speaker also, the real world is that we are faced with clinical inertia in the clinicians, clinical inertia in the patients, causing many, many people for many years to be out of control. Now, as you all know, in 2018, the ADA ESD came together again, and we made a new consensus, but we stuck again with this buildup of therapies, baseline being lifestyle and metformin, and then adding one treatment after another. Again, we had the concept of hypoglycemia, weight. Again, we introduced the cost. And as you can see here on the top right corner, we also focused on this clinical inertia being important. But as you can see here, we had a consideration, namely at the baseline, you had to look at the characteristics of the patient, and in particular, focus on whether atherosclerotic cardiovascular disease or chronic kidney disease was present. Now, why did we make this new consensus? As said, every 5 years, ADA, ESD come together. We made this consensus new because we wanted to really put emphasis on putting the patient at the center of care and looking at the characteristics of the patient, atherosclerotic cardiovascular disease, chronic kidney disease, but also involving the patient in the decision-making of what therapies to choose. Again, we acknowledge the importance of a multifactorial approach in people with type 2 diabetes, not only glucose control, but also having statins on board, having blood pressure control, etc. Now, as said, we put at the beginning, look at the characteristics of the patient. And if you had atherosclerotic cardiovascular disease on board, we proposed an approach with the two classes, the GLP-1 receptor agonists and the SGLT2 inhibitors that were discussed before. Or if you had chronic kidney disease, and here we introduced heart failure, then we preferred the SGLT2 inhibitors or the GLP-1 receptor agonist if the SGLT2 inhibitors were not tolerated or contraindicated. Now, why this emphasis on atherosclerotic cardiovascular disease, chronic kidney disease, and then here also heart failure? Because, as indicated again by the previous speakers, it is cardiovascular disease that is still the big killer in people with type 2 diabetes. Here, a figure from a couple of years ago indicating the SIR mortality, the excess mortality in people with type 2 diabetes, men and women. And you see, the younger the people are, the bigger the number of life years lost if you have type 2 diabetes compared to people without type 2 diabetes. And as indicated in the black, it is mainly vascular deaths that cause the SIR, the excess mortality. Now, when we think of cardiovascular disease, many of us still think about a myocardial infarction, a CVA, but there's also heart failure. And again, very elegantly indicated by the previous speakers, this heart failure is not a trivial phenomenon in people with type 2 diabetes. We have the heart failure with the reduced ejection fraction. We have the typical, what we used to call, when I was still very young, the diabetic heart, with the heart failure with the preserved ejection fraction. And as you can see here, heart failure is quite prevalent in people with type 2 diabetes. Now, is it bad news? It is very bad news if you have heart failure and you have type 2 diabetes. Here you can see a Kaplan-Meier survival estimates in more than 115,000 people with type 2 diabetes. And as you can see in yellow, if you have type 2 diabetes but no heart failure, your survival over 5 years is quite okay. But if you have, in addition to type 2 diabetes, also heart failure, then you are in big trouble. That really increases your mortality. Now, it's not all gloom and doom. Indeed, if you look at how we did in previous years, here you can see a publication from 2014 looking at the progression in reducing all events, complication events in people with type 2 diabetes, acute myocardial infarction and stroke. You can see that between 1995 and 2005, we've seen quite a nice reduction, mainly because of the introduction of statins and blood pressure control. Also, amputations going down, they're a very important place for education and foot care. But look at end-stage renal disease, not a lot moving there. And indeed, if you look at recent years, here different cohorts in the enhanced population, where you can see that in particular, stage 3A, so having eGFRs between 45 and 60 milliliters per minute, you can see that stage 3A is even becoming more and more prevalent in this enhanced population. So why this emphasis on atherosclerotic cardiovascular disease, heart failure, and chronic kidney disease? Because they are important endpoints in people with type 2 diabetes. But they were important endpoints before 2018. But what has changed? Oh, it is the evidence. The evidence we have now in our hands because of these big cardiovascular outcome trials. You remember that it was FDA that mandated all companies introducing new glucose-lowering agents to the market for treatment of people with type 2 diabetes, that they had to do a cardiovascular outcome trial to show that these agents were safe. And that is exactly what happened with the yellow studies, namely those with the DPP-4 inhibitors. DPP-4 inhibitors in people with type 2 diabetes and cardiovascular disease are safe. But the blue and the red studies with the GLP-1 receptor agonist and the SGLT2 inhibitors now show much more, not only safety, but also efficacy. And indeed, these studies have now not only been done in people with type 2 diabetes, but also in people without type 2 diabetes. We have now hope in heart failure and chronic kidney disease that, in particular, the SGLT2 inhibitors can protect, again, hospitalization for heart failure and even cardiovascular mortality, and can prevent the progression of chronic kidney disease also in people without type 2 diabetes. So two big winners, GLP-1 receptor agonists, SGLT2 inhibitors that have shown efficacy on these very important outcomes. And here, because of time, I just brought overviews where you can see that, especially here for the GLP-1 receptor agonist, that especially MACE is affected. Overall, all studies on the good side of the unity with a reduction of MACE 12%. But what was most spectacular and really pushed the place of the GLP-1 receptor agonist in our ADA-ESD consensus is the effect on stroke. Indeed, again, all the studies on the good side, 16% risk reduction on stroke. I put a green arrow on the rewind study because that is the study with the majority of people in primary prevention, only with a high risk of cardiovascular disease. And here you can see that on MACE, indeed, there is this 12% reduction of MACE in the rewind study. But if you look at the effect on stroke, it's even more spectacular with a 22% risk reduction. And that is the reason why after the 2018 first publication of the ADA-ESD consensus, we have done an update in 2019, and we pushed the GLP-1 receptor agonist for atherosclerotic cardiovascular disease. Indeed, not only happening for established cardiovascular disease, but also primary prevention. There's no p-value for heterogeneity for interaction. There is a little less effect, and that is because of the size that allows us to analyze these effects. Now, one question we always have, is it a class effect? And here we need to be very open and transparent. If you do the meta-analysis, like has been done here by Dr. Christensen, you see that indeed, if you look at the structure of the drugs, then there is a clear benefit for those with a structure that is related to GLP-1, the human GLP-1, and not exendin based. And so here I need to say that liraglutide, dulaglutide, semaglutide are the agents with the more convincing evidence in protection against cardiovascular disease, MACE. What about all-cause mortality? Yes, there's also this effect, 12%, hence the very prominent place of GLP-1 receptor agonists in our consensus document. Heart failure, less convincing. Indeed, here you have more heterogeneity in the different studies, with some studies showing a clear effect, like the intriguing Harmony study with the now disappeared drug, and all the others being less convincing. So for heart failure, GLP-1 receptor agonists are not really convincing. And the same is true for chronic kidney disease. Indeed, here you can see everything depends on the definition of the endpoint. If you use a composite kidney outcome endpoint, including macroalbuminuria progression, then all the GLP-1 receptor agonist studies have a good effect, indeed a reduction of 17%. But when you only take eGFR worsening or needing dialysis or transplantation or renal death, there's much more heterogeneity, and there's a non-statistically significant effect. So GLP-1 receptor agonists, mainly atherosclerotic cardiovascular disease. And so this is what the update of the 2019 update of the consensus looked like, namely, if you have indicators of not only established, but also high risk atherosclerotic cardiovascular disease, chronic kidney disease, or heart failure, you should have, if ASCVD predominates, the GLP-1 receptor agonists on board. If heart failure or chronic kidney disease predominates, you should have the SGLT2 inhibitors on board. What is important is that now we said, consider this independent of the hemoglobin A1C of your patient, because we have now arguments to say that also in individuals without type 2 diabetes, so independent of the glucose effect, we have an effect on the outcomes in these patients. What about the SGLT2 inhibitors? Here you can see the effect of the SGLT2 inhibitors on the big cardiovascular outcome trials with empagliflozin, canagliflozin, dapagliflozin, and ertugliflozin on MACE, cardiovascular mortality, and hospitalization for heart failure. What is clear is that on MACE, it is a split verdict with some studies showing an effect on MACE, but just at the edge of being statistically significant, others do not. In DECLARE, this is clearly a phenomenon of the population being studied, 60% in primary prevention. Cardiovascular mortality, there it's only the EMPA-REG study that showed an effect, a very convincing effect, but only EMPA-REG showed the effect, not the others. But where you clearly have a class effect and a dramatic effect is on hospitalization for heart failure, 30% or more reduction in hospitalization for heart failure. And then it is beyond type 2 diabetes. Indeed, we have now 2 studies in people with reduced ejection fraction, consisting of individuals with type 2 diabetes and without type 2 diabetes, where in 2 studies, one with dapagliflozin, one with empagliflozin, we have an almost identical reduction in hospitalization for heart failure and cardiovascular mortality, namely 25% risk reduction. So very convincing that this happens independent of glucose control and independent of type 2 diabetes being present. And so also in the cardiologist guidelines, as you've heard also before, we have now a very prominent place for the GLP-1 receptor agonist in atherosclerotic cardiovascular disease in people with type 2 diabetes, and for the SGLT2 inhibitors, especially for prevention of heart failure, not only now in people with type 2 diabetes. This is the case for the European Society of Cardiology and also for the American College of Cardiology. They've also introduced SGLT2 inhibitors and GLP-1 receptor agonists in treatment of people with type 2 diabetes. And then comes the chronic kidney disease. Again, as an endocrinologist, we're even more excited about this phenomenon than about the heart failure. Indeed, here, interpretation of these effects for the SGLT2 inhibitors is a bit more difficult because the definitions of outcomes are different from study to study. And here we were convinced that it was a class effect because look at this, more than 40% risk reduction in these different endpoints. And then came the VERTIS study that didn't show this effect. And we reflected and we discussed, and what appears to be the case is that it is really a point of how you define the endpoints of protecting the kidney. And if you use the same definition, namely a sustained more than 40% reduction in eGFR, needing renal replacement therapy or having renal death, you see again this class effect coming through with 40 or more % reduction in these very significant endpoints. And I want to end with some new studies. Indeed, we have now new studies specifically in individuals who have type 2 diabetes and who have already pre-existing chronic kidney disease. The CREDENCE study with canagliflozin and the SCORED study with sotagliflozin, a mixed SGLT1/2 inhibitor. And what is interesting is that in this very high cardiovascular risk population, now the MACE comes out again. You have again a reduction in MACE. And when looking at the SOLOIST study that had individuals with already pre-existing heart failure, you do not see cardiovascular mortality being affected, which suggests that cardiovascular mortality is not really affected in people with type 2 diabetes. But look at this phenomenon of hospitalization for heart failure, as well happening in the original cardiovascular outcome trials, as well happening in those with pre-existing chronic kidney disease, as in those with pre-existing heart failure, more than 30% reduction in hospitalization for heart failure. And again, beyond type 2 diabetes. Indeed, we have now an indication that chronic kidney disease is affected also in those who do not have type 2 diabetes. Here you can see the dramatic primary endpoint in the DAPA-CKD study with dapagliflozin in mixed population, people with type 2 diabetes, without type 2 diabetes, having chronic kidney disease. Look at this p-value, it's almost ridiculous. You have a 39% reduction in this composite endpoint, including cardiovascular mortality. If you exclude cardiovascular mortality, it's again more than 40%. And so here, very recently, also the KDIGO guidelines, the guidelines of the nephrologist, having a very prominent place, of course, for individuals with type 2 diabetes and chronic kidney disease now for SGLT2 inhibitors. We have to remind ourselves, however, that the glucose lowering capacity of the SGLT2 inhibitors is very small, below 60 milliliters per minute. And so you will have to add other agents to bring glucose down, but still the SGLT2 inhibitor will protect the kidney. So we still believe that our 2019 consensus stands, but for one or other reason, the ADA has now unilaterally revised their standards of care. And we were quite surprised because there's actually not a lot of new evidence. So they did something very strange. They went back a step and put again for atherosclerotic cardiovascular disease, whereas in our consensus, we had the GLP-1 receptor agonist as preferred. Now they put again either or, and they make a separate column for heart failure, only suggesting SGLT2 inhibition and what happens afterwards if your beta cell failure progresses. We have no clue. So there will be a lot of discussion again, which is quite sad because these are my conclusions. I think it is very important that we realize that we have now a very prominent role for, somebody has written on my slides, we have now a very prominent role for GLP-1 receptor agonists and SGLT2 inhibitors in the treatment of people with type 2 diabetes, with a very dramatic effect on atherosclerotic disease, heart failure, and chronic kidney disease. But what is so important, and this was very nicely formulated by Nico Marx in this paper in Lancet Diabetes Endocrinology of a couple of weeks ago, time to integrate the recommendations. It's time to stop discussing about all these little guidelines and the little differences. People are not being treated correctly with these very powerful agents. So we need to stop discussing and playing around and need to start applying the guidelines like the people in Manchester. Just make them practical, make them real, and apply them. And I want to finish by inviting you to our ESD e-learning so that you can learn more on all these wonderful guidelines and wonderful agents. So visit esd-elearning.org. Thank you for your attention.
Dr. Anand and Dr. Pradeep, please.
Thank you, ma'am, for a very lucid presentation and they make us realize that how the guidelines can help us in our day-to-day practice. Bansi, if there are any questions, we can take the questions and then we can end this session.
Dr. Anand, you want to make any comment?
Just wanted to ask, Bansi,
yes,
is diabetic cardiomyopathy, Ashish, is today accepted as a definitive entity? And what percentage of heart failure in diabetics are because of CAD and or because of non-coronary cardiomyopathy?
So, Dr. Das, you are asking this to Dr. Thakur or Dr. Shen?
Ashish first.
The first, Dr.
Right. Thank you, Dr. Das. I think I'd already replied to you in the chat box.
Yeah.
The more you look at it, the diabetic cardiomyopathy is a very complex term. So it would still be a valid diagnosis. However, over the last 20 years or so, what we used to say as a diabetic heart, as a way of diabetic muscle disease, has now evolved into a at least threefold in terms of causation, which involves the muscle, which involves the electrics, which involves the vessels. And of course, within the internal milieu is the whole metabolism. And that now is called diabetic cardiomyopathy. So indeed, yes, it would. If you don't consider that within, if you're a diabetologist, by the way, in terms of your primary practice, then you will come across that almost every other day, every single day. The only confounding factor being that we are not educating people about this at all, especially if they are breathless. We do an echo, and the echo may be normal or essentially normal, and off you go. But actually, they all have a degree of impairment in their muscles. Anatomy-wise, I think we don't have a mandate that we should go on and routinely assess their anatomy. No, there's no. You will realize that for the high and the very high risk patients, we now have aspirin recommended for them. It wasn't before, so the change has been there. So in terms of muscle, I think my position as a cardiologist would still stand. You know, the vast majority of my patients are not yet established on even the half dose of what it should be, the beta blocker, ACE, ARB, RNAs, and MRAs. That is still my focus 20 years down the line or 25 years into my trade. I'm still struggling to get my patients onto these basic medications which would protect them going forwards. So yes, diabetic cardiomyopathy still stands and will continue to evolve as you go. There's a very nice paper actually from December, and it's only been confounded further by the HFPEF and HFMEF going into it. So if you look at some of the publications from August to December, there are 2 or 3 very fantastic papers which elucidate all this and link into that. Thank you.
Thank you.
Dr. Shantal, even after this DAPA-CKD, where it had shown and it is protecting and further progression of kidney problem is decreased, even in the patients with non-diabetic also, but still in diabetes patient in India, as per the regulatory authorities, the initiation of SGLT2 inhibitor should not be initiated when eGFR is less than 30. So, I mean, what the newer guideline is been changed after DAPA-CKD, or is it still same that we should not initiate the SGLT2? Off-label we do use, and we do use up to eGFR 15, but as per the guideline or the guidance from the FDA and as well as the Indian guideline is talking that it should not be initiated when it is less than 30.
Correct. There is a difference between evidence and guidelines, and on the other hand, where the regulators stand. And where the regulators stand, for instance, in Europe, is still that we have the cutoff of 60 milliliters per minute to introduce an SGLT2 inhibitor, because that is the limit where you have a meaningful glucose lowering by an SGLT2 inhibitor. If you drop below 45, you have 0.2%. And so remember, that's how these agents were introduced to the regulators as glucose lowering agents. And so the only thing that needs to happen is that the companies go back to the regulators, present the evidence. But again, at the moment, it is only canagliflozin who has evidence in Credence. It is only dapagliflozin who has now evidence, that has now evidence in DAPA-CKD. So we cannot do anything but wait for the regulators, and we have evidence, as you know now, until 25 milliliters per minute. Again, protecting the kidney, protecting dramatically these patients that are very frail most of the time, also against hospitalization for heart failure. And remember also, all-cause mortality was decreased dramatically in the DAPA-CKD study. So things are evolving, things are moving with FDA and with EMA, and I don't know with other regulators, but as you realize, in these COVID times, they have other dossiers to tackle. And everything is going a bit slower than and less coordinated than what I think it should.
Great, Chantal. Ashok here. Thank you.
So, Anand, can we wrap up?
Yes, sir. I think I must thanks all my speakers from Belgium, from UK, Dr. Ashish, Dr. Paresh, Dr. Chantal, for their excellent oration.
Your voice is very low. Bit loud.
Am I audible, sir?
Yes, please.
Now better.
I thanks all my speakers, Dr. Ashish, Dr. Naresh, Dr. Chantal, for giving us very nice illustration, and we are more wiser for our use in SGLT, especially in our cardiac and renal patient. So thanks to all of you, and over to Dr. Bansi, sir.
Thank you, Anand and Pradeep, for moderating this session. Thanks, Dr. Ashish and Dr. Naresh from UK and Dr. Chantal from Belgium. Thank you for joining for this DiaCareCon virtually, and hope to see you soon, physically, face to face, maybe in next year.
Thank you very much.
Definitely.
Thank you. So now we start with the next session. It's very important that we have report here Dr. Deepak Dalal, and then Dr. Rishi Shukla, my close friend, Dr. Deepak Dalal, Dr. Rishi Shukla, Dr. Sujata Jali. They all are one who are taking care of type 1 in India like anything. And, it's very important topic, because every time in diabetes, whenever I'm doing any meeting, wherever I'm in the organizing committee or as well as in scientific committee, I make sure that 10% or more than 10% of the time we should devote only for type 1, and at least another 10 to 20% it should be on technology. So I mean, this is a dedicated symposia on a type 1, but this time we had kept completely different topics. So I request first Dr. Deepak Dalal to introduce Dr. Rishi and Sujata, and then we will introduce all three speakers. Over to Dr. Deepak Dalal.
Good afternoon, everybody. Merry Christmas and Happy New Year in advance. I welcome Dr. Rishi Shukla from Kanpur and Sujata Jali from Belgaum. They are our very dear and near diabetes specialist friends, and I welcome them. And can I have Dr. Rishi Shukla's biodata? I need Dr. Rishi Shukla.
You tell 2 lines about me and that's it. Once you said 2 lines, there is more than a formal introduction.
Dr. Rishi Shukla is a endocrinologist with a heart thumping for type 1 diabetics. And Dr. Sujata Jali, this year she got the award from the ISPED for the one of the best management. And I think these 2 lines will speak aloud rather than reading from those things. So I hand over to my chairperson, Dr. Rishi Shukla and Dr. Sujata for taking further. Thank you so much.
Thank you, Dr. Deepak, for good words. And thanks, Dr. Bansi, for the invite and thought about us. And one line I'll say about that, you have made my dream fulfilled, because what I thought about type 1 diabetes, say 15, 20 years back, and I sat with you and you had these meetings, that meetings, inviting people all across the country. And so much has happened in last 15 years. I witnessed it and I liked it. I loved it. So whole credit goes to you, but you brought type 1 diabetes into forefront. And what I remember, 20 years back, there was not a single talk in my endocrine society, RSSDI, Diabetes India came a little later. On state chapters, nobody talked about. Now, your efforts and our efforts and everybody's effort, things have reached to the shape that we have not one talk, but we have a couple of symposia, be it RSSDI, be it Diabetes India, be it Endocrine Society of India. Because earlier I used to say, have one talk, then they say you come and speak. Then I say, not me, invite people, involve people. And this is what exactly you did. So thank you so much and compliments. And I think wishing the life and everything about type 1 diabetes will go ahead, and it will reach to the tune that even when we are not there, it will keep progressing and type 1 diabetes, people with type 1 diabetes will be had a big way. I think with this, I introduced to our first talk, Dr. Sunil Gupta will be speaking, I believe. Can I have? Oh, he's a very well-known person in Nagpur and in entire India. He has published 193 articles, 6 consecutive Best National Award, 14 National Oration, President Orations. His center is recognized as IDF Center for Education and Excellence in Diabetes Care, National Treasurer. So he is a very well-known person all across the country. And he's the one person who has done a lot of meetings on type 1 diabetes, and perhaps he's the first person who had a virtual meeting for patients with type 1 diabetes. And he's going to speak on life with type 1 diabetes. I think this is a very relevant and a very important topic, and I learn and all of us will learn a lot through Dr. Sunil Gupta. And above all, he's a nice and very dynamic person, a good friend of mine. Thank you, Sunil. And I request you to go ahead with your deliberation. Dr. Sunil.
Rishi, thank you, Bansi. And I'll just take 30 seconds for this sharing. I feel even less than that. Can you see the slides now?
Yes.
Yes. Yeah. So thank you, Bansi, and thank you, DiaCare, for this honor of keeping me there in one of the very, very important topic. And I'll be very brief. The talk is little new for most of us, and we'll try to justify whatever has been assigned to me. Thank you, DiaCare team. There's nothing to disclose for this particular talk. Now, whenever we talk about the challenges and about the rights of a person with type 1 diabetes, it's not just the just giving the free insulin, free syringes, free glucometers, some test strips. Some of them do adopt people with type 1 diabetes. Most of us in the country, maybe it is our place at Nagpur Diabetes Care Foundation of India, or maybe it is Bansi's group of DiaCare, or maybe Rishi's place or Dr. Deepak Dalal's place. Across the country, everyone is just taking care of type 1 diabetes in best possible way. But I feel still there is a lot of lacunae which all of us need to take care and need to possibly address. And that is why Bansi has given this talk to me. So it is many more things. Apart from that, I feel nutrition part is still lacking too badly in our country when it comes to type 1 diabetes, especially those who are poor people sitting in rural places, remote places, and does not have any access to tertiary care centers, acceptability of the disease, medical care, psychological support, and of course, hospitalization in rare situations in a good place, and then education, which is one of the most important part in, I feel, the whole care of type 1 diabetes. So I'll finish up this rights of child with type 1 diabetes in very brief for 8 to 10 slides, and then we'll proceed for challenges. So these are some guidelines which has been addressed for the global team and for all the countries. So all children around the world should have or be able to have the same rights. These rights are provided by the United Nations Convention on the Rights of Child in 1989. So what about type 1 diabetes? The child asks you, we need affordable access to the medicine and equipment, and every country, every government is expected to give the proper access to the child. That's the right, and no child should die of lack of insulin, which is happening still in smaller places and some poor countries and underdeveloped countries. We need more education and research and advocacy. I feel education is one part. Every child has a right to not only get educated in type 1 diabetes, but to take proper education in school and colleges, and also enter into his or her own life of proper profession, getting a proper job, So proper education, proper job, and proper life in future as a successful adult, as everyone expects. So that's also the government says that every government should try to give proper right to education to every type 1 diabetes across the globe. Most of the type 1 diabetics, they are happy with the family support, but rarely there are situations where family support is not being properly available. And we have some of them, some of the cases don't have father, some of them have lost their mother, some of them have lost both of them. And even today, one of the cases has been admitted where where father and mother not available, only some other caretakers are taking care. So we have such situations available across, and government also recognizes that a child living with a mental or a physical disability should enjoy a full and a decent life in condition which ensures dignity, promotes self-reliance, and facilitate your active participation in the community, and right of a child living with disability to special care subject to available resources. This is what they say. We are poor. My family needs financial independence. So for this, I feel government should also be taking initiative, which many of the places still are lacking, especially in our country. And there's no proper insurance guidelines, and insurance company also are not very much pro for giving insurances to type 1 diabetics. Now there are few of them that started giving insurance to diabetics, but I'm not sure about type 1 diabetes. Still there are some lacunae across. And then there is always a right for a child to for the physical, mental, and spiritual development, along with right for education. Now there are some guidelines which says which are specifically made for schools. So right at the school, what is every child has a right to be safe, to be supported, and to be included in the mainstream of the school. So right of safety says that there should be individual care plan. There should be staff should be trained for symptoms of low sugar. The students must be able to treat low sugar. There even during the school timings, checking sugar and administering insulin, there should be a special permission for that, and enough time should be given for him to take his snack and proper meal compared to others. That there should be 2 staff members must be trained to provide support by the school. And if the blood sugar is high or blood sugar is low, they have to give enough time to take care of these fluctuations of blood glucose when they take possibly a little more time to study or to possibly even appearing for the exam. They need to be taken care. Right to inclusion, sometimes they have a social stigma and embarrassment being called as type 1 diabetes. Even that part need to be taken care by the school. Support and plan regular physical activity. They should be allowed to attend all the sports or other social activities of the school. And attendance policy should not penalize the student for taking care of their health. So this is another thing. This is a United States newer Patient Protection Act, that it dictates that health insurance companies cannot refuse to cover or change you more just because you have type 1 diabetes or any other pre-existing condition. In addition, a health plan can no longer limit the total amount it will spend on benefit of a particular individual. So I feel such laws should also be existing in our country. Australian government has readily come out with the needles-free syringes, blood sugar test strips in the local pharmacies, and they are being given free. And they also provide now from 2017 continuous glucose monitoring products to all people under 21 who has type 1 diabetes. So this is what is learning for all of us, including DIACARE and RSSDI, and all of us should join hand to promote such law should be enforced in our country too. So this was a right about type 1 diabetes and the challenges. I feel this particular talk is very, very broad talk, and I have divided it into small pieces. What are challenges we in our country we face when it comes to type 1 diabetes? At diagnosis, we still are facing, though if everyone possibly will agree, maybe 2 decades from now, we used to have most of the type 1 coming with severe diabetic ketoacidosis and ketoacidosis coma. But now in last 1 or 2 decades, at least the cases of type 1 diabetes are not coming in that serious state. That means the diagnosis has become little better and people have started using glucometers and suspecting type 1 diabetes better. But still in the periphery, in the rural places, less resourceful situations, our healthcare professional still need to be aware for it. The sense of suspicion has to be improved, and a lot of education and empowerment is required at that level. Society level, we have illiteracy, poverty, myths, rural stigmas and superstitions that also need to be taken care. We have poor social resources for our healthcare system, lack of social awareness, and of course medical conferences. Someone just commented, Rishi just commented that medical conferences never used to time given for type of the conference. That's such initiatives should also I feel I still remember when Lucknow has RSS that time they had included the type 1 diabetes education program, and Bansi when did Diacare, they on NRSS they also organized type 1 education programs in that place of around 3 to 4 hours. I feel such initiatives are across important. I'll be very brief here now. This is a slide which I have shared from Dr. Deepak Dalal. At diagnosis, initial reaction can be guilt. Guilt is maybe it is called as garbad. Garbad is guilt, anxiety, denial, bargain, anger, and depression. And this garbad starts with a difficulty to accept multiple insulin pricks. How will the child will monitor blood glucose? There will be a guilt amongst parents. They must have done something wrong in their life, and why only my child? So acceptability is at the immediately after the diagnosis is a big challenge. Then anxiety comes is whether my child can live the normal life. These are all have to be answered by us as a healthcare professional. Will they do their studies? Will they be able to cope with stress? Will they get or be able to do any job? What about the marriage, the sex life, the conception? And what about the forthcoming generations? Suspicion about the lifespan, whether my child will be able to survive for till 76. And then comes a denial that no one in our family have diabetes. How can our child will have this? Possibly reports must be wrong. And when the denial in, can we take on instead of 4 injections? Can we take tablets? Can we take tablet and insulin in combination so that science is no research cure this, and then no one help child. These are the that first challenge and paper. I'll just go through the summary of this. As the undergoes a variety of physical, psychological, and lifestyle changes in his own understanding of the he understands.
Dr. Sunil Gupta.
I think he lost the connection.
Okay. So Rishi, in between you can talk, or Dr. Deepak Dalal or Dr. Sujata, then we can move to the second session. Again, Sunil, I mean, you are getting disconnected.
He has muted his.
You have to unmute. Dr.
Unmute,
Sunil.
please.
Sunil, you have to unmute.
Yes, I did it. Yes.
I think there is some connection.
So as a child with diabetes grows, he undergoes various changes, and then parents they go away from the means the responsibility of parent reduces little bit, and then the child takes over. Then there are academic compulsions, peer pressures, everything becomes a challenge.
Share your screen,
and then
sir.
They have to understand
Please
about.
share your screen, Dr. Sunil.
It's not
Please
there?
share it. No, sir.
It's
Your
not there?
screen is not, yes.
Please share your screen.
I'll have to go back.
In between, you are disconnected. So the last part of the slide you can show, and I think your internet connection is also poor or bit unstable.
Actually, biggest problem in type 1 diabetes is understanding. Once the family understands, the society understands, and if the child is grown up, the child understands. Possibly you have done the task, because once you understand you have a problem, and the best part of this ailment is you know that the treatment is available. And I think Dr. Sunil has come.
So a lot of pressure on the child, and then sorry for this disconnect and poor connection here. So then we have to train them for self-monitoring blood glucose, which again, it's a challenge. We have to make them understand the skills to manage their different situations. Continuous education is important. And there should be a team which should train, we should treat, we should motivate and support these children to take care, which should also involve a family member, a dietitian, a diabetes educator, a diabetologist or an endocrinologist, as well as the sometimes pediatricians and maybe gynecologists. So we have such support system, like we have prepared a juvenile diabetes parent organization. So all parents of children, as well as now all adult children, they are the part of it. It's almost a 21 years organization. And we go on educating them on a regular basis. These are very early days of, you can see my mustache here where I did not have now. So all early days of such educations is almost 20 years back. And then we still are continuing. And we have Dr. V.S. Asgaonkar and others from Mumbai who have always encouraged for type 1 diabetes education. So more and more such things are required. Sometimes you utilize such leaders. I feel I should congratulate Bansi for putting this concept of the diabetes leaders. So that is one thing. And Dr. Rishi Shukla, when we had type 1 diabetes conference, the conclave for educating type 1 diabetics in Lucknow. So then there are challenges about the resources, financial constraint, limited availability of the free insulin and delivery devices, almost negligibly availability of the free blood glucose monitoring strips, maintaining a consistent carbohydrate intake even in rural places because their diet is fixed and we have to adjust the doses of insulin according to their dietary habits. And many of the places people are uneducated. Newer technology like CGM and insulin pump, we talk a lot, it is important and important for some subset, good subset of number of patients, but still majority of them cannot afford to go for it, and limited availability of the expert. All these are the challenges which we are facing here. Diabetes knowledge, I'll emphasize on at least 1 minute on this. Basics of type 1 diabetes, glycemic goals and other goals. Insulin, we always speak so loudly in most of the meetings that every type 1 should be on the basal bolus therapy, but still people are keeping such cases on premixed insulin. Then on hypoglycemia, ketosis, job, driving, marriage is a challenge, preconception counseling, macro angiopathy. A lot of such educating materials and education is required to actually empower these children. So diabetes educators, trained educators, can really change a scene here. So we have to develop a structured diabetes education program to address these challenges of various, from diagnosis till the follow-up, and maybe next 20, 30 years or 70 years or 80 years of life of type 1 diabetes. Periodic reinforcement is required, and then conducting periodic workshop for these caretakers as well as children is important. Diabetes and obesity is now a dual challenge in our country, and they are more prone to have cardiovascular morbidity. It's a dubious challenge. Now we are getting type 1 diabetes along with obesity with insulin resistance, which is again a challenge for us. I feel these are some of the last 1 or 2 slides. So empowering a child and his family to take the reign of diabetes management in their hand is the single and the most important intervention to improve the glycemic control and the quality of life to all type 1 diabetes. The price of ignorance is far higher than the price of education. Because we never try to empower our type 1 diabetes, and many of them, they remain ignored for their type 1 diabetes and their future. So because of ignorance, people die from undiagnosed diabetes. Because of ignorance, people die from lack of insulin. There is social discrimination against the people with diabetes, And due to lack of education, I repeat, due to lack of education, people with diabetes suffer unnecessarily and die prematurely. The unnecessary suffering and premature death is not because of diabetes, but because of lack of education. I feel we have to now incorporate education as a part in our curriculum. And not only that, we should educate me and Rashi and Bansi and Deepak Dalal and Archana Sarada, not only these people. I feel many more of us need to educate, become a good educator and create good educator in our system. These are the nurses. We have a big lot of nurses. We have a big lot of pharmacists. We have a big lot of nutritionists. And I should really congratulate RSSDF for now. They are going to start with a nutrition course along with nutritionists in the country. I feel we need to have more and more such programs to be organized and to create more educators. I'm proud to say that today I'm delivering a lecture on this topic. And immediately after that at 4 o'clock, we have a nurses conclave, which is an annual conclave, which is going to be inaugurated again by Dr. Bansi here. I have time to show this video to you. So I feel the final answer is education, education, and education. I feel that is the only challenge we have. Other challenges, I feel every one of us are taking care of it. Thank you very much for patience listening. Before I conclude, I would like to convey my best wishes and best wishes to everyone for the new year to come, and hopefully that we'll be meeting in person after this corona, maybe in subsequent days. Thank you very much, Bansi Bhai, once again.
Thank you, Dr. Sunil, for a wonderful talk. I think we'll have question answer session at the end. And I pass it on to Dr. Deepak Dalal. Dr. Jali, I think you should introduce Dr. Lee.
Not me, now Dr. Jali. You and Dr. Jali, not me.
Yes, Dr. Jali should introduce.
Yes, she is there.
Yes. Thank you, Dr. Deepak. And it's my great privilege to introduce Dr. Varun Lee. And I loved his biodata, the way he has put it up. Of course, he has done his MBBS, MD, and fellow academic of medicine. But what I was impressed with his biodata was that what he is really working on. And he trains all the pediatricians in Singapore. And he is in pediatric endocrinology at Royal Children's Hospital in Melbourne. And he has traveled to and taught on diabetes and endocrine topics all over the world, both in developed and developing countries. This is very important. Then he has, his professional philosophy is to try and assess patients as carefully as possible. Then another what impressed in his biodata was that he's working very hard on diabetes education, which is need of the hour. And he has traveled and taught endocrine all over the world. And with these few words, I introduce Dr. Varun and present to the audience. Thank you.
Thank you, Dr. Jali, and thank you so much also Bansi Bhai, Rishi, Deepak Dalal, all my friends in India. Thank you so much for inviting me. I really enjoy these sessions. Let me share my screen. I'm conscious that we don't have that much time. Just a minute now. Yes. Okay.
Yes, it is visible. Yeah.
Yeah. All right. So comorbidities in childhood diabetes. What else ails the child with diabetes? I thought I would change a little bit of what I normally speak about. But anyway, I don't really have any conflicts of interest. And really, for those of you who want the details, I refer you to the excellent ISPER Clinical Practice Guidelines 2018, which was actually launched in Hyderabad at the ISPAD meeting chaired by our good friend Banshi Sabu, right? And along with the other speakers, along with Rishi, I really say, you know, through the years since I started visiting India in 2004, how much of a change Banshi and his colleagues have made towards the understanding and practice of diabetes in children in India. And I'm sure you are going to be able to inspire people around the world as well. But the details are from here, but I just wanted to give my little take on it. I'm a practical person. I just want to say at this point that this is not really in the guidelines, but this is a very recent piece of work by Leena Priyamdipa from Hyderabad, plus seniors from ISPAD, Joe Wolfsdorf and Stuart Brink, where they recognize that in the treatment of DKA, where we have conventionally emphasized putting the child in ICU wherever possible, this may not really be possible in countries which are facing, or cities which are facing high COVID-19 loads. So they've actually been very practical and given suggested doses of insulin analogs or regular insulin given as subcutaneous injections. So this goes back to 20, 30 years ago when we started training, and we only had subcut insulin. So we're going backwards, but for a different reason. So have a look at this at the ISPAD website if there's a need. But my talk today is about kids in clinic. The kid whose control is bad and can't seem to get the right insulin dose, no matter what you do. The kids with recurrent DKA, the kid who always seems to be a bit the shortest guy in class, the kid who's always tired, the kid who can't gain weight, the kid who is in puberty but is not having a growth spurt, and the kid, this funny kid with bad teeth and mouth ulcers and skin rashes and seems to be getting into trouble in school all the time. What about these kids? Because they are the ones with type 1 diabetes. And I think this is timely for us to speak like this, because initially it was all about making sure that the children with diabetes are diagnosed and treated before they died. But now that we have moved on, and we have got clinics that are full of these young people, we need to go and figure out the problems that they have. Now, one of the things that I just want to bring up, it's there all the time. Of course, the old soldiers among us, we know about this, but I just want to remind people in the audience that lipohypertrophy is one of the reasons for erratic glycemic control, okay? Sometimes we are looking at all sorts of interesting reasons and all sorts of theories, but we have to go back and say, well, you know, no matter whether you come from a rich country or a poor country, kids like to give injections into lipohypertrophic areas because it's less painful, right? But because of that, about 25% of the insulin may not be injected at that point in time, and that leads to erratic absorption, erratic duration of action. And even when we are using pumps, this is still an issue, right? And of course, in fact, sometimes for the people who are using pumps, it's even worse because there is actually a much smaller part of real estate of skin where you can actually use skin for infusion sites. So do think about lipohypertrophy when you have kids who don't have good control. The other thing that I want to spend some time on is eating disorders in children with type 1 diabetes. We know, but we also don't know. I would say we know, but we don't know. I mean, we've all had eating disorder patients in our clinic. Sometimes we pick it up immediately. Sometimes the kids fool us for a while. Sometimes for years before we realize that, yeah, this guy had eating disorder all along. But, you know, eating disorders are about 2 to 3 times as common in children with type 1 diabetes versus those without type 1 diabetes. And we sometimes can figure out that there's some psychological profiles that we can see These are children who tend to be perfectionists. They're very self-driven. Many of them are from elite schools, or they've had very controlling parents. And as a result, they become obsessed with body image. They become obsessed with control. And one way that they can assert control when they seem that they're no longer in control because of diabetes is to control what they eat. So eating disorders and diabetes can also present as recurrent DKA or hypoglycemia or failure to grow and gain weight. And eating disorders in type 1 diabetes can also present as obesity. So Orit Penhas-Hamel has done a very nice overview, and the reference is below, 5 years ago in World Journal of Diabetes. It's free to download. Besides the classic eating disorders, I think we also need to remember that dysfunctional eating behavior is also very common. Dysfunctional eating behavior is a bit broader than eating disorders. They run the gamut of the people who eat too much, eat too little, or have got problems with eating. And it's about 7.2% in the group of children who have diabetes and are underweight, but it's 1 in 3 of the obese children who have type 1 diabetes. And it's also more common in the late teens and young adults. Okay, so this is actually something we must remember. I know our speaker after this is actually going to be talking about transition, and I think many a pediatrician is so glad that the child with eating disorder is going to transit away from his clinic, right, or her clinic. So it's important to remember the place of eating disorders, because actually, besides the more obvious eating disorder, they actually have about 2 to 3 times more retinopathy and nephropathy than people with type 1, but no eating disorder. And also about twice as many foot problems. And this is because eating disorders always lead to poor control. This is actually quite a classic situation where a child who previously was very well controlled, and arguably the parents were in charge of treatment in the childhood and early teens, later on has got vast excursions in HbA1c as they enter young adulthood. Sometimes good, sometimes bad, sometimes good, sometimes bad. And this is actually one of the hallmarks of eating disorder in evolution, all right? So it's all good in the initial years, right? And then somehow there's a flip and they have very bad HbA1c. Okay. Recurrent hypoglycemic episodes may occur among individuals with type 1 diabetes and eating disorders, mainly among those participating in binge eating and self-induced vomiting. So their kind of eating disorder is actually to give themselves hypoglycemia. And of course, sometimes they do hypoglycemia so that they can binge eat on sweets, I mean, they're treating hypoglycemia. And in fact, actually, one interesting article in Pediatric Diabetes says that 1 in 5 children with type 1 diabetes aged about 10 to 18 years actually reported intentional overdosing of insulin, right? So we are on the one hand trying to get the doses right. On the other hand, these are young people who intentionally overdose themselves on insulin. So this is one of the schema. There are many schemas about this. But this is just a schema for us to try and understand a little bit about why people with type 1 diabetes get eating disorders, their family factors, their personality factors. There's the fact that actually once you are treated with insulin, your BMI will increase because people do lose weight. And then because of this obsession in some families with carb counting and weight gain and strict eating, and intensive insulin treatment, sometimes these children find that one of the ways that they can get more control in their lives is to actually omit insulin or, deliberately give themselves hypoglycemia so they can binge and eat on sweets that they crave, right? The outline for treating eating disorders in these children is also that you have to address the issues that got it started in the first place, looking at the individual, treating the family, and actually giving support through the groups, because actually these are children who are becoming young adults, and actually this can go on for years. I actually have children who have grown up with me and they look at me and say, you know, Dr. Lee, back then when I was a teen and I had eating disorder and I bluffed you, you never knew. And I sometimes have to admit that, yeah, I had my suspicions, you know, but those days there was a bit of a stigma. We didn't like to say the word eating disorder. I would also think that it's important for us to remember this. And I think perhaps you in India might see a few more cases that I have in Singapore, but we all see this, Moriak syndrome, where there's growth failure and hepatomegaly due to glycogen and fat storage in liver cells. And this is because of chronic insulin underdosing. And it's more common in the early days when children couldn't get hold of regular insulin supplies. But in Singapore, there are also some other reasons sometimes. We also do get people who believe, the grandparents who believe that insulin is a poison, and they were actually deliberately withholding insulin in some cases. But there are also Cushingite features. You notice there'll be high HbA1c. And it's also important, sometimes we should not just blame the patient. One of my Moriaks actually had celiac disease, but I didn't pick it up till 5 years, 6 years later. Hypothyroidism, Addison's disease, B12 deficiency. In fact, I have one patient with all of the above. And we also have to remember that if insulin treatment is done too fast at diagnosis, rapid improvement of metabolic control induces rapid appearance of retinopathy or aggravates existing retinopathy, right? Tends to be forgotten in these days. So the short child with diabetes can be under-insulinized. So we always must ask ourselves, what is the dose per kilogram per day that we prescribe? What is the dose actually being given? Is it poor adherence, or is it because the family cannot afford the insulin? Are we actually looking at an eating disorder? Is there hypothyroidism? Is there celiac disease? Is there actually gluten intolerance, which I think is about 3 to 4 times more common than celiac disease in my clinic population? Is there pubertal delay due to poor diabetes control? Is there also renal pathology? Because these are all risk factors. Hashimoto's thyroiditis is seen in up to 20 to 40% of diabetic populations. So you have to think in terms of the short, slow child who is presenting with decreased linear growth, who has a painless goiter, who has fatigue, cold intolerance, bradycardia, weight gain, and sometimes hypoglycemia. And I think the most important test is actually the TSH. Graves' disease. I had one patient who presented at diagnosis as Graves' disease. And when the registrar called me up, I said, you know, just thinking about this child, please do the blood sugar. And about 10 minutes later, the registrar called me up and said, Dr. Lee, why did you ask us to test the blood sugar? This child has diabetes, right? So it can actually present with DKA and Graves. And similarly, I've had a case of DKA where we said, let's go test the thyroid. And lo and behold, although we usually think in terms of sick euthyroid or hypothyroid syndromes, a child can actually have Graves' disease presenting as DKA as well, right? Weight loss, increased appetite, palpitations, goiter may be small. Proptosis may not always be there in children. And the tests that you can do are below. But sometimes I find that you might actually need to go to TRAB or TSI, which is not always available. How about the sporty child with low HbA1c? I always worry about these kids because they look too good, right? And if the HbA1c is too good, you actually ask yourself, is this child at risk for hypoglycemia unawareness? So always ask about the type, duration, and frequency of training. Some children are really either pushed by their parents or so self-motivated, they have many hours of training every week. Ask about eating. The child may be eating, the child may not have an eating disorder, but the child may still not be eating enough for the intensity of treatment and the duration of training that this very competitive family sometimes have. If the HbA1c is too good or very bad, look for hypoglycemia unawareness, ask for headaches, highs on waking up in the morning, ask about post-game highs and post-training lows. Post-game highs come because there's excitement during the game or performance. So some of these actually are jazz dancers or ballet dancers, or even traditional dances, right? Traditional Indian dance also can be very intense training. So excitement can lead to hypoglycemia, but routine training often leads to hypoglycemia because they have a more structured training. Now, we also know that in India and Asia, everywhere, many children with type 1 diabetes are actually becoming more and more fat. Why in Asia this is the case is that many of our children are born small for gestational age and have rapid weight gain in infancy because parents want to so-called do the right thing for the child. But we know now from pediatrics that if you have rapid weight gain in the first 3 years of life, it predisposes to later obesity. And whether or not you have type 1 diabetes, the same thing will still happen. Gestational diabetes pregnancies are a function of multipara and later motherhood. And of course, in our competitive society, people are getting married later, at least they are in Singapore. And because they're getting married later, they're getting babies later. So there's a higher prevalence of GDM pregnancies. And of course, many people have a family history of type 2 diabetes. And this can actually show up in type 1 diabetes, so the so-called double diabetes, which was seen to be a rarity and therefore worth discussing as an oddity in many European clinics when I was a younger doctor. But I see that actually this is very, very common in our populations. So always ask our family history of type 1, type 2 diabetes, look for hyperlipidemia. And it's classic, they have increased insulin requirements. And because insulin is the most expensive item among the medications, I have always been an early advocate of adding metformin early on. Metformin actually can reduce the amount of insulin needed for the child substantially. Studies have shown that it does not necessarily improve diabetes control, right? These tend to be American studies, but it can reduce the amount of insulin required substantially. Off-label, I actually do use some of the glitazones in the past. I think use whatever you need to use, but address the fact that there's type 2 diabetes, right? Celiac disease is actually what prompted me to ask Banshi to let me change my topic. Celiac disease in diabetes is not uncommon. It is certainly there. We do not need to have fancy biopsies or expensive blood tests in order to make the diagnosis. Dr. Jali talks about me going to funny countries to give talks. And yes, I was in Africa a few years ago, and some colleagues from Sudan were telling me that actually in their country, they diagnosed celiac in type 1 diabetes on clinical grounds alone. There is no money necessarily to do serological tests because it's very simple. You just make sure you change the diet. So how do we suspect these children? They are the tired child, the short child with delayed puberty, with anemia. In fact, in the Indian papers, especially in Northwest India, one of the common presentations for celiac disease in non-diabetic adults and children is the unexplained anemia or the unexplained rise in liver transaminases, right? But in our diabetes cases, it can be asymptomatic or unsuspected. It can present with brittle diabetes because when you eat gluten, transient insulin resistance causes a very high insulin requirement. If we are the unsuspecting physician and we increase the child's insulin dose, the next time the child has a meal that is low in gluten, that child will have hypoglycemia. They will lose trust in us as physicians, and you can go around and up and down like this, and then we blame the parents or we blame the child for doing the wrong thing, but we should actually blame ourselves for not recognizing that there's celiac disease, because it can present with hypoglycemia due to delayed gastric emptying, or hyperglycemia due to inflammation and transient insulin resistance. The insulin resistance can last the whole night, by the way, and the insulin doses may need to be 3 times. So they get poor linear growth, they've got diarrhea, nausea, vomiting, abdominal pain. They can get mouth ulcers. And they often have learning and behavior problems, including ADD behaviors. And there's a strong association with thyroid disease. So the Americans always talk about TTG IgA. I find that in my population, you should test for TTG IgG, anti-gliadin IgA, anti-gliadin IgG, or deaminated gliadin peptides, IgA, IgG. Anti-endomysial antibodies, people think it's important. Intestinal biopsy, they think it's important. I personally think it's not the most important thing. If you have tested for the 4 antibodies and you've got a strong clinical suspicion, treat the child as if you've got celiac disease. If the glycemic control improves, if the growth improves, you've got the diagnosis. In children where it's expensive to test for the gluten antibodies, I have a trick. Gilbert's disease has been described in the Indian literature, Gilbert's disease. It is isolated high total and direct bilirubin with normal transaminases. If you see this in a child who has no business having gallstones, think celiac disease, all right? The other thing is a high isolated T3 with normal free T4 and normal TSH, okay? High T3 above the range. In a child where you've got this suspicion, you've got family history of thyroid, you've got IBS, irritable bowel, the kid's not doing so well in school, or you've got actually growth faltering. That means previously growing well, and then there's a growth faltering or there's pubertal delay. Think celiac disease. Okay, remember that celiac disease and gluten intolerance, many children actually have gluten intolerance. They do not fulfill the criteria for celiac disease, but you know what? Gluten intolerance can screw up diabetes control in exactly the same way as celiac disease. Exposure to gluten in a gluten-intolerant diabetic child may result in temporary insulin resistance, requiring 2 to 3 times the usual amount of insulin for the whole night, just like a sick day. And then 2 days later, they're fine, okay? In our modern days, we must remember that even in the non-diabetics, celiac disease is changing. We used to think of it as being seen only with diarrhea, weight loss, and malabsorption. Now 1 in 5 have no symptoms, and half of them have symptoms like anemia, constipation, osteoporosis, abnormal LFTs, neurologic disorders like seizures, dermatitis herpetiformis, or keratosis pilaris. Okay, so we might think in terms of seizures because of hypoglycemia, think celiac disease as well. Govind Makaria from All India Institute of Medicine, who's actually a good friend of mine now, has really helped with telling people that really India and Asia, you see the color Malaysia and Singapore is the same color as India on this slide. We in Asia actually may have more celiac disease than all the countries of the West. Okay, look at the color of this map. Actually, this is much more common than you think. Okay, whether you do serology or whether you do biopsy, celiac disease is there. And celiac disease is up to 6 times more common in children with diabetes than they would be in the normal population. If you look at why and where celiac disease occurs in India, you can see that actually in North and Northwest India, it is more common than in Southern India. But actually, although the books talk about HLA-DQ2 and DQ8, the prevalence of HLA-DQ2 and DQ8 is pretty similar throughout all of India. But it is actually the wheat intake that makes the most difference. The Northerners, of course, eat more wheat, but I think even in the South, just like in Hong Kong and Singapore, the hitherto rice-eating parts of Asia have started to eat more and more wheat because of, McDonald's and fast food and snacks. And also there's more operative delivery, less breastfeeding, more use of antibiotics. These are risk factors. Okay, I just want to say that this is actually true even in my part of the world, Malaysia and Singapore. The Chinese and the Indians are actually more likely to get celiac disease, right? Martin Blazer has done a very nice summary of all the risk factors. And he says, look, if you have operated delivery, cesarean sections, more antibiotics, you're going to reduce your natural microbiome. And it's the bacteria, the natural microbiome, which was able to degrade gluten for you. If they don't degrade gluten, you can become intolerant to gluten. Okay, so remember early antibiotic exposure in the first year of life and celiac disease. And guess what? India is one of the countries with the highest antibiotic consumption. So it's not surprising to us. And I'm not pointing India, you know, because I see that in my part of the world, we have the same story. It's just, you know, Singapore doesn't have that good statistics in some things. So what are the wheat-related disorders? Don't forget that besides celiac disease, you also have non-celiac gluten sensitivity. As I said, it's more common, but it gives the same issues with growth, with impairment of puberty, with impairment of glycemic control through cytokine inhibition, not necessarily malnutrition. Okay? So don't forget that in our parts of the world, we should not just be thinking in terms of wheat, but barley, which will be in drinks like Ovaltine and Milo, can cause problems too. And some people in our part of the world also will be reacting to oats. So it's not about gluten-free oats, but that oats themselves, the oat protein itself, can cause problem in Asians. This is an article from Frontiers in Nutrition, you can look it up, where it is an algorithm for you to look at if you suspect celiac disease or gluten intolerance, how you might work this patient up. I also want to point out that autoimmune gastritis and pallor are common. We do get parietal cell antibodies, which gives you vitamin B12 deficiency and pernicious anemia. It does occur in childhood. If you get gluten intolerance, you also get poor iron absorption. So think in terms of celiac, think in terms of B12 deficiency when you get the pale diabetic. Okay, there are other autoimmune conditions associated with type 1. There's a very, very long list down here. It includes so many things. Just take a look at that list. But I want to talk about a few things because I've had patients like this. Remember that up to 2% of patients with type 1 diabetes have adrenal antibodies, and they will present as a tired child with low BP who craves salt and might have frequent hypoglycemia. There might be an unexplained decrease in insulin requirement and a deep suntan, and pigmentation of gum margins, palmar creases, the nipples, and skin. Actually, this might be one of the reasons for dead in bed syndrome in diabetes. But they do complain of fatigue, nausea, weight loss, salt craving. You can get postural hypotension and hyperpigmentation of the skin and mucosa. Do the morning cortisol. ACTH may not be easy. Synectin test if you can do it. And even I can't get 21 hydroxylase antibodies. Maybe you all can. There are some syndromes associated with this, APS1, APS2, and it is more commonly found in children with type 1 diabetes. For example, adrenal insufficiency together with chronic mucocutaneous candidiasis and hypoparathyroidism, so calcium abnormalities, or there's an association with Graves' disease, hypogonadism, hypopituitarism, Parkinson's disease, myasthenia gravis, celiac disease, vitiligo, and alopecia, right? So vitiligo, not that uncommon in Indians, but it is in 1 to 7% of patients with type 1 diabetes versus 0.2 to 1% of the normal population. Remember the association with thyroid disorder. Remember the association with vitamin D deficiency, polyglandular autoimmune syndrome, and celiac disease. Alopecia areata as well, not that uncommon in type 1 diabetes. Look for it. Sjogren's syndrome, if you don't ask, people won't tell you because you've got a dry vagina. Who wants to tell you you've got a dry vagina? But dry eyes, dry mouth, and because of the dry mouth, they get tooth decay. What ails the child is not always diabetes alone. Remember, the child has diabetes, but what ails the child is not always diabetes alone. Yes, if we have the resources, we can follow the algorithms of screening of comorbidities, but I think that clinical suspicion and clinical observation is more important than cleaning tests. And with that, I just want to end here. Thank you very much once again for giving me the chance to share.
Dr. Jali?
Yes, we can invite Dr. Alok Gupta now.
Indeed, it's my great privilege to introduce Dr. Alok Gupta too, and he's going to talk on transition care for young person in diabetes, which is very important again. And he's a clinical director for pediatric department, Dartford and Graham's NHS Trust since 2015. And he has been working for child health for last 32 years. And he has secured a solid foundation of clinical experience and management strategies. Then he believes in his abilities for communication skills, broad-based clinical acumen, and he has always stressed on high standards of a clinical service in pediatric medicine and hospital management. With these few words, I introduce Dr. Alok and present to the august gathering. Thank you.
Let me share my screen. Good morning. Just
Alok, please share your screen.
yeah, that's what I'm trying to do. Can you see?
Yes,
my
yes, yes.
Yes.
Are they moving?
Yes.
Yes.
No, yes.
Oh, very good. Thank you. So before I start my talk, really, I'd like to extend my good morning from London and good evening to my colleagues across in India. And thanks to Bansi and DiCare.com team for inviting me for such an important topic, which is very close to my heart. And morning to my chairperson, Dr. Shukla, Dr. Jali, and Dr. Dalal. And I don't have any conflict of interest for this talk, which is really good news. I'm going to spend 15 minutes or so on this talk, which is really quite important talk and topic for all of us. But perhaps it was not considered important topic for many, many years and decades because the diabetes in children and adults were looked after by adult physician or one team. So we hardly thought about it. There's a need or there's a change in that person's dynamics or lifestyle or various other issues. But lately we are acknowledging that there's more and more reason for think about transition for that particular age, like 15 to 25, because the outcome is quite bad. Despite we are thinking about insulin pump, closure of loop, artificial pancreas, the data around that age group is very dim, very depressing actually. And this topic has been to my really close to my heart for many years because I started something in 2004, thinking about transition that time. But before we talk about really my experience and the data across the globe, what do we really know what transition means? And the transition, I think the best definition described by Blum in 1993, the transition is a purposeful, planned movement of adolescents and young adults with chronic physical and medical conditions from child-centered to adult-oriented health system. And this is still very valid. And really, we need to think about the future of the youth before we think about future of the nation. So really, again, this is very, very strong quote, I think, to make sure we keep in our practice on in day-to-day life. And why really we feel that transitional care service is so important. And there are multiple reasons, and I'm going to describe a little bit some of them over here. Think about the increasing number of long-term chronic conditions in childhood, which we never really diagnosed before. The increasing prevalence and recognition of these conditions in that age group, which is affecting our young adult. There's increasing morbidity, as Dr. Lee described. There are many coexistent health conditions which affect our this particular age population, which obviously we need to look after. We acknowledge these are really important issues I think we need to acknowledge in order to tackle, I think, healthy adult in the society. There's a lot of weight problems in this particular age group population. There's a lot of obesity and overweight problem. Now, because of all this region and there's no effective service in the country, clearly this age group population is staying much longer in children's services, which is really not very desirable because we are not equipped with all those expertise for young adult to adult in the children's clinic. We are really seeing a lot more acute and chronic complications. So we need to think about how do we prevent and manage these complications in this age. We noticed, I think, these group of population is not engaged, and there is a significant decline in clinical attendance where we have a pre-booked appointment system, and up to around 60 to 70% population are not attending their healthcare professional appointment, which is very concerning. We know there's a lot of issue about the insulin adherence or treatment adherence issue in this group of population. Dr. Lee just described about the disordered eating. Around 35% of the population, especially female, they misuse the insulin treatment in order to maintain their body image and things. So that's really quite serious issue. We have a problem with a lot of behavioral issue, which predicts very adverse outcome in terms of HbA1c and overall diabetes outcome. We have seen young adults with a lot of psychiatric problems, again, very adversely affecting the outcome from the diabetes point of view. And the very dim data is about 60% of children only have a kind of arranged appointment to transfer their care to young adult clinics. And out of them, only 50% have appropriate healthcare professionals in those clinics. And this was discussed and planned. So very many reasons why we require transitional care service in any health system. And this is really important. Now, not to make you more depressed, but when we talk about DCCT trial, which is one of the gold standard trials in the history of diabetes, comparing intensive insulin therapy versus conventional, thinking about this will have similar effect in this age population. But interestingly, the young adult did not have any improvement in intensive insulin therapy regime arm, which is very depressing actually. And there's a lot of adverse outcome data, which is very, again, concerning. How do we really help? But then when they become adult, their HbA1c improves, regardless whether they are in intensive insulin therapy or they are in conventional. So there's something very peculiar about that age group between 15 to 25. And we know a lot of data is about the UK, and we know that there's a significant increase premature morbidity and mortality, and up to 3-fold in men and 6-fold in women, affecting age of 20 to 29. We know that under 30, a lot of mortality is because of diabetes, hypoglycemia, and DKA. So again, it's very, very clear difference between under 30 and over 30. A lot of, we're beginning to see the complications related to kidney, related to eyes, and even this age group population requiring treatment, which is very, very concerning because we hardly used to hear that a young diabetic will have complications of kidney and eyes. We think, I think it's a late onset disease of 40s and 50s, but that's not the case. A lot of issue about when I only described in terms of the follow-ups, but 30 as a healthcare service or system provider, we are not able to engage this group of population, and 30% of the patient at least miss their appointment once when they are given, I think, every 3-monthly appointment. 10% patients are more lost to follow-up. There's a lot of complexity about health service management, so these group of population find very difficult to really interact and coordinate their care. And many people, I think, felt, I think, the process too abrupt without any preparation. And up to 40% of population did not have any follow-up appointment in young adult or adult diabetes clinic, which is very, very concerning. I think that the opinion that pediatric endocrinologists or diabetologists are very hesitant to facilitate this process because they don't have any confidence in adult diabetes team either. Again, there's a very clear difference between adult diabetes team and children's diabetes team, the way we function. And we want these children or young adult populations to come independently when they are not used to coming to these clinics without their parents or carer. And as I just said, I think most of the time, I think the pediatric endocrinologist trying to delay the process because as we don't have a confidence in the system. Also, we need to think about, are we really trained to look after this age group population, especially for adult diabetes team, because they are not really have expertise and experience to dealing with this young adult population. So they try to treat them as like adult population as well. There's a lot of communications problems, and which really is being reported in some literature, either about the information or they've not been heard or parents didn't have a chance to talk about them. They compare, I think, the children's services like more informal, more family-centered, socially oriented, compared to where adult programs are more formal. And they really talk about long-term complications when this young adult are really not prepared about listening to long-term complications. So they get really completely switched off. We talk about transition a lot, but we hardly really studied as a proper formal randomized controlled trial. And a couple of studies are picked up from recent time, from 2017 to 2020. And they talked about really whether if you manage appointment more effectively, will that improve the engagement? And answer is no. If we provide a structured transition, does that improve? And answer is yes, it does improve clinic attendance, improve satisfaction, improve the distress. But this beneficial effect is not very long lasting. We have done a lot of work, I think, as a country in the United Kingdom, and we started doing national diabetes audit, and there's a couple of national diabetes audit. But again, very similar kind of theme where we have a concern there about completion care process. We got 8 completion care process, which clearly really get worse during transition time. Some of them they maintain like annual blood pressure, cholesterol, retinopathy. They don't get worse, but clearly a lot of things get worse. So one of the important thing is really why we choose age of 16 to 19, because we found most favorable outcome when the transition happens between the age of 16 to 19. So just to keep in mind when we are trying to organize transitional care services, maybe this is the age we need to think about. Most of the really targets are achieved pre-transition, not the post-transition, and that's really concerning. But when you look at the DKA data, they get worse post-transition, which we know a lot of children or young adults, they come with recurrent DKA as soon as they go into transition or post-transition. It's exactly the same data which I just described, thinking about various care processes. In the light of time constraint, I would not go in detail here again. And then another really audit was done in 2017, published in 2019, again confirming similar finding. Here, the annual care process, achievement of treatment targets, and DKA frequency get worse during transition. And there's a lot of variation in the service provision. So if you go to one unit to another unit, you will see a lot of variation. So there's guidance around it. What do we do, I think? And the most important thing is how do we work collaboratively with the young, like a children's team and the adult team from unit to unit, and learn from each other with the help of quality improvement projects to see what good practice they do. Very similar finding, but the interesting thing in this slide is once I think the deterioration starts, just in first year of transition, it does not improve for second and third year, which is really quite concerning. And as I said, I think if you look at the country, it looks like we are right. But when we think about individual units, there's a lot of large variation. But average becomes all right for the country, which is really not a true picture. What could be the ideal transition? Again, Blum described in 1993, which is really still valid. You need a multifaceted active process that attends to the medical, psychosocial, educational, and vocational needs of the adolescent when they are moving from that age group to become a young adult. And this is still really the key thing. How do we work together, addressing all 3 or 4 domains of this particular age group? There are a lot of data being produced, and the guidance is produced in the UK. And this is a long list, really. But despite all this, the state of affairs is not great, even in the UK. The National Institute of Clinical Excellence, we all know NICE, and produced the guidelines in 2004, and they are revised in 2050. And the important points here is we need to allow sufficient time. We need to have a local protocol and guidelines around this. We need to think about what is the best age to transfer, not the automatic transfer, not the set age. We need to think about relative stability when we transfer this care from a children's team to young adult team. And we need to really prepare this population by saying there would be some key changes in the service provision from when you move from service A to service B. This is really quite interesting data from 29 studies with 16 systematic review, and they found these are the common good points. So process has to be centered around CYP, which is children and young people, has to be planned, has to be structured with some written roadmap. We have to have designated clinics where we have a really input from children's and adult diabetes team. We have to have prepare this group for education and certain set skills. We have to have a transition coordinator. We have to have a MDT approach, multidisciplinary team approach, with the social and primary care involvement, because not just diabetes which affect this population. There's a lot of other issues around these age group which affects and influence the diabetes care. We need to have a good communications, and we need to have an ongoing training of healthcare professionals. I don't think we are really expert in dealing with this particular age group population, and we need to have the right resources to start this program and maintain this program. Another interesting really slide is about, we looked at in a study about different models of transitional care, and what they found is there are certain key elements about the different models, which is based on relational and longitudinal continuity, cultural continuity, management continuity, information continuity, developmental and flexible. And sometimes there's a trend between two continuity in terms of like flexible continuity would not allow developmental continuity to proceed. And unless you have a right proportion and right ingredients into any model, it would not really progress to become successful in transitional care. There's a lot of, again, diabetes, NHS diabetes quality care. They provided the standards, how to design your transitional care. Now I'm really going to rapidly share what we have done at Dartford in Kent area. So we acknowledged there is a need for this transitional care in 2004, which is almost like 16 years. But that time we started with transfer of care services, where we were offering 2 clinic appointments before we transfer child to young adult or young adult clinics. And this program was really addressed around age of 16 to 18. We created a 2 team, team A, team B, with a hybrid model where a children's clinician will sit with the adult diabetes nurse. We didn't have a dietitian that time. We didn't have access to clinical psychologists that time. But even with a little attempt, we have seen some improvement, and we managed to publish some data in SPET and shared in the conferences as well. So we did a 2 study. One was the qualitative one and one was the quantitative one. And both studies shows really favorable outcome in terms of patients and family were much more satisfied. Their attendance rate was much more improved compared to people who were not engaged in a transitional care program. We also looked at the quantitative data, and again in the early studies, we have seen improvement in their HbA1c and their attendance rate. The people who are engaged, they attended 100%, and their HbA1c improvement even when they started with higher HbA1c than people who were not engaged. And this was really encouraging, and this is with little attempt as a transfer of care, but in a planned, structured way. Now, recently in 2017, 2018, we really revised our transitional care services. Now we are hoping to provide, and we are providing proper transitional care services, which is really 3 years program. And obviously we are hoping the children or young adult will be ready by the time they go to young adult clinic. They have a structured program. Most of them, or should be all, should be on basal bolus program or CSII. They should be able to download their own data before the appointment and their day-to-day life. They should be really empowered and should be able to manage their own diabetes. They should have an annual review and completing 8 care process. And they should all have a individual care plan with individual HbA1c target. And this is a real proper MDT. As I described, we got an adult diabetes team, we got a children's diabetes team, we got a diabetes coordinator, we got a access to psychologists, we got dietitian, and we all sit together in one room. And before the clinic, we all sit together. After and during the clinic, we divide into 2 teams, as I described, where pediatrician sits with the adult diabetes nurse and adult dietitian, and vice versa. And they all are engaged with the annual retinal screening program. We are not just doing traditional clinics. We provide the workshop. We're still maintaining a school and home visits. We contact them 8 times in a year. And obviously, we send them reminder before the clinic appointment in order to improve their attendance rate in the clinic. And with this, in the UK, we got a best practice tariff. So we are claiming best practice tariff as an incentive. So the managers, really NHS managers, understands why we need to do all this. And within 6 months of this service, we could see that the number of encounters with this group of population has gone from 3 to 12, which is extraordinary. We started seeing the improvement in the attendance rate, which was really 30% DNA rate did not attend, which has come down to 21, I think, which is really even better than 21 now. We started beginning to see the improvement in the HbA1c. A majority of patients started displaying sign of improvement in their HbA1c. We did not have any decay or admission with severe hypoglycemia within that 6 months of study from the start of the service. And we had a lot of positive comments from the young adult population, but also with their parents. And this is absolutely brilliant, I think, and encouraging to the local team. So really, in summary, we can say this is a really active process. This is not something we can be very laid back or we can neglect or ignore. It has to be young person centered. This has to be, I think, family oriented, not just patient as a patient. We have to prepare. We start preparation around the age of 14, but real transfer happens between age of 16 to 19. We need to be adaptive and resilient, multidisciplinary, multi-team, multi-agency work. And I think it has to be age appropriate, developmentally appropriate. I described the 5 key or 6 key, I think, continuity thing. We need to make sure we bring really right proportion. We need to have our own training. I don't think we are trained enough to look after this particular age group of population. And I think at the end of the day, we need to really impart and transfer these skills and independence to this particular age group population. And eventually to make sure we get maximum potential. There are a lot of documents internationally, nationally, locally produced. I think here is the list. I think if you would like to look at it. And but obviously it's a very complex topic. It can be boring topic, especially with the people who are completely disengaged or unengaged, to engage them back into the system. But it's one of the key area. Without this, I think you can't really make a successful diabetes care and healthy population in any nation or globally. Thank you. Thank you for listening.
Thank you very much, Dr. Alok, for a wonderful talk. And I think it's a really useful talk. I think when you come to India, I would like to have in-person talk and interactive talk. I think this is very much required. Dr. Deepak, I think, would agree to this.
Yes, this is a very dear need, you know.
Very much needed talk.
In a physician is absolutely essential.
And Dr. Lee, your talk was amazing. I learned a couple of things, and the 1-2 things I would like to share and understand from your talk as well. 2 things here. Your celiac disease you discussed in quite a lot, and I do agree with you that we see many patients with celiac disease, type 1 with celiac, and even in non-type 1 with celiac, thyroid and type 1. But the word you use, gluten intolerance. my understanding was gluten sensitivity or intolerance are one of the synonymous, and it is basically a part of celiac disease. But how do you diagnose? Can you elaborate a bit about gluten intolerance?
Okay. I actually find that in my population, gluten intolerance seems to be part of the spectrum of celiac disease. I know this is not what, say, the UK experience is like. But even in the UK, I think their figures show that gluten intolerance is supposed to be about 6 times more prevalent than celiac disease per se. But I'll show you, I'll talk about what I see. I see children with type 1 diabetes who have, when you do the 4 tests, TTG, IgA, TTG, IgG, and anti-gliadin, IgA, IgG, a variety of tests turning up more than 0, but less than, say, the upper limit of normal. I call these gluten intolerance because they behave like celiac disease. Melanie O'Day, UHDE O'Day, writing in Gut in 2016, actually described this group, which is distinct from celiac disease, which is distinct from normal. They have intermediate serology. Currently, people think of this gluten intolerance as being primarily driven by innate immunity. But in my experience, many of them have sort of somewhere below the threshold for celiac disease. But where it is important for us in diabetes is that when you get this child with erratic control or with growth failure or this constellation in the family history of IBS, learning issues, thyroid issues, the kid's not growing all that well, the diabetes isn't wonderful, that's when you suspect either you look for celiac disease, and if you find numbers on the testing which do not quite fulfill the criteria for celiac disease, but nevertheless are clinically significant, then you treat accordingly. I know that my UK trained colleagues in Singapore sometimes have difficulties with this because to them it's a matter of terminology. But I say that, you know, it's not about terminology, it's about getting the diabetes care correct. And then they can go and argue about whether the kid has got gluten intolerance, gluten sensitivity, whatever. You know, those who want to go and get a biopsy can go ahead and get a biopsy. But I've seen children with very high titers in the 200 range whose biopsies come back negative. And I see children who have very, very low seropositivity, just only if somewhere within the low end of the, even within the normal range, who nevertheless have much incredibly improved diabetes care, incredibly improved growth, puberty, behavior, learning, when you remove gluten. And, you know, like Cox postulates, if you then put back gluten, you will get a recurrence of syndromes. You take it away, you get a decrease in symptoms. And this actually also fulfills something called the Salerno, S-A-L-E-R-N-O consensus of 2013. Which is written by a bunch of gastroenterologists. But what do you do with gluten intolerance that doesn't fulfill the rules? Sorry, it's a very long answer.
It was very, Dr. Alok wanted to say.
And wants to make some comment, but I would like to have the comment from Rishi, who is a senior endocrinologist based at Kanpur, North India. From Western India, Deepak is also having a lot of type 1 diabetic patients since last 30-40 years. He's working in field of pediatric diabetes. And Dr. Sujata Jalisi is a pediatrician and taking care of a public hospital only pediatric diabetes. I just wanted to know from them also that how frequently they get also for celiac disease screening is a regular part of it. Unless, I think in my practice, what we have started doing is only those patients who have growth failure, I mean, some intolerance, you have GI symptoms, only we get it done. But I think now we are, Dr. Deepak and we were talking that we should think of getting our guideline again, and we should think of getting all patients for celiac disease screening also. With this, I want first Alok comment that what they do in UK, and then we would like to have Alok is a very close friend of mine who is an eminent.
Mine too.
I know. Whoever is known to me through his pad, it is all through you, Rishi. Come on.
Yes, and be it Lee and be it Alok and Dr. Dalal, Dr. Jali. Yeah.
Yes,
Alok, please.
Please.
Yes, in terms of celiac, I think I really endorse what Dr. Lee just said. And we acknowledge this problem as a really significant hidden problem. So in 2003, I think the National Institute of Clinical Excellence acknowledged that there's a problem. So they made it, I think, as a screening criteria. And they recommend now every 2 to 3 years celiac screen for any patient with type 1 diabetes. And the reported data, this is reported data, is about 10% you will get a positive celiac screen, and 5% out of them will have a positive biopsy. So, but there are a lot of unreported, symptomatic or hidden or silent celiac, as we know, I think. And we pick up really a lot of children who never had any symptoms. Even they were well-grown children, but we picked up really. So that's really quite silent. So I think my advice would be, I think, some kind of program, whether every 3 years you will screen everyone with a type 1 diabetes, whether they children or adult, because a lot of adult population found to have a silent celiac disease, but presented with long-term chronic complications of celiac disease in terms of cancer and things. So I think it's really important. But how do you now recently SPEGAN, they really concluded, I think if person is symptomatic or they have a strong titer, you don't need to really go for fancy tests like endoscopy and biopsy thing. It's very expensive to any system. So you simply really put them onto gluten-free diet and see. Even if they have gluten intolerance, they still require the treatment to become asymptomatic and improve their quality of life. May not have a bad influence as much as celiac disease, but clearly the quality of life is completely impaired. So that's a current guidance for the country. And when I talked about 8 care process, the blood test is one of them for celiac disease, thyroid function, and obviously urine for microalbumin, all this kind of stuff. So I completely endorse Dr. Lee. Not very different in UK than what you're doing in Singapore.
No, let me just put it. I was just thinking that the one thing about this Zoom conference that you can't throw tomatoes at me. I will tell you, not everybody agrees, and certainly you get some resistance from the gastroenterologists because it's a very existential issue for them. If you tell them you don't need to do a scope, but really the thing that I realize is that if you follow the American guidelines and to some extent the UK guidelines, you will miss cases. Because actually, if you look at the whole of Asia, the whole of India, we've become westernized, but we don't eat bread 3 times a day. We don't eat pasta 3 times a day. We have the occasional pizza as a treat for the kids and so on and so forth. So I think that maybe the criteria, the neurological criteria that come from the Western learned societies may not really be that applicable to our people. I think clinical suspicion it should be there. I know that in Delhi you can definitely get the serology and in the full 4 panels. And I would actually suggest you look at the full 4 panels, and anything really above 0 shouldn't be there. Why would you get allergic to gluten? Why would you get allergic to tissue transglutaminase even at a low level? You shouldn't be if you're normal. Yeah, thank you.
I published a case study many years ago about, which was really 2 centers, one from Newcastle and one from here. The people who presented with pica, they found a iron deficiency anemia, and then they, like in both centers, those children have a celiac disease. So celiac is very, very pleomorphic condition, really, which we can't be confident as a clinician we know enough, and we can diagnose every celiac unless you integrate some kind of screening program. Now, I think, and we should be there, not the gastroenterologist, because it's our condition. We may be missing those group of population by not having some screening program. Maybe a gentle blood test, that's enough. That's more than enough.
I think I could smell Bansi's question, and I'll share my 26 years. First 15 years, I was not very particular about celiac. Last 10 years, we are getting it done in almost every patient with type 1 diabetes, at least tissue transglutaminase IgA. And what we have noticed that the yield has definitely gone up, and we have some data, and we have also shown that the celiac disease is associated with reduction in bone mineral density also. So we have data on this also. We did, but I'm fortunate to work in coordination with a pediatric endocrinologist as well. So that is my take on. But definitely, I would say all of us should have a strong suspicion, and those I think at least 50-60% of our patients can afford. So we should pass on. They should at least be getting benefit of our knowledge.
The two things really. One is it's very important to acknowledge this as a healthcare professionals. There's a need. Then we need to think about what resources we are going to put it. That's more public health question really.
Because
so we should not be ignoring the test because we can't afford. That's really because we're defeating the purpose. So as a recommendation, we bring the recommendation as a healthcare professionals.
Problem, Alok, I'll quickly share problem in India is if we stop doing and using our abilities, we stop using it. Sometimes
before we close this session, I just want to introduce Jayesh is also with us in this forum. And
hero.
Yes, Jayesh. So you want to make a comment because she's running Diabetes Foundation, taking care of hundreds of children. So what's your, opinion about this celiac disease? And then we will close this.
She's real life hero. She's real life hero. Yes.
You want me to talk about celiac disease?
Talk about you, beta.
Your opinion just simply for that.
I think there's at least in the type 1 community, and I'll talk as a person living with diabetes, there is a serious lack of awareness, at least within the people who have type 1. I was not aware as well, that people with type 1 are more susceptible to celiac as well. And I think I was having a conversation with Dr. Sabu once, and he was like, do some more fun seminars with the people who have type 1. Because I think it's very important for people with type 1 to know the symptoms, to know what to look out for, and what they can do to better maybe manage it. So my opinion is that we need to do more patient education sessions with celiac and type 1.
Good, thank you. So with this, I think now...
Can I ask a final question?
Yes.
And maybe you may not be able to give me an answer right now, but think about transition really, and think about, obviously, we have physicians where I think we look after children to adults like Bansi, and most of the clinical team may be doing this. But I think just think about, and maybe you put your comments in the chat about what kind of transition you have. And kind of like city like Mumbai, for example, we got a very well-defined children's diabetes team versus your adult diabetes team. And what we are doing around, I think, this particular age group to tackle, because the outcome data is very bleak. And that's what I think, that doesn't change from place to place. This young adult population is very neglected, very disengaged, with a lot of adverse outcome in the adult population because those golden years have gone lost. So I think at this, I would stay quiet now and think about answers, and your comments and reactions.
बोल भाई. Bansi, you are on me.
Yes. Can we close this session? Dr. Deepak Dalal, you are with final comments. And then thanks to Dr. Alok Gupta. Thanks, Dr. Warren. And thanks, Dr. Rishi Shukla. Thanks, Dr. Sujata Ben. And Dr. Deepak Dalal, your final comments, and we close the session.
Thanks.
So thanks to Dr. Bansi for such an excellent session. And thanks to chairpersons and speakers. And I think we close the session. Okay.
Thank you.
Thank you. Have a nice evening. Thank you. Bye.
Bye. Bye, Alok. Thank you for joining. Bye, Dr. Lee. You reduced a lot, huh?
You reduced, Lee.
He reduced significantly. Dr. Warren Lee had reduced significantly.
Warren Lee is looking thin.
Yes, he is now looking thin.
Looking handsome.
Alok, you are same, eh? Come on.
I'm the same. No change. A lot of sweet, I think. Chocolate around the festival.
So now with the next session, we have the reporter, Dr. Ghosh, Dr. Subhajyoti Ghosh from Dibrugarh, a very upcoming diabetologist of Northeast India. We have Dr. Bharat Bhai Solanki. Dr. B.B. Solanki is a very close friend of mine, a professor of medicine. He's from city of Ahmedabad, who is heading the department, heading the unit in BJ Medical College, and also running diabetes clinic there. And then we have a Dr. Narendra Patel, who himself is a consultant diabetologist from North Gujarat. He is eminent diabetologist and senior physician from North Gujarat. Now, to start with this session, I will just request Dr. Subhajit to start with, and then I will request both the chairperson to introduce. But there is some technical difficulty. I think Dr. Kamlakar Tripathi had joined, so now he can start his session. I was worried, and that's the reason. So, Dr. Solanki, you please introduce Dr. Kamlakar. Subhajit, if you want to make any comment, please talk.
Good evening, sir, and good evening to everyone. So today on this session of diabetic and kidney diseases, three important topics will be discussed. So for this discussion, to take it forward, I request Dr. B.B. Solanki sir and Dr. Narendra Patel sir to take position from here on. Thank you, sir.
Good evening all, and welcome you all on the session of the diabetes and kidney. We will have 3 lectures, and Dr. Kamlakar Tripathi is already on. Dr. Kamlakar Tripathi is going to speak on high CV risk and CKD, muscle disease spectrum. Dr. Kamlakar Tripathi is an ex-professor and head of the Department of Medicine, Division of Nephrology at Banaras Hindu University, Varanasi. He has more than 300 publications, which includes 200 international publications also. He has delivered more than 600 lectures, out of that around more than 100 plus for international lectures. He has 2 international awards and 30 national awards and 10 fellowship. He is the ex-president of Uttar Pradesh Diabetic Association and chairman of RSSDI Uttar Pradesh chapter. He also served as a president of various society like Indian Society of Wound Healing, Indian Society of Hypertension, Indian Society of Chronomedicine. He has around 10 research projects, and he has supervised around 15 PhD students, around 60 MD students and 2 DM students. He is member of
Apex body of New Drug Division.
Apex body of New Drug Division, Ministry of Health, Government of India, SETSFO, DCGI, and DGHS, Government of India for 2013 till continuing as 2020. And he is an advisory board member of Ayush Ministry of Health, Government of India. So such a renowned person now, Dr. Kamlakar Tripathi, I request him to start his lecture.
Hello. Hello.
Hello.
Yes.
Sir, एक minute. We are just trying to connect audio for Dr. Kamlakar. Just one.
Okay.
If we have any technical issues connecting with Dr. Kamlakar sir.
Yeah, maybe we can start with Dr. Amit sir's presentation.
Dr. Amit sir is already there.
Yeah.
So I will have a brief introduction about Dr. Amit Saraf sir. His lecture is a third, but he is going to deliver the lecture as a first number. He is going to talk on role of DPP4 inhibitor from a renal perspective. And Dr. Saraf is a director, Department of Internal Medicine, Jupiter Hospital, Mumbai. He is a head of the quality control of Jupiter Hospital. He is an MRCP London examiner, DNB teacher, MD teacher and examiner, and he is a National API Governing Council member. So over to Dr. Amit Saraf, request him to start his lecture.
Thank you, Chairpersons, Dr. Salanki, for that kind introduction. Thank you for the administrators for accommodating me and sort of pushing me ahead of the session because of technical reasons. It's always a pleasure to be on the show of Dr. Bansi Sabu. I think he's the main anchor man here, Bansi Bhai. It's a pleasure to be here on your platform and always a pleasure to talk on anything that you have crafted and executed because it's one of the best platforms to be on. So without further any ado, I would want to share my screen and start with my talk of this evening, which is as was told by the chairperson that I'm speaking upon DPP for the renal perspective. So at the outset, I would say that we are all aware about the role of DPP4 per se in diabetes treatment. The main crux of today's talk was what is the role in a specific nephrology perspective. So we are all aware about this. There is nothing new here. We have all been seeing a steady rise in diabetes. Unfortunately, in the world, it's now declared a global emergency. And India, unfortunately, especially in Southeast Asia, leads the way where maximum number of diabetic type 2s are present. And look at this particular graph that the average control of HbA1c worldwide was mean at 8.4 and India, unfortunately, what 8.6. And that's nothing to be proud of. It's a very, very sad and a shameful figure to be very honest and frank about it. But can we do something about it? We as clinicians this evening, we've gathered together on the DiaCareCon and last 2 days, we've tried to deliberate on this simple map that can India have a better A1C control. So that is the need of the appropriate treatment for the Indian diabetics. And what are the challenges that we face in India? We know that the usual factors are that we have a greater abdominal obesity, visceral fat at any given BMI. We have a higher waist circumference and a waist hip ratio. We have a lower level of adipokine and high plasma leptin, increased concentration of triglycerides, low rate of glucose disposal, impaired insulin secretion, and thereby increased resistance of insulin and genetic factors. So we are all aware of this. What are the possible reasons that in spite of knowing all of that, why can't we intensify the treatment? So there's certain patient factors such as pill burden, fear that something may go wrong, the cost of therapy, obviously in India, and the treatment factors such as clinical inertia, wait and watch approach, dropout on multiple pins. So there are many reasons because of which an Indian clinician may not want to intensify early. But we've all seen, all cut out throughout all these years of ADA and EASD and even the RSADI guidelines that we have seen a much better control, whether it's a monotherapy going on to dual therapy to triple combination therapy. Finally, we see that the earlier we get a better glycemic control, we see that we add on to the better life years of the patient and better is the A1C control. Vis-a-vis, if we do not do that, what are the consequences of a delayed intervention? As clinicians, we are all aware of this, that if we don't, we are, as the A1C rises on the left-hand side graph, as we can see, on the right-hand side, we can see the months and the years, unfortunately, steadily decline, and vice versa, for people who had an A1C less than 7% before the first year of diagnosis, had a better life efficacy in terms of MI, strokes, heart failures, and even composite CVE at 62%. So that's basically the bad glycemic legacy and the drive risk of complication. This is what, ladies and gentlemen, the UK PDS tried to tell us so many years prior, that legacy, the glycemic legacy, the better it is, the better for the patient, the bad it is, the much worse for the patient. So what are the factors we consider while choosing an antidiabetic therapy for glycemic goals? So basically we have to choose and pick the risk potential associated with hypoglycemia, adverse drug effects, disease duration, life expectancy, important comorbidities which may be present with type 2 diabetes, established vascular complications, patient preferences, obviously, and the resource and support system also, the last but the most important point. And this is all published in Diabetes Care 2020 in this ongoing year, which made us choose the patient therapy factors. Bottom line of it all was that we've seen over the years fixed dose combination in diabetes were much more crucial for effective control in terms of clinical inertia being not there, adherence to be a little better, and patient compliance also was better. And amongst the FDCs, I think the metformin and DPP4 FDC was considered an excellent option due to a strong pathophysiological rationale, the robust efficacy, and basic safety and tolerability was much better with this. So what are the currently available DPP-4 metformin formulation in India? So that brings me to the crux of my talk, wherein I'm going to now concentrate upon metformin and the saxagliptin combination, which we have is one of the fixed dose combination, which is with the extended release metformin available in India. And it has a better control, more convenience, reduced compliance, as we shall see in the slides to come. So need of the hour, obviously, as we see in the earlier slides, if we decrease the patient factors for reduced compliance in terms of number of pills, I'm going to now concentrate upon compliance. The inconvenience of patient is lost, and therefore the compliance and convenience is better. There is a better 24 hours control with a single pill, and thereby compliance is better. So the point being, the extended release metformin with saxagliptin as a fixed dose combination works via a gel technology, wherein the gastric fluid can enter the tablet, cause the polymers to hydrate and swell, following a jet matrix, and the gel matrix eventually, gradually over a period of time, gives a sustained extended release over a period of time, leading to a better glycemic control than the initial combination of only Saxa with metformin versus metformin alone, as very rightly proven by these two typical graphs out here, where we can see the advantages of both. The adverse GI effect which we as clinicians have seen with metformin immediate release compared to the metformin extended release is again very well depicted here, that an immediate release can typically give rise to what we call, and we've seen clinically, as a dumping syndrome, hypotendencies, GI intolerances. But with the extended release, we've seen that it scores much over the immediate release, thereby leading to obviously increased adherence compared with the immediate release. Patient population base, when studied and who was shifted from immediate release metformin to an extended release metformin, the A1C was improved from 9.1 to 8.4, and that was almost 19% better, and a very, very significant p-value as well. What about the pharmacodynamics? I think efficacy, the initial couple of slides have proven. Anything to do with pharmacodynamics? So we've seen that when this combination is taken, it was done as a study design of a 4-week multicentral and multinational centers with adults between 18 to 77 years of age were taken with type 2 diabetes. A1Cs was 7 to 10%, and saxagliptin 5 versus the placebo add-on was given with a metformin 1500 milligram to 2000 milligram and once a day with meals. And it was seen that Saxa with metformin extended release versus up titering of metformin only plain extended release was seen that there was more drop in A1C baseline with Saxa metformin combination extended release than up titering only the plain metformin. So this p-value again was significant for the combination. The intensive control reduces the microvascular complication of type 2. Again, the UKPDS findings, that is one trial we as clinicians should always be adhering to as a benchmark. And it has shown that better the glycemic control, better the microvascular, better control and reduction of the microvascular complications also seen. Long-term, almost 30 years reduction in complication of intensive control was seen. And thereby the key takeaways of this study was that 35 to 60% reduction in early microvascular disease was seen with a mean A1C of 7% vis-a-vis the uncontrolled diabetics, and a durable effect of initial assignment despite a loss of metabolic control reduction in long-term complications. Now, that brings me to the third aspect of my talk, that where does this FDC stand in terms of a chronic kidney disease patient? So I would want to draw the audience's attention to the DPP-4, that's the fourth column from the left-hand side, and look at the green bars all throughout. That whether it was CKD 1, 2, 3A, 3B, 3, CKD 4, and 5, I believe cut across the entire Sita, Saxa, Lina, Vilda, and telnigliptin drug threshold available, hardly any dose adjustment was required in all the spectrums of CKD. That's a very, very sort of important thing for us clinicians to note. Taking it further, when individually the molecules were compared from a CV safety point of view, CV renal point of view, sorry, the dose modification at CKD 3B was hardly there for Saxa. Lina also didn't require much. Sita, a further modification if the EGFR was less than 30 ml an hour and below, and Vilda required nothing. Hypos, all of them required no hypo risk were there. Glycemic efficacy in hemodialysis patient was available in 3 unknown for the Lina molecule. The CVOT trial also established that primary endpoint of non-inferiority was met in all 3 of them except the Vilda, because they didn't have a published CVOT as yet. We are expecting one coming out in 2021. And the CKD trials at all stages in CVOT trial has shown that Saxa was quite ahead compared to its own other molecules of the same family. and the renal safety and long-term data was available for all four, and reversible between proteinuria and microalbuminuria was statistically significant in CVOT. Again, the data was available for SAXA, but not so much as for the others. So basically, SAXA evidence with CKD perspective have shown that there was an improvement of ACR irrespective of the glycemic benefit. It's basically seen in the SAVOR-TIMI. So SAVOR-TIMI has very robust data showing that this particular molecule has shown a good amount of control in preventing the proteinuria and thereby the microalbuminuria and proteinuria and reversing it back. So almost giving a kidney safety profile when the patients of type 2 with CKD are put on a SAXA combination. And statistically improved ACR was seen in basically on saxagliptin baseline 39 to 22 over years. This was the real world evidence from Italy on albuminuria on patients with saxagliptin. As we can see here, that at baseline, if the eGFR is 84, end of the first year it became 85, and ACR, if it was baseline 39, at the end of the first year it became 22. So I think pretty robust and very significant p-value significant data is shown on this particular slide. So if the eGFR is maintained along with the reduction of A1C, together it could possibly improve the underlying progression of cardiorenal disease, and treatment with SAPSA improved ACR even in normal albumic without affecting the eGFR. So the SAVOR-TIMI, SAXA and a cardiovascular outcome patient with type 2 diabetes result analysis based on renal parameters and outcomes have shown that primary endpoint being patient with any effect from composite cardiovascular non-death or a non-fatal MI or a non-fatal ischemic stroke. And the analysis of renal was shown the composite of a doubling of serum creatinine level, initiation of a patient on dialysis, renal transplantation, or a serum creat of more than 6 milligram per deciliter. The prior composite renal endpoint together with death was also seen. And what was the study proving at the end of it? That the total patient who had an average eGFR of 71 to begin with a normal to mild renal failure, that is eGFR more than equal to 50, moderate renal failure, that's 30 to 50 eGFR, and a severe renal failure, that's less than 30 ml/h of eGFR, have less frequently treated baseline with metformin sulfonylureas, which more frequently with insulin. But patients with severe renal failure, older and more frequent, had a longer duration, higher prevalence of urinary ACR, high levels of N-acetylcholine fragment of natriuretic peptide, which with normal renal function. So SAVOR-TIMI at a 2-year cardiovascular endpoint according to renal function have shown that patients with definitely more than 50 ml/h eGFR had a better outcome in terms of CV death, MI, ischemic strokes, cardiovascular death, and hospitalization for heart failure compared to the ones who had a eGFR less than 50 ml/h to begin with. And the frequency of progression to microalbuminuria with composite health as per the renal function was shown that saxagliptin definitely gave an advantage to the patient compared to the placebo arm, as shown by the green bar on this slide here. That improvement was seen in the patients who were put on saxa compared to the placebo groups. The risk of progressive albuminuria was defined as a treatment difference in number and proportion of worsening, no change in improvement of urinary albumin to creat ratio, defined as shift from baseline to the duration of patient with complete data. So p-value was definitely much more significant here. The SAVOR-TIMI, the frequency of renal and glycemic endpoints according to the renal function. Again, if you see at the bottom, people with more than 50 ml/h of eGFR again had a better sort of survival in terms of not requiring doubling time of dialysis, renal transplantation. The creatinine also settled. The hospitalization of hypoglycemia because of hypoglycemia and the initiation of insulin therapy was much lesser in people with eGFR of more than 50 compared to the people with less than 50 of eGFR. So SAXA compared to LINA from a renal perspective, again, we have compared between Carmelina trial and the SAVOR-TIMI, which has clearly shown that when it came to saxagliptin, the endpoints have shown clearly in terms of both these molecules that Saxa had a little bit definitely better advantage in terms of prevention of doubling of serum creatinine, prevention of dialysis to a large extent, prevention of renal transplant, and prevention of serum creatinine in more than 6 milligram per deciliter compared to LINA on head-to-head comparison trials. And progression and reversible albumin microalbumin was by completion of therapy in SAVOR-TIMI again showed that Saxa had a better advantage compared to the other standard anti-diabetic drugs. So the eGFR patient included in this trial, less than 15 eGFR obviously not taken for the Carmelina. The SAVOR-TIMI on the other hand had chosen patients of that, and we have seen that they were definitely benefited on a saxagliptin arm. So improvement in efficacy with Saxa in dialysis patient with no adverse effects was seen, and the PPG risk also decreased significantly, the postprandial glucose in the Saxa arm compared to the others, and there was no risk of hypo with Saxa at all. So from a renal perspective, I think what the last couple of slides have tried to show us, that we can try as clinicians to go down to a very, very low eGFR when it comes to saxagliptin, with no much risk of hypoglycemia and a good sugar control as well. So basically, to conclude with, I think early and individualized treatment approach is recommended as per the most guidelines for diabetes that we are all aware of. Early intensive control with combination of anti-diabetics will give a better patient care for both glycemic control. This Saxa and metformin extended release FDC is the only one-study formulation available in the country, which has shown much more better control as compared to metformin alone. Early intensive treatment can reduce the macrovascular risk complication in type 2, and as I said, give them a better glycemic legacy. Saxagliptin has not shown any nephrotoxicity. For Saxa, renal protection endpoint was evaluated in severity, which we've seen was not inferior in any way to the standard of care. And Saxa is one of those few DPP-4 inhibitors having this renal protection analysis. In addition to this, saxagliptin has shown evidence of 32% reversal of proteinuria and 31.3% reversal of microalbuminuria, and doesn't increase the risk of hypoglycemia in the bargain in mild, moderate, or severe renal failure in patients, including those on hemodialysis. So that, in short, ladies and gentlemen, was my submission of a particular molecule, saxagliptin, amongst the DPP-4 family, and with a combination of metformin. I think we as clinicians can give it much more liberally in our type 2s with a renal involvement, and try to achieve a better glycemic control and take India away from that shameful 8.6 A1C control worldwide, which is seen compared to the others, and try to get a better glycemic control to our patient. Thank you so much, everybody, the chairpersons, the organizers, especially Dr. Bansi Sabu, for his opportunity. It is a pleasure, as always, to be on this particular platform. And I will hand it back to the organizers. I will end my slide sharing now. Thank you so much for a patient hearing.
Thank you, Dr. Saraf. Now, Dr. Saraf, you are requested to stay on, because we will have a discussion at the end of 3 lectures. So we are moving for the lecture 2. I think Dr. Kamalakar sir is already joined.
Yes, he is already there. You can share the slide. You have already introduced him. So now over to Dr. Kamalakar.
Yeah, Dr. Kamalakar. Thank you. Already. Now, Dr. Saraf, you are requested to stay on, because we will have a discussion at the end of 3 lectures. So we are moving for the lecture 2. I think Dr. Kamalakar sir is already joined.
Yes, he is already there. You can share the slide. You have already introduced him. So now over to Dr. Kamalakar.
Yeah, Dr. Kamalakar.
Are you listening me, sir?
Yes, we are listening, sir. You please start the talk.
And my slides are you seeing my slides also?
Yes, we can see your slides also. Just make it on the full screen. Yes. And now start the talk.
Thank you, Dr. Bansi, for bearing me. My ignorance.
Yes, listening, sir. You please start the talk.
My ignorance and my shortcomings, not being in time, and I try my best, but still I couldn't do it. Lot of echo.
Dr. Kamalakar Tripathi, there is a background noise. I think some other laptop or other mobile phone is on.
I don't know, but thank you, Dr. Bansi, for bearing me. My ignorance. Let me put it off. My ignorance and my shortcomings.
Dr. Rutul, Neelam, can you mute everyone? Dr. Kamalakar Tripathi, there is a background noise. I think some other laptop or other mobile phone is on. Rutul.
Let me put it off. I don't know.
Sir, all are mute.
तो नीलम रुतुल म्यूट नहीं है, रुतुल का चालू है. डॉक्टर रुतुल,
Is it still coming?
कमलाकर ने ऐसे डेलीगेट जो ज्वाइन किया है वहां से लॉग आउट कर दीजिए.
डॉक्टर कमलाकर त्रिपाठी, नाउ
मेरा कोई और मेरे पास कोई भी मोबाइल है नहीं. कुछ और.
नीलम, रुतुल का ऑफ करना. रुतुल का
सर, रुतुल सर का ऑफ ही है. उसने
ऑफ यार, उसका
माइक उसका कनेक्टेड ही नहीं है सर.
मेरे पास कोई नो डिवाइस.
वहां से लॉग आउट कर दीजिए.
Dr. Kamlakar Tripathi, now
मेरा कोई अभी कहीं कोई आवाज आ रही, मेरे पास कोई है डिवाइस।
नीलम ऋतुल का ऋतुल का
सर ऋतुल का तो आउटफिट है उसमें
हो गया उसका
माइक उतना कनेक्टेड ही नहीं है सर।
मेरे पास कोई नो डिवाइस।
શું કરે છે તું પાછી
कोई आवाज आ रही, मेरे पास कोई है डिवाइस।
तो इनके मोबाइल में दो जगह मोबाइल है क्या
नो डिवाइस
sir in your laptop only you have already joined with the same laptop you joined as a delegate and now you have joined as a speaker so the same voice is coming again in the in audience form also
so what should I do now? क्या करें?
सर आपका सर 1 मिनट वो जूम वाला विंडो है ना उसको मिनिमाइज करके आपको ब्राउजर बंद कर दो
you joined as a delegate and now you have joined as a speaker so the same voice is coming again in the in audience form also.
What should I do now? क्या करें?
सर आपका सर 1 मिनट वो जूम वाला विंडो है ना उसको मिनिमाइज करके आपको ब्राउजर बंद कर दो
And now you are joined as a speaker. The same voice is coming again in the in audience. What should I do?
आपका सर 1 मिनट वो जूम वाला विंडो है उसको मिनिमाइज
Sir, best way is you first disconnect both the things completely and you again log in as a faculty. Till that we can have I think Dr. Jiten Vora is there. We can take his talk and Dr. Jiten Vora is there.
Sir, please verify Dr. Jiten Vora is connected by audio and video both.
I can see actually he was there. His video was also on, but then I think he has kept it off.
He may be thinking that lecture is going
can
on.
You call him again and just please on video call you can take. Dr. Jiten Vora is there, so now we can take Dr. Jiten Vora talk.
Yeah. Okay. Now we can. Now we are going in a reverse way. Second lecture is now second. Dr. Jiten Vora is going to talk on the a very important aspect that is a nephroprotection in type 2 diabetes, contribution of newer therapies. Dr. Jiten Vora is from United Kingdom. He is a clinical director for pediatric department of Dartford of NHS since 2015. He is also dealing with the diabetes of the children and young since last more than 15-17 years. He has served in various hospitals and external committees, and Professor Vora's ongoing research interests include the development of screening and treatment of diabetic retinopathy, renal hemodynamics, and hypertension in type 2 diabetics, the prevention of renal disease in diabetic, the physiologic of aspect of treatment of type 2 diabetes, and mechanism of osteoporosis. Professor Vora has also published extensively in the field of diabetes and endocrinology, and he has also served on many advisory panels, including the NICE, which are the guidelines we use for many diseases, particularly lifestyle diseases. So over to Dr. Jiten Vora for his talk on nephroprotection.
Thank you very much. Thank you for those kind words. I have to say that some of that is not related to me. I'm not a pediatric endocrinologist, nor have I ever been. I've always looked after adults, but the rest of it is fine. Thank you very much for asking me to participate in this trial. I'm honored to be part of the DiaCare conference on this occasion. Now I'm trying to make this work, which I'm not doing at the moment. Are we all good, Banshi? Can you see my slides now?
Yes, sir, we can see you.
Yes, yes.
So, thank you. So thank you very much for asking me to participate in the THERAPIE conference for 2020. I'm honored to be here. Let me start with some background points. We know that there is a huge population with patients with type 2 diabetes. We also know that somewhere of the order of 30 to 40% of those patients will develop a degree of renal impairment, as measured either by eGFR reduction or an increase in albuminuria. 10% of those patients will still develop end-stage renal disease. So the numbers that we deal with are large, and there's a large residual risk despite all the other background therapies that we should be using, standards of care. So with that background, what I'd like to do in the next 15-20 minutes is to cover the SGLT2 trials and what they mean to us in terms of potential prevention of renal disease, secondary prevention of pre-existing disease, i.e. delay the progression and or possibly regress, and then the treatment of established renal impairment. And we will talk a little bit about the GLP-1 receptor agonists. So let me start you off by looking at this KDIGO trial. You are all very familiar with this. On the y-axis, we have eGFR categories, and you will see that at the top left-hand corner, we have an eGFR of 90 and then gradually declining as we come down. On the x-axis, we have median urinary albumin-creatinine ratio increasing from left to right. Now, I put this up because it demonstrates the risk and it allows us to consider the data that I'm going to present to you in relation to the risk. You will see that the trials on the left, CANVAS and DECLARE, were predominantly in the low-risk groups, with many people having normal eGFRs and very low levels of albuminuria. And then we move to the EMPA-REG trial, where the number of people with GFRs in grade 2 increases, as does the albumin excretion rate. And finally, on the right, we have the CREDENCE trial in people with established renal impairment. So we know by looking at the outcomes, the primary composite outcomes of all of these trials, that they've demonstrated an improvement in the renal composite endpoints. May that be related to empagliflozin, canagliflozin, dapagliflozin, or indeed canagliflozin. So this is a class effect. And also note that the reductions, the improvements in outcomes are about the same in every trial. So they're reducing outcomes by about 40 to 50% consistently. So let us then move on to the possibility of regression or prevention of development of kidney disease. We've noticed that somewhere of the order of 30 to 40% of our people will develop renal impairment, either as measured by eGFR reduction or an increase in albumin-creatinine ratios. The DECLARE study is a particularly prominent study. If you look here, in patients in the DECLARE study, the GFRs were in 85, median GFR was 85 and a very low level of albuminuria. So these were essentially renally very healthy patients. And despite that, as you can see on the curve on the right, there was a halving of the development of the renal composite endpoint. So to me, this indicates that by using these compounds early, as here it's dapagliflozin, we are actually reducing the development of renal disease in people who otherwise had normal renal health. So this is evidence of primary prevention of kidney disease. Prevention of kidney disease to reduce those number of people who at the moment are of the order of 30 to 40%. Similarly, if we look at the data from the EMPA-REG and CANVAS trials, you will see that the benefit of these two drugs in these two trials were related to every stage of renal development, including up at the top, the new development of microalbuminuria. So we've seen that eGFR, deterioration of eGFR is reduced, as is the development of new albuminuria. Of course, in these trials, we also saw that the benefit was present for every stage of renal impairment, either the development of macroalbuminuria or end-stage renal disease or doubling of serum creatinine. So there is evidence now of prevention of kidney disease in people with type 2 diabetes, either measured by eGFR or measured by albuminuria. Now, so the important question for us clinicians is, do we have to check the eGFRs before we initiate SGLT2s from the perspective of renal prevention, renal protection? The answer to that is no. In here, on this slide, in this figure, you will see data from the 3 biggest trials demonstrating that the benefit of SGLT2s in renal disease is present regardless of your baseline eGFR. So at the top, we start with the highest GFR greater than 90. And you can see that there is approximately 60% benefit of the SGLT2s. And as we go downwards, we go to groups with lower GFRs, and you will see that the benefit is still present because the hazard ratio is to the left of the line of unity. So SGLT2s demonstrate benefit in every patient with regardless of the eGFR, and also demonstrate the possibility of prevention of kidney disease. The same is also true for baseline albumin creatinine ratios. So here again, we have data looking at going from the top, normal albumin creatinine ratio, increasing albuminuria as we decline downwards. And you will see that the hazard ratio is again to the left, demonstrating a benefit is present regardless of baseline albuminuria. So let's just summarize the data so far. We've shown you some data that says that there is possibility of prevention of kidney disease, particularly from data from the DECLARE, but also to a certain extent data from EMPA-REG and CANVAS. Benefit of SGLT2s in terms of renal endpoints is present regardless of baseline eGFR and baseline albuminuria levels. So what happens in these trials to the eGFRs? So here we have EMPA-REG on the left going to CANVAS and DECLARE. As you go to the DECLARE study on the right, please note that the y-axis is a different scale. So all of these trials show you an initial reduction of GFR with SGLT2s, but thereafter a stability. So in the EMPA-REG, the baseline GFR was 76 or so, and it remained stable. Similarly in CANVAS. And if you remember, the eGFR in DECLARE was 85.2, and that too remained stable over the course of 3 to 4 years. So the stability of GFRs is also reversing the natural reduction of GFRs that we see in people with type 2 diabetes, which is of the order of 1 ml per minute per year. So even the natural reduction of eGFRs is protected by using SGLT2s. Now let's just summarize the data for albuminuria and protein excretion. This is quite a complex slide, so let me take you through it. On the left-hand end, we have primary prevention or progression of disease, or at the bottom, regression of disease. And as we go to the right, we have the 3 big trials. So if we stick to the top left-hand panel, this is primary prevention. So this is looking at people who are currently normal albuminuric, who may develop micro or macroalbuminuria. And you will see as you go through the 3 trials that there is a 20 to 25% reduction in the development of micro or macroalbuminuria. Again, exemplifying the data for primary prevention. Then if I could take you back to the left-hand panel again, then the next 2 are relating to progression. People who have normal or micro and develop macroalbuminuria, or normal microalbuminuria develop either abnormal proteinuria. And the point to note here is as you go through the study, anywhere between 30 to 40% reduction is witnessed in these trials. And finally, at the bottom, we see regression of proteinuria. Now, you know that regression of proteinuria also means an improvement in cardiovascular mortality. So the bottom line shows you a regression, a reversal of the current proteinuria level to the level below in over half the people. So what this slide does is it summarizes a huge amount of data showing you that not only eGFR results demonstrate primary prevention, but also albumin excretion rate. Albumin excretion rates also demonstrate the reduction in progression of pre-existent disease. And finally, there is a major regression of the level of proteinuria in these patients. So as a package, the GFR and the albuminuria data shows you primary prevention, prevention or secondary prevention of disease, and finally, an improved regression of albuminuria. So let us now turn our attention to the right end of this KDIGO risk chart. That is the credence study in the people with established renal disease, in whom the risk of renal progression as well as cardiovascular disease is huge. And again, as in keeping with all the other trials, in these people whose mean GFR was 56 mils per minute and an albumin excretion rate of 927 milligrams per day, so we're talking about people who have significant renal impairment, again, there was a 40% reduction in the renal composite endpoint. And the panel on the right shows you that that balance of that protection is present for the development of end-stage renal disease, or at a slightly earlier stage of development of doubling of serum creatinine. So these are hard endpoints demonstrating a 40% reduction in this otherwise extremely high-risk group. Also in this group of patients, the GFR was maintained. So in the blue here, you see canagliflozin, and in the orange, you see placebo added on to standard of care. And what you can see here is that there is at least a halving of the decline of eGFR. And what that means is that you will delay end-stage renal disease by anywhere between 10 to 12 years, having therefore cost implications as well as societal implications. Now, the latest study to report is the DAPA-CKD trial. As you can see below, it was in a group of people who had an eGFR between 25 to 75, albumin creatinine ratios of 22 to 565, and they had either diabetes or no diabetes, but they had glomerular disease. And in these patients, what you find is, here is the placebo arm with 312 events, renal composite endpoints. And in the blue, we have dapagliflozin with 197. So it's almost a halving of events. So the hazard ratio is 0.61, so a 40% reduction in the development of a renal composite endpoint in a group of people whose baseline GFR is 43 and our baseline albumin creatinine ratio is almost 1 gram per day, and 67% of them had diabetes. Now, the important thing, of course, we all know is that in people who develop end-stage, who are developing declining eGFR or an increasing albumin creatinine ratio, is that their cardiovascular mortality increases, all-cause mortality increases. So it is important for us to look at all-cause mortality in these patients. And indeed, what you find here is that all-cause mortality will also decline in this group of patients. So here we have data on just all-cause mortality in DAPA-CKD, and you will see that there's a 30% reduction in all-cause mortality. So in people with and without diabetes, GFR of 40, 1 gram per day, 67% had diabetes. You reduce their progression to end-stage renal disease or doubling of serum creatinine by 40%. That data is exactly the same for people with diabetes or those without diabetes. Furthermore, you see an improvement in all-cause mortality in an otherwise very high mortality group of patients. The most important thing here is that finally the DAPA-CKD study shows you that when the treated GFR of reduction of 2.86 mils per minute is half compared to all the other renal trials that we have seen. So this goes a little bit further in addressing the residual risk of patients with renal impairment, particularly with type 2 diabetes. It's important to notice, of course, also that the use of SGLT2 in patients with heart failure. So you're using SGLT2s in heart failure trials, and what is the outcome of the renal outcome in this study? You and I all know that these patients sometimes have limited treatment options because of renal impairment. However, in the trials, DAPA heart failure and EMPEROR reduced, The use of SGLT2s demonstrated the reduction of development of renal endpoints whilst being treated for heart failure. So even in people in whom there's heart failure but not pre-existent kidney disease, there is a reduction in a protection from SGLT2s. Furthermore, and the most important finding in this group, in these two studies, was a reduction of acute kidney injury in the patients who were treated with DAPA or EMPA in these two trials. So even in people with heart failure, where SGLT2s are used for heart failure treatment, there is renal protection as well as a reduction of acute kidney injury. So let us then now turn our attention to GLP-1 receptor agonists. Here are two examples, and of course you know that there are others with dulaglutide, the REWIND trial, etc., showing you that a renal composite endpoint, which uses macroalbuminuria, doubling of serum creatinine, end-stage renal disease or death, there is a 30 to 40% reduction in the renal composite endpoints with either semaglutide or here with liraglutide. Similar data is available for dulaglutide too. However, the important thing is when you break the results down to look at where the predominant benefit is. You will recall that with the SGLT2s, we saw benefits at regardless of the GFR baseline or regardless of albuminuria baseline. Whereas with the GLP-1 receptor agonists, what you find is if you look at the top panel, which uses a broad renal endpoint, but more specifically uses macroalbuminuria, then the meta-analysis shows you a benefit, a reduction of 17% in the progression of nephropathy and renal disease. However, if you take out macroalbuminuria, as you can see in the bottom panel, where you're looking at only all the other renal endpoints, you find that the significance is lost. So the suggestion here is that the predominant effect of GLP-1 receptor agonists appears to be further later in the disease journey of renal impairment in type 2 diabetes and is particularly related to macroalbuminuria and progression of macroalbuminuria. So, Mr. Chairman, ladies and gentlemen, my summary is there are still very large numbers of patients with CKD in type 2 diabetes, which is associated with an increase in MACE and heart failure. The recent SGLT2 trials demonstrate a protective effect in all stages of renal disease, from prevention to progression and also from regression. There is a reduction in renal death, and there is a simultaneous reduction in cardiovascular death. GLP-1 receptor agonists appear to have a smaller nephroprotective effect, about 17% compared to 30 to 40% with the SGLT2s. And this seems to occur later in the renal journey when you're talking predominantly about macroalbuminuria and not related to earlier changes of development of renal disease or development of microalbuminuria. Thank you very much. And I'm again grateful for the opportunity to participate in this conference this year. Thank you very much.
Thank you, sir. Now moving for the last lecture, not the last, but it was the first lecture, Dr. Kamalakar Tripathi, sir. I think he is connected. His introduction was already done earlier. He is the ex-professor and head Department of Medicine of BHU. Dr. Kamalakar, sir, is going to talk on high cardiovascular risk and chronic kidney disease, a single disease spectrum. Over to sir, please.
Can you now see the slides?
Yes, sir. We can see now.
Yes, sir. Yes, sir.
Full slide. Okay, sir. Thank you.
Is that all right?
Yes, perfect.
Yes. Extremely sorry for the delay and not understanding, appreciating the technical snag. But sorry, Banshi, for giving this opportunity. And I appreciate your concern. And still you had a potential to excuse me for my delay. We're talking on high CV risk and chronic kidney disease, a single disease spectrum. And Dr. Jitin Vora was also talking, and prior to my two talks, you understood how important it is that those people, patients with the diabetes, have a chronic kidney disease, have albuminuria, have a declined EGFR also equally are responsible for deteriorating the cardiac condition. And we nephrologists have seen many times most of these patients would die because of the coronary and cardiac event. Therefore, the risk in CKD is primarily increased as soon as the chronic kidney disease can be measured. And this is important because most of us do not measure chronic kidney disease in the beginning. As renal function deteriorate, risk of cardiovascular disease increases proportionally. And end-stage renal disease cardiovascular risk up to 200 times than the general population. And it is associated with poorer outcome in post-cardiovascular event. This is what is important to look at, that you have the significant values with the CV mortality as the ACR start declining, as well as also the CVD mortality, and have been shown that as the EGFR declines, albumin creatinine ratio increases, mortality goes up. Therefore, overall, it's close to 41% patients of chronic kidney disease die because of the coronary artery disease, and others 8.6% acute MI, atherosclerotic cardiomyopathy, arrhythmia, and cardiac arrest. So it's preventable. It's a preventable, and therefore it has the importance to appreciate that these patients, sorry. Okay, what are the major causes of death in CKD? It's 54%. This is the latter publication. And then you look at the outcome of the mortality risk and the medical cost. As Dr. Bora was also talking, as the time increases, the complication increases, the total number of death as well as the cost also increases. And the severe kidney disease is the highest comparison with the total final outcome. So prevention of chronic kidney disease is equally as important as CVD in patients of hypertension, diabetes, and other conditions. Looking at the different stages, to look, if it starts 100% here, stage 2, this is the total patient and the high CVR group, and it keeps on increasing as the stage deteriorates up to stage 3B. There's a 100% decline, and slowly over the period, there is increased risk of the death. The risk also increases according to the EGFR and the number of events also. This is the, if you have less than 15 EGFR, it's 36.60. If it is less than 60, means normal EGFR is only 2.11 number of event. This is a complex slide. What it shows that primarily chronic kidney disease could be in diabetic patient because of many reasons. Could be because of glomerular involvement, could be because of the podocyte involvement, could be because of the tubular involvement, could be because of the interstitium involvement. And there are patients who also develop acute kidney injury and chronic kidney failure, and both can lead to chronic renal syndrome. So therefore, as the nephron number decreases, there is adaptive hyperfiltration of the glomerulus, increased glomerular permeability. So there is a proteinuria, dyslipidemia, RAS activity also increases. And all these two have importance in choosing the molecule for the treatment. There are also inflammatory remodeling and tubulointerstitial fibrosis at the last, in which lead to decrease in GFR, decrease urinary output, and many systemic complications. These are the risk factors which are traditional: advanced age, hypertension, diabetes, one important risk factor, dyslipidemia, tobacco consumption, male, gender. And there are the novel risk factors like albuminuria, bone and mineral disease, anemia, vascular stiffness, atherosclerosis, prothrombosis, and oxidative stress. So a CVD risk with the, when you start with the normal, as it increases, there's a damage, decrease in EGFR, kidney failure, leading to death. So there's a common milieu, cardio-renal interaction because of the heart failure, structural heart disease, prior current heart failure, and refractory heart failure, all would lead to deterioration. So Now going again back to the traditional risk factor, which are could be reversed. These are the one which is malnutrition, serum albumin, renal failure, creatinine, inflammatory cytokines, oxidative stress, and calcification on one hand. And these are the traditional one like gender, which we cannot reverse, sex we cannot reverse, blood pressure we can certainly manage. We can look at the antihypertensive medication and the lipid level. So the CKD is in the center point, but the cardiovascular events are interrelated. If you take care of the cardiovascular risk, the CKD would be reduced. If you take care of CKD, the cardiovascular risk would be reversed. We talked already about it. And there are conditions in which you can have acute kidney injury and if not treated, lead to early CKD. Still GFR less than 60 ml, but hypertension becomes one of the component with ischemic phenomena. Post-acute kidney injury, you can have tubulointerstitial changes, you can have also changes in the vascular compartment. Mild to moderate CKD, then also it leads to hypertension, dyslipidemia, and chronic inflammatory condition. Whereas sclerosis further leads to reduction into the filtration space, which is also cause of hypertension, dyslipidemia, and also a bad milieu like hormonal factor, anemia, malnutrition, hypocalcemia, retention of the phosphate, soft tissue calcification, and also uremic toxins. So the main core factor which is responsible with the common soil which leads to both endothelial dysfunction on both sides is atherosclerosis, endothelial dysfunction, and myocardial fibrosis. Therefore, large percentage of dialysis patients have traditional risk factor. Many dialysis patients have more than one of the risk factors resulting in the high risk, and some risk factors are result directly from loss of renal function. CKD alone should be considered to be in high risk category equivalent to that of patient with no CHD. Risk of increase with increasing renal dysfunction and severity of proteinuria, calcium intake and disorder of mineral metabolism. Anemia is major contributory factor. It affects even the ejection fraction. It also affects ultimately the RAS system and also affects the oxygenation. Uremic toxins and renal replacement therapy, we'll talk in a moment how they affect. But when the patient goes on the long-term dialysis program, if the vascular structure is not very good and they have adaptive background, they also tend to complicate. Increased plasma homocysteine level due to decreased renal removal, abnormal nitric oxide metabolism, and increased fibrinogen level all lead to prothrombotic state. Angina during dialysis, I was talking about this, most common presentation patients with coronary disease, and those years, about 30, 40 years back when we were doing dialysis regularly, most of these good drugs, we never had it. And diabetic patient would sometimes appreciate severe angina during the initiations of the older system of the dialysis. No, we don't see that. There could be exercise angina, dyspnea, arrhythmia, and silent myocardial ischemia, another contributory factor. So what should we do? We should screen and diagnose. This is the KDQI guideline. All patients upon initiation of renal replacement therapy, independent of symptom, should be screened. Transplant waitlist patient should be screened. Change in symptoms and sign including recurrent hypotension, heart failure, they should be screened. Baseline ECG and echo, and I think it's mandatory, we all do it. Then exercise pharmacological stress echo if we are not able to observe it with the conventional investigation. Angiography should be considered in dialysis patients only when they have a very high risk, and we can use a non-contrast substance. Among non-ionic contrast, among those with residual renal function and acetylcysteine and isoosmolar radiocontrast media should also be administered to help decrease the risk of radiocontrast nephropathy. And administration of sodium bicarbonate hydration is not recommended given the increase in intravascular volume. Acute MI, we do it the traditional way, CK, MB, and troponin or to be looked. And then cardiac enzymes, which are in now prognosis for end-stage renal failure patient. We talked about troponin. Prevention is the issue, and the main prevention would be the hypertension. and we have to treat it meticulously. Diabetic younger people 130 by 70 or 130 by 80, elderly people 140 by 80. So this is the pre-dialysis value, less than 140 by 90. It should close to 130 by 85 during the day and 120 by 80 by night. Hypertriglyceridemia has to be answered, and fasting hyperglycemia should not increase more than 500 milligram. Hypercholesteremia also should be referred. In hypercholesteremia with 4D trial, now we have evidence that it would decrease the cardiac event. This is the atorvastatin, this is the placebo, and these patients have significant decrease in LDL cholesterol, and they also decrease the cardiac event. This is a cumulative incidence composite endpoint percentage when statin was used. Increased calcium phosphorus product, the kidney guideline also maintain about the diet below 55 milligram per deciliter in dialysis patient. It is unclear whether maintaining lower calcium phosphate level is associated with decreased risk of heart disease. Oxidative stress increase is also contributing, and we have some nutritional supplement. So anemia should be treated either by the transfusion or doing by the iron therapy or by doing the erythropoietin therapy. Hypertension should be controlled by removal of fluid, if necessary, antihypertensive medication and ultrafiltration. The drugs, anti-anginal drugs, we all use it, we know about it, and nitrates, if necessary, beta blockers, calcium C. Aspirin, though, there is a paucity of data related to the effectiveness of safety of aspirin in patients with end-stage renal disease. However, it should be reserved with caution. All dialysis patients presenting with acute coronary syndrome should be treated in the non-dialysis population, almost as in, with the exception of a specific attention to drugs that have altered clearance in kidney failure. And mortality after acute hemodialysis patient has been reported to be approximately 75% in 2 years. And that's very bad. If we take all steps of prevention, it wouldn't happen. So we can start aspirin, beta blocker, nitroglycerin should be given in initial time. Thrombolytic agent. PCI is the preferred modality in these patients who are waiting for transplant program. Thrombolytic agent, caution with hypertension, one can use glycoprotein 2B3A inhibitor, abcimab, and also eptibatide should also be used, but there is weak evidence. Heparin, old drug we all use during dialysis, and it also prevents the coronary event, and one should take care of the prothrombin time before connection, we all know it. Invasive management, short-term and long-term mortality after coronary revascularization procedure in dialysis patients is considered by higher than those in the general population, and the indication for these procedures are similar to one for patients without renal failure. One has to go for CABG in the preferred therapy, those with 3 vessel or left main disease, and CABG may also be preferred in those who are candidate for internal memory graft. Now, because of the better drugs available to us, most of these modalities are a little older. We can go for primary prevention, we can go for secondary prevention, and we can go for tertiary prevention. Therefore, to summarize, CVD and CKD evolved from a common soil, and the common soil is endothelial dysfunction, RAS activation, and dyslipidemia. And we have a drug now. You can give drug which would correct endothelial dysfunction, correct RAS activity, and also good drug for dyslipidemia. Early identification of these factors can help in planning for primary prevention, I was talking. And now all this empirical study, Carolina study, Kamlina study, all have said that you can look for primary prevention, and because of that, these patients would try to get better advantage rather than conventional therapy. Choosing a specific molecule to treat CVD like ARB inhibitors, statin, aspirin, and anticoagulants will not only improve cardiac outcome, but will also prevent chronic kidney disease. Non-ionic radio contrast should be used in, and renal function should be evaluated before any cardiac intervention, especially in the diabetic patient. Thank you very much. Over.
Yes, thank you. Dr. Bharat Solanki, are you there? Dr. Ghosh, you want to make any comment or any question? Amit, I just wanted to have one from you regarding this use of gliptins. We are using gliptins so often and almost like it is a first add-on drug after the metformin in our country. And with the SGLT2 and now with the SGLT2, which has become also cost effective, probably these two drugs in combination of these two drugs will be a choice of therapy for most of our diabetics. And we might be replacing or we might be postponing our sulfonylurea use maybe in early in the course. First, it will be definitely by diabetologist, endocrinologist, followed by primary care physician. So maybe in another 4 or 5 years. But where you see the future of the gliptin and particularly the sexagliptin and the other gliptins in the era of when you are going to have the oral GLP-1 LRO, which may be available. I fully agree with you that it may be very costly, but if it will also become a cost effective, then where you see the future of gliptin in the era of your GLP-1 LRO.
So you've taken the answer right out of my mouth, Mansibhai. I think you're right. If the cost is not an issue, then as a new age diabetologist, I would obviously try to use the oral GLP-1s when they come. And I think they would take the center stage at the time of coming and the launching. And I'm sure that the diabetics would worldwide be benefited with them. But till that time, I think my specific talk, because it was on DPP-4 inhibitors and metformin combination, as you've rightly said, it is the almost the first add-on after starting with metformin. So nothing will take away the place. I mean, I have very strongly felt in the entire armamentarium of diabetes therapy, nothing has replaced anything. If all the senior clinicians here would reflect upon, we still have used sulfonylureas today. We still see the use of some molecule like voglibos for that matter. Pioglitazone has stood the test of time. So even the oral GLP-1s, when they come in, I'm sure they will be just added as another armamentarium to the entire basket we have as clinician. They would not replace. But to answer Sir's question, I think I'll be the first to try to give a hand at them and see their efficacy, safety profile as well. But the others are definitely here to stay. I would definitely ask the comments of Dr. Vora and Dr. Kamlakar on this, please.
Dr. Saraf, what about linagliptin versus vis-a-vis saxagliptin or vildagliptin, other gliptin? Do you think linagliptin has an advantage over? Because there are experimental evidences that the epidermal growth factor improves with linagliptin. That's the only molecule in which we have evidence in experimental animal that it improves on the epidermal growth factor.
So very right.
Renal condition, because we have a epithelial, the embryologically the Bowman's capsule, the outer part is from the invagination. So there are people who believe, strongly believe, that it prevents epithelium, especially the podocyte protection. The reduction in proteinuria is more with the linagliptin. Other gliptins may have evidence, but I need your comment.
So very rightly said. I think as we saw the Carmelina and the Severtimi I was quoting about in my slides, I think Lina has a lot of potential. The only hitch I would say is the human I can't even say trials. I think the human practice. We all, when it comes, and we all, maybe the next year when Dr. Bansibhai hopefully will call us for the DiaCareCon, we could have much robust data on the use of Lina, and then probably we could talk about this molecule then. But as of today, I think the other gliptins, because of the availability of data, that's all I would say is in their favor. And that's not saying the Lina is bad per se, but if the availability of data improves especially in the human use for linagliptin in the time to come, I'm sure it will be a much more nephroprotective molecule compared to the other gliptins. Dr. Vora, your comments, please.
Dr. Jiten Vora, you wants to make any comment? You have to unmute, please.
I think that this discussion depends on the patient, which patient we're talking about. I think that if you're talking about early patients and you want appropriate glycemic control as well as cardiorenal protection, to me, the data is strongest for the SGLT2s and GLP-1 receptor agonists. Yes, as you said, Dr. Saraf, that some of the glycemic efficacy of the metformin-saxa combination is good, and certainly I would agree with that. Some of the other gliptins by themselves, their glycemic efficacy is not fantastic. At best with linagliptin, I have seen an HbA1c lowering of between 0.5 and 0.7%, and the meta-analysis shows that. So given the small category of renal protection from linagliptin, given that the HbA1c lowering is not dramatic, I would not be using it second or third line.
Right.
And I'm, of course, putting the cost issue completely out of the equation.
Very true.
Right. I think that's a good summation.
Dr. Jiten, still, I mean, even after the DAPA-CKD trial, still the regulators are asking that the use of SGLT2 inhibitor should be stopped once the eGFR goes below 30. In India, you cannot initiate the eGFR when it goes below 45. If you have a patient, then it is not to be given. That is what it is advised. We do use, that's a different issue, but this is what the... So do you think after DAPA-CKD, when you are talking of even non-diabetic patients are also getting benefit, the regulators or the guidelines should change it, and they should be used, as you were saying in your slide, that at given point of time, any eGFR, you should start with the patient with SGLT2.
So the regulators are going to change their mind very shortly, Bansi. The FDA is currently looking at it in great detail, and the initial suggestions are that they're going to take us down to at least an eGFR 25.
Oh, that's great.
So below that, we have no data. I think that up to 25, the data supports you. DAPA-CKD was 25. The credence data breakdown shows that there is a
benefit,
halving of the rate of progression of eGFR in people who had a GFR less than 30. So the data is all there, and as you know, Bansi, regulators take their time over it. And at the moment, all they're interested in is in COVID.
I agree with you fully.
There was a question in the chat box from Dr. Vora. Where is the indication to use SGLT2 and where is the indication to use separately or in combination?
Yeah, so
that was his chat box, Dr. Saraf.
From a glycemic perspective,
the question is to you, where you will advise SGLT2, where you will advise DPP4, or when you will use the both in combination. First to you, Dr. Jiten Vora, followed by Dr. Amit Shah.
So Bansi, thank you for that. As I've said to you, my preferred options are now related to what the ADA EST guidelines say. My second line choice is either a SGLT2 or a GLP-1 receptor agonist, whichever out of the many that you want to choose GLP-1 receptor agonists. So that would be my natural progression. If cost, etc., is an issue aside, then my natural progression would be metformin, SGLT2, or GLP-1, and then the other. If you've got a GLP-1 receptor agonist, then the addition of a DPP4 is meaningless. It doesn't give you much in the way of benefit. Although, having said all of that, I am aware that there are certain patients where DPP4, because of cost, is a preferred choice. In that case, give them metformin, give them your DPP4 inhibitors, but keep a close eye on your glycemia and keep a close eye on your renal parameters, because if they are declining, then you may want to add in some of the others. So I don't think that that DPP4 inhibitors are out of the treatment armamentarium. For me, and I practice in a different part of the world than you, they are in a different place for different patients. And my prominence at the moment is very much SGLT2s and GLP-1 receptor agonists based on the cardio-renal data.
Dr. Vora, you rightly said that you have to look at the patient, which patient you are treating, and that would decide. We nephrologists in this country are quite scared. Some of these patients with stage CKD4, so bad in their appetite, keep on vomiting, don't eat anything. They are not good on maintenance dialysis program. Do you still want them with that eGFR to use gliflozin, or you want some consideration? And because that is the only limiting point. And many patients do land up in AKI, many patients do land up in deterioration.
Yeah. So Dr. Kamlakar, you are absolutely right. When you use an SGLT2 inhibitor, you need to think about sick day rules, number one. And the sick day rules, if you see, they are exactly the same as for metformin. In other words, if you have, and I'm talking about a group of patients that are not your patients at the moment, but if you have a group of patients that the endocrinologist sees, in them, the answer is if you get any form of dehydrating condition, you're going to have a contrast medium for any investigations. You ask them to stop their metformin. You do the same with SGLT2. You stop it for 3 days before you restart it. Of course, with SGLT2, you don't need to check the creatinine before you restart like in metformin. So sick day rules are the same for these patients. And, mostly for my patients, I say to them, if they go to a holiday somewhere, India or wherever, and they get diarrhea and sickness, they stop their statin, they stop their ACE inhibitor, they stop their SGLT2, and they stop their metformin. And then 3 days later, they're back on it. Okay, that's much better than being in the hands of a nephrologist with AKI, right? But in the group of people that you're talking about, yes, of course it's difficult. So you have to be careful. If your patient is particularly nauseous, vomiting, etc., likely to be dehydrated, then don't use SGLT2s. But the other thing to think about SGLT2s is data that was presented at the American Society of Nephrology a few days ago shows that the SGLT2s reduce by half the development of significant hyperkalemia. So you have somebody with a GFR of 30 who is otherwise okay for an SGLT2. Effectively, by giving them an SGLT2, you are renal protecting them, but you're reducing your work by reducing the chance of developing significant hyperkalemia by half. So the need for acute dialysis goes down. So even in that group of people where you select them carefully, there are other benefits too.
Thank you.
And can I just quickly answer the question asked for me, whether the combination of DAPA and SAXA, somebody wanted to comment on that. So I just want to draw the attention. I'm forgetting the month it was released. It was sure 2019 in Diabetes Care. I think it's the middle of 2019, the Diabetes Care of the ADA publication. They had a good study which they had compared the same thing, DAPA with SAXA within an insulin naive population. And they had seen the results based on 3 criteria. One was sugar control, one was risk of hypoglycemia, and third was the weight reduction criteria. So when people were put on DAPA SAXA combination, I believe the glycemic control was comparable to the other subsets. There was nothing majorly seen in this combination. But definitely the risk of hypos and weight neutrality or other even little benefit was seen in a combination of DAPA and SAXA. So I would want to answer this question, as Dr. Vora has rightly said, it all boils down to the patient choice. If you have somebody who's a little on the overweight side, if you have somebody who has run a risk of hypos or had a history of hypos on other drugs, you would rather put them on this combination to derive these 2 benefits. Glycemic efficacy, I think, has been cut across almost similar to the other combinations when it comes to DAPA and SAXA. Dr. Solanki, anything else?
Looks
like everybody's
any
bored.
other question? Chat? No, chat box. Any other questions? Because I am actually
now we can close the session, and Dr.
Okay.
Ghosh, Dr. Bhagirath Solanki, both of them we are here, and we can close the session.
Bansi bhai, thank you so much. It is a pleasure being on your platform.
Thank you, Dr. Jiten Vora. Thank you,
very
Dr.
much.
Kamlakar Tripathi. Even after so many technical glitches, you could join. Thank you for that. And thank you, Dr. Mishra, for exchanging your talk against Dr.
Thank you so much, Dr. Bansi Sabu, sir. It is a pleasure to come and talk on your platform.
Thank you.
Thank you.
Everybody keep safe. Keep safe.
Thank you, sir. Please
Keep
take
safe.
care.
Thank you.
Well, now new strain is there in UK, so we all are worried.
Yeah. Keep safe.
Thank you.
Bye-bye.
So now for the next session, we have report here, Dr. Rohan Patel. I think he is there already. Rohan must have joined. Dr. Manisha Singh, I am not seeing her. Dr. Manisha? I can see my good friend, Dr. Jay Shah, Dr. Vijay Vishwanathan. Manisha is joined. Rajeshwar Singh.
Good evening, sir. Good evening, sir.
My sister. And then Dr. Rajni Saxena is there. So yes, they are there. So all 3 of them are there, but still we have 2 minutes more. So,
Bansi, can you hear me?
Yes, I can hear you very well, says Jayesh. Kem cho?
Good, thank you. Good.
So Rohan is a reporter. Rohan is from Bharuch. So Rohan, you please introduce yourself, and then if you don't know Manisha and Rajnish, I would like to introduce them. Manisha is my sister and Rajnish is also like my brother. So I would like to introduce them. Rohan, you want to make any comment, please?
No, sir, you can proceed for this beautiful scientific academic phase ahead.
So this is very interesting session which we are going to have. It's the end of the day and Sunday the second day, rather the end of the conference also, and last session of the meeting. And we have two eminent person to chair this session along with Dr. Rohan Patel from city of Bharuch, who is from Gujarat. Dr. Manisha is a diabetic foot surgeon, and I know her since last almost 10 years. The only female surgeons, there are very few surgeons who are female in India because most of them are gynecologists. And then the surgeon being a diabetic foot surgeon, I think a unique one and a very close friend of mine. So Dr. Manisha is from city of Gwalior, which is a central part of India. Dr. Rajneesh Saxena is primarily a diabetologist based at Ajmer, near to my village, which is in Rajasthan. And he take care of a lot of our patients because we also run a RSSDI center in my village, that is Kuchaman city, and where he visits regularly. Every month he goes. And Dr. Rajneesh Saxena have interest in diabetic foot. He runs a diabetic foot clinic also at Ajmer. So with these two persons, we have this session, which is the from India. We have Dr. Vijay Vishwanathan, very close friend, Vice President of RSSDI, and Dr. Shah from Gujarat, and he's in US. And that's the reason why we kept the last session, because Jayesh could join it, because that's the only way. It's almost 12 hours difference. For them, it is early in the morning. And then Dr. Jude from UK. So over to Manisha to introduce the speakers.
Thank you, sir. You are more than a brother to me. And I have the pleasure of introducing Dr. Vijay Vishwanathan, who has been working in this field for last so many years. I have ever opened my eyes in the field of diabetic foot. I have found Dr. Vijay Vishwanathan there, and I have grown up listening to his talks. And currently, he is the head and chief diabetologist at MV Hospital for Diabetes and Foot Care. And it's a WHO collaborating center for research, education, and training in diabetes. He is the president-elect 2021 to 23 for DFoot International, based in Belgium, and consists of experts from 193 countries. He's a national vice president, RSSDI, and he's completed 29 years as a diabetologist in the diabetology field. And he's a PhD in diabetes nephropathy and published 50 research papers in this field. He's the first Vivian Fonseca Award. He has won the first Vivian Fonseca Award from the American Diabetes Association for his work in diabetes and tuberculosis in 2013. He also developed especially the field of diabetic foot care in India by training over 2,000 physicians in the prevention of amputation, setting up a state-of-art podiatry center in Chennai since 25 years, and published 150 original research papers in the field of diabetic foot. A remarkable achievement, and he has been awarded fellowship of Royal College of Physicians, London, for research contribution in diabetes. In the field, his field of interest is mainly diabetic foot, as is evident from his biodata, and diabetes and kidney in diabetes, diabetes in patients with tuberculosis, and socio-economics of diabetes. Over to you, sir, for your deliberation.
And thank you, Manisha. I'm going to finish in 10 minutes because you took 10 minutes for my introduction. It's a pleasure to...
Yeah, it's impressive and lengthy, sir.
So I'm going to finish in 10 minutes.
Yes.
It's a pleasure to be with two of my colleagues, Ed Jude and Jay Shah. And I'd like to thank Dr. Banshi Sabu, the president of the RSSDA, for this invitation, and Rohan Patel, who's our student actually, and Dr. Rajneesh for joining as chairperson. So I'm going to finish in 10 minutes. And what I'm going to show you is how a physician can help a surgeon to actually look after wounds. Because when you talk about wounds, people tend to think it is more a domain of the surgeon. But in the next 10 to 12 minutes, I'm going to show you how a physician can be helpful in looking after the wounds. So this is the title of my talk. And we know that, let me start with a small introduction about what is happening in India. Throughout the 10, 12 minutes, it's going to be only about India, what's happening in India and our experience in India. So a lot of amputations are happening in India. We say amputations are coming down in some countries, but in India, during the lockdown in India, I have seen a six-fold increase in the amputations in our hospital. Right from March 25th, when Prime Minister Modi announced the lockdown, till yesterday, we have seen a threefold increase in the number of amputations. So amputations are very much happening in India, and this was probably one of the earliest studies which look, I'm looking for my laser pointer. Yeah, found it. So this was one of the earliest studies which we did along with Stephen Morbach and Abbas from Tanzania and our group in Chennai, where we looked at what were the risk factors for diabetic foot amputation, ulceration in about 613 patients from Germany, Africa, and in India. And this was published in Diabetic Medicine about 17 years ago. What we found was infection and bad wound care was the primary reason for amputation among the patients in Tanzania and in India. Now, this was a recent study which we did during the lockdown, where we contacted about 89 diabetologists across the country. And we found that diabetologists treat a lot of diabetic foot lesions, cellulitis, callus, infected callus. About 52% or 50% of the diabetic foot infections were being handled by diabetologists, and they were referring to a surgeon if they could not manage or any debridement was needed. Therefore, a diabetologist is very much a part of the team caring for people with wounds. Of course, nurses and orthotists, surgeons play a very important role, but the diabetologist also and the primary care physician also plays a very important role in India. That is why way back in 2004, about 16 years ago, along with the World Diabetes Foundation, we started this program called Step by Step, where we trained diabetologists. And I'm happy to say Banshi Sabu is one of them who got trained at that time. And we took doctors, diabetologists, and their nurses from India, Nepal, Bangladesh, and Sri Lanka. And we had Dr. Ali Foster from the King's College and a couple of diabetologists and surgeons from India, where we did this program. And it's very important that we work with diabetologists and diabetic foot. And about 45,000 patients were screened in the first year of this basic course, and about 15,000 of them were identified with high-risk feet. So the diabetologists in help to actually prevent wounds, and trivial lesions were managed by the diabetologist and the nurse who was working with the diabetologist with the help of the training they got from the step-by-step program. Carol Baker mentioned that the step-by-step project, which started in India and then went on to Africa, is now an official part of the IDF United Nations Resolution Implementation Program to develop it in the developing countries. Now, this was a typical example where there is a confluence, I would say, interaction between the diabetologist and the surgeon. This patient came to us in the month of April, when there was an acute lockdown in India, and came with a pus pointing in the sole of the foot, and there was an abscess there. And the surgeon was kind enough to come and operate. Now, this patient takes to about 2 or 3 weeks to reach this stage where we suture the wound and try to heal the wound. Now, it takes about 2-3 weeks, and who's going to look after this period? So it's again the wound, and it's the surgeon with the diabetologist who looks after the diabetes control and also helps in wound management before the surgeon actually does the final act of suturing the wound. This was another patient who came to us during the lockdown. This is not lunchtime, so this is a lot of maggots you see. Maggots in India means dirty wound, and the surgeon cleans it. And so we have a big wound here. So who's going to look after this wound till the surgeon puts in a skin graft? It's again a teamwork of both the diabetologist, the nurse, and the surgeon. And the patient keeps coming to the diabetologist for proper wound care and sees a surgeon also now and then. Now, the fact in India, among the Indian patients, if you use the Wagner's classification, most of them have bad wounds, as you saw in the previous picture. About 63% of people have bad wounds. They come very late, and that is one of the reasons for the high amputation rates about which I told you in Dr. Stephen Morbach's study. Now, this is the multidisciplinary approach given by the King's College, by Mike Edmonds and Ali Foster several years ago. So the physician or the diabetologist has a very important role to play in wound control, mechanical control, microbiological control, which antibiotic you should be taking, whether it's intravenous, change to oral, and so on, and the metabolic and the educational control. Of course, the surgeon plays a very important role in wound control. In vascular control, of course, we need a vascular surgeon, and so on. So physician plays a very important role in this multidisciplinary approach. The first thing which a diabetologist or a physician must do when you get a person with foot infection is to examine the feet for high-risk feet and look for loss of protective sensation. We have several from Ed Jude's Manchester group. We have the neuropathy disability score. We have so many scoring systems. We have the Michigan system from Eva Feldman, which was used in the DCCT. We can use any of these and make a diagnosis of high-risk feet by looking at the loss of protective sensation, absent pedal pulses, and asking for a history of a past history of a foot ulcer and so on. We showed in 2001, about 19 years ago, that the Rydell CFA tuning fork is a good device to make a diagnosis of high-risk feet. And also, we showed in the Postgraduate Medical Journal in 2002, about 18 years ago, that if you look at the temperature sensation, the temperature difference between that using a tip thumb, using the metallic end and the wooden end in an air-conditioned room, you can see the difference. So these are all ways in which we can make a diagnosis of a high-risk feet. So that's up to the physician or the diabetologist when a person comes with a foot infection to make a diagnosis of loss of sensation and loss of pedal pulses. Making a diagnosis of peripheral arterial disease is also one of the important things which a physician should do, and he should examine the peripheral pulses and also look for changes in the skin which are suggestive of a peripheral arterial disease and refer to a vascular surgeon. So the diabetologist plays a very important role. Now, talking about the microbiological control, in India, most of the organisms we see are gram-positive, but there is an equal proportion of pseudomonas or gram-negative sepsis, which occurs in patients in India because they come in very late, poor wound care, and therefore we have a lot of gram-negative sepsis, and not to talk about the methicillin-resistant Staphylococcus aureus and so on. So during the wound care, wound repair stages, the diabetologist, the physician, can do a lot of things along with the surgeon during the stage of inflammation, which is shown here. And even in the later stages, the physician has to play an important role along with the surgeon. The biofilm is a major cause of concern in India, and 4 in 5 wounds in India have a biofilm, which is often not identified. So it's once again, the biofilm by definition is a group of microorganisms embedded in a thick slimy barrier of sugars like glycocalyx, protein and water produced by themselves. So what happens is if you have biofilms, it's very difficult to manage because it leads to chronicity of the wound. It is difficult to diagnose and it's frequently resistant to antibiotics. We keep treating with antibiotics, but the wounds don't improve and so on. So there the surgeon plays a very important role by frequent debridement using a scalpel. This is what we do in India mostly. The diabetologist and the surgeon should work hand in hand and try to do as many debridements as possible and not leave the job to a nurse to do dressing of such wounds. The surgeon must spend time with the patient and try to do a sharp debridement and remove the biofilm. Now, wound dressings. So wound dressings are very important. Again, the physician must get involved and not just leave it to the surgeon. Many physicians don't even open the wound. They think the surgeon will look after. It's wrong. In India, people still use a lot of saline gauze, and saline gauze was believed to facilitate wound healing by keeping the wound margins apart and allowing the wound bed to granulate. It was also believed that a dry wound environment would facilitate the death of bacteria. But the management of wound has undergone a sea change in India with the advent of the hydrocolloid materials available from the companies like Urgo and from Coloplast and Smith and Nephew. They have totally revolutionized the management of wound care, and I feel physicians must know the basic dressing materials with these hydrocolloid dressings, which are available in India for about 250 to 300 rupees. They should not give it to the nurses or always depend on the surgeons. The physicians have a very important role, and these moist wound dressing materials which are available from Urgo and from Coloplast and from Smith and Nephew will actually reduce the shorter, they'll lessen the healing time, and you can see the patient less often. If you do a saline gauze dressing, you have to see the patient very often. Here you can give the dressing, that's what we do. You can actually give the dressing materials and the patient does it at home. The negative pressure wound therapy is available in India for the past 10 years. And though it's a little expensive, I think it has revolutionized the management of wound care in India, and physicians and diabetologists must know how VAC works and must motivate their patients to undergo a negative pressure wound therapy, because it removes the interstitial fluid, infectious material, and most importantly, it provides a closed, moist wound environment. And in the last 2 minutes, let me talk about offloading, which is very much under the purview of a diabetologist or a physician. So wound healing consists of multiple things, but one of the most important things is offloading. And in India, we do a lot of total contact cast and the posterior cast in patients. And we also use some orthopedic footwear in some patients. So what is most important in our country, we have the footwear materials which are available in India, and we can make footwear like this and give them a special insole which offloads the pressure if the patient is fit enough to walk in a footwear. Otherwise, it should be a total contact cast or a posterior cast. When the wound starts healing, you can actually advise patients to wear footwear. We have developed for the last 27 years our own offloading center in Chennai, in our hospital, and we are able to provide all the footwears which, like the auto-wedge footwear and offloading for Shako foot and so on, at a very cheap cost of about 10 to 20 US dollars instead of importing them from Europe. Finally, what do the it's a mistake. It's not during COVID crisis. It's about what do the international guidelines say about managing diabetic foot. I think we have a special chapter written in the International Working Group on diabetic foot by Fran Game and his colleagues, Applequist and so on. So if I would encourage all of you to read the IWGDF guidelines, which talks about wound healing in a very systematic manner. So I would like to conclude this talk by saying that it's the responsibility of the surgeon and the physician in this wound healing process. And I'm trying to find out the stop share button. Can somebody stop sharing it? I'm not able to find my pointer. So I think it's an equal responsibility for the physician as well as the diabetologist to take part in this wound exercise. Can somebody switch off my slides from the... I'm not able to stop sharing. I can't find my mouse. Yeah. So I think it's an equally important for a physician to take part in wound healing. So that's why I gave the title of the talk, Modern Wound Care for Physicians, because in India, physicians tend to take the back seat and give it to the surgeons to take care of the feet. But I think it's a wrong policy. The physicians, the surgeons must work hand in hand to manage the wounds and prevent amputations. I would like to thank Dr. Banshi Sabu once again for this invitation. Thank you.
Thank you very much, Dr. Vijayashanathan. You nicely covered the topic, and as usually, you are greatest knowledgeable personality. You are of COVID crisis. Welcome. Now over to Dr. Edward. Welcome, Dr. Edward.
Sir, your audio was not very clear. Can I just request Dr. Manisha to introduce Dr. Edward? I think there is some.
I thought it was my internet.
Actually, hello, I am audible to you?
Yes, sir. Now you're audible. You can introduce Dr. Edward.
Now I welcome our second speaker, Dr. Edward Jude. He is consultant physician and professor at MSL Foundation. Professor MBBS He is a professor in medicine, honorary professor at Manchester Metropolitan University. He has done his undergrad at Manchester University and then completing his training in diabetes and endocrinology. He took up his consultant both in he has 140 papers and chapters. He learned from diabetes, TB, ST, and so on. His studies including infantile and function in the he passed year of European diabetes society and on the he is also for the North
शेयरिंग नहीं हो पा रहा है मेरा श्री
अभी हो गया आपका आवाज है
Yes, Dr. Edward, your screen is visible. You can put it in slideshow and you can begin with your presentation. Dr. Edward, need to unmute.
Can you see my slides?
Yes.
Yeah, yes.
Okay. Thank you very much. And thank you, Rajneesh, for that kind introduction. Thank you to Dr. Sabu and the organizers for the invitation to speak on the COVID crisis and the diabetic foot. And it's a pleasure to be on the same platform with Vijay, who we've been friends for many years. So Vijay, good to see you. So I'll be covering East versus West on the COVID crisis and what's happening currently in the world, mainly to do with diabetes and the diabetic foot. These are my disclosures. So COVID-19 or coronavirus disease 2019 was first described in Wuhan in China in December 2019. It was called the Severe Acute Respiratory Distress Syndrome Coronavirus 2 or SARS-CoV-2 in February 2020 because it is genetically related to the coronavirus responsible for the SARS outbreak in 2003. It was declared a public health emergency by WHO in January 2020 when more than 100,000 people were infected in over 100 countries. It is the biggest pandemic to hit mankind in over 100 years. The last pandemic was as you all know, the influenza pandemic of 1918, 1919, where up to 50 million deaths occurred globally. What we know about the pandemic in 1919 was that when the virus mutated the third and the fourth time, that's when the number of deaths increased phenomenally. And that's why the concern at the moment that the current virus has mutated, and there's a worry that we may face similar deaths globally. So what is the coronavirus 2? It is a beta coronavirus. It's a single-stranded RNA virus with a genetic sequence similar to coronavirus 1. It shares 80% of its genes, similar gene sequence with the coronavirus 1 and 96% similarity with the bat coronavirus. It has a viral envelope which is coated by two spike glycoproteins S1 and S2. The S1 is the protein that binds to the host cell receptor, which is the ACE2 receptor, and promotes entry into the cell. And the S2 spike protein promotes fusion of the virus and cell membranes, fusing the two cells. Because ACE2 is represented so well and extensively in the lungs, it is the lung that has the peak viral load, with people being infectious up to a week after developing the infection, being most infectious 5 days after developing symptoms. Diagnosis is made using RT-PCR of swabs of the upper respiratory tract, and swabs are usually positive up to 9 days, but some can be positive up to 14 days. So this slide, this cartoon down here shows the S protein that is attaching to the ACE gene receptor, and this then enters into the cell. So looking at the global severity of the of COVID-19, this is data up to this week actually, so 51st week of 2020, and you can see the numbers increasing exponentially over the last 50 odd weeks. There have been 78 million cases globally and 1.7 million deaths reported globally. And again, this graph here at the bottom is showing the deaths that have occurred up to this week. What about COVID-19 in the UK and India? On the left, here is data from the UK. There have been 2.2 million cases in the UK to date. This is data of up to day before yesterday, the 25th of December. There have been 70,000 deaths. And on Christmas Day, unfortunately, there were 32,000 cases reported in the UK with 570 deaths occurring on Christmas Day. What about in India? There have been 10 million cases reported in the last 11 to 12 months and 140,000 deaths reported in India. You can see the numbers gradually increasing in the UK, and this is the worry that the virus is now mutated and the numbers might start to increase, especially with the setting in of winter and the freezing cold. There's a risk that numbers might increase exponentially in the UK. So what are the risk factors for somebody developing COVID-19, severe disease, admission to ICU, and mortality? Because of this conference, I would like to stress diabetes and obesity, but even other comorbidities such as hypertension, cardiovascular disease, etc., can increase the risk of people developing severe disease. People usually present with high fever. They have raised CRP, IL-6, and D dimers. And what's important of these 4 features is that all these 4 features also will be seen in patients with diabetic foot. So what we need to understand is the patient presenting who's got diabetes and has these symptoms, one must also think not only of COVID, but have they got underlying diabetic foot disease, because there is a similarity in the presentation of the 2 conditions. What about COVID-19 and ethnicity? The reason for this is that in the UK, we were seeing a lot of ethnic minority people developing COVID-19, but also among healthcare professionals. And unfortunately, there have been quite a few deaths among healthcare professionals and doctors in the UK. So there was an investigation into why so many of our ethnic minority people are developing COVID-19. And this editorial in the BMJ recently describes this as a possibly socioeconomic, cultural, of lifestyle factors, along with genetic predisposition that leads to some of these ethnic minorities developing COVID-19. But probably more importantly is the increased prevalence of vitamin deficiency among people with darker skins because of the inability to manufacture or synthesize vitamin D when they are exposed to sunlight. So why the interest in vitamin D? Is it all in the latitude? And because when the COVID-19 numbers were increasing dramatically in the West, they found that it was mainly in countries that were north of the 35-degree latitude or the 35 parallel. And you can see Belgium, Spain, UK, France is up there, Sweden, USA, Switzerland, all countries that are further up north compared to India. What about vitamin D and mortality? Again, you can see the mortality also was increased in countries that were above the 35th parallel, but also vitamin D deficiency showed here in red dots, showed increased mortality in patients who had low vitamin D levels. So what is the evidence? Just one slide I'm going to show you. On the left here in red is patients with low vitamin D levels, and on the right here in blue is patients with adequate vitamin D levels. You can see that those who had low vitamin D levels, that's more severe illness, raised CRP, low lymphocyte counts, hypoxia, and higher inpatient mortality. So there is some evidence that vitamin D does play a role in people developing COVID-19 symptoms. What about vitamin D and the diabetic foot? So this study we did in Bulgaria, and we looked at a population of patients with diabetic foot ulcers, type 2 diabetes with neuropathy and without complications. And we showed that patients with foot ulcers had low vitamin D levels when compared to patients without foot ulcers and neuropathy and patients without complications. So there is a definite underlying reason for why people with vitamin D deficiency get foot ulcers. I mean, you look at the prevalence of vitamin deficiency in people with foot ulcers and those without foot ulcers here on the right, you can see that most patients actually were vitamin D deficient, but vitamin D deficiency was more significant in patients with diabetic foot ulcers. What about vitamin D in patients with diabetic neuropathy? Again, studies have shown that patients with neuropathy have got low vitamin D levels, and there is it is implied that vitamin D may play a role in patients developing neuropathy and other diabetic complications. So what we did in this study, we gave patients low versus high dose vitamin D on a weekly basis, and we measured their microcirculation, and we showed that patients who were given the higher dose vitamin D at 24 weeks showed improvement in blood flow as measured by laser Doppler microcirculation. We also then looked at other risk factors. Firstly, to show you the vitamin D levels, it improved as you would expect. In patients who were given the high dose vitamin D, there was not much change in patients who were given the low dose vitamin D. But there was an improvement in HbA1c. Despite no change in diabetic treatments, we saw an improvement in patients who had high dose vitamin D. There was no change in those who had low dose vitamin D. There was also an improvement in IL-6, and we know that IL-6 is one of the main cytokines that's involved in the cytokine storm seen in COVID-19 and the ARDS that these patients present with. And we showed a significant reduction in COVID-19, in IL-6 in patients who were given the high dose vitamin D, and there was no change in the low dose vitamin D patients. We also showed an improvement in the anti-inflammatory cytokine, which is IL-10. And again, you can see there was an increase in high dose vitamin D patients, and there was no change in patients who had low dose vitamin D. So vitamin IL-6 is known to upregulate ACE2 receptor, and we know that the COVID-19 or the coronavirus 2 enters into the cell while the ACE2 receptor, vitamin D, reduces cytokine production, including IL-6, and therefore there may be an implication of using vitamin D in treating these patients. So what about in the diabetic foot and in COVID-19? How can we improve the outcomes? And there have been some really good papers from India and also from the West, and Vijay also mentioned a study himself of some work that they've been doing in Chennai. This algorithm here shows the interaction between the patients with diabetes, COVID-19, and diabetic foot ulcers. And the main impact here again is vitamin D, but also the increased coagulopathy seen as a result of COVID-19. And we know that patients who develop COVID-19 infection, they increase risk for developing pulmonary embolism and raised D-dimers. But this increased coagulopathy can lead to increased risk for peripheral arterial disease. So there is a definite interaction between COVID-19, the coagulopathy, peripheral arterial disease, vitamin deficiency, and ultimately this patient developing diabetic foot ulceration. So there may be some interactions between somebody who's got a COVID-19 infection and them developing diabetic foot ulcers. This is a new term that has been coined recently. It's called COVID toes. And these patients present similar to chilblains. And they present with painful burning sensation in the toes. And you can see the discoloration. They have micro ulcers or ulcers on the tip of the toes. And this may be because of the enteral dysfunction that is enhanced in COVID situation, but it also could be the micro emboli that is seen in the microvasculature, leading to these small ulcers in the tips of the toes. So since the COVID situation has impacted globally, it has also had a massive effect on our patients presenting to the foot clinic. And many patients do present late to the foot clinic. And these are just two of the patients who have I'm presenting here. Here on the left is a patient who had an ulcer for almost 6 weeks before he decided to come to hospital, underlying X-ray showed osteomyelitis. And unfortunately, although he came to hospital with IV antibiotics, we were not able to save the foot. The patient on the right here, we managed to successfully treat the ulcer, and the patient went home with all toes and feet intact. So there is an implication, as Vijay mentioned, the increased risk for amputations for patients in the COVID situation because of the inability for patients to attend clinics, the lack of availability of clinics because of the way practice has changed over the last few months. Just briefly talk about Charcot foot and inflammation. As we all know, Charcot foot is a swelling of the foot with pain, discomfort, and deformity. These are how the patients will present. They may have mild deformity with increased temperatures and swelling, or they can have quite severe deformities if they present late to the clinic. Again, looking at the inflammatory markers, some of the studies that we have done, and we have shown increased TNF-alpha, interleukin-1 beta, IL-6. And these, as you know, as I've mentioned earlier, are similar markers that are seen in the cytokine storm. And therefore, it may be that patients who develop COVID infections may have an increased risk for developing Charcot foot, although this has not yet been proven, that there have not been many case reports to mention this. And of course, the anti-inflammatory markers, again, that we have looked at, OPG, CGRP, and eNOS, are reduced in Charcot foot, which leads to the development of this inflammatory condition. So how can we reduce complications in people with diabetes during the COVID-19 pandemic? This is a nice study done in Michigan from the Department of Internal Medicine by Schmidt and colleagues, and they call it the STRIDE study, strategies to reduce severe diabetic foot infections and complications during epidemics. They came up with algorithm where all patients are triaged when they present with a new foot ulcer, and they're divided into patients with low acuity diabetic foot, in other words, no infection, no risk for amputations, or patient with high acuity foot, so they have an infection, osteomyelitis, Charcot, etc. Patients who've got low acuity diabetic foot will have their care delivered by video visits or telephone, but patients with high acuity diabetic foot will be seen face to face. And then if required for emergency treatment, they will be admitted. If required, surgery will be performed and then discharged. And depending on when the high acuity becomes low acuity, they will go on to video visits, telephone visits, or if the low acuity becomes high acuity, they will then be seen face to face. So there was an interaction between the two treatment modalities. And what did they show? They showed that they compared data from March to May 2020, so the first 3 months when the pandemic started, and they compared it to similar time span in the previous year, so 2019. So in 2019, March to May, there was only one virtual visit. This increased to 220 during the pandemic, and you can see this was a 21,000% increase in the virtual visits. Outpatient volume was around 2,300 in 2019. This dropped by 80% to 425 in March to May. So you can see that many of these visits became virtual or not at all, because you can see that the numbers don't match up between these two. So I think many patients were not being seen at all in the March to May 2020 time span. Inpatient volume also decreased by 62%. Minor amputations decreased, but if you look at the actual percentages, there was no change in minor amputation between the two time spans. So looking at diabetic foot related care, you can see that 40% of patients in 2019 were seen for diabetic foot. These numbers, so that was 938, which reduced to 416. But if you look at the number of patients who were actually seen face to face, 98% of this volume was for diabetic foot. So although the numbers decreased by 55% for patients attending face to face in the diabetic foot clinic, majority of the face to face was actually for diabetic foot patients. So that was a 1.45-fold increase in patients who were being seen for diabetic foot face to face in the 2020 cohort. This study looked at data for Manchester and Los Angeles, and again pre-lockdown here on the top row for both the cities, and the bottom row is post-lockdown. You can see in Manchester there were 373 clinic visits since lockdown. Pre-lockdown, this reduced to 208 post-lockdown. So they were still happening face-to-face, but the numbers decreased. Many patients then went on to have telecare or home visits. And also in the US, from 282, clinic visits dropped down to 86, and telecare went from 0 to 113. But looks like in the US, they don't do any home visits, which in the UK happens quite regularly. Looking at hospitalization, there was a 90% decrease in hospitalizations in the UK, whereas in the US, it was a 2/3 decrease in hospitalization. So one wonders where these patients were actually being treated when they had severe diabetic foot infections, when we know that severity actually has increased since the COVID situation started. What about arterial thrombosis? This study, which was done again in the US, it compared to the distribution of arterial thrombosis in patients with and without COVID. So lowest rheumatic clot was seen in 100% on CT angiograms in people with COVID-19, and only in 32 patients in the control group, and this was an increase of 69%. Now all these patients were not diabetic, only 50% of the two groups actually had diabetes. What was most significant, and we know that mainly patients with diabetes have mainly peripheral disease, and the study that we did a few years ago, which showed more below knee clots than above knee clots, which was the reverse for patients who did not have diabetes. But you can see here that patients who had COVID, they had more proximal clots when compared to patients without COVID. They then looked at the mean clot score, and again, this was higher in patients than controls, and death and amputations was also much greater in patients with COVID than those without. The odd ratios was a significant 25 with a p-value of 0.001. So patients with COVID have got increased thrombogenicity, and this study has clearly shown the increased risk for arterial thrombosis in patients with COVID versus those without. Another study again looked at acute arterial and deep vein thrombosis now, and again this was in the first 2 months since COVID-19. All patients had COVID-19, and they looked at lower limb thrombosis or DVT. The mean age was 68 years. 1 patient died in the lower limb thrombosis group, and 3 patients had amputations, whereas patients with DVT, 28% of patients died of major organ failure. And I doubt that this is because of DVT itself. I think it's partly because of the cytokine storm and the COVID situation. But patients who died had raised fibrinogen, CRP, and D-dimers, as we showed earlier. Again, some of the risk factors that are seen quite prominently in patients with diabetic foot problems. So what will happen if the pandemic does continue? And this is an excellent study done by Ghoshal Mishra and colleagues, where they used a simulation model from previous pandemics, and they looked at using a multivariate regression analysis, what will happen to some of the important risk factors in people with diabetes if lockdown were to continue. And they showed that if the lockdown were to continue for 30 to 45 days, you would see a 2 to 3% increase in HbA1c, a 10 to 20% increase in neuropathy, a 3 to 4% increase in amputations, but also an increase in myocardial infarction, cardiovascular, strokes, and also infections. So all of these risk factors, which are important that we deal on a day-to-day basis, if patients, if the lockdown were to continue for a significant amount of time, we could see deterioration of all these risk factors and clinical parameters in our patients. So how do we manage diabetic foot ulcers in the COVID situation? There are a lot of algorithms that have been published, including the International Working Group on the Diabetic Foot, NICE, etc. And this is a lovely algorithm from India by Atri and colleagues. And here they recommend home community care and teleconsultation in most situations, unless the patients have got osteomyelitis, Charcot foot, where they might need hospitalization and then ongoing care in the community. Another study from India, again, similarly describing that if patients have got mild symptoms, then managing patients by online consultation. If that is not possible, then patients can be seen in the hospital where appropriate management can be given with follow-up via telemedicine. This is FE UK, which has again described the protocol for managing and preventing a lower limb amputation. This has not changed from the pre-COVID situation, and they again stress the importance of regular assessment of the foot and appropriate management of people with foot ulcers and also ischemia. What is our management protocol in our hospital? Patient presenting with a diabetic foot ulcer, we initially assess them in the clinic, so face-to-face using appropriate PPE. We do a COVID test if required, but all patients who come into hospital will have a rapid COVID test. We get the results within 2 to 4 hours. We do a complete foot assessment, what we call triage. So we look for neuropathy, PAD, and any infection. Arrange investigations as necessary. So blood tests, full blood count, CRP, HbA1c, etc. Do an X-ray if required. If the ulcer is deep, probing to bone, we then dress the wound, provide offloading footwear, discuss glycemic management. And we're using a lot of insulin these days because we know that patients with diabetes have got increased risk for mortality. So we are trying to bring the blood sugars down as quickly as possible. We also do cardiovascular risk factor management, blood pressure, lipids, antiplatelets. We're using a lot of DOACs now, one because of the procoagulant state of diabetes, but also the procoagulant state of the coronavirus. And with the COMPASS study, which has had a nice presentation yesterday at this conference, we are using a lot of DOACs to prevent people from developing ischemic legs. Subsequent follow-up depends. It could be face-to-face or teleconsult. We are privileged in the UK that we've got district nurses, so the nurses can visit patients at home. They can send us pictures. We can do video consultation. It's difficult for the patient to do this because most of these patients are elderly. They don't have the know-how, the technique, or the availability of teleconsultation. So if we were to do to the patient, it would be by telephone. But we are using district nurses. Our podiatrists also will visit patients at home, and then we can do teleconsultation with them. If antibiotics are necessary, we prefer to use oral antibiotics. If IV is required, we have now set up an IV at home therapy where the nurse will go to the patient's home. They'll put in a midline, a PICC line, or Venflon, and patients are given IV antibiotics at home. And we tend to use stuff, flucloxacillin or teicoplanin as part of the treatment regime. And this way we can avoid admission to hospital. So NHS England has come up with its own guidance. This is for general practice, and they do recommend where possible to do a one-stop visit that prevents patients coming in to contact with healthcare professionals, but also others where social distancing may not be done properly. So at one-stop visit, get the blood test, foot examination, and check urine for microalbuminuria. And this is what's happening at the moment here in the UK. So coming back now to the vitamin D story, this study, which was done by Rastogi and colleagues in PGI Chandigarh, looked at vitamin D supplementation in patients with COVID-19. It was a randomized controlled trial. All patients had low vitamin D levels, and patients who had COVID-19, they had mild or asymptomatic disease and no comorbidities. 16 patients received very high dose vitamin D for 7 days on the daily basis, repeated for another 7 days if the vitamin D was less than 50 at 7 days. Total dose given was 14 days, and the controls did not receive vitamin D. All patients had oropharyngeal swabs at intervals up to 21 days. They also measured the inflammatory markers, PCT, fibrinogen, and D dimers. And what they showed, vitamin D levels improved in the intervention group, as you would expect, but there was a reduction in fibrinogen, and you can see the vitamin D levels there. But what was more important is that patients who had high dose vitamin D, there were more chances of becoming COVID-2 virus negative. So 62% versus 20% at day 21. You can see the p-value there is significant. What about treatment for COVID-19 with vitamin D? This study here done in Italy, they used calcifidiol treatments, that is 25-hydroxy-D. They randomized patients who received or did not receive calcifidiol. It was an open label study, and they looked at ICU admissions. Patients who did not receive the vitamin D, you can see that 50% of patients required ICU admission compared to only 2% for patients who received the vitamin D treatment. So there is some evidence coming out there that vitamin D may be beneficial for people with COVID-19. And this is a study that we did here in Tameside Hospital. It was a 3-center study, Tameside with Preston and Leicester. And we looked at high-dose cholecalciferol booster therapy, and we showed there was a reduced risk for mortality in patients with COVID-19. And we showed that patients who had low vitamin D levels, also those who had borderline normal vitamin D levels, actually improved when they received booster therapy. This was an observational retrospective study done in about 1,000 patients here in the UK. For lack of time, I'm not showing the slides, but the study is available online. If you want to read it, it's free to download. What we also showed in this study is that patients with blood sugars of more than 6.9 on admission had higher mortality. So all the more reason why patients coming into hospital should have their blood sugars measured, and if possible, given vitamin D. So in conclusion, there's a similarities between the presentation COVID-19 and diabetic foot complications, namely diabetic foot ulcers, and maybe an interrelationship is highly plausible. Due to disruption in healthcare and the apprehensiveness of patients to visit hospital, greater need to telehealth care should be encouraged. Improved treatment at home or the community, such as podiatry, IV antibiotics at home, will help maintain care for patients with foot ulcers, reduce risk for amputation, and possibly reduce hospitalization. Self-examination by patients to identify early ulceration is crucial, and we recommend this to all patients now here in the UK to examine their feet on a regular basis. And we advise them if they find any change in the foot, discoloration, pain, swelling, or breakdown in skin, they must inform the multidisciplinary foot care team. Vitamin D deficiency plays a role in both disease conditions. I've shown you data both for diabetes and also for COVID, and healthcare professionals must strive to manage this appropriately because there is a interplay between vitamin D deficiency, COVID, and diabetes, and also diabetic foot complications. So governments and healthcare providers must play an important role in the delivery of care for diabetic patients, especially for diabetic foot patients. So thank you very much for listening.
Good talk, Ed.
Thank you.
Can you hear me?
Yeah.
Yeah, thank you, Dr. Jude, for a very comprehensive and excellent talk. And now we move over to our next eminent speaker, Dr. Jayesh B. Shah, who is the president of South Texas Wound Associates and president of Time to Healing Concepts, medical director, Wound Healing Center. He's currently president of American College of Hyperbaric Medicine. And he is also currently, he's also published Wound Care Certification Study Guide in 2011. And its second edition in 2016, and written many textbooks on chronic wound care, authored over 40 chapters on wound topics in four books and 30 scientific articles. He's a recipient of Lifetime Achievement Award by TIPS SW Chapter 2020 and first Diabetic Foot Research Award in India in 2019. And over to you, sir, for your deliberation.
Thank you so much for that kind introduction. And I'll like to share my screen. But before that, I want to thank Dr. Bansi Sabu. Dr. Bansi Sabu has been a co-chair when I was in Ahmedabad in 2014 when we did API Global Summit. And I'm really thankful for his work at that time. And I was hoping that I will be in Ahmedabad today giving the lecture. But with COVID-19, we are all on Zoom. And really thankful and blessing of the holiday season that I already got my vaccine, and I hope 70% of the people in the world gets the vaccine so we can get rid of COVID-19 and we can be back in Ahmedabad again. Thank you, Vijay. Dr. Viswanathan's facility in Chennai is very unique, and I'm so impressed with the work he does. I think he's well renowned in the world. His facility does great job at a very, very minimal cost. And I have taken several delegation from United States to his facility, and he has been a very kind host. So thank you, Dr. Vijay Viswanathan, for being a kind host to a lot of physicians from United States who have visited your facility. You are pioneer, and you've done a great job with diabetic work in India. So with that, I'm going to just summarize. My job is really very easy after speaking after Dr. Viswanathan and Dr. Jude. I'm going to try to summarize what we need to do, where we are, and what are the updates with diabetic wound management. This is the typical patient. Doesn't matter where you are, whether you're in India, UK, or United States. This is the patient that we deal with. A 45-year-old car mechanic who gets an ulcer, who doesn't take care of it. By the time he comes to the hospital, it's bad, it's infected, it's foul smelling, and everybody's talking about amputation. This patient, if you look at the statistics, is fearful of more of amputation than death. When you look at the statistics all over the world, every 30 seconds, someone is getting amputated somewhere in the world. If you look at the statistic, this patient has a higher mortality than breast cancer, prostate cancer combined. So if you look at this patient, the clock starts kicking. As soon as that patient has diabetic foot ulcer, this patient's chances of amputation increases every day. So what can we do? How can we help these patients? By working together, as Dr. Viswanathan rightly said, this is not a surgical or a medical turf. This is a teamwork. We need to work together because these are high-risk patients who can get amputation if we don't work together. This is a grade 3 also. This is a very good comparison. It's in the textbook of chronic wound care, where you can compare a pressure ulcer staging and a diabetic ulcer staging. And as you see, this is rightly a grade 3 deep full thickness ulcer with osteomyelitis, tendonitis, and deep abscess. A diabetic foot ulcer needs a very comprehensive care. Every diabetic patient needs to be looked at from the diabetic control, general health, comorbidity, needs a good mini vascular exam that anybody can do. Any physician can do in his clinic, can check the pulse with Doppler. It does not need a rocket science to check the vasculature in a diabetic patient. But half of the patient gets amputation without getting good vascular assessment. Pretty staggering bad statistics. You can do toe pressures. You can really, if you are available, you can do a good Doppler if it's available. And if there is availability of transcutaneous oxygen studies, you could do that. Doing a good neurologic exam, very simple thing. Everybody should be able to do it. Taking a 10 gram, putting a 10 gram of pressure using 5.07 monofilament and checking for neuropathy will help your patients to prevent ulceration and prevent amputation. When you look at the wound, basic exam, checking for the size, location, where it is, what's the smell, whether there is a signs of infection, looking for deformity, looking for charcot foot. Just a simple basic assessment is very important in every diabetic patient. Like this diabetic foot ulcer patient. And we all know it's not just one thing that doesn't let the wound not heal. This patient is not healing because he has a poor local vascular supply. They have excessive proteases, increased MMPs, concurrent illness, diabetes, obesity, heart disease, cell senescence, low volume of growth factor, devitalized tissue, a lot of necrotic tissue, prolonged inflammation, alkaline pH. More alkaline the pH, more longer these wounds are going to heal. Excess exudate production, excess bacteria. Dr. Viswanathan talked about biofilm. And this also increases psychosocial issues. Diabetic foot ulcer patients have very high incidence of depression. And again, this is well documented statistics. So how do you assess this patient? You do simple ankle brachial index to check for vasculature, which we all should be doing in our clinics, right? Checking your blood pressure in the ankle and taking a ratio with the highest systolic blood pressure in the arm tells you a lot. Doing arterial Doppler, sometimes you do MRI, X-ray to check if there is any deep infection, osteomyelitis. You can do vascular check by doing an angiogram. But now what are the new things that's out there? Let's just briefly touch on what are the new things that's out there we can do to assess them properly and better. We all know that transcutaneous oxygen studies does better than ABI in predicting healing with foot ulcers. And only modestly. So if you compare ABI with TCOM does better in predicting amputation, healing, and the foot ulcer healing. So again, TCPO2 is a simple test that you can do if it's available in your clinic. You basically put an electrodes on your foot and you're basically checking for microvasculature, checking for a skin oxygen, checking for perfusion. But this is a lengthy test. It takes 2 hours. It needs a good technician who can do it properly in your clinic. So what else can you do? There's a new thing that's out there, which is called a snapshot, where you can basically check the tissue oxygen and saturation by just checking the ratio of oxygenated and deoxygenated hemoglobin by just taking a picture. And a lot of data out there, and we start using in our clinic. And this is a simple test that you can do. It takes less than 30 seconds, taking a picture. This is a diabetic foot or diabetic amputation, open amputation. This is before hyperbaric oxygen therapy. And you see just after hyperbaric oxygen therapy, this is just the 3-hour difference. And you see that increase in oxygenation, increase in perfusions, really telling us hyperbaric oxygen therapy immediately improves the oxygenation. This is a simple thing that is out there, which is called SPY angiography, which you could do in the clinic. Usually done when they do a plastic surgeon does flap, very commonly used in plastic surgery literature. But now we're trying to see this can be used in wound care before they do amputation, because a lot of times, because diabetic patients have poor circulation, they have bad angiogram, they have microvascular disease. If intraoperatively or before they construct that flap over that amputation, if we can tell is that flap going to survive by a simple test, by just injecting a little ICG dye and taking a picture and looking at the flap perfusion, that will make a huge difference. So again, this is something that's happening in the wound care arena. So that's a good thing to remember. But whatever we learn about advances, don't forget the basic wound care. That's what saves life. That's what helps you to heal wound. The basic things are important in debriding the necrotic tissue, controlling the diabetic blood sugar, offloading the wound, treating the comorbidities, treating the infection, managing the exudate, taking care of nutrition. Those are the most important things that you need to do on every patient. I'm going to talk about innovation to make it a complete list. But remember, the standard wound management is what saves lives. That's what helps you to heal patients. Okay. These are the additional things when your patient does not heal. So 5 things you need to remember when you are trying to heal a wound: debridement, infection control, moisture control, edge effect, and correction of hypoxia. 5 things really helps you to decide whether this patient can get to the level. And that's where the physician role comes into the play. As Dr. Viswanathan said, you need to get that patient ready before that person can get a skin graft. But now we could do a bioengineered skin or a skin graft. A physician can do it in his office. So there is a lot a physician can do, and very rightly pointed out by Dr. Viswanathan. So this patient, again, got decompressed. You did immediate surgical debridement, or the osteomyelitic toe needed debridement. But again, that patient needed continued debridement, which you could do it in the clinic. There are multiple ways you can debride the wound. I'm not going to go in details of this. Wet to dry and whirlpool is kind of getting out of fashion. The main thing that we do is a sharp debridement, which Dr. Viswanathan already talked about. There are newer ways of debriding these wounds, which you could use, which are water power tools like VersaJet, or you can use ultrasound-based debridement in your clinic and can get a much better debridement, a much better tissue by doing it in a much quicker way. So this is a gentleman who had in the clinic who had an extensive diabetic patient, was strapped under a wheeler for 45 minutes, had extensive hematoma, a lot of necrotic tissue. We were able to do this debridement in the clinic, get that wound prepared in the clinic, and then get that patient to get better so that we could put a skin graft or a bioengineered skin. All can be done outpatient, all can be done in the clinic. All right, important things. The second principle is infection control. Once you have done the good standard wound management, you've done the debridement, second important thing is to really look at the patient and make sure you treat the infection. A lot of chronic diabetic wounds don't heal because of biofilm. Earlier you detect the biofilm, earlier you figure out why this patient's wound is not healing, what is the microorganism, what is the resistance, the better it is. Now there are a lot of newer cytotoxic wound cleansers. Before we used to just clean this wound with normal saline because that was the only thing that was available which was non-cytotoxic. But there are now multiple things out there. Debridement is still the key things when you're thinking about biofilm. Systemic antibiotics tailored specifically to wound infection, and then rotating the antiseptics. That helps when you're treating
phenotypic diversity along with genetic diversity, that is multiple different species of bacteria within the biofilm, allows the biofilm to reconstitute itself after a major attack. This is an important survival mechanism for biofilm.
And again, remember, that the biofilm is something which we all know about. We knew about it. It came from the dental literature. We knew that these microorganisms are smarter. They come in form of microcolony. They form this mature biofilm. They're like spider web-like substances and does not allow topical antibiotics or systemic antibiotics to work. This is the typical wound which where you will see that when you debride this wound, you will find that spider web-like substance that come out of that wound, and it keeps on coming back. You put them on antibiotics, you do the topical antibiotics, they come back to your clinic, and they come back, and you need redebridement. That's what you're talking about. So why can't we do this better? Why can't we take care of this biofilm better? But we need to first identify that. We all do a swab culture, but if you do a swab culture, do it right. You know, a lot of times people do a swab culture and then they have a garden variety of organism and they don't know really what they are treating. So the best thing to do when you do a swab culture is to make sure you clean the wound up, and you then put a swab inside the wound, in the depth of the wound, and you basically try to get the fluid from the depth of the wound. You put it for 30 seconds, and after you clean the wound, and get this fluid from the depth of the wound. That will give you a better culture. If you're going to do a swab culture, though wound biopsies, needle aspiration, those are much better way of doing cultures. And now we routinely do molecular culture. By doing a DNA analysis, we are able to really figure it out what this biofilm is, what is the real infection. And we find there is a true underestimation of a diversity of infection in a diabetic foot ulcer. You find that diabetic foot ulcer has a lot of mixed organism. It's not just staph and strep. We find that it's anaerobes, and we find that sometimes it's yeast causing this infection. This is becoming very cost effective and is being routinely done. Now, what can we do on a point of assessment and check for biofilm so that we can do a better assessment of the wound by just taking a picture? So now we have another camera. We can take a picture of the wound, and with the sign of fluorescence staining, you can know what area has a biofilm, what needs further debridement. So you can do a better debridement in the clinic, so you can make sure that you have taken care of all the things that needs to be removed. As you see that this picture has that cyan fluorescence, and you know that that is infected, you got that debridement done, and you see that that has decreased post debridement. So this really helps. You can find that this imaging is more sensitive in deciding bacterial pathogen just by taking an image. So this is what is going to happen in future. Point testing, deciding what needs to be done right away. Non-cytotoxic, new wound cleansers decreases bacterial bioburden. Several examples. I don't know what's available in India, but there are so many of them are non-cytotoxic. A lot of silver dressings out there, they seem to be work against the mature biofilm. Silver appears to work by inhibiting cell respiration, cell membrane disruption, and denaturing of nucleic acid. And in biologic fluids, you're looking at 12.5 to 25 parts per million of silver atoms are needed to be bactericidal. Silver product does have some efficacy against mature biofilm. The third principle is moisture balance. If it's too wet, you get it to moist. If it's too dry, get it to moist. Wet to dry is old terminology. It's not a scientific terminology. You don't put wound to dry. You put wounds to moist. So the new terminology you need to use everywhere is wet to moist. Okay. So if it's dry, you get them to moist. If it's wet, you get them to moist. Okay. That is the third principle of wound management. That will get you where you need to be. There are multiple dressings out there. Dr. Viswanathan already talked about what's available in India, and there are collagens, there are hydrocolloids, there are calcium alginates, a lot of this good things that's out there, but you don't want to get that wound dry. That is an important thing that you want to remember, okay? And again, if you cannot do that, then that is going to be a problem. I'm having a little technical difficulty, but I'm almost to the end. So again, remember the third principle is moisture balance, and the fourth, where you can use negative pressure therapy also. Negative pressure therapy is also an important thing that you can do. which will help you with moist wound healing, clears MNPs, does mechanical and debridement on autolytic debridement, helps you, a great tool for exudate control. That is something that you can do. And if your wound stalls and it's not moving, if they have a non-migrating keratinocytes, then you're going to need some advanced wound care products. You're going to need some shockwave therapy. You may need skin substitute. And there are multiple of them out there. There are multiple of advances out there. There's a lot of literature about it. And this is a video about shockwave therapy that we started using.
When he did that, I could feel it going into the skin.
Mark, a longtime diabetic, suffers from significant open wounds triggered by his battle with the disease.
This is a good alternative for patients who are not healing. You basically give 360 shocks per minute. So the treatment usually lasts 3 to 4 minutes, and it's not really complicated. It's pretty easy.
DermaPACE helps the body create new tissue and blood vessels caused by peripheral artery disease, a hallmark of diabetes. And according to longtime diabetic Jerry Fernandez, who has already had his first treatment, it's a quicker, faster alternative to the hyperbaric oxygen chamber.
The new treatment that they have is only lasts like not even 5 minutes. 5 minutes, I think, total, including the setups and all that. But just you go inside the chamber in hyperbaric, you're there for 2 hours. You know, just kind of rub it around your foot, and it's done.
For now, Dr. Shah is one of a handful of physicians nationwide clinically evaluating the dermaPACE.
It's a completely brand new technology. It's kind of a breakthrough compared to what we had so far in wound care.
I'm Marty Salt reporting.
So there are multiple things that's out there. There are a couple of randomized trials which helps us understand how the software therapy works. It basically helps you with perfusion, helps you with inflammatory response, help you with growth factor regulation and angiogenesis. So again, that's a new tool in the toolbox that you can use. There are a lot of cellular products out there, multiple things that you can do in your clinic, which is out there, which we do. So a lot of these patients, we heal them outpatient. They do not need surgery, and they get taken care of right in the wound clinic. There's many things out there. I have not a lot of time to discuss that, but there are like at least 40 to 50 different kind of skin substitutes out there which we use. And now we can do epidermal bubble grafting right in the clinic, right? We just get like a pinch graft. We have this harvester, we take the cells out of the thigh and then put it on the wound. And like on this patient, once the wound bed was prepared, we got the IV antibiotics, we got negative pressure therapy, we got hyperbaric oxygen therapy. Once the wound was ready, we were able to put epidermal graft right in the clinic and got the wound to heal. So what the diabetic foot care is all becoming outpatient. It's going to be something which will be led by the physician, and that's the one who's going to lead and make sure that all the patients are being taken care of properly, and surgery will be indicated for an acutely infected wound. Correction of hypoxia is again equally important as the 5th principle in diabetic foot ulcer. And again, I don't have time to look at it, but I'm going to show you this video.
An experiment, in fact, shows that life without blood is possible under hyperbaric conditions. Pigs breathing pure oxygen at 3 eta are totally exsanguinated. The volume of fluid in their circulatory system is maintained. The absence of erythrocytes makes the pig look very pale, but the oxygen supply is adequate. After reinfusion with their own blood, the pig lived happily ever after.
So in conclusion, hyperbaric oxygen therapy has multiple roles. The diabetic foot ulcer last couple of trials have come out negative, but overall, the evidence shows support of hyperbaric oxygen therapy for diabetic foot ulcer. It helps you with improved oxygen delivery, bubble reduction, tissue gradient, antibacterial, improves WBC bactericidal function, impairs neutrophil beta-2 integrin addition. It is anti-inflammatory, decreases cytokines, increases stem cell mobilization, and increased local stem cell engraftment. So again, a lot of important basic mechanism that helps us to understand role of hyperbaric oxygen therapy. So in summary, just remember the 5 things when you talk about diabetic foot ulcer is mainly making sure that you do the standard wound management, debriding the wound, taking care of infection control and biofilm, moisture control, edge effect, and correction of hypoxia. There's a tremendous innovation that's happening in diabetic wound care. Diabetic wound care is a team sport. It's not about physician. It's not about surgeons. It's not about nurses. It's not about technicians. We all work together so that we can decrease the risk of amputation in our patients. There are a lot of point of service and diagnostics available that will allow us to make more precision-based, evidence-based treatment technology. And in future, if I come back on to lecture, I'll be talking about the wearable devices. A lot of things happening in terms of prevention that is going to be taking over in diabetic ulcer management. So before an ulcer happens, how can you prevent it? That's what is going to be the biggest innovation that we're going to talk about in future. Thank you so much, and I appreciate this opportunity, Dr. Sabu, to allow me to share my thoughts on updates on diabetic wound management. Thank you.
Thank you, Dr. Shah, for a very lucid talk. And we have very less time left for interaction with these speakers. My first question to you, sir, Dr. Jayesh, is regarding recommendations and guidelines from the recent diabetic foot infection guidelines, where they state that adjunctive treatment, hyperbaric oxygen, and use of local antiseptic, silver-based preparations, maggot therapy, plankton therapy, and also when you talked about those stimulation of the wound bed, etc. That is not given a stronger, it has come up with very weak recommendations from these guidelines. So what is your take on that?
Yeah, I think you put a lot of things together. So if we divide each one of them, I think that will be better. So yes, again, standard wound management is always going to be the first, right? This is an adjunct treatment for something where nothing else works when you are thinking about amputation. Hyperbaric oxygen therapy, if you look at the guidelines, hyperbaric oxygen therapy is still the great review in Canada, the one done by UHMS, where they put all the data together. You know, if you just look at the couple of data, the last data that came was from Santema. And again, if you look at that data and dissect it, if you finish the 30 treatments, those patients did well. Okay, the randomized trial, if you read that last data. So it's a dose, hyperbaric oxygen therapy is based on the dose, how much and what, like any other medication. If you don't do what is prescribed to you, you get a bad outcome. That's what the recent data shows. So if you are given 30 treatments, if you don't do it, you're going to have a bad outcome. If you do 30 treatments, you have a good outcome. So that is the recommendation at this time. The shockwave therapy is a very, very new treatment. It's not something which is out there. It will be a weak recommendation at this point. There is only 2 randomized trials right now. It still needs a lot of work. It still needs a lot of research. What was the third thing you talked about? The silver dressing. The silver dressing. Silver dressing is, again, as I said, a lot of these things that's out there from the data standpoint, they don't have it. None of the dressing have it. Okay, if you look at many of the advanced dressings, they have not done enough research to give you the data at this point. Okay, so like a lot of things in wound care, we are not like cardiology field where we have done so much research and we know exactly what is working and what is not working. We are at infancy. We are still developing. So you're going to find that data is developing. It's not there yet. Yes.
Yeah. Thank you. Thank you, Dr. Shah.
Anisha, can I just answer one thing about the hyperbaric? See, if you have revascularization done, and today we have excellent interventional radiologists who put a balloon into the anterior tibial artery. After that, if you do hyperbaric oxygen, the collateral supplies will open up beautifully. So hyperbaric may not be a substitute for revascularization. Nobody says that. But after revascularization, if you do hyperbaric for about 10 days or 14 days, the collaterals will open up beautifully, and we have seen fantastic granulation prevention of amputation. So when these guidelines are written, they take the whole picture as a whole, but you have to take the individual case. And Jay Shah is the president of the American Board of Hyperbaric Medicine. So, so there is definite use for hyperbaric oxygen in certain situations. That's my take on hyperbaric oxygen.
Yes, sure, sir. We need many studies for getting good recommendations for all these. And so my another question was to Dr. Jude for his very comprehensive talk. And sir, I just wanted to know that from mild to moderate to severe infections, where do we actually introduce the subcutaneous low molecular weight heparin for the diabetic foot wounds?
I think if you want to use anticoagulation, I would now go for the DOACs rather than using low molecular heparin. There was a small study that was done in Sweden by Jan Appelqvist, where he showed that giving people low molecular heparin reduced amputations. But now that we've got the better oral anticoagulants, I think we should go down for using those rather than using low molecular heparin. It's more user-friendly, it is non-injectable, so it's much better for the patients rather than giving them injectable therapy.
So is there any change COVID times are we introducing low molecular weight heparin early in the COVID times for moderate infections or milder infections also?
So if people come into hospital, they all get higher dose anticoagulation compared to what we would give them before. So before we give them 5,000 units, international units of low molecular heparin, now we give them higher doses. And this is because we have shown higher risk for permeabilism and also DVT in this population. So we are using quite a lot of subcut heparin, but at a higher dose than we would normally use.
Do you recommend high doses for home-based telemedicine management?
So we don't use it at home. No, we don't.
Thank you, sir.
So I will just end by saying on the hyperbaric oxygen therapy that you need to look at the combined data and look at the recent UHMS paper and the Canadian paper where they did a great analysis of all the research that's been done and not focus on just one study. So when you put the whole data, and that's where the guidelines come into picture of where hyperbaric oxygen therapy plays a role.
The problem, Jayesh, in the UK, it is not recommended by NICE. So we can't use it in the UK because of the lack of evidence. So I know in the US, a lot of people do use hyperbaric oxygen, but in the UK, it is not recommended, and I've not used in a single patient.
Sir, is there role of topical oxygen therapy or oxygen releasing gel or dressing in the wound management?
Yeah, absolutely. I think topical oxygen therapy, there are a couple of randomized trials that just came out last 2 years. And those are two different animals. So when you think about hyperbaric oxygen therapy, you're getting a systemic oxygenation, you're in the chamber, while in topical oxygen, you're putting on the wound. So there is a local effect of topical oxygen therapy. And they have found the last 2 trials have been positive. So again, it's not approved in United States yet, and it's not reimbursable at this time because again, not having enough evidence at this stage for that. But it's definitely another evolving technology that we might be using in a combination, and maybe for certain kind of wounds. Like for hyperbarics, we use it for severe wounds like grade 3 and grade 4, just to prevent amputations. While topical oxygen therapy may be for less severe wounds like grade 1 and grade 2 also. So that's what we are thinking will be in future.
Dr. Jayesh, in the absence of shock therapy, I have seen some places where they use a shaking therapy. They just shake the feet inside a small chamber. I mean, I'm just telling any innovation in that, and does it improve the circulation? Biji, do we have in India shock therapy? I'm not very sure. We don't have.
No,
so does it help? I'm not sure. Just ask you, Jayesh.
I'm not sure. Vijay, maybe you can answer that. I don't know.
I don't know.
Achha, good.
He's Professor A.K. Das. He's Professor A.K. Das, one of the vice presidents of the founders of the Diabetic Foot Society of India.
Jayesh, I've heard you before. Ed is my close friend and BG is my close, just like my younger brother. I'll tell one more thing. The thing is about that we have discussed today is great. And you know, I got the message in the beginning of the lockdown, BG and Ed, that during the lockdown period, possibly the two conditions, diabetic foot and the GDM, they must be seen in person. There's a guideline from the RS, our society, Jayesh, we should see them in person and not distant mode. And so that was the GDM and diabetic foot, and we followed that. And maybe now the lockdown will not be back again. We are absolutely certain. But was such the indication, such type of directives were there also in UK and USA for the seeing the diabetic foot during lockdown, not on a distant mode?
Well, again, it's very hard. Again, UK has done, they have home health nurses and doctors who go.
They have.
For us, we were doing telemedicine quite a bit, as you saw some recent papers. Yes. In my clinic, patients with diabetic wounds came to my clinic because they knew they needed debridements, they needed much more care than what that can be provided over home, which we didn't have capacity. In UK, probably podiatrists will go home and do the debridements, will do the things that's necessary. We were able to do IV antibiotics. We did have home health, but for debridements, they did come to.
Yeah, I think same thing was in India. My friend Dr. Sunil Kari and also Bijay, they saw the patients in person and delivered the. One question Bijay has asked: did you see more amputations during the lockdown period? I said I don't think so, but what's your experience, Joyce and Ed?
The data in United States showed that there were more amputation in COVID-19 period because the patients were afraid to go to the doctor. That was the reason. It was no other reason, because even the heart attacks, people didn't go to the hospital just because they were afraid to go. Yeah. They were afraid. Even people had a stroke and they stayed home because they were afraid. So that fear probably affected the statistics more than anything else.
The paper that I presented was from the US, and it didn't show any increase in amputations. But I think because those studies were done in the first 2 or 3 months of COVID, I think we were postponing the amputations to beyond those 3 months. So if you look at what happened, because studies done from March to May, if you look from June to October, we might see an increase in amputations. I think this is a nice time now to look at the data and see if we have just delayed the amputations because people weren't coming to hospital, and now the amputations actually have gone up.
Well, the last paper did show that it did go up, yes. So. All right.
So I think we have had a very good discussion and a very good speaker session, and highly enlightened. Our audience, I'm sure, must be enlightened on the current foot care and foot care during the epidemics. So thank you, Dr. Shah, Dr. Jude, Dr. Vijay Vishwanathan for an excellent session.
Yeah, great session.
Thank you.
Thank you, Dr.
Dr. Banshi, thanks. Yeah.
Thank you, Jayesh. Good.
Thank you, Dr. Rajesh, for.
Sorry, your closing remarks, and then we close the session and we close the meeting also. Dr. A.K. Das is a program director, so I take the last word from him, and then we can close this whole also.
Okay, thank you.
Thanks, Dr. J. Shah. Thanks, Dr. Vijay Vishwanathan. Thanks, Dr. Manisha. Rohan is here, and Dr. Edward Jude had already left, I think, and Dr. Shailesh Trivedi and Rajni Saxena. Dr. Ashok Das, you want to make any comment, because we are.
I just say one thing, Rajneesh was great.
Session, but we are closing the meeting.
Just before lockdown, I went to Rajesh, and he took care of me and my wife, Rajesh, Dr. Saxena, and then I went for some religious trips. Thank you, Rajesh, being here. I think this was a great meeting. BG, Jude is here. Jude has not gone. Ed is here, and Jayesh and Madam. It was a great meeting. Having 45 international speakers, 102 national speakers in 3 days, and it went absolutely on dot of time. And the amount of information, amount of science, clinical points, the practice changing points that has been given, it is very difficult writing Ramayana, Mahabharata on the postage stamp. But I hope that Bansi is multifaceted. You'll have some way of catching out the practice points and disseminating. Is it possible, Bansi, through your colleagues, if it's possible? But it's a great meeting, and I will just end by saying, then I'll hand it over to Bansi, that I was there from the very beginning. The talks were great. It was woven around most important contemporary challenges and the emphasis on the clinical practical points. And also there was a variety. There were two wonderful debates. Biji, did you watch it in the morning? Wonderful debates. I mean, and there were 3 orations, 2 debates, and multiple symposias. And from SGLT to metformin, I discussed about the legacy effect from sulfonylurea and metformin. It was, everything was covered. I'll just last sentence from my side, handing over to Bansi. A great beginning was made when in 2008, Bansi started on Happy Day Sunday morning session. Over the years, there has been well continuation, a good beginning, a well continuation of the DICARE conference. And I wish and pray with the grace of the divine, no end and endless progression for the DICARE Con in our country.
Thank you, sir.
Thank you,
Thank you for very kind words, Dr. Ashok Das, who is the program director.
Bansi, it's my duty to thank all the speakers who responded. Not a single speaker dropped out, Biji, Joyce, not a single speaker. And all the chairpersons who joined us. And also I must thank the 30,000 people who registered for the meeting. So it is my duty. Bansi had given me this charge. And I must thank the speakers, the chairpersons, and the great, great audience for whom we are here, profusely from the core of my heart.
Thank you, sir. Thank you. So first of all, thanks to all international experts who could join from different parts of the globe. Thanks to all national speakers, faculty members, all moderators, all chairperson. And as you said rightly, that we are very much thankful to all our delegates all across the country. The primary idea of doing a digital meeting that we can reach to many more. And this year we could reach to almost 30,000 registered delegates. Just before Jayesh had messaged me that why not it is on Facebook Live, but it is live on Facebook. I sent you again the link for that. So, people can listen it. And on this same platform, we are going to continue on another 2 to 3 months. The lectures will be there and then it will be on my website, also on DICARE. So people can listen, those who had missed. And once again, thanks to Dr. Das. Thanks, Dr. Mithun. I mean, my close friend, my dear friend, and who really helped me. So thank you, Dr. Mithun. I can see Akash from my team in this hall. Thanks, Sailesh Bhai, all the time his support. Rohan is from Gujarat, and Manisha and Rajneesh for sharing this session. And thank you, Dr. Vijay Vishwanathan, Jayesh, and Dr. Edward Jude for this last session. I think now we close this meeting and we close this session. Thank you. Thank you.
Congratulations, Dr. Bansi, for nice effort. Dr. Clapping for Dr. Bansi.
Thank you, Rajesh. Thank you, Mithun.